kindly drop your comment on Q&A box and it will be discussed after the presentations. Now I would like to pass these sessions to the main chair. Over to you, sir and ma'am. Thank you.
Thank you very much. This morning I would like to welcome my co-chair and all the presenters and the audiences of this morning session. We have a total of 1 hour and 20 minutes and we have 6 presenters with wonderful research papers. We will allow 10 minutes time for each presenter, and the last 15 minutes will be utilized for discussion and 5 minutes for the closing of this session. Now, may I request my co-chair to take questions and help in the timekeeping of this session. Dr. Myers, now it's to you.
Thank you so much, Dr. Kiran Regmi. This is immense pleasure to me to co-chair with you for this important session. First of all, thank you very much for NSRC for actually organizing this conference and also selecting this maternal child health as one of the theme of the conference. We have, as Dr. Regmi said, we have a very good 6 papers, ranging from nutrition of children to geriatric health. And then we also have a very good coverage region-wise as well. We have papers from like Jumla to people from Biratnagar in Province 1 as well. So it's a very coverage in terms of geographic regions and also in terms of, from child health to maternal health to geriatric health. So both in terms of subjects and coverage, and then also the issue is very diverse. So as you know, maternal and child health is a kind of big topic, but we will try to discuss this issue in 1 hour and 20 minutes with these 6 papers. So because of the time, I'm not going to give any kind of background about maternal and child health in our country. So because of that, I'm going to invite our first speaker, who is Sophia Opreti, who is going to talk about nutritional status and practice among 16 to 23 months old children. This is a hospital-based cross-sectional study from Bhaktapur, Nepal. So Sophia, the floor is yours.
Fellow researchers and co-authors, I'm today presenting our study titled Nutritional Status and Feeding Practices Among 6 to 23 months old urban children, a hospital-based cross-sectional study from Bhaktapur, Nepal. These are my co-authors and their affiliations. We started with the background of prevailing high child undernutrition in Nepal and the fact that despite progress made over the decades, the burden still remains unacceptably high. Though the situation in urban areas is slightly better off than rural areas, however, the prevalence rates indicates that they are still high enough to be a significant public health concern. As per the recent Nepal Multiple Indicator Cluster Survey of 2020, the stunting, underweight, and wasting rates were found to be 29, 22, and 11% respectively, also depicts the problem. Similarly, 2.6% of the under 5 children were found to be overweight or obese, which indicates the double burden of malnutrition, which is rising. And poor infant and young child feeding practices among urban children are also documented. That is why we felt that it is important to look at how the infant and young child feeding practices as well as nutritional status are in the core urban areas and how are they being affected by the nutrition transitioning in the rapidly urbanizing context of our country. We set out to fill the gap in studies that were simultaneously assessing nutritional status as well as feeding practices among core urban children of this particular age group of 6 to 23 months. To our knowledge, there is no study in urban context of Nepal that has looked at that particular age group and their nutritional status. So our specific objectives were to understand the feeding practices, assessing the standard WHO recommended IYCF indicators, plus assessing the situation of consumption of unhealthy, nutrient-poor packaged foods by that age group. And the second objective was to understand the nutrition situation, assessing the prevalence of stunting, underweight, wasting, as well as overweight and obesity amongst the 6 to 23 months old urban children. We adopted a cross-sectional design, and this study was based at Siddhi Memorial Hospital for Children and Women in Bhaktapur. Our study population were healthy urban children aged 6 to 23 months and their mothers who were visiting the hospital for regular immunization services. We had a sample size of 305 and we collected data from September 2019 to January 2020. We measured weight and length of all children, and mothers were interviewed on their IYCF practices using a semi-structured questionnaire. Data analysis was conducted using the WHO Anthro software and Microsoft Excel, as well as Stata 15. Our results on the IYCF practices are: for the early initiation of breastfeeding, we found that 47.9%, so around half of the children were, only around a half were initiated breastfeeding within the first 1 hour. Similarly, the use of bottle to feed the children was also prevalent among around half of the children, 48.5%. Around 2/3 of the children were meeting the minimum dietary diversity at 66.2%, and minimum meal frequency was being met by 80% roughly. So overall, minimum acceptable diet indicator was again met by slightly bit more than half of the children, or can say around half, at 54.4%. On the other hand, 63%, almost 2/3 of the children were consuming nutrient-poor packaged foods. And for the small age group of 6 to 23 months, that is quite significant finding. And the most commonly consumed food in that category was biscuits. And mothers, we also found that 2/3 of the time it was the mothers themselves who were giving these food to the children. Another interesting finding from our study was that 1/3 of the children were found to be drinking tea, and for that small age group, this is again something very significant. With regards to child malnutrition, our study documented for the 6 to 23 months age group children, 13.8% were stunted, 3.9% were underweight, and 1.7% were wasted. On the other hand, overweight and obesity was actually higher than wasting at 2.3%. And undernutrition rates was slightly higher among males than in females in all three indices. Similarly, overweight and obesity were also slightly higher among females. And stunting and underweight were higher among children who were born low birth weight compared to children who were born normal weight. The conclusions that we drew from our study is that the practices related to breastfeeding and diets of young children in the core urban areas of Nepal are not optimal. Only around half of them meet the minimum criteria specified by WHO. Contrary to the popular common belief that there is not much problem in the nutrition in the feeding practices of young children, that may be commonly perceived, that we would perceive that the problem is more in the rural areas. Our findings is showing that it is not the case. There is equal problem in urban areas as well. Similarly, there is a big shift towards consumption of commercially produced nutrient-poor packaged foods. And there are indications of rising overweight and obesity in the young urban children. And that is why there is an urgent need to wake up to this reality and address the rapidly changing and poor dietary patterns among the young urban children. We end our study by call to the policymakers and programmers for targeted nutrition policies and programs for urban areas. If we are able to intervene early, then we can nip this problem at its bud before it gets too pervasive. And another recommendation that we would like to make is to capture the consumption, the practice of consuming nutrient-poor packaged food by the periodic national surveys like Nepal Demographic and Health Survey and the Nepal Multiple Indicator Cluster Survey. This dimension of, in addition to the standard nutrition practices indicators, this dimension can no longer be ignored and has to be included in the periodic national surveys to understand the prevailing practices and its scale much better. Similarly, we would also like to recommend to have special disaggregation for IYCF and child malnutrition indicators by the national surveys in the most densely populated core urban areas, because combining with overall urban areas or even Kathmandu Valley, for instance, it may dilute and skew the actual situation in the core urban context. And at the same time, more studies should be, ours is just one study based on a hospital platform assessing children who were brought in for immunization purposes. Hence, we would like to recommend for further studies to be conducted in the core urban areas with larger sample size in various settings, including community-based settings, different study designs, etc. Thank you very much for your attention and for this opportunity to present our research. Namaste.
Thank you very much, Sophia ji, and for your very good presentations, and then enlightening us about, kind of double burden of nutrition, especially among the children. So on the one side, we are facing the challenges of undernutrition, and then at the same time, we are also experiencing kind of overweight and obesity among children. This is really a kind of increasing issue in the country, and also talking about kind of very poor breastfeeding practices and dietary practices, despite our all efforts to actually increase breastfeeding practices and improve dietary habit among children. So thank you so much, Sophia. So please stay on connected. We will take the questions on your paper at the end of the sessions. Now I would like to invite our next speaker, who is Barsha Tamrakar, from Institute of Medicine, Maharajganj Nursing Campus. So she will be talking us about effectiveness of food reflexology on post-operative pain among cesarean mother in tertiary level hospitals from Bagmati province. So Barsha, floor is yours.
नमस्ते सबैजनालाई आजको मेरो on post-operative pain among cesarean mothers in a tertiary level hospital, Bagmati province. And my name is Barsha Tamrakar, and my co-author are Kiran Bajachari and Sarmila Neupani, and we are affiliated to Cuban University Institute of Medicine, Maharajganj Nursing Campus, Maharajganj, Kathmandu, Nepal. So my background childbirth is one of the most excellent and memorable segment in woman's life. But along with childbirth, there are many other factors such as fear, pain, psychological changes, and anxiety about childbirth, which often prevents most women from enjoying this lifetime experience. And in this modern obstetric, there are many options for deliveries, and among them, cesarean section, an alternative option to vaginal delivery, is one of the most common surgeries that is performed nowadays. So after cesarean section, post-operative pain, which is expected post-operative outcome, is experienced by all the mothers. One of the major challenging issues for health professionals is the management of post-cesarean pain. Over the years, mankind has devised many methods to combat pain. Among them, pain relief methods can be divided into two main groups, pharmacological and non-pharmacological. But despite the use of various pain medications, prevalence of post-operative pain is still high. And effective pain control is best achieved through a combination of pharmaceutical and non-pharmaceutical therapies. So reflexology is a powerful healing practice based on the premises that our entire body is mirrored on the feet through a system of reflexes. Therefore, pain reduction through complementary, non-invasive, safe, and simple methods such as foot reflexology is one of the important tasks of all health personnel. So moving into my objective, so my general objective is to find out the effectiveness of foot reflexology on post-operative pain among cesarean mothers in a tertiary level hospital, Bagmati province. So as my specific objectives are to measure the pre-interventional level of post-operative pain among cesarean mothers in experimental and comparison group. Next specific objective is to differentiate between pain score in experimental and comparison group after foot reflexology. And the last one is to measure the difference of pre-test level of post-operative pain and selected demographic variables among experimental and comparison group. So my hypothesis was, for hypothesis, I have formulated three hypotheses. For hypothesis 1, there will be significant difference between the pain score in experimental group and in comparison group after foot reflexology. For my second hypothesis, there will be significant difference between the pre-intervention pain score and post-interventional pain score after foot reflexology in experimental group compared to comparison group. And my last hypothesis was there will be significant difference between pre-interventional level of post-operative pain and selected demographic variables among experimental and comparison group. Now moving on to research methodology. So I used quasi-experimental research design and for that I used non-randomized control group pre and post-test design. And my research setting was maternity ward and birthing center of Triveni University Teaching Hospital, Mazagan, Kathmandu. And my research population was all postnatal cesarean mothers who are shifted from post-operative ward to maternity ward or birthing center. And my sampling procedure was non-probability purpose of sampling. And for samples, the calculation of the sample size, I have used a standard formula based on the prevalence of study that was conducted in India. And the calculated sample size was 65 and the sample size was 66. And these 66 cesarean mothers are divided into two groups consisting of 33 cesarean mothers in each group. And for instrumentation, structure interview schedule was used, and it consists of two parts. Section A consists structure interview schedule for demographic variables, and section B consists visual analog numerical pain intensity scale to assess the level of pain measured in 4 different levels that are no pain, mild pain, moderate, and severe pain. So for foot reflexology was provided to experimental group on first and second post-operative day for 30 minutes along with other routine care. And pre-assessment of pain was taken just before intervention and post-assessment of pain soon after intervention. For I'm still in the intervention. So after informed consent, 66 participant mothers were recruited and were assigned 33 in experimental group and 33 in comparison group. And I had only 4 weeks for data collection, and so each week is divided for each group. Such as for first week, I only took samples from comparison group where 17 samples were taken, and activity was pre and post test activity was only done. And for second week, 18 samples from experimental group was taken, and activity was pre-test, intervention, and post-test. So as in third week, 16 samples from comparison group was taken, and pre-test and post-test was only done. And for the last week, 15 samples from experimental group was taken, and pre-test, intervention, and post-test was done to them. So for the results, table 1, so the respondents pre-interventional level of post-operative pain on day 1 and day 2. So we can say in this table that on day 1, mild pain was same in both experimental and comparison group, that is 6.1%, but moderate pain is 48.5% in experimental group, and in comparison group it was 57.6%, whereas severe pain was 45.5% in experimental group and 36.4% in comparison group. And similarly in day 2, mild pain was 33.3% in experimental group and 27.3% in comparison group. Moderate pain was 63.6% in experimental group and 72.7% in comparison group, and severe pain was only in experimental group, that is 3% of them experience severe pain, whereas no severe pain was perceived by comparison group. So this, in table 2, respondent post-interventional level of post-operative pain on day 1 and day 2. So in this figure also we can see that on day 1, mild pain was in experimental group, mild pain was 45.5%, and in comparison group 6.1% perceive mild pain. And moderate pain was 51.5% in experimental group, and so as 69.7% in comparison group, and severe pain was experienced by 3% from experimental group, and no any severe pain was experienced by comparison group. But on day 2, no pain was experienced no pain was experienced by 6.1% from experimental group, and no pain was experienced by comparison group. So mild pain was 87.9% from experimental group, and from comparison group it was 57.6%. For moderate pain, 6.1% from experimental group and 39.1% from comparison. And lastly, severe pain was not experienced by experimental group, whereas 3% of them, 3% of comparison group experienced severe pain. And for table 3, comparison of pain score before and after intervention in both group on day 1. As we can see that pre-interventional mean score from experimental group was 6.18, whereas in comparison group pre-interventional pain score was 6.03, whereas in post-interventional, and the p-value was 0.683. So as in post-interventional, experimental group mean score was 3.85, and comparison group mean score was 5.33, and the value is 0.00, which is less than significant level, 0.05. And table 4 shows comparison of pain score before and after intervention in both group on day 2. And in this table also we can see that mean score of experimental group pre-interventional level was 3.97, and comparison group mean score was 4.09, and p-value is 0.665, whereas post-interventional mean score of experimental group was 1.91, and comparison group post-interventional mean score was 3.39. So p-value is 0.00, and which is again less than significance level of 0.05. And these both table 3 and table 4 accepted my first hypothesis, that is significant difference between the pain score in experimental and comparison group after food reflexology. So for table 5, there is a difference between the pre-assessment and post-assessment pain score on both day and day 2. And so in this table also we can see that experimental day 1 and day 2 pre-assessment of pain from experimental group is mean score was 5.08, whereas comparison group is 5.06, and the p-value is 0.026. And on day 2, post-assessment experimental mean group was 2.88, and comparison group has 4.36. So p-value was 0.00. So in this table also, by this table also we can say that my second hypothesis, which is significant difference between pre-intervention pain score and post-intervention pain score after food reflexology in experimental and comparison group, was accepted. So from this table, we can see the demographic variables of selected demographic variables in experimental group. And in this table, we can only see that gravity of the mother only have p-value of 0.030, which is done by the Annovatis and independent t-test. And so here also the p-value of the gravity of mother is less than significance value 0.05. So we can, but in comparison group, there was no any p-value that denotes less than 0.05 significance level. So
Hello. Hello.
सर हामीलाई इच प्रेजेन्टरलाई 10 मिनट्स मात्रै टाइम हुन्छ द्याट्स वाइ वी कट द हिज प्रेजेन्टेसन सो ओभर टु यु सर
Okay. Okay. Thank you, Barsaji. I'm sorry we have to cut your presentations because the time is automatic. Or I'm sorry, it's not me who cut your time. So anyway, we got your main message because we have the quasi-experimental design, and then you tested the pen before providing the kind of food reflexology, and then you are comparing to experimental and control group, is there any effect on pain management? And we know that from your conclusion that the experimental group has better pain management compared to a comparison group. Okay, thank you, Barshaji. Now, because of the time, I'm going to invite our next speaker, Ms. Vidya Basnet, who is from Viratnagar Nursing Campus. So the title of her paper is Experience of Maternity Care Providers During the COVID-19 Pandemic in Public Hospitals, Viratnagar, a qualitative study. So we have heard from women's perspective. Now this paper will talk about the provider's perspective. Vidyaji, over to you.
Namaste सबैजनामा I am Vidya Basnet. I am presenting here my research entitled Experience of Maternity Service Providers During the COVID-19 Pandemic in a Public Hospital, Viratnagar, a qualitative study. So we 7 were involved in a team, and I as a principal investigator. Now going on to the background and objective of my study is the world battles COVID-19. Women continue to get pregnant and babies are still born. Thus, the maternity service provider must continue caring for and supporting women. Globally, during COVID pandemic, 81% of maternity service provider experience an increased level of stress. Previous studies have also shown that the care providers' personal, professional life and their mental health have been severely affected during the pandemic. This study aims to explore the motivational factors and challenges faced by the maternity service providers during the COVID-19 pandemic. Now going on to the methodology part has been prepared by using consolidated criteria for reporting the qualitative research. So regarding ethics and consent to participate, the ethical clearance was taken from Institutional Review Committee IRC of Tribhuvan University Institute of Medicine. The purpose of study was clearly explained to the participants. Written and verbal consent was taken prior to audio recording as well as prior to in-depth interview, and participation in the study was voluntary and they were given the choice to withdraw from the study at any time. Confidentiality was maintained throughout the study. Now regarding research team and reflexivity, we were 7 in a team, and among 7, 6 were female and 1 was a male researcher, and all are trained in qualitative research. Regarding study design, we choose a phenomenological study design, and the eligibility criteria for our study was maternity service providers who were working as a frontliner, and we choose the participants through a proposed sampling. Sample size was determined by the data saturation. In-depth interview was conducted among 7 floor nurse and 3 nursing in charges. Now regarding study setting, the study was conducted in Kosi Hospital, Viratnagar. It's the largest city of Province 1 and located in the Tarai belt, and it's a main referral center for maternity service and has a capacity of 100 bed. Regarding data collection, data was collected using a semi-structured interview guide. Semi-structured interview guide guide was prepared on the basis of previous relevant literature, research questions, and informally interviewing 4 maternity service providers of similar setting. And the interview guide was reviewed by the research team. An in-depth interview was conducted using a local language in their own setting. The duration of in-depth interview lasts for 4 to 45 minutes in first session and 10 to 20 minutes in second session. Saturation was reached when any new information was obtained. Now, regarding data analysis, Clark and Brown 2006 technique was used. According to this technique, first of all the findings of the study was transcribed, and the researcher revisited the transcribed document several times, and the significant narration were derived, and from those narration, quotes, soft themes and themes were generated. Now, regarding result of the study, in part 1, socio-demographic information was obtained, and majority of varying the age group of 25 to 34, and majority has the year of experience of 10 to 14 years. All were female, and 4 had done masters in nursing, and 7 out of 10, 7 have dependent family members, and 4 were COVID positive during their duty time. And findings of the study of second part, that is in-depth interview, we generated 6 themes and 19 soft themes. The first theme was a fear of COVID-19 at work, and soft themes: cause of fear, manifestation of fear, coping with fear. Second was challenges at work, and soft themes were managing, visiting, crowding in hospital, staffing issue at work, issue with personal protective measures, training and guideline. And third was changes at work and services, and soft theme were change in work infrastructure, change in procedure and newer protocols. Factors influencing motivation to work, and soft theme was enablers and impediments, and other was stigma due to COVID, and family, neighbors and institution was soft theme. Impact of COVID at work was other last theme, and soft theme were decreased service utilization, patient flow, decreased outpatient, increased emergency patient, and perceived quality of care. So I have tried to narrate some of the important narration of my study. Like regarding fear of COVID-19 at work, participants says that I had a panic attack once while returning home after duty. I doubted as if disease got transmitted to me. I then started feeling difficulty in breathing, a dry cough, feverish feeling in the forehead. It was all about I panicked a lot. Similarly, regarding challenges at work, participants mentioned that we did not encounter any problem in the first positive case, but during the second case, we had a problem. In the evening shift, we have only one sister for a duty. So when she was doing her work, second case, along with the visitor ran away. We had called for an ambulance, but before the ambulance arrived, they ran away. They were scared of going to COVID hospital. This case could not be traced later on. And similarly, on theme change at work and services, participant mentioned that we made many changes in our practice. We reduced bed to 2 from 3 and maintaining a distance of 1.5 in the admission room of the maternity ward. Previously, we did not use Doppler, but nowadays we use Doppler for taking a fetal heart sound. We have designed a new maternity card for assessing our patient. Similarly, regarding factor influencing motivation to work, participants mentioned, I feel like resigning from my job as I had a 2-year-old baby. Family members were also forcing me to quit the job. I registered and they told me to leave the house, and I lived separately. Now, regarding stigma due to COVID-19, participants mentioned that I had many problems. A big tree fell down and hit above my room ceiling with so much difficulty, and so let the tree cutter came for its solution. And then again, pipeline of the tap was cut down in the sequence. I asked for help from neighbors. With such pleading effort, I phoned management for help and sought from administration. Finally bought a new pipe. Till this difficult time, no neighbors from quarters supported me. I did not even bath for 3 days due to this problem. Even the shopkeepers denied bringing water to my place. She mentioned by sewing. And other impact of COVID-19 at work, participant mentioned that I am observing that there is an increase in intrauterine fetal death, premature delivery, low birth weight ranging from 2 to 2.5. And anemic mother. Low birth weight may be due to lack of nutritious diet. Many lost their job during the lockdown. Previously, we used to counsel on PPIOCD very effectively, but nowadays it has been reduced because there is a fear of transmission in direct communication, and we have insufficient human resources too. Now, deriving the conclusion of my study, this study concludes that health workers are valuable assets to any country. In an overwhelming situation, the motivation of health worker is only the hope for ensuring quality service. The health worker positive as well as negative experiences during a pandemic is influenced by various factors. During the future pandemic, these factors are to be considered in order to deliver the best services in overwhelming situations. Moreover, the need and demand of maternity service should not be generalized with other services. Otherwise, there will be a significant impact on the health of the mothers and the newborns. So I would like to acknowledge all these persons and place who helped me to conduct my study. And these are my references. And thank you so much.
Thank you very much, Vidyaji, keeping your time in the presentations and also highlighting kind of the issues or the service providers are facing in the context of COVID-19, how challenges they are facing in these days to provide the services and managing their daily life. Thank you so much for your presentation. Now I would like to move to the next presentation. Our next presenter is Mamta Kesi, again from Maharajganj Nursing Campus, Institute of Medicine. So the title of her paper is Knowledge and Practice Regarding Antenatal Care Among Pregnant Women Attending in a Government Hospital, Biratnagar. So may I invite Mamta Kesi for your presentation? Mamta.
नमस्कार सबैजनालाई मेरो नाम ममता केसी र मेरो रिसर्चको टाइटल भनेको नलेज एन्ड प्र्याक्टिस रिगार्डिङ एन्टिनेटल केयर एमङ प्रेग्नेन्ट वुमेन एटेन्डिङ इन अ गभर्नमेन्ट हस्पिटल विराटनगर सो मुभिङ टुवर्ड्स द ब्याकग्राउन्ड एन्टिनेटल केयर भनेको चाहिँ कुनै पनि केयर हो जुन चाहिँ हेल्थ केयर प्रोफेसनलहरूले चाहिँ प्रेग्नेन्ट वुमेनलाई चाहिँ दिइरहेको हुन्छ इन अर्डर टु इन्स्योर द बेस्ट हेल्थ कन्डिसन फर द मदर एन्ड द बेबी ड्युरिङ द टाइम अफ द प्रेग्नेन्सी सो इट इज वान अफ द बेसिक कम्पोनेन्ट अफ म्याटर्नल केयर अन विच द मोस्ट अफ द लाइफ अफ द मदर्स एन्ड द बेबी इज डिपेन्ड सो जति पनि ड्युरिङ द एएनसी पिरियडमा चाहिँ वुमेन पोजिटिभ एक्सपिरियन्सहरू चाहिँ गेन भएको हुन्छ त्यसले गर्दाखेरि चाहिँ एउटा फाउन्डेसन्स चाहिँ डेभलप भएको हुन्छ फर द हेल्दी मदरहरूको लागि चाहिँ सो इट इज वान अफ द एसेन्सियल एन्ड द मोस्ट की स्ट्राटेजी टु डिक्रिज म्याटर्नल मोर्टालिटी रेट इन केस अफ द लो रिसोर्स सेटिङ एक्जाम्पल जस्तै नेपालको कुरा गर्दाखेरि है अब त्यसै गरी हेल्थ नलेजको कुरा गर्नुपर्दा इट इज वान अफ द मोस्ट भाइटल फ्याक्टर्स टु इनेबल द वुमेन टु बी अवेर अफ देयर हेल्थ स्ट्याटस एन्ड टु नो रिगार्डिङ द इम्पोर्टेन्स अफ द एप्रोप्रिएट एन्टिनेटल केयर सो जति पनि इभिडेन्सहरू चाहिँ देखिरहेको छ त्यसमा चाहिँ एडुकेट एन्टिनेटल नलेज भयो भने केयर भयो भने ड्युरिङ द टाइम अफ द प्रेग्नेन्सी द्याट विल हेल्प्स टु इम्प्रुभ द म्याटर्नल मोर्टालिटी एन्ड द मोर्बिडिटी एज के हुन्छ द एन्टिनेटल केयर्स इट विल प्रोभाइड डिफ्रेन्ट काइन्ड्स अफ द अपर्च्युनिटी जस्तै कुन इम्युनाइजेसन्स रुटिन आइरन फोलिक एसिड सप्लिमेन्टेसन भिटामिन ए कन्जप्सन है टिटनट इम्युनाइजेसन डिफ्रेन्ट एन्टिनेटल केयर अपर्च्युनिटीहरू चाहिँ प्रोभाइड गर्छ जुन चाहिँ द्याट इज भेरी मच बेनिफिसियस टु मदर एन्ड द चाइल्ड हेल्थ सो इट इज भेरी मच इम्पोर्टेन्ट टु बी aware and the antenatal healthcare practices among the pregnant women, which will help to reduce the maternal mortality as well as the morbidity. So objectives, my general objectives, मेरो study को भन्नु पर्दाखेरि it was to find out the knowledge and the practice regarding antenatal care among pregnant women attending in a government hospital, Biratnagar. The specific objectives मा to assess the level of knowledge regarding antenatal care, to identify the level of practice regarding antenatal care, and to measure the association between level of knowledge and practice regarding antenatal care. And the last one is to measure the association between level of knowledge and practice regarding antenatal care with selected socio-demographic variables. Methodology मा चाहिँ research design भनेको चाहिँ descriptive cross sectional research design was used in my study. र setting भनेको चाहिँ the study was conducted in the antenatal outpatient department of Kosi General Hospital, Biratnagar. र research population मा चाहिँ primary pregnant women of third trimester was included. र sample technique भनेको चाहिँ non probability proportive sampling technique was used. र sample size भनेको चाहिँ 190 sample size was used for the study. र result of my study को कुरा गर्नु पर्दाखेरि चाहिँ in the respondent level of knowledge regarding antenatal care, most of the responded, that is 85.8% had the adequate knowledge. And in the table 2, respondent level of the practice on the antenatal care, there was also the most of the respondent, that is 85.3 had the adequate practice on the antenatal care. So associations between the level of knowledge and with the selected socio-demographical regarding antenatal care. In this, regarding the level of knowledge and the practice regarding antenatal care, there was a statistically significant association between level of knowledge and the practice with the p-value 0.001. In the table 4, there is association between level of knowledge and with the selected socio-demographic variables. There was also the statistically significant association between the level of the knowledge with the selected socio-demographical variable, which includes place of residence with the p-value 0.048 and with the religion with the p-value 0.041 and in the educational status of the husband, that is 0.144. So in table 5, the associations between the level of the practice and with the selected socio-demographic variables, there was a statistically significant association between the level of the practice and educational status of the woman with the p-value less than 0.001 and in the educational status of the husband, that includes with the p-value 0.003. So this was the result, and now coming towards the conclusion. Based on the study finding, it is concluded that most of the pregnant women had the adequate level of the knowledge and practice regarding the antenatal care, and also there was statistically significant association between level of knowledge and the practice, and also their level of the knowledge had the significant associations with the place of residence, religious group, educational status, and socioeconomic status. Similarly, there were no any statistical significance between level of the practice and selected demographic variable, except only two, that was educational status of women and educational status of husband. So thank you.
Thank you very much, Mamataji, for your presentation, and then very important topic on antenatal care, seeking behavior, and reconfirming the relations between the knowledge about ANC and then practice. We don't find always a kind of positive relationship between knowledge and practice, but it's good that you found very good positive relationship between knowledge and behavior when it comes to antenatal care. Thank you so much, Mamtaji. Please stay online for question and answer session. Now I would like to invite our next speaker, who is Pasang Tamang from University of Huddersfield in UK. So Pasang is going to talk about women's perspective on maternal and neonatal health services in Jumla. So we're moving from Biratnagar to Jumla. May I invite Pasang for your presentation, please?
Namaste, I'm Pasang Tamang. Today I'm going to share a part of my PhD findings about women's perspective on maternal and neonatal health services in Nepal. In this presentation, I will briefly touch on the background of the study and the objective, followed by the methodology, results, and conclusion section. Every day, more than 800 women die due to the pregnancy and childbirth-related complications. Most of these deaths occurred in low and middle income countries with low resource settings. In Nepal, about 1,200 women died every year, which is about 3 women per day. And 2.5 million children die in the first month of their life in 2017 globally. In Nepal, 23,000 children died before reaching the 5th birthday, and more than 50% of these deaths are within the first month of their life. Nearly 1 million newborn deaths and 50% of maternal deaths could be prevented with high quality coverage of care during pregnancy, at the time of the birth, and after the delivery. Maternal and neonatal health is a national priority health program for Nepal. Women's perception and experience of care has a direct impact on maternal and neonatal health services. For challenges that limit access to quality maternal health services must be recognized and addressed at all levels of the health system. Hence, this study explored women's perspective on maternal and neonatal health services. A descriptive cross-sectional study was conducted in Jumla in late 2019. Semi-structured interviews were conducted with pregnant women and mothers of under 2 years of children's age. Total 15 interviews were conducted using purposive sampling. Thematic analysis was done using the in vivo software. The two main themes that emerged out of the analysis were experience of care and expected quality of care. There were some of the common themes that emerged from these two themes. They were communication and information, health workers' behavior, and choice of companionship. Other sub-themes that emerged in experience of care were emergency birth preparedness, waiting time, and referrals. And the other sub-theme that emerged in expected quality of care were healthy outcome of mother and baby, emotional support, accessible health services, upgraded health facilities. Waiting time. Waiting time varied depending on the day of the visit as well as the time. For example, if it was an immunization day or antenatal checkup day, then the waiting time were higher compared to the normal days. But if it was a normal day, then the woman had to wait for 5 to 10 minutes, depending on what time she arrived at the health facilities. Most of the women in their third trimester of pregnancy, were also given counseling on emergency birth preparedness. Here is a quote from one of the respondents, which was her second pregnancy. She said, "I was told to have my blood group checked and prepare 2 to 3 persons who have similar blood group. It will be easier to contact them in case of emergency. Sister, referring to the nursing staff, also gave me contact details of an ambulance. I have also stored rice and wheat in stock," and she laughs. The information given to the woman by the health worker were very clear to them, and women were also given enough time to ask their questions if they had any. Most of the information they received were based on for the health of a mother and the health of a baby. For mother particularly, the information were based on personal hygiene and safety, counseling on nutrition, family planning and birth spacing, and when to seek the health care or follow-up visits. And the information for the baby were mainly on how to keep baby warm and safe, breastfeeding techniques and importance of breastfeeding, and the immunization doses for the children. Women were not allowed to have any companion during the labor. However, most of the women were allowed to have some form of companion after the delivery of the baby. Whereas during the labor and at the time of the delivery, their companion, their people, whoever had visited with them, were allowed to stay in the waiting room outside the maternity ward. When further exploring about women's preference of having anyone with them, most of the women preferred having either their mother, sister, or mother-in-law during labor and after delivery for comfort and emotional support, because they felt that they understand them and they gave them encouragement during that period. However, none of them preferred having anyone during the delivery. Husbands were not a choice of companion for women, either during the labor or after the childbirth, or even during the childbirth. Health workers' behavior. In terms of health workers' behavior, we had a mixed feeling of a woman experience, because some women were very, very happy about the health services that they received, whereas some of them faced impolite behavior of health worker, particularly during the labor period. So here's a quote from one of the woman who was not happy about the health workers' behavior during her labor time. So she says, "We are going through so much ourselves during the labor and we get emotionally down. So at such period, it would be nice to hear some polite words from health worker rather than their anger. Now I don't have to face that phase again, but it will be nice for future mothers." So this was one of the mother who experienced impolite behavior from health worker, and she thinks that it would be nice to have a polite behavior, especially during that period for the future mothers. In contrast to that, there is another health worker who was very happy about the services that they received from their health services, and say that they would definitely recommend their friends and families to use the local health facility, because she trusts in that health facility services received from her local health facility, as well as she is happy about the health worker behavior. Another thing was accessible health services. Most of the participants, especially the women, most of the participants, they thought that it would be really nice to have accessible health service in their local community. So one of the women was sharing her experience about being referred to the higher facility center. She says, in such time, referring to her current pregnancy, it would have been much easier if we can have all the necessary services here in our health posts, such as video x-ray, referring to the ultrasound, and blood tests. Sometimes it is very difficult to travel as I get nauseated often. It is also difficult to go to the hospital alone for someone like me who is not educated. They say to go in this room, that room, like that for the test, and it's really confusing for me. So the woman really got confused when they were referred to, other than their local facility, when they were referred to the higher facility, they were confused and they preferred having all those services in their local health facilities. In conclusion, the overall experience of care received by women were satisfactory, with few women experiencing impolite behavior by health workers. Respectful maternity care can provide women with positive experience of maternal and neonatal health services. Accessible maternal and neonatal health service can have impact on quality of care. So these are some of the references that I used for my presentation, and that's the end of my presentation. Thank you for listening to me, and if there are any questions, I'm happy to discuss on it. Thank you.
Thank you very much, Pasangji, for your presentations. And then I recall my experience of conducting qualitative research study on maternal health care utilizations during a national maternal mortality and morbidity study in 2008-9 in Jumla districts. It seems that not much changes has been actually observed in Jumla, when I listened to your presentation. Thank you so much for bringing the women's perspective on healthcare utilization, especially for maternal health. And good luck for your PhD as well. So now I would like to move to our last but not the least presentation. The presentations will be from Bharat Kafle. And Bharat is going to talk about the prevalence of mistreatment among elderly by their family members and its associated factors in Gandaki province. It's about geriatric health, which is the only paper we have in this conference. So Bharatji, it's over to you, please.
Namaskar सबैजनालाई मेरो नाम भरत काफले I am going to begin my research topic on prevalence of mistreatment among elderly by their family members and its associated factor in Gandaki province. This is the outline of today's presentation. Elderly mistreatment is a serious public health issue which hamper the various aspects of the health and life of elderly. This is a elderly mistreatment definition. The general objective was to assess mistreatment among elderly by their family members and its associated factor in Gandaki province. And specific objectives were to assess the mistreatment among elderly by their family members in Gandaki province and to identify the factors associated with elderly mistreatment. This study method was quantitative in nature. Study design was a community-based descriptive cross-sectional study. Study population 60 years and above. Sampling unit was household. Duration of the study from November 2019 to May 2020. This is a study area map. Justification for the selection of the study area in Gandaki province, elderly population increasing day by day in terms of absolute number and proportion. Out of top 10 districts with a higher number of elderly population of Nepal, 6 of them lies in a Gandaki province. As compared to other provinces of Nepal, Gandaki has a low fertility rate, high life expectancy rate, a higher elderly dependency ratio. Multi-stage stratified cluster sampling was applied for the sampling method. Sampling method depicted in the diagram. This slide shows the figure of the sampling method of the study. Total 616 sample was study sample size. With the help of the strata, the one proportion method of prevalence used for the calculation of the sample size. A semi-structured questionnaire tool used for the data collection, and face-to-face interview techniques used for data collection. Data management and statistical analysis. Data were collected, checked, edited, and coded, and entered in the EP data. Analyzed Analysis on IBM spaces importance. Univariate analysis was done by computing percentage, mean, and standard deviation. Chi-square test assessment of the elderly mistreatment. Logistic research regression was used to find likelihood ratio of elderly mistreatment. One sample test used to find probability estimates of elderly mistreatment and confidence interval. Guest elderly reported mistreatment by stranger and neighbors are excluded in this study. Only one elder from the selected households, verbal and hearing problems with elderly use their proxy are well inclusion criteria. Validity was maintained during the study. Reliability was calculated with the help of Cronbach alpha, which was more than 0.6 in general. Ethical consideration was maintained during the study. Ethical approval was obtained from the IRB of IOM, approval from the Gandaki province. Safety consideration was maintained during the study. Obtaining the consent, beneficiaries do not harm, respect for anonymity and confidentiality, respect for privacy. The limitations of the study. Sensitive issues which leads to underreported. Qualitative perspective was not included, only triangulated by observation which might not capture all the issues. Results. Geographical distribution of the respondent. Majority of the participants from the Nepal districts and Kalika-wise distributions. Majority of participants from the urban municipality. Socio-demographic and economic characteristics. Majority of the participants were females. Mean age of participants was 70 years and standard deviation 8.3 years. A majority of the elderly participants were illiterate and they were for the Hindu religion. Most of the participants living arrangement with their son and daughter-in-law. Most of them were dependents with their family members. Health service utilization related characteristics of the respondent. A majority of the elderly perceive that their health condition is neutral, neither good nor bad. That under regular medications, most of the elderly were under regular medication. Majority of the participants, 73% were utilized the healthcare services. 80% of the elderly were suffered from any form of the disease, and 35% elderly have a comorbidity status. This slide shows the estimation of the probability of elderly mistreatment prevalence. Estimation of probability prevalence of the various forms like the any mistreatment, prevalence of the physical mistreatment, prevalence of the psychological mistreatment, prevalence of the caregiver neglects, prevalence of financial mistreatment, and prevalence of sexual mistreatment. Factor association with the elderly mistreatment by family members. This slide shows the factor association with the any elderly mistreatments by family members with the help of the chi-square. Various variables shows in the association with the chi-squares that were local government, sex, education, land ownership, exercise, belief in traditional healer, under medication, health service utilization, financial capacity, prevalence of geriatric depressions, morbidity of disease, suffer disease, upright revealing the problems, participating the social work, participate in any programs, test behavior, history of violence in family, decision toward the treatment were factor associated which were further plotted in the multiple regression model. Multiple logistic regression of the various factors on the elderly mistreatments by their family members. This slide shows the prevalence of the elderly mistreatment by their family members or ratio adjusted. After odd ratio adjusted, residential locality, gender, education, belief in traditional healer, participated in any type of social work from childhood, faced any misbehavior, disease status. These variables have a higher risk or a higher chance of the getting the elderly mistreatments. By after the adjusted of the odd ratio, these variables are significantly associated with the elderly mistreatment. Further, multiple logistic regression of the various factors on subtype of elderly mistreatment by family members also shown in these slides. This slide shows the various subtypes of the elderly mistreatments or ratio adjusted with the gender, educational status, belief on traditional healer, health service utilization, financial capacity to pay for health care, prevalence of geriatric depression, Similarly, household decision maker, operator of the revealing health programs, participate in any type of the social work, participate in program, face misbehavior from the childhood, history of violence. These variables also attributed the various subtypes of the elderly mistreatment. Finally, conclusion. Study found that 5 in 10 elderly were mistreated by their family members. Most common form of elderly mistreatment was caregiver neglect and followed by psychological, physical, financial, and sexual mistreatment. Study found most common risk factor for the elderly mistreatment were female elderly, urban elderly, the illiterate elderly, disability status of elderly, belief in traditional healers, disease status, history of violence in a household. They face a higher chance of the getting the elderly mistreatment. Similarly, study found that participated in any type of social work, participate community engagement programs, improve educational status, good health status of the elderly, having the provision of the health financing were seen as a protective factor of the elderly mistreatment. This slide shows the references. This is also references. Thank you. Namaskar.
Thank you very much, Bharatji, for your presentations. You is one of the very neglected topics. So thank you so much for bringing this issue in this important national conference, because there is, except one, there is no any kind of national study conducted among elderly people, and this is a very emerging issue in the country, and then very rarely research and discuss topics. So thank you so much for bringing this issue in this conference. So this is, we have now all the 6 presentations for the sessions, and now I would like to move for the kind of discussion session. So for the discussion and question answer, there are a couple of questions. It's very good that even in the morning we have like 145 people attending this session, which is great. So there are few questions in the chat box. So I'm going to read some of the questions and request the presenter to respond. The first question is from Sanjita Subedi. I think this question is for Barsha. Barsha has actually received 2 questions, one from Sanjita and another from Durga Misra. The question from Sanjita is, how did you provide food reflexology in intervention? The questions for Barsha. The second questions for you is the policy implications of your study. I know that the technology has caught your presentation. You didn't have a time to present your conclusion and the recommendations. So Durga wanted to know what is the implications of your study. Sanjita, would you like to respond? Sorry, Barsha.
Thank you, sir. Good morning, sir, and good morning, ma'am.
Your intervention. How do you provide intervention? And second is the implication of your study.
All for your queries. I'm a bit confused about the first question. Whether the
how did you provide कसरी त्यो intervention कसरी दिनुभएको थियो? How did you provide the reflection?
त्यो इन्टरभेन्सनको बारेमा डिटेलली बुझ्न खोज्नु भएको हो कि कस्तो छ?
कसरी दिनुभएको थियो भन्नुभयो होला उहाँले, फुड रिफ्लेक्सोलोजी कसरी दिनुभएको थियो भनेर क्विकली दि आन्सर मात्रै गर्नुस् न.
ओके, त्यो फुड रिफ्लेक्सोलोजी भनेको एउटा छुट्टै नै कम्प्लिमेन्टरी मेडिसिनमा पर्छ सर, हैन? अनि त्यसले गर्दाखेरि मैले यसको लागि चाहिँ छुट्टै 2 विक्सको ट्रेनिङ लिएको थिएँ. अनि त्यो ट्रेनिङबाट चाहिँ मैले त्यो ट्रेनिङबाट जे कुराहरू सिकेको थिएँ त्यही कुरालाई मैले इम्प्लिमेन्ट गरेको थिएँ. अनि त्यो मैले इन्टरभेन्सन गर्दाखेरि चाहिँ अघि पनि मैले एक्सप्लेन गरेको थिएँ. मैले पहिला प्री एसेसमेन्ट गरेँ, देन आफ्टर प्री एसेसमेन्ट मैले फुड रिफ्लेक्सोलोजी प्रोभाइड गरेको थिएँ. फुड रिफ्लेक्सोलोजी चाहिँ 2टै फिटमा प्रोभाइड गरेको थिएँ. फर इच फिटको लागि चाहिँ 15 मिनट्सलाई फुड रिफ्लेक्सोलोजी प्रोभाइड गरेको थिएँ. सो 30 मिनट्स, टोटलमा 30 मिनट्सको फुड रिफ्लेक्सोलोजी प्रोभाइड गरेँ. र अनि फुड रिफ्लेक्सोलोजी सकिने बित्तिकै नै मैले भिजुअल एनालग पेन स्केल मेजर गरेर उहाँको पेन मेजर चाहिँ कति भयो भनेर त्यसरी मेजर गरेको थिएँ सर, इन्टरभेन्सनको कुरा गर्दाखेरि. सो अनि दुर्गा म्यामको क्वेसन अनुसार what is the policy implication of your study भन्दाखेरि obviously अब यो चाहिँ मैले स्मल स्केलमा मात्रै गरेको स्टडी थियो यो, एकदम सर्ट टाइममा मात्रै स्टडी थियो यो। सो यस्तो खाले स्टडिजहरू जुन यो कम्प्लिमेन्टरी नन फार्माकोलोजिकल मेजर्सहरू जुन छ यो चाहिँ अलि एक्सटेन्सिभ वेमा र अनि अलि अरू स्याम्पल साइजहरूमा पनि गर्न पायो भने मात्रै हामीले चाहिँ यसलाई यो उसमा पोलिसीमा लान सकिन्छ होला। तर पनि अब मैले मेरो स्टडीको कन्क्लुजन अनुसार चाहिँ के देखेको थियो भन्दाखेरि फार्माकोलोजिकल भन्दा नन फार्माकोलोजिकल सँगसँगै हामीले यदि नन फार्माकोलोजिकल मेथड्सहरू पनि युज गर्न सक्यो भने चाहिँ त्यसले धेरै हदसम्म जुन म्याटर्नल एन्ड चाइल्ड बन्डिङलाई इन्हान्स गर्नुपर्ने छ त्यो चाहिँ गरेको देखेको थिएँ, किनभने पेन चाहिँ धेरै नै कम भएको देखेको थियो। र अनि त्यो कारणले गर्दाखेरि चाहिँ अब मैले अब पोस्ट सिजरियन मदरहरूलाई मात्रै गरेँ, यो अरू अरू मदर्सहरू या चाहिँ अरू पेसेन्ट्सहरूलाई पनि गर्न सकिन्छ वा कम्प्लेनिङ अफ अदर काइन्ड अफ पेन। सो त्यो गरेपछि मात्रै हामीले चाहिँ यसलाई अरू एक्सटेन्सिभ वेमा गरेपछि मात्रै बल्ल हामीले चाहिँ त्यसलाई पोलिसी लेभलमा लान सकिन्छ होला। सर म्याम अहिले स्मल स्केलमा गरेको भएर चाहिँ अहिले नै पोलिसीमा लगिहाल्न चाहिँ अलि इम्पोसिबल नै हुन्छ होला म्याम।
थ्याङ्क यू वर्षाजी। अब म चाहिँ नेक्स्ट क्वेसन हाम्रो भरतजीलाई एउटा सजेसन्स र एउटा क्वेसन छ भरतजीलाई। सजेसन्स चाहिँ हाम्रो दिपेन्द्र थापाजीबाट आएको छ, सायद तपाईँले हेरिसक्नुभयो होला। अब एलआरडी भन्ने शब्द चाहिँ इज अ स्टेरियोटाइप भयो नाउअडेज र बेटर टु युज ओल्डर एडल्ट्स एन्ड ओल्डर पिपुल भन्ने उहाँको सजेसन आएको छ। आई डोन्ट थिङ्क यु हेभ टु रिप्लाई फर दिस अनलेस यु वान्ट टु डिसएग्री विथ द्याट टर्मिनोलोजी। अर्को क्वेसन चाहिँ हाम्रो दुर्गा मिश्रजीको भरतजीलाई नै छ, वाट इज द फ्युचर रिकमेन्डेसन भनेर। बिकज अफ द टाइम वी डोन्ट ह्याभ अ टाइम टु डिस्कस इन डिटेल्स अबाउट द योर रिकमेन्डेसन, बट इफ यु हेभ वन अर टू क्विक रिकमेन्डेसन्स प्लिज फिल फ्री टु सेयर। भरतजी तपाईँको वन अर टू रिकमेन्डेसन मेजर रिकमेन्डेसन्स छ भने हाम्रो दुर्गाजीले सोध्नु भएको छ।
थ्याङ्क यू, नमस्कार म्याम, and thank you for question. मेजर रिकमेन्डेसन भनेको दुईटा पोइन्टमा भन्नुपर्दाखेरि यो प्रोभिन्स वाइज भएको भएर चाहिँ अब एउटा नेसनल लेभलको चाहिँ यसलाई सर्वे हुनुपर्छ भन्ने मेरो चाहिँ एउटा रिकमेन्डेसन छ। र दोस्रो भनेको चाहिँ अब 2020 देखि 30 सम्म डब्ल्युएचओले हेल्दी एजिङ डिकेड मनाउने भनेको हुनाले हेल्दी एजिङको लागि यो मिसट्रिटमेन्ट भनेको मल्टिडिसिप्लिनरी एउटा इस्युज भएको हुनाले यसले पब्लिक हेल्थ जस्टिसदेखि लिएर धेरै कुराहरू सोसियोलोजिकल एस्पेक्टहरूलाई चाहिँ यसले कभर गर्छ। सो द्याट हेल्दी एजिङ डिकेड मनाउनको लागि यो इस्यु एकदमै चाहिँ अहिले ज्वलन्त रूपमा चाहिँ अगाडि बढाउनु पर्ने जस्तो मलाई लाग्छ। र अर्को कुरा चाहिँ मिसबिहेभियर फ्यामिलीले गर्दाखेरि भन्ने कुरा चाहिँ एउटा चाहिँ प्रिभ्यालेन्स स्टडी देखिसकेपछि अब फर्दर यहाँ चाहिँ रिस्क फ्याक्टरको पनि कुरा गरिएको छ र प्रोटेक्टिभ फ्याक्टरको पनि कुरा गरिएको छ। सो अब के बिहेभियरहरूलाई चाहिँ अब प्रोटेक्टिभ फ्याक्टरहरूलाई चाहिँ अझ फर्दर सर्वे गरेर कस्तो इन्सेन्टिभ के बिहेभियर अब भनौँ न रिवार्ड र पनिसमेन्टका चाहिँ कुराहरू आउन सक्छन्, हो त्यस्ता किसिमका बिहेभियरहरूलाई फर्दर स्टडी गरेर त्यसलाई हामीले अब पोलिसी लेभलमा चाहिँ इम्प्लिकेसन गर्नुपर्छ भन्ने चाहिँ मैले चाहिँ रिकमेन्ड दिन चाहेँ। र अनि हाम्रो चाहिँ अर्को सरले जुन सेरोटाइपको कुरा गर्नुभएको थियो त्यो मैले फर्दर स्टडी गर्दै जाँदाखेरि अब यो युज गरेँ। अब आर्टिकलको अवस्थामा चाहिँ त्यो हजुरको चाहिँ सजेसनलाई चाहिँ मैले इन्कर्पोरेट गर्नेछु। थ्याङ्क यू
भरतजी, थ्याङ्क यू सो मच। तपाईँको लागि थुप्रै प्रश्नहरू छ र बिकज अफ द टाइम मैले सबै प्रश्नहरू लिन सकिनँ। आई थिङ्क भरतजीलाई चाहिँ कसैले भरतजीले डाइरेक्टली एन्सर गर्न सक्नुभयो भने राम्रो नै होला पछि, अदरवाइज यु क्यान कन्ट्याक्ट हिम लेटर अन आफ्टर दिस मिटिङ। तर आई वुड लाइक टु टेक वान क्वेसन फ्रम हाम्रो डाक्टर प्रोफेसर सानु दली। उहाँले चाहिँ क्विक क्वेसन सोध्नु भएको छ, डिड यु हेभ एनी डिफिकल्टी यु फेस्ड व्हाइल इन्टरभ्युइङ एल्डरली पिपल भन्नुभएको छ होइन, त्यो स्पेसली इन प्रेजेन्स अफ फ्यामिली मेम्बरमा त्यस्तो भएको थियो कि थिएन भनेर चाहिँ क्विकली जान्न चाहनुहुन्छ। इज देयर एनी डिफिकल्टी टु इन्टरभ्यू योर पार्टिसिपेन्ट्स भरतजी?
Yes, there is lots of difficulties during the face-to-face interview. This is a sensitive issues. So हामीले चाहिँ एकदमै यो मैले त्यही भएर चाहिँ प्रायः जसो हामीले इथिकल कन्सिडरेसन मात्र भन्ने कुरा गर्छौँ, यसमा चाहिँ मैले सेफ्टी कन्सिडरेसनको पनि कुरा चाहिँ जोडेको थिएँ प्रेजेन्टेसनमा। यो सेन्सिटिभ इस्युज भएको भएर यसलाई एकदमै ध्यानपूर्वक चाहिँ गरिएको थियो। प्रत्येक दुईजना चाहिँ हामीले मोबिलाइज गरेका थियौँ बिकज अफ फ्यामिली मेम्बरको कन्सर्न भएको हुनाले चाहिँ त्यसलाई चाहिँ हामीले गर्दाखेरि फर्दर फेरि इन्टरभ्युअर इन्ड्युस मिसट्रिटमेन्ट नहोस् भन्नको लागि हामीले धेरै नै मेहनत गरेका थियौँ। यो चाहिँ एकदमै डिफिकल्ट टपिक छ र अब अन्डर रिपोर्टिङ पनि हुने चान्स भएको हुनाले हामीले लट्स अफ टाइम खर्च गरेर र अनि एकदमै जेन्डर ब्यालेन्स गरेर चाहिँ गरेको हुनाले चाहिँ सजिलो भएको थियो। जेन्डर ब्यालेन्स चाहिँ एकदमै इम्पोर्टेन्ट हुन्छ यसको लागि चाहिँ, र अनि ट्रेन्ड इन्टरभ्युअर पनि आवश्यक परेको थियो। यो नै कुरा मैले जनाउन चाहेँ। थ्याङ्क यू।
थ्याङ्क यू भरतजी। अब तपाईँलाई थुप्रो क्वेसन्सहरू आएको छ, यता च्याट बक्समा पनि छ, क्वेसन आन्सरमा पनि छ, and this is not surprising because as I said, this is a very, very important and under-researched area in Nepal. So त्यसैले यो खालको जिज्ञासा हाम्रो एटेन्डिज पार्टिसिपेन्ट्सहरूबाट आउनु चाहिँ मलाई नराम्रो लाग्दैन, तर because of the time I'm really sorry I have to cut this discussion. हामीसँग समय भएन डिस्कस गर्ने. There are a lot of questions raised, particularly हाम्रो यो भरतजीको प्रेजेन्टेसनमा सजेसन्सहरू आएको छ, क्वेसन्सहरू आएको छ, तर I'm not able to take all these questions. I'm sorry about this. So with this, I would like to conclude this question answer sessions, and I would like to pass to my co-chair, Professor Dr. Kiran Rekmi, to give her remarks and then close the session. Over to you, Dr. Rekmi.
Thank you, Dr. Mahesh. I thank all the presenters. All 6 presentations were very interesting and informative. I'm sure this would be helpful for policy makers. Presentations nicely covered the geographical variation. It also covered the life cycle approaches, and also there were methodological variation, both qualitative and quantitative methodology. The presentation also covered the most recent area, the COVID pandemic. We all were very worried about, and it also covered the neglected and marginalized areas, geriatric area. That was also interesting. Regarding the first presentation, the nutrition, this is very interesting to know many things that the junk food culture is still prevalent in Nepal, and still now almost half children are bottle filled. That is alarming, and also stunted number of stunted children were 13%. Malnutrition was higher in the male children. That was one interesting observation to know, as our this was contrary to our belief that women were neglected in nutrition and all. And regarding second presentation, the post-operative pain management, I congratulate her because she has given an alternative method for pain management. This is a touch management. We now are working to integrate this alternative medicine with primary health care. So this would be one very important, helpful for policy implication. The third presentation was on experience with during service COVID pandemic. We really need more presentations in such area. During COVID, not only the people were personally suffered, but all the health workers, they personally suffered and their families also suffered, and they were the most targeted group. So I thank her also for bringing such an important research in this morning. And fourth presentation was in antenatal care. Yeah, we all know that knowledge is very important for childbirth preparedness, and that will really help in maternal mortality reduction. And the fifth presentation was a perception of maternity care in the remote area. This is very important because in remote area, because of lack of resources and knowledge and all, it is very difficult, and the maternal mortality is also higher in the remote area. And the last presentation was on the geriatric problem. As we all know that he got many questions, and this is really a neglected area, and we also need to do a lot of things in this area, and also many researches. So by this, I would like to thank once again all the presenters, my co-chair and the organizer, and would like to say that the session is over, and hand back to my co-chair if he has any reflections regarding this session. Thank you.
Thank you, Dr. Regmi. Because of the time, I'm not going to give any kind of remarks. Thank you so much for all the presenters, and then, and the HRC for organizing this session. Thank you so much, and now over to Sasi.
We really have a really insightful presentation and discussion. Now let's acknowledge our chairperson once again. Thank you, Professor Dr. Kiran Regmi and Dr. Mahesh Puri and all presenter for making this session more vibrant and more informative. Now with the permission of the chair, I would like to wrap up the first sessions and have a good day. Stay connected to the next session. Thank you.
Welcome back. We are ready to begin our next session. Namaste and very warm good morning to you all. Distinguished delegates, ladies and gentlemen, it's my immense pleasure to welcome you all in this session who are virtually and physically present. Myself, Upama Ghimire, Research Officer working at Nepal Health Research Council, and I will be the host of this session today on interdisciplinary and implementation research. In this session, Ms. Urmila Sake and Ms. Sijana Dangol will be note-taking and Ms. Urmila Koirala will be compiling the comments. For this session, I would humbly request Dr. Roshan Koirala and Dr. Susil Baral. Sorry. For this session, I would humbly request Dr. Roshan Pokhrel and Dr. Susil Baral on the stage to chair the session jointly. We welcome you, sir. Although our chairs are well-known personality in the field of research, I would like to give a brief introduction about our chairs for this session. Let me start with Dr. Roshan Pokhrel. Dr. Pokhrel is a chief specialist in Ministry of Health and Population in Nepal, former Director General of Department of Health Services. Likewise, Dr. Pokhrel is former Medical Superintendent of Kosi Hospital, Biratnagar. Dr. Pokhrel is also a Chief Consultant of Psychiatry and has been practicing his psychiatry since 17 years. Dr. Pokhrel has extensive career in the medical field and experience which he shared from working on many different districts of Nepal is a motivational factor to every individual working in a medical field. Sir, we are really proud to have you here. Though he has numerous records in the career, establishment of de-addiction clinic at Kosi Hospital and methadone and buprenorphine replacement therapy are major highlights. Similarly, I'd like to share a brief introduction of Dr. Susil Baral. Dr. Baral has 25 years of experience in the health system, public health policy and planning, implementation research, and wider social development in developing countries, especially in South Asia. His professional portfolio ranges from a community health worker to a public health professional and advisor to a reputed national and international organizations. Dr. Baral is the founder of two health research institutes, that is HERD Nepal and HERD International. His area of expertise includes operational research, development of sector-wise approach, health service decentralization, health sector reform, strategic planning, health policy and management. Likewise, he has gained experience in the area of disaster management, response to emergencies with his strategic engagement in Nepal post-earthquake health and recently national lead response to COVID-19. We welcome you, sir. I would like to welcome our both pioneers to grace this session. Likewise, in this session, there we have altogether 5 invited talks. Now let me welcome our invitees, Professor Dr. Naveen Kumar Vaidya, Professor Dr. Ramesh Singh Vandari, Professor Dr. Sunil Kumar Joshi, Dr. Pitambar Dahal, and Dr. Om Kurmi for this session. Now, I'd like to request our chairs to commence this session. Thank you.
Thank you very much, Suprema. A big congratulations to Nepal Health Research Council for the summit, and a another historic day, second day of summit, with a number of presentations. I'm fortunate enough to co-chair this session along with a reputed personality, Dr. Roshan. We have prominent speakers who will be presenting their research papers. Let me start with this. This session is more about interdisciplinary science and implementation science. It is less commonly understood in the field of public health or health science what the interdisciplinary and implementation science is about. It is an emerging area, but there is no consensus in terms of how we define it in the context of public health and health systems across the globe. However, the implementation research is primarily focuses on no-do gap in real world, in real setting. And it basically addresses the practicalities of achieving national and global health targets, generating knowledge which is much more contextually tailored and more practical in terms of informing global health policy as well as national health policies. It is an integrated concept that links researchers and policy players brings together. So which is an important area that we will be hearing from prominent presenters about what the implementation research is about and how it can contribute to the development of knowledge, not only the development, but also uptaking knowledge into policy and practice. Likewise, the interdisciplinary research, I mean, it brings more than one discipline together. It flourishes the culture of working different disciplines together in terms of forming a knowledge that is applicable to the local context. So, with this note and permission of Chair, Dr. Saab, would you like to say a few words on this?
Thank you, Dr. Sushil. Yeah, we have been talking about other things, but I think that this topic today looks quite interesting. So I am quite new to all these things. So I think we are very eager to hear what our speakers have to say. So I think, Dr. Sushil, we better start, rather than talking ourselves, we better start with the first speaker, Professor Dr. Naveen Vaidya. Thank you.
Let me introduce Dr. Naveen Vaidya. Is an associate professor of mathematics in San Diego State University in the US. He has published many articles, research articles, as part of his academic career related to HIV co-infection, avian influenza, infectious disease control like malaria, typhoid, etc. So he has been providing better knowledge to the science, to the world, in terms of bringing multiple disciplines together as a mathematician. Over to you, sir. Dr. Naveen Kumar Vaidya, are you connected?
Very much. Thank you, chairs, moderators, and NHRC, especially for the invitation, and especially Dr. Demal and Dr. Gyali for the great opportunity. And this is, I'll be talking today about the mathematical modeling, actually, of COVID-19 in Nepal, key findings and its implications. So I'm mathematician and I'm giving talk to this audience in 10 minutes. So it will be challenging for me. I'll try my best. Okay, so anyway, so as I said, today I'll be talking about modeling COVID-19 in Nepal, key findings and its implications, so different perspective of talks. And this work is basically by our group. We have established the Mathematical Biology Research Group in Nepal with Kedar Upreti, myself, Ramesh Gautam, Anjana Pokhriel, and Khagendra Adhikari. And we are actually trying to promote the mathematical modeling to help for the management of the infectious diseases, and especially currently actively we are working on COVID-19, malaria, and measles. and these are the fundings we have received. So this is the COVID-19 in Nepal. It's just the data, just the case reports, the incidence data. And if we look at, I just want to note down, usually people call this is the first wave and this is second wave, but I would like to divide this first wave into two cases. July 21, where the lockdown actually started to relax. So that's a control phase before that, and after that, this is actually, I will call it first wave, but people usually call everything as a first wave. And second wave is around March 13, in the 13, 14, the second wave is started, and second lockdown is started from April 29. And September 16 is whole national-wide travel opening or something like that, okay? So I will try to give the brief outline. Like I said, it's a mathematical modeling, mathematical concept, so I cannot talk in detail, but I just want to tell you we are really serious about developing model, and our model is data-driven. It's not like we did just for fun. So I want to give a 30-second snapshot of the methodology. I won't be talking too much, but what we learned from the past, that's how I will be telling a little bit, and actually currently, we are actually timely giving the model prediction of what's happening today and what happens in the next 2 weeks, 2 months or something like that. So that's I will be talking about. And by the way, we have a website, I'll tell you at the end too. And in website, we are continuously, every day, we are actually giving updates on what is happening, current situation of Nepal through mathematical modeling. Okay, regarding the methodology, I will basically focus on two things. One is reproduction number. You might have heard a lot about R0, R0, RT, reproduction number. It is extremely important index. It's actually basically it's just the reproduction. That means expected number of secondary infection produced by an infected individual during his or her infectious period. Like that means in average, one infected person, how many during its infectious period, how many new it can produce. So that number is actually reproduction number. And why it is so important? If we can track the effective reproduction number over time, this is actually just, it tells that RT greater than 1 or less than 1 tells us that currently whether our epidemic is going, actually it's in the increasing trend or decreasing trend. Just knowing greater or less, that it can tell. And most importantly, it is actually correlated with the policy implementation. So therefore, it helps a lot of policy guidance. Like a main policy has to be in such a way that that will make the reproduction number as less as possible. Okay. So then we have in this paper all data that we are using maximum likelihood based method. I'm not going to tell anything about that one. It's all about in this paper. And now next thing I'll be talking about dynamical model. So basically that's about the differential equation based model. So and the details is in this paper. But again, to give you a 30-second snapshot, what we do is this in the model. So there is a reality. The infection is going on, then our goal is to develop some kind of description of the process. Same as like you can think of the regression analysis. In there, your description is the things change like a line with a constant slope, right? Same idea. We want to develop that. And then with some experiment, measurement, and survey from the reality, we get a data. And in the model also, there are certain parameters describing all these realities. And through these parameters, we can get a solution, and that solution also gives us model prediction what we have in the data. Then we work really hard to fit and match models, same as the regression line fitting, but it is very complicated. And then we get the best parameter, and if our model prediction and data are equally, they match each other, then we have at least our model is valid, and we can at least use our model to understand different things. Okay, so this is our model. So if you look at from the April to almost today, actually July 1, this is the data, incidence case reported data, and the rate curve is our line. So there are so many ups and downs in this curve, and it's very rare to see that our model, like our model, it's very rare to see in the literature that the model is doing excellent job. It almost covers whole year's epidemic. And if you look at cumulative number, it's excellent fitting. So that tells us at least that our model is valid. We are very happy with this result. Now, what we learned from the past? I'm going to tell 3 things that we learned from the past. Number 1, we calculated reproduction number. If we compare the same data, control phase, like a first wave, at the beginning of the first wave, if you look at that reproduction number, it is below 1, below red line, consistently until July, until the lockdown opens. Then even after lockdown opens, there is an increasing trend, but it is not too high. But this second wave, if we look at the second wave, right away, way before actually lockdown starts, this actually, it's already greater than 1, and magnitude is also very high. And that means there are clearly two differences in the waves. First wave is actually very well controlled, first wave, and what the second wave, before the lockdown, there is already community spread in the second wave. So that is one thing is different. That's why we are having a hard time to control disease. So maybe lockdown has started a little bit slow. And why is that? First wave was so successful because it's a border screen and quarantine, lockdown, and detection and isolation. These are the three policies government implemented at that time. And we did that. This is reality until July 21. If that policies were not implemented, it would have been almost 15,000 per day case already in the July. But that time it was really successful. Government's policies were really good at that time. So then we also did among these three control strategy, which one is more effective? And obviously lockdown seemed to be the extremely effective, but others are also effective. But interestingly, because we have a border screen, lockdown, detection, isolation, but our geography and related to borders and everything, contact patterns, urbanization, so much different varieties among our provinces, then what we did is, we did detailed analysis on each province, and we try to see that which actually among these lockdown, testing, isolation, and quarantine, which one is most effective in each province. And what we found, this red one tells us that effective, and what we found interesting, it widely varies among provinces. So then there is a provincial disparity. Then what we learned from here that even though government implemented national levels, but there is a way different. So that's why we cannot have a same model for everywhere. So that's why we started doing high and low risk regions. Now when we did that, now current and future, I'm going to tell you every 15 seconds one information, today's situation. Let's see. This one is today. Effective reproduction number today is July 1. We have in the whole Nepal it is 0.9. In actually high risk region it is 1.06. Unfortunately, it was already below in high risk region, but it's already up in couple of days. So it's growing up again. And in low risk region it is 0.85. And we can use our model to do the model prediction of the seroprevalence. And roughly until July last year, where there were control, only 0.1% seroprevalence. Now on the March, after the first wave, we predicted around 23% seroprevalence. And now today, as of today, we roughly predict around 47% seroprevalence in Nepal. So then what we did is, this is actually the daily reported cases. This is again data and until today, this line. And we also did, okay, if this lockdown continues, what happens? So this is the rate curve. And if we relax, we go back to the pre-lockdown stage, what happens? It might go this way.
Dr.
And
Navin, you have 2
75%
minutes to wrap up.
Yes, sure. So I'll be done by 2 minutes. Yeah. So you have this, if you have a 75% open, then we get this peak sometimes in August, and it goes down. If you have a 50% open, we have blue curve. So then same thing in the high risk region and in the low risk region, we have similar cases here. So then idea is, now we also, what happens, we also try to find the medical care. What is expected medical cares for the next 2-3 months until December. So this one we'll see total available. Maybe if we completely group pre-lockdown state, we may little bit overwhelmed with the medical care need, but otherwise we will be okay below the capacity. ICU bed, we are still okay. This is the available patient for ICU bed in Nepal, but we will be below that still. And also patient ventilators, that also below this line means we won't be more than the capacity we have. So then what we now, this is the last slide actually. One of the key questions we are always interested is, we are tired of lockdown, but can we relax the lockdown? So then only way of relaxing lockdown we see here is vaccination strategy. Then what we did here is, this is the level of relaxation, and this is the, if we 80% people we vaccinate by certain time. So if we vaccinate 80% people by January only, so if we do that 80% at least by January only, so then we might still get, if we don't do any lockdown, we might still get one peak around 8,000. But if we 60-70%, we might be in the current situation. If 70%, we can relax the lockdown. But if we aim to vaccinate, really optimistic, and aim to vaccinate by August 1, let's say 80% people, then we can actually have a 45 or just around 40-50% lockdown. Also, will do the relatively good jobs. Okay, so this is one example only, but we can produce a lot of results like this. And now, in my conclusion, dynamical system model can accurately explain the COVID-19 case. We can see very well for the case of Nepal. Model are extremely valuable for timely prediction and evaluation of control policy, and also combine non-pharmaceutical policies that actually implemented in Nepal before July 22 was highly successful. We really have to appreciate what government did at that time, save a lot of lives, a lot of cases. And actually looks like combination of non-pharmaceutical policies somehow balanced, not exactly going lockdown, open everything, but in the relaxed form, little bit in the balance along with the vaccination might be right strategy to move forward to control the, for the control of transmission, medical care, ICU patient, as well as ventilation. And looks like in a long run, only ways, of course, that I have experience here in US. Now it's the condition is better in US. Way for the long-term control is still is the nice vaccination policy. Okay, so this is the group. Thank you very much. If you have any questions, comment, I would love to say that.
Thank you very much, Dr. Naveen, for your excellent presentation. This actually highlights the true integration of the interdisciplinary research in terms of informing the public health policies. And it highly underscores that the government of Nepal has adopted good policies in terms of responding COVID-19 through your modeling. I call it dynamic and real-time modeling. It's really good. And thank you to you and your team members. Questions will be there. We request you to stay till the end of our session, so there might be questions. Sure. We will discuss later on. Now, with the interest of time, now I would like to invite another great speaker, Dr. Ramesh Singh Bhandari, is a professor and unit chief for GI and HPB and liver transplant and Department of Surgical Gastroenterology in teaching TU Teaching Hospital in Nepal. He will be talking more about the work-life balance of surgeons, which is indeed a need to know how our healthcare professionals, particularly the busy surgeons, have their work-life balance to maintain their professional delivery intact. Over to you, sir.
Thank you, sir. Respected chairpersons and everyone, very good morning. First of all, I would like to thank the NSRC team for giving me this wonderful opportunity to present in this great meeting. And you all must be wondering, what am I doing with this topic here in a meeting which is dedicated to hardcore research? But let me tell you that I'm here to remind you there is life beyond your profession and research. So I'll be talking on work-life balance because I'm a surgeon, I'm an academic surgeon, a clinical surgeon. So I represent surgeon, but I think it applies to the professionals coming from all walks of life. So I don't have any conflict of interest except that all the contents that I put in my slides are from the sources available online. So how do we define work-life balance? I think in the simplest form, the work-life balance is the amount of time that we spend doing our job compared with the amount of time that we spend with our family and doing things that we enjoy. I think this concept lately has gained a lot of attention as we all are hearing that there are increasing reports of physician surgeons burnout and which are actually due to disbalance in work and life. But what I'm trying to emphasize here is that the life as a separate from work and pleasure as separate from profession. I think everybody needs to understand these facts. Of course, all of us strive to balance our life and work because everyone of us wants to be happy, successful, and healthy. But it's not possible for everyone. People like us coming as doctors and surgeons who have no regards for 9 to 5 work every week, I think it's very difficult to achieve this balanced blessed. And especially for surgeons, it's difficult. But I think it's not impossible. If there is a will, there is a way. I found this very interesting and very surprising facts online. You can see here, 1 out of 3 fail to balance their work and life. The average lifespan of a doctor is less than 10 years. Depression is more than four times more common than general populations. Almost 9% high risk of emotional exhaustion, 10% high risk of burnouts. Suicide risk is 3% high in comparison to the general population. I think it's all because we fail to maintain the work and life at balance. So when we see our work and our life, I think there is a nice triangle has been described in form of work, relationship, and self-care. But there are many other aspects, many perspectives of life, like financial, spiritual, professional, family, social. So these all need to be balanced in a very successful professional career. We have seen and we have heard a lot of these great talks and addresses on speaking on the professionalism and work-life balance. But these are mostly delivered by the people who are retiring, who are exiting from their professional career. But I think it's too late to understand and realize that this is the time when you regret. So it's very important to understand the importance of work-life balance as early as possible in our career. Being a surgeon, I think due to obvious reasons, the surgery is very stressful, and all surgeons are at high risk of burnout and other stress-related disorders. So it's very advisable for surgeons to develop some kind of personal strategies to manage stress and maximize their job engagement. There are many factors which work in a cycle that can lead to the burnout and exhaustions. I think, for example, it might start with compulsion to prove yourself. We want to do the best, for which you start working harder, and you start neglecting personal needs. And it keeps on going on. Finally, you reach a stage of depression, and finally, you burn out. And so what happens if you burn out? I think it has a lot of adverse sequelae. It impacts your own health. It impacts your workforce. The quality of care is worsened. Your family, social life is damaged, and finally, you have a professional dissatisfaction. So the burnout can affect your physical, emotional, and mental energy, and which can be evident by these symptoms like changes in your behavior. You might become a chronically late person, you're chronic absentees, and you might indulge in excessive drinking and drugs. So this needs to be really cared about. It's not about the effect in your personal life or your career only. I think for doctors and surgeons, it's very important, as it can also affect the patient's safety. So this one very interesting study that I found, which was published some years ago in American College of Surgeons, and they did a survey on the members of American College of Surgeons. Almost 8,000 were surveyed, and what they found is the surgeons are worst at balancing their work and life. Almost 50% of surgeons said that they would never recommend their children to pursue the career what they are doing, like they are surgeons. They never wanted for the kids to become a surgeon. And less than 40% people responded that they had not enough time to maintain their personal and family life. I think that's a very relevant finding. These important human function curves tell us that some amount of stress works as a good stress, which increases our performance level. So as long as we're able to maintain the work-life balance, we remain on the left side of this curve. But as soon as we fail to manage these work-life balance, we start moving into the right side of this curve, and finally we reach to this breakdown stage. So is there any ways to balance our work and life as a surgeon? I don't think there are any strong recommendation, any scientific research to tell us, to guide us, to recommend us the strategies to maintain our work and life balanced. But I think whatever we get, whatever we hear, are mostly from advices from the experienced people. Most of the experienced people who tell us we should be able to manage our time, we should have someone to help us in making decisions, and also if we are able to outsource our tasks that we don't really enjoy but wasting our time, probably that would help us in balancing our work and life. But one of the most important to maintain the work and life balance is to avoid the burnouts. I think there are very simple but yet very important ways how we can stop going to the phase of the burnout. I think one very important is to realize and understand there is life beyond our profession and career. We have our hobbies and activities that needs to be kept alive. No one would disagree that the time management is one of the most important factor for work-life balance. I think it's again also an important key for the success of our professionals. So this very important slides tell us that we should know how to categorize our work and our activities into different components. We should know which are important and urgent, which are important and not urgent. So those who are very important and urgent, we should know, we should be focused on managing at the earliest, but those who are very important, not urgent, we can prepare, we can plan. But most important here, what I'm trying to say is, we should be able to avoid those kinds of activities which are not important, and even though they are urgent and not urgent. This is the only way that we can keep our work and life balanced. Definitely, there are a lot of time-saving techniques have been described, but I would say that every professional has to be adapted with the smart use of technology. Failing to do that will leave us leave us far behind. So, besides this, I think we need to know how to keep ourselves de-stressed, because that's again one of the important factors that can disbalance our work and life. There's simple things that has been pointed out. I think what I understood mostly is we should be able to give our enough time besides our profession to our family as well. Maintaining a strong relationship. It's been said that some professionals are married to their profession, and these are the people who might look good and successful at their profession, but they behave as very problematic partners. So it is equally important to maintain your strong relationship, and also as being a person, you have kids, and it's equally important to prove that you spend your good time with your kids and make sure that you don't regret in life that you are not a good parent and you could not do a good parenting. These are all these personal studies that I've just explained in this. This is just a summary of what I've just explained, and I'm not going to read all. I think these are all simple yet very important ways to keep our work and life balance. So at the end, being a surgeon, I want to end my talk by saying that we should enjoy being a surgeon. I think enjoy being what we are professionally doing. We should focus on good things, and we should know how effectively to manage our time, and it's the main key to work and life balance. We should evolve as a comprehensive human being with the surgeon or what profession you are carrying on, and we should plan ahead for a whole career. I thank you very much for your time. Thank you all.
Thank you, Professor Ramesh. Very nice and contextually relevant presentation for most of the professionals, not only working in health, and not only surgeons, but also overall professionals, how to really think about a balanced approach of their professionalism as well as their life. Thank you very much. If there are any questions, please use Q&A function in the virtual platform. So we will direct your question to the respective presenters as they arise. So now I have a privilege to introduce another prominent personality in this talk, Professor Dr. Sunil Kumar Joshi. I have learned quite a lot. He is my guru as well. So Professor Joshi is a medical practitioner, but specialized in occupational medicine, hygiene, diabetology, and has obtained PhD in health and community medicine. He has received several research awards and working currently at the Swedish Research Council postdoctoral fellow at the European Center of Gender Excellence, thematic gender studies department of Ligpong University, Sweden. So he's only the registered occupational physician in Nepal, looking at the Nepal Medical Council. So we have a great honor to invite him. Professor Joshi currently, he's working as the head of the Department of the Community Medicine, Kathmandu Medical College, Kathmandu University in Nepal. And He is also the director of the Nepal Injury Research Center, which is a part of the National Institute for Health Research, NIHR, in the United Kingdom, and the Global Health Research Group on Nepal Injury. So Professor Joshi will be giving talk on activities towards the prevention of injuries, a public health problem, and priorities in Nepal. Over to you, Professor.
Thank you very much. Dear chairs, both of you, and NHRC officials, I'm very grateful to you for inviting me for this talk on injury prevention. So today I'm going to talk on different injuries related studies we have been conducting for the last 4 years. So why evidence-based research, you see, injury research? So if you look at the theme, the current theme of NHRC Summit, this is research in public health emergencies, evidence to policy and action, you see. So today I'm not going to talk much more about the burden of injuries in terms of data. We do understand that injuries are a big public health problem. Nevertheless, all injuries are predictable and preventable. We as the injury prevention practitioner, you see, we do not use the word like accidents, because accident, the word seems like, you know, unpredictable and unpreventable. So what we think is, you see, for the perfect policy, you see, which is quite effective and practical, we need to base on evidence through data. So what we do is, you see, we have followed this important pathway of injury prevention. So if you want to make a good policy on injury prevention in any country, or mainly in Nepal, what we have to do is we have to engage the stakeholders right from the very beginning, and they should be, you see, we should think about their capacity building. So they should we should involve them in different capacity building activities. Then it will lead to evidence, you see, generation of evidence through data, and which will further lead to effective and cost-effective interventions. And further on, we'll be able to prevent injuries in our country. So in the same way, you see, Nepal Injury Research Center, we have followed the same pathway of injury prevention as the guiding principle. So Nepal Injury Research Center has been established in Kathmandu Medical College as a part of partnership between Kathmandu Medical College and the University of West of England, Bristol. So you can see the different funding agencies from where we have received, you see, different funds for injury prevention activities in Nepal. So talking about the sources of NIRC data on injuries, we collected data, you see, whenever possible, we try to collect the primary data, but we also use secondary data. We use all sorts of studies like qualitative studies, quantitative studies, Delphi technologies, you know, for photo elicit interviews. Basically, we have done conducted 18 research studies, and we have focused on injuries at home, injuries on the road, at work, at school. We use data from hospitals, from communities, from the police. We did systematic reviews on the injuries-related publications in Nepal. We did policy analysis on the injuries-related policies and legislations in Nepal, you see. So we also use different, you know, themes for our data collection. Here are a few themes you can see. We use, you know, first response group theme, roadside interviews, road users perceptions, and so on. And based on those 18, you see, researches, we have done quite a few publications, and now I'm going to talk about few key learning points based on our findings which have already been published. So this study is on is from the hospital-based surveillance studies in Makwanpur district in Hedorat. We ran injury surveillance, you see, for one complete year, 24 hours a day, 7 days a week, for whole 1 year, and we have published this. So the main finding, from that study was the effective use of injury surveillance data in Nepal could support reduction in adult and childhood morbidity and mortality, you see, from injuries. So that is very important. So if we have this information, then it will really help us to prevent different injuries. Similarly, another key point from one very important qualitative study on home and workplace injuries in Nepal, you see, it enabled us to learn about the barriers and enabling factors for injury prevention in Nepal. So we came to know that we got convinced that it is very important that we involve the community, you see, community involvement and engagement is really very important for injury prevention activities. Similarly, this study finding, key learning finding is from the quantitative study on home and workplace injuries in Nepal. So here, the most worrying part you can see, there is inequalities in injury occurrences. And home and workplace fall injuries are very common. So such type of community-based quantitative studies are very important as well. And it's really very interesting, it's quite very close to my heart, this photo elicitation interview. We usually do not follow such data collection tools, you see. We have children in everyone's house. Every day they go to school, maybe not now, but during the normal time they go to school. We usually worry about their ergonomics, they carrying heavy loads on the back, but we are never worried about how they reach the school. What are the safety stuff when they walk to the school, they drive to the school, they take bus, you see. So we use this photo elicitation interviews method. So we distributed cameras to the school-going children. They took photographs on the journey to the school, and during the interviews, we used them at the probes, and you see, had a very nice discussion with the students, and it could play a very vital role in improving children's journey to school. You see, this is such type of findings are sometimes very, very important. And another very important study finding here is, policy review. So we did policy analysis of all the, injury-related policies and legislations. And we came to know that there are very few legislation in Nepal that could emphasize on the prevention of injuries at home or school. And in the current political scenario of the different level of different tiers of government, it could be really effective to work in collaboration with different level of government for the prevention of injuries. So that is very important thing. So I have tried to make my presentation quite short. So at the end, at the conclusion, what I would like to say is I have just tried to share a few key findings from our studies that have already been published, but not all those 18 studies that we have done have been published. So if you want to find more information about our activities, you may go to our website, nirc.org.np, and find all the information we have been doing. But at the conclusion, I would like to emphasize that changes at the individual, organizational, societal, and governmental levels are needed for the prevention of injuries in Nepal. And key areas for action are education, resource allocation, improved infrastructure, and accountability. So this is very important. So I would like to conclude my presentation with this slide. So this is the, you see, funding acknowledgement and disclaimer. And I would like to thank you all for your time, for listening to my presentation. So this is the photograph when we had this launching ceremony of Nepal Injury Research Center 4 years back. It was really good ceremony, and since then we have been received very good cooperation for all the stakeholders. We have been received very good cooperation from the Ministry of Health and Population. Dr. Roshan Pokhrel is here. So other dignitaries, current dignitaries, you see, at the Ministry of Health and Population are very, very supportive to us, and we have been working very closely with all stakeholders for the prevention of injuries in Nepal. Thank you very much for your time. Thank you very much for this opportunity.
Thank you, Professor Joshi. It was nice hearing from you and what you have done from your side to prevent injuries and how we can tackle injuries. Now we move on to another presenter, and the topic is improving nutrition and immunity with dry chain and integrated pest management. I take this opportunity to welcome Dr. Pitambar Dahal from USA. He's a retired scientist currently living in USA. Dr. Pitambar Dahal is a research scientist at the University of California, and he expertises in molecular biology, plant physiology, plant biology, plant biotechnology, and seed germination. He has more than 35 published research in international journal, and he has also published many articles related to food and nutritional security in Nepal, improving nutrition, food safety. I welcome Dr. Pitambar Dahal. The floor is yours. Thank you.
Namaste everyone. I'm Pitambar Dahal from University of California in Davis. I'm going to talk to you about health-centric food technology that was published in Lancet Planetary Health in 2020. This is the title of my presentation is Toxin Minimizing Dry Chain and APM Food Technology Complement to Biodiversity, Food, Nutrition and Health. We are a group of large group of researchers, including Dr. Meghna Dhimal. Thank you, Dr. Dhimal, for inviting me to this forum to present to this health forum. And other colleagues from the AFU and the Minister of Agriculture and several colleagues from university in the USA and Australia. So the food toxins are mainly of two types: the natural one that develop in the low moisture foods, and the artificial one that are mostly used in the high moisture foods. So the inability to protect the foods from the flooding, that's the ongoing situation right now. The natural toxins, especially the mycotoxins and the aflatoxins develop, and they also insects develop after the dry food gets wet, and the nutrients are lost. So in case of artificial toxins, these are the man-made toxins used to produce the fruits and vegetables. And of course, we need to consume these fruits and vegetables, but we need to minimize these toxins in these foods, and a drawn standoff upward between India and Nepal on this one. So in the low moisture food, again, about a third of the global production is lost due to the porous packaging. So if we could save these food from losses, it will be equivalent to increasing the production. So this inability is not limited to India or Nepal. That's a global knowledge lacking here. This is the food donated in the aftermath of the earthquake in Nepal, and this was dumped under the ground due to the quality was bad. So a premier in Thailand is in exile mainly because of this food storage issue. And so just having this structure is not good enough. So the humanitarian agency is just like Durmis Suntali, Ariana Rani, Chaudhary group, they all need to realize that the moisture protection concepts must be used. Just see the damage over here. And the traditionally food is stored in the open structure in Nepal, just like this one shown here, and even in China here. At a closer look, you can see the quality of the grain here in from this grain in China. So when the food gets bad or is rotten, then it's given to the cow, and we worship the cow. And the cow gives back the toxins to the human, and so similarly the case in the fields. So here is depicted the human exposure to toxin. This one for Aspergillus. Of course, there are other disease causing fungus, just like Fusarium. The end result here is that there is, in case of Aspergillus, there is acute aflatoxicosis, and there is liver cancer. The end result is liver cancer, and there is failure, growth failure in children and immune suppression. You can see this is coming from the milk as well. A pregnant woman study in 2014 in Sarla, including 5,000, and in 2020, including 1,648 in Banke. In both cases, 94% of the pregnant women had aflatoxin markers in the blood. The toxin dose was 10% of the Kenyan mold epidemic in 2014. So you can imagine what's happening to the health of the children and the mother. So the long-term strategy to minimize these natural toxins would be breeding, incorporate disease, insects, molds, and nutrient loss resistance into one crop. But this nutrition aspect is rather new to the global agencies, even just like the BMGF. In the Grand Challenger, they ask not to include the mold issues in the nutrition proposal. So, so the pre-harvest strategy also need to be used when there is a rainfall, dual rainfall, rainfall during during 2 seasons, as in Africa. In Nepal and India, whether this is the case or not, it has yet to be determined because the aflatoxins at harvest and after storage have to be determined. So we propose a dry chain technology, which is drying of the food to the precision moisture content, published in 2018, and maintaining the value chain. So basically, this is in brief. A dry chain is for the dry products. You make it cold and maintain the dryness. So that's the best one. But this refrigeration is not available to the people. So in the developing countries, so we propose this one here when it's warm or hot, but by drying the food and maintaining the moisture by the moisture packaging, we could change. We could maintain the value chain for medium term storage. And this was in fact demonstrated by the research from China, where in a 50-ton maize storage in a barn, they monitored the moisture content over 5 years, and they monitored all the amino acids and the fatty acids and the grain quality parameters, catalase, peroxidase, and the fatty acidity of the fatty acids. Just note that there is no difference until 4 years in any of these parameters. And in the 5th year, these grain quality parameters began to decline, and they put this one to the chicken, and they saw the effect on the growth rate as well as in the quality of the meat in the chicken. So you can just imagine by maintaining the moisture what is possible. So we try to demonstrate in plot-prone subtary using this Vicion and the knapseeds which produce these pigs bags. Just before the rains, the only way to protect the grains, foods from the flooding is to package into moisture-proof containers. In fact, we had demonstrated in 2017 at Kabre, just after the earthquake in Nepal. Here is the insect damage in the traditional storage, about 10%. And using the PICS bag, after 6 months, it was still at, it was similar to the initial one. But in case of the porous packaging, the insect damage was about 92%. And it has been published here. So you can just see the utility of maintaining the moisture in the moisture-proof packaging. So here are the small dryers that could be used during the rainy season to dry the foods to the precision moisture content 12 or 13%. These are the small dryers. Within 5 hours is possible. If you want the bigger ones, there are $50,000 capacity, and even the tractor would cost that much. But they can dry 50 to 70 tons within 24 hours to the precision moisture content. So in the high moisture foods, the pesticide residue need to be minimized by using IPM, which is a genetic, biological, cultural, and physical and chemical tools. Chemicals are the last resort. This will minimize the economic, health, and environmental risk. and increase the agrobiodiversity. And the several groups like Nepal Health Foundation and PSD are also involved in this one, and the government is also involved in this one. But this is IPM is before the organic vision. So the main fundamental difference between the food system in the developed and the developing countries is that in developing countries we put emphasis on profitability and we have a food system less with pesticides. But in developed countries they put food safety as the primary concern, and they have separate food systems. So please minimize the food. Our recommendation: please minimize the food toxins, implement IPM and dry chain technologies. That will also increase agrobiodiversity, and also it will increase the local strengthen the local seed systems. And we need to regulate and minimize the pesticides use and import, and monitor the quality of both domestic and imported foods using independent agencies and sensitive tools to conform to Codex standard and involve civil societies and the media. So once again, thank you, NHRC, for giving me to present this to this health forum. Thank you.
Thank you, Dr. Pitambadhar, for a nice presentation and especially concern about the Saptari district incident, especially with the dry chain management and the integrated pest management. Definitely that will help us to improve the loss of food, the 1/3 loss of food that we see every day. And now finally, we're moving to our last presenter, air pollution and health during COVID-19 pandemic. Dr. Om Kurmi is associate professor in epidemiology and healthcare research at Coventry University, England. He has strong research professional background with a PhD focused on environmental health and non-communicable diseases from University of Aberdeen. His area of expertise includes respiratory epidemiology, research design, data analysis, program evaluation. He has experience in working in large population health, biobank registry studies, and he in over 42 countries across 5 continents. So I welcome Dr. Om Kurmi for your presentation. Thank you.
Thank you, and good morning, namaste to everyone. Thank you for inviting me to talk about this topic, particularly Dr. Meghnad Dhimal. Today I'm going to speak on mainly 2 major sources. One is the household air pollution and then the ambient air pollution in my talk. So if you see in this figure, it shows you the air pollution in the changing world. Mainly it is concentrated in high-income countries, but we can see a pattern. In the 1940s to 1950s, you had coal burning was the major source, where you have sulfur dioxide soot was the major pollutant. There were many people smoking and less car, but after the London smoke, which killed over 12,000 people in UK, and there was a Clean Air Act which introduced a much better policy, and then the pollution changed. We had, following that, we had carbon monoxide, lead, and ozone. And then now we have the main pollutants are the particulate matters, whether it's PM10, PM2.5, or ultrafine, and nitrogen dioxide as well. So this figure I took here yesterday evening at 7 o'clock, and you can see there is a various degree of pollution if you look throughout the world. And on the top right, if you see Nepal, which is a relatively small country, and if you see in different regions, we see a lot of variation of pollution. I mean, mainly concentrated in Kathmandu, which is mainly ambient air pollution. And there are certain other cities as well where we see quite high pollution when you compare it to the other sources. We did carry out one of the most detailed study in China. We got a funding and we found there was regional and seasonal variation. So in this study, what we did was we did the personal exposure monitoring in the individuals, they carried the exposure for 1 week in 2 seasons, in 2 different regions. We measured in the kitchen for a week period, in the living areas and outdoor as well, continuously measuring. And what we found, and I think it is relevant to every other countries as well, where the kitchen has the highest amount of pollution, followed by the personal exposures, and then the living room, and then following the outdoor, which were much more cleaner compared to the other sources. And this is the case for low and middle income countries, many including Nepal as well. So this is a quite old, but I think it's you see the figure here. It's on the top left. It's the typical air pollution in rural areas, where it shows you the PM 2.5 and the carbon monoxide, where you see the high peaks during the cooking period. And the bottom left, right, is the air pollution in Kathmandu, which we measured around in 250 homes and outdoor as well. And when you aggregate this, you find like the rural areas were very, very high, which is over 500 in our finding, and the urban areas, which was around 100 microgram per meter cube. And when you look at the outdoor PM 2.5, the urban was really high, 178. And this can be, if you look at some recent finding, you can see these numbers, which is very much similar. And when you compare it to the WHO air quality guidance, they are many-fold higher. So you can see the amount of air pollution we inhale, whether you are in Kathmandu or in rural areas or in other part of Nepal. If you look at the GBD, I mean, you know, compare the figure here shows you the number of death by risk factors in Nepal in 2017. This is just GBD data. And when you see the air pollution is the number 1 risk factor in case of Nepal. And when you compare it to the world, it is number 4 in terms of both combining outdoor and indoor. This data is for 2017, that's what we have. So we had the air pollution contributes about around over 14% of total death in Nepal. And when you compare to this, the world, it is around 9%. So we are a very high amount of pollution and contributing to a large amount of death, disability, and as well. This is another one very interesting finding published by the Harvard group this year. And what they found is the GVD data, which I showed you before, there were around 25,000 deaths, which is underestimated. They found these are underestimated, and it is much more higher. They reported mortality in over 14 years. And what they found, China and India contributes to around 62% of the total world's mortality. But look here in the Nepal, and the mortality which the GBD suggests is around slightly over 14%, 14.5%. Here they, in over 14 years, they have the mean attributable fraction is over 23%. So this is quite interesting. There is a lot of variation, and as you see which modeling you use, there is, but nevertheless, air pollution is a major factor to a number of health outcomes. This is again from the GBD database, and here we, in the top left, we see the Nepal in the South Asia regions. We are number 2 according to the GBD in 2017. When you look at the right figure, here we see a good sign that the air pollution has been decreasing in Nepal. The top, the red one, I don't know whether you can see that one, air pollution total. It has been, the death rate has been decreasing due to the, which is caused by air pollution. But when you see, when you come to by 2002, there has been slow decline. The death has been 2002, between 2004, there has been, the death has declined. And it shows the major decline in death in Nepal due to air pollution was due to reduction in the household air pollution. Initially, we had over 90%, but I think around we have between 60 to 70% at the moment. People use a household like biomass for cooking. But when you look at the outdoor air pollution, it has been increasing consistently. And in 2005, if you onwards you look, it has the death due to outdoor air pollution has been higher than the indoor air pollution, which is the household air pollution, and that is a worrying sign as well. We, based on, this is again, we published based on our data. This is one of the first finding in the anywhere published in the world. We published in ERJ. What we found is the young adults, which were between 16 to 25 years old, they already had a reduced lung function. So we know that if you have a reduced lung function, you are likely to have number of health conditions, whether it is cardiovascular, it is related to other metabolic disease as well. So, and you see in the pandemic as well now, so the lung is one of the major reason for the death and disability as well. And this was, we found that, and based on that, there are a couple of studies going on in different parts of the world. So we also look other respiratory health condition as well. And what we found was the, in the rural areas, mainly the respiratory health was higher, the prevalence of respiratory, whether it is COPD or whether it is the symptoms, you find much higher in the rural areas compared to urban. But what we also found was mainly it was due to air pollution and smoking as well. But when you look at the symptoms, some of the respiratory symptoms, you had much higher like phlegm production in the urban areas, particularly in Kathmandu compared to the rural areas. There was another study published in Nepal. I think this is the first one looking at longitude, the case crossover study, which reported the percent change in hospitalization per 10 microgram cube increase in PM10. And when you look at the total admission there, there is 1% increase, which is related to increase in PM2.5. Whether you look at different sex, whether it's different age group, whether you look at the respiratory conditions, cause-specific mortality, so you find this similar. And we compared this to in the same year, one of my PhD students, when I was in Oxford, Catherine, we did a systematic review and meta-analysis published in the Lancet, Planetary Health as well. We found the increase was around 0.5%, but when you compare to the previous one, it was 1%. So we do see there is a higher increase in the... So then we also look in the gaseous pollutant, and then we found around 70 to 90% of the 0.7 to 0.9%. Can you hear me? I mean, it says I'm muted for some reason.
Yeah, we can hear you now.
Okay.
Please conclude your presentation in a minute.
Yeah, something has gone wrong, so I can't now stop for something this screen.
We can hear you.
So, okay, so we recently did a study on the household air pollution and small for gestational.
We appreciate if you could conclude in a minute, please. Because
so yeah, we found that the household air pollution was over 5-fold risk. We look at cataract as well. It was much higher in Nuwakot and Sorlai as well. Even from China, we look at cardiovascular and respiratory. We found there was a dose-response relationship as well. There is, we published from other 11 countries studies. Again, we found the similar findings. So I won't go into detail, but the finding is almost similar. We look at the chronic liver disease as well in the prospective study. That's again. So just quick, when you look at this COVID and the air pollution, there have been quite few publications, quite a lot of publications, I would say, mainly coming from China. They are coming from Europe. I won't go into the detail. And there is from US. And all these studies, they do suggest there are increased risk of infection, there is hospitalization, as well as mortality, where there has been higher increase in, the air pollution. And this is one of the study from China, which is from 63 multi-city studies. And what they've looked at is the mobility scaling index. So, and when you see this graph, there has been, when there are more movement, there are more air pollution, and then you have higher cases as well in China. But when you look at all this evidence, a recent review published, a systematic review, I don't think you can read this one, but what it shows is the red are all the evidence which is there. I have a lot of
Professor
bias.
Kumi, may I request you to conclude your presentation in the interest of
so
time,
this is just
please?
a few seconds only. So, and there is less in the, I mean, most of the evidence are not that great. There have been a lot of bias as well. So one thing what you can do is we know there is a lot of evidence, but we need to act now. That's what the overall message is. Thank you.
Thank you, Professor Kumi, for a very good presentation highlighting the importance of air pollution in terms of determining the health outcomes in different ways, in different settings. I'm sure there are a lot of questions. We would like to request you to remain until the end of this session to answer any questions if there are. Thank you very much, all the presenters. Very good presentations in their respective areas. We have a couple of questions. In the interest of time, I would request if there are any questions to the particular panelist presenters, I would suggest you go to the chat box function and respond. The one question from Dr. Basudev Pandey to Professor Naveen Kumar Baide. Are you connected? Dr. Naveen? Yes. Okay. There was a seroprevalence survey done by EDCD, and which basically highlighted the prevalence rate of 13.9, and which whether or not you have correlated your results, and have you taken the consideration of virulent factor for the second wave?
Yes.
Quick response,
Okay.
please.
Yeah, so I have actually 3 questions. These are 2 and 1 more. I will just respond in 15 seconds actually. The first one is, unfortunately, we haven't computed exactly for the September because we just did for July 21. That's a very fast control phase. Then after the first wave, we got 23%, and after that, today it's about 47%. Exactly around September, October, we haven't done, but we can definitely compute. Sorry about that. And the second, did you consider virulent factor for the second wave? I should say yes. Yes, because virulent factor or infectivity is one of the important parameters that we estimated from the data. So that's why we have that factors included. And there is one more anonymous attendee. Can we predict about third wave through this model? I have yes and no. So depends on what brings the third wave. Because this next wave is very complicated issue. If we are thinking that third wave is coming because of the behavior, like when we relax the lockdowns and those kind of changes, we make it. So then that brings the third wave. Yes, we have that. We can predict that in the model. I also showed some slide, that one. But if the third wave is because of the new strain coming and escaping from the immune responses and those kind of things, then we haven't considered that. That's definitely the next step.
Thank you very much, Professor.
Yeah, thank you.
Naveen, for your response to the questions. Now, I mean, it's important. All the presenters, they presented really nice in their topic area. There's one question to Professor Ramesh Bhandari. Yeah. Bringing the work stress to the family and sharing the workforce issues, will it help to reduce the anxiety or level of stress, or will it really enhance the profession? Very quick.
Yeah, very interesting question, and I think it's very difficult to answer. But I think it depends upon the profession of your spouse. Well, if it is too hardcore, your work related, and your spouse, your partner is completely, from a different profession. Well, and I think it will be hard for them to understand. So there are different ways. It's not that, you cannot share your work related stresses, but we just have to make sure that we are not adding up the stress to our family. Okay? So we need to present ourselves in such a way that we get some reassurance from the family rather than further increasing the stress of the family.
So another need to balance what
Exactly.
to bring home or what
Exactly.
not to bring home.
Thank
Thank
you.
you very much.
Thank you.
There is one comment, rather question to Professor Sunil Kumar Joshi from Professor Kumod Kafle. If you have to prioritize your interventions, what order would you really recommend to prevent the injuries?
Oh, that's very interesting, very important, but really very difficult question to respond right now. But you see, what I would recommend is, this injuries, hospital-based injury surveillance is really very important. It will give us a very good picture on the pattern of injuries. You see, it gives us about the demographic factor, demography of the people's having injuries, and with all those information, it will really help the government to develop policies and plan to prevent injuries. So I would rather, in one sentence, I would rather say that hospital-based injury surveillance is very, very important. Trauma registry is another very important point, and there are many other, things. There should be a proper coordination between different level of governments, and that is also very important. So looking at the time factor, I would just like to conclude here.
Thank you very much, Professor Joshi. In the interest of time, we are already running behind 20 minutes this session. Let me briefly conclude, and very huge applause to all the presenters. I mean, this session truly blended the interdisciplinary approach. We brought a lot of different topics together in order to enhance the public health measures, public health policies, ranging from a dynamical modeling for COVID-19 or any infectious disease, it can work better. From the work-life balance, how a professional should have a greater balance in their work and life, so the longevity of the professionals is ensured, along with the happiness and with the family and friends. The other thing, it was very important to note the injuries. I mean, it's the biggest public health problem. We cannot continue to ignore the consequences of injuries in health outcomes and the quality of life of people. It's a very nice presentation by Dr. Joshi. Thank you very much. Highlighted a couple of policy options which need to be adapted in order to reduce the injury, which is injury always preventable, as we heard. And another important thing what I also learned personally is how the storage or the food chain affects the quality of food, as well as how it impacts the human health outcomes in various contexts. It was really, really highlighting, enlightening presentation. And we heard our final presenter about the air pollution. It was very, very big public health issues in the context of Nepal, not only, but I have a couple of observations here. I think it's when we compare the rural and urban area, and urban seem to be, in terms of indoor air pollution, urban seem to be performing well in terms of their kitchen. However, if we need to disaggregate data, are the urban poor also having the similar kitchen or the indoor air pollution in the kitchen? It may be masked, the reality is maybe masked by the rich people or the middle class people. So perhaps some disaggregated data on the socioeconomic aspects and indoor air pollution is interesting. With this note, there are a lot of really critical deliberations been made here, which informs the policy and practice in order to enhance the public health functions in the fall. And personally, I would like to really acknowledge my sincere appreciation to all the panel members, for the presenters, as well as to the NHRC for this opportunity. And I'm deeply honored to co-chair this session along with Dr. Roshan Pokhrel, who's my guru. I hand over to you, sir.
Thank you, Dr. Sushil. I think without any delay, I thank all the presenters, especially Professor Dr. Naveen Vaidya, Professor Ramesh Singh Bhandari, Professor Dr. Sunil Kumar Joshi, Dr. Pidambar Dal. Yes, it was quite amazing to hear your talk, especially we are not looking at that aspects, in our everyday life. And finally, Dr. Om Kurmi, air pollution. As Dr. Susil rightly pointed out, yes, we might be masked by some poor people in the urban areas using, the rural setting to cook. So overall, it was a very interesting 1 hour session. We took a little bit more time, and I take this opportunity to thank everyone and end this session out here.
Yeah.
Ask Supma to do the ending part, Let's not delay it. Thank you.
Thank you, Cheers, for your valuable remarks. And thank you all the presenter for your great presentation. Now it's time to acknowledge our presenter. So for this, I'll call upon our Cheers to acknowledge our presenters with token of love. For this, I'll call upon Dr. Roshan Pokhrel to acknowledge our Cheers, Professor Dr. Ramesh Singh Banjari with token of love. Thank you. Likewise, I'll call upon our Cheers, Dr. Baral, to acknowledge our Dr. Susil Kumar Joshi with token of love. Sunil Kumar Joshi with token of love.
It's a really pleasure.
Thank you. Now, thank you. Now, it's time to acknowledge our Cheers. So I'll call upon Chairman of NHRC, Dr. Gehinath Baral, to acknowledge our Cheers with token of love. For this, I'll call upon Dr. Pokhrel to receive the token of love from Dr. Baral. Thank you. Likewise, I'll call upon Dr. Baral to receive the token of love from our chairman, Dr. Baral. Thank you. Now it's time to take a group photo.
Once again, thank you
Thank
very
you
much.
all. Now we are at the end of the session. Hope you all had a great learning from this session. Now I'll call upon our next session moderator, Ms. Risa Acharya, to continue this session. Thank you. Have a nice day.
research without action, no action without research. Kurt Lewin. Good morning, everyone, and namaste to all. I am Richa Acharya, Master of Disease Research, which is based on the theme Research in Public Health, Public Emergency, Evidence to Policy and Action. Now, I would like to welcome all the distinguished personalities, scholars, participants, and all the viewers across the globe who are joining us by live means of Facebook, live of our event page, YouTube channel of NHRC. Today, we are pleased to have eminent personalities as chair of this session, Professor Dr. Jivan Bahadur Seth Prakash Kimire. We would like to welcome the chairs with a big round of applause. Few words to highlight the introduction of chairs. Professor Dr. Jivan Bahadur Serchan is Emeritus Professor, Department Head of Microbiology Research Laboratory of TUIOM. Professor Serchan served more than 43 years as an assistant instructor to professor in TUIOM. He was the former research director of IOM, former ERB chair and coordinator of NHRC. He served as the advisor to the Vice Chancellor TU. He is still working as consultant and senior lab technical expert to NPHL and National Center for Infectious Disease. Professor Serchan is involved in several research activities. Till date, he has published more than 280 scientific papers in national and international journals. He has received awards like Health Research Lifetime Achievement Award, Royal Nepal Academy's Award, Outstanding Health Research Award, and many more. Welcome, sir.
Thank you.
To introduce our next chair, Professor Dr. Prakash Kimire. Professor Dr. Prakash Kimire is a professor of microbiology at Tribhuvan University, Nepal, with 25 years of contribution to infectious disease research. Currently, he is chairperson for the National Ethical Review Board under Nepal Health Research Council. Currently, he is president of Nepalese Society for Microbiology. He served as ambassador for Nepal in American Society for Microbiology from 2012 to 2017. He worked with WHO for more than 15 years, including 2 years based at WHO headquarters Geneva. Professor Dr. Kimire is involved in several research activities. Till date, he and his team has published more than 125 original research articles. He has been providing expert technical to government of Nepal. Dr. Kimire is highly regarded microbiologist and research ethicist in the country. Welcome, sir.
Thank you.
After the introduction of the chair, I would like to have a list of different presenters of the today's 7th session. They are Navin Adhikari for invited talk, Rajesh Kumar Yadav, Sushant Pandey, Gunraj Dungana, Kancha Shrestha, Navin Kumar Chaudhary, and Pramod Kumar Mehta. This is for your information that question and answer session will be at the end of the session. I would like to request participants to drop their queries in Q&A box, which will be addressed accordingly. Now I would like to hand over the session to the chairs. Thank you.
Thank you. Thank you, Richa ji. Namaskar and welcome everybody. Jivan sir.
Yes, please. Yes, yes, I'm here. I'm seeing you.
Sir, you can announce the first and I'll go with second so that alternate would be happy.
So, okay. So I think today we have 7 presenters and one is invitee speaker. So I think I would like to request the invitee speaker Navin Adhikari to present his paper on genomic analysis of SARS-CoV-1 circulating in second wave of COVID-19 in Nepal. So Dr. Navin Adhikari, please present your paper.
Namaste सबैजनालाई. I am Navin Adhikari, working as research project coordinator at Dhulikhel Hospital, Kathmandu University Hospital. र म चाहिँ बेसिकली इन्भल्भ छु हाम्रो जेनोमिक सिक्वेन्सिङ फेसिलिटी एट दुलिखेल हस्पिटलमा. फर्स्ट अफ अल thank you for the NHRC team for providing me this opportunity to present our teamwork on SARS-CoV-2 sequencing. at the 7th National Summit of Health and Population Scientists in Nepal. My presentation will explain the genome analysis of SARS-CoV-2 circulating in the second wave of COVID-19 in Nepal. Our sequencing team is led by Dr. Rajiv Shrestha, and me and my colleague Mr. Nissan Katwal are involved in this work. And we'll start with to give a brief background of which all of us are aware of by now, that COVID-19 has affected millions of lives around the globe, and this is mainly due to the first three variants of concern that occurred around the globe, namely alpha, beta, and gamma, which emerged in different continents. So currently, a new Delta variant of concern emerged in India and transmitted exponentially, and it has even reached to other parts of the world as well. And Nepal, being a neighboring country of India, it follows the similar trend, but in delayed manner of the increase in number of cases, which can be seen here in the adjoining graph as well. So here the pink one is of India, pink line, and the green line is of Nepal. We can see that during both the waves, the first and the second wave, always the wave is initially initiated by the increase in number of cases in India, but sooner or later the spike in number of cases is occurring almost in a month interval from India in Nepal as well. And so due to this emergence of Delta variant in India, so it is likely that the second wave of COVID-19 is due to the Delta variant in Nepal as well. So with this, we set our study objective to sequence the whole genome of SARS-CoV-2 circulating in Nepal during the second wave, and to identify its variant or lineage, also including the mutational profiles in the sequence genome. So for this, what we did, as we saw from the graph that the second wave was at its peak during the May 2021, we retrospectively collected SARS-CoV-2 positive swab samples, and then we extracted the RNA from them. Then real-time PCR was done to confirm the positives. So after confirming the positives, then the extracted RNA was processed for the whole genome sequencing in Illumina ISEQ 100 sequencer. After this, we got the consensus genome sequences, which were analyzed with the proper bioinformatic tools. So what we got in our result was, so we had almost 99% coverage of the SARS-CoV-2 genome, and of all the 5 samples that we sequenced, as you can see in the table. And all these consensus genomes have already been submitted to GISAID with the different ID as in the table. And to our surprise, we found that all of the samples were of variant of concern B.1.617.2, which is a Delta variant as renamed by WHO sometime before, and they belong to the next clade 21A and GIS8 clade G. So here we can see in the table for sample S2 that the lineage shown here is AY.1. So I would like to mention that when we submitted these sequences, so all of the samples were of lineage B.1.617.2, which is a Delta variant. And so at that time, the Delta plus lineage was not shown. So, and later, after some days, then it was again re-identified as a new lineage or the variant Delta plus. So if we see here the characteristic spike mutation in the Delta variant, which is highlighted in yellow, in addition to that, we have K417N mutation, which is highlighted here in pink, which is in our 2 of the samples among 5. although the AY.1 lineage is given only for sample S2, so it is not given for sample S6, which might be due to some missing other mutations in the genome. And so, as far as my knowledge, we are the first ones to report this K417N mutation in the Delta variant, which makes it a Delta plus variant. So with these results, we confirmed the genomic sequences of variant of concern, which is Delta variant, and another variant of lineage AY.1, which is Delta plus in Nepal. And second wave of COVID-19 in Nepal is indeed due to the Delta variant, including Delta plus. So to add up the biological effects or the significance of the presence of K417N mutation in Delta variant, which is a Delta plus variant, must be further investigated, and the genomic surveillance must be increased to identify any new variant with increased transmissibility or the pathogenicity, because as seen in the earlier variants, another mutation of concern is N501Y, which is not observed in Delta variant. So it might be pathogenic or with increased transmissibility, which is not known by now, but it remains a point of concern here, as if the Delta variant acquires that mutation, what would the result be? So the genomic surveillance should be constantly increased or intrigued for the identification of any new variant which might be circulating in any place. So with this, I've come to end of my presentation. I would like to thank the Dulikil Hospital for providing me this opportunity to be a part of the team and the project, and also the Department of Microbiology, Dulikil Hospital, and the NHRC team, including Dr. Pradeep Gewali, Dr. Meghnad Dhimal, and Mr. Saroj Vatrai for facilitating us with the COVID samples. And to not miss out, I would like to thank Bill and Melinda Gates Foundation, which has helped the Dulikil Hospital to strengthen our sequencing lab. Thank you, everyone. Please, if you have any questions, put it in Q&A section. Thank you.
Okay, Dr. Prakash.
Thank you, Naveen-ji. Sir, Jeevan sir, over
Please.
to you.
Okay, now you can, Dr. Prakash, I think, you can call the presenters.
Thank you, Naveen-ji. I would like to invite another speaker of the session, Rajesh Kumar Yadav, speaking on health-related quality of life and associated factors with medication adherence among tuberculosis patients in selected districts of Gandaki province of Nepal. Rajesh.
Namaste everyone. I am here to present health-related quality of life and associated factor with medication adherence among tuberculosis patients in selected district of Gandaki province of Nepal. Authors and co-authors and institutions are included in this slide. Presentation outline of this thesis presentation. Background: tuberculosis is a significant public health problem around the world, most prevalent in the developing country, including Nepal. TB continues to pose a serious threat to the population health, accounting 80% of the case among the age group 15 to 49 years, which is the productive age of life. Tuberculosis is the 7th leading cause of death among this age group, which is the preventable and curable. Adherence and health-related quality of life are the two outcomes representing different points in the time flowing process of care. Adherence is an intermediate outcome or process variable, while a health-related quality of life is an ultimate outcome. Medication adherence is associated with the health-related quality of life of tuberculosis of patient. A research objective, general objective, to determine the factor associated with medication adherence and its effect on health-related quality of life among tuberculosis patients in selected district of Gandaki province. A specific objective, research methodology. study design, health facility-based cross-sectional study method, quantitative method, study setting, Gandhi province of Nepal, 3 districts included in the Gandhi province. Study population, the study population were all the TB patients who are under medication from the DOT center of Gandhi province of Nepal. Inclusion criteria, all the TB patients registered under the DOTS therapy and who were complete 60 days under DOTS medication in the selected district of Gandhi province. And TB patient, TB medication patient who were above the 15 years of the age is included in this study. And techniques, face-to-face interview method and tools, structure questionnaire and WHO QL brief questionnaire and Morisky scale questionnaire used in this study. A map of this research including the 3 districts of Gandhi province, Kaski, Tonhau and Navalparasi. Sampling of procedures, these were the selected of the multi-stage sampling methods. Among the 11 districts in the Gandhi province, Kaski, Navalparasi East and Tonhau district which has highest tuberculosis patient load were selected of this study. Among 160 DOT center in the 3 selected districts, 22 DOT center was selected from the Kaski 8 DOT centers, Navalparasi 5, Tonhau 9 district 9 DOT centers based on the TB case loaded. Required sample size was determined based on the probability proportional to size of the total TB case from the selected DOT centers. TB patient to be interviewed were selected randomly from the sampling frame. This is the flow chart of the sampling techniques. Ethical considerations, ethical approval was obtained from the Nepal Health Research Council and administration approval was obtained from School of Health and Allied Science Pokhara University and Ministry of Social Development Gandhi Province, Province Health Director Office and Health Office Kaski, Health Office Tonhau and Health Office Navalparasi. Results. Socio-demographic characteristics of the participants. Majority of the participants were the 15 to 40 years. 65% were the male and 82.8% were the Hindujans and 84.4% is the living in the urban area and more than half of respondents were nuclear family. And educational status, 31.1% is the were basic education and secondary educations. And majority of respondents were the unemployed. A score of the health-related quality of life among the participants. In the health-related quality of life included 4 domains and overall quality of life domain included 5 domains. And total score is converted into 100 and minimum, maximum and mean and standard deviations included here. The participants with the score of 50 and above were classified as having the good health-related quality of life and less than 50 scores having the poor health-related related quality of life. And categorization of Morisky medication adherence scale, YMAS 8 among the participants. Here the 3 categorized, high adherence, medium adherence and low adherence. The categorized of the health-related quality of life based on the scores and medication adherence. In the right side, those participants had a good quality, good medication adherence and proper medication adherence had a good quality of life. And those TB patients had low medication adherence with have the poor quality of life. Are included in the blue color included the poor scores of the participants and the brown color indicated of the good quality of life. And adjusted relationship explanatory variable with the health-related quality of life. Here the independent variables and in the column side included in the domain of the quality of life, 4 domains. Treatment facilities association with the relationship or social relationship domains. And age is the association with the environmental domains. Religion is the physical domains. And treatment compliance is the association with the social domains. Experience of the side effect of the drugs is associations association with the physical domains. And medication adherence, medication adherence were not adjusted association with the quality of life. And adjusted relationship of explanatory variable with medication adherence in the 3 independent variable, the directly association with the medication adherence. Co-infection, though TB patient had the co-infections like diabetes and hypertension and other disease were association with the medication adherence. Those TB patients had the co-infections. There are the low medication adherence, and next the time favorable of the dot center is the association with the medication adherence and relationship with the health workers. Those TB patients had good relationship with the health workers. They had the good medication and proper medication adherence of tuberculosis medications. And major factor associated with the health related quality of life among the participants. Physical domain is association with the history of smokeless tobacco use and side effect of drugs and taking drugs. Those are co-infections. And psychological domain is association with the TB registration treatment category based in the national tuberculosis programs. And social domains, treatment compliance and the preferable time for the dot sensors and the relationship with the health workers. And environmental domain is association with the level of treatment facility, age and religions. And causal factor associated with medication adherence and health related quality of life among the participants. Three independent variables, those are directly association with medication adherence and quality of life. The variables included co-infections of TB patients and time favorable for the dot centers and relationship with the health workers. These three independent variables is the causal relationship with the medication adherence and quality of life. And conclusions, quality of life of TB patient was 55.96, standard deviation mean the 14.65, which defined the poor quality of life. More than half of the respondents were adhered to medications. Majority of tuberculosis patients adhering to medication had good quality of life. Medication adherence and health-related quality of life was found associated with co-infection, relationship with the health workers, and favorable time at dot center. Medication adherent TB patients were not statistically significant with the domain of health-related quality of life in multivariate analysis. Especially emphasis should be given to tuberculosis patients with the co-infections. Health workers should be behave friendly and provide appropriate counseling in order to maintain the medication adherence and quality of life. Those TB patients have the co-infections and this type of TB patient more counselings and proper education to provide during the medications. In addition, this study suggests to favorable time for taking medication by the TB patient in morning time. So the concerned health institutions and our providers should be advised about this factor in order to ensure the medications. Reference. This paper is published in the Journal of Clinical Tuberculosis and other Mycobacterium tuberculosis. Thank you.
Thank you, Rajesh, for your presentation. We will come back to questions and other discussions afterwards. I now pass on to Professor Serchan for inviting another speaker. Professor Serchan, please.
So now after Dr. Rajesh Kumar, very good presentation. Now next is Dr. Sushant Pandey. Please kindly present your paper on awareness of cross-infection. Dr. Sushant.
Greetings everyone attending the summit. I am Dr. Sushant Pandey and currently I am working as dental surgeon at BP Koral Institute of Health Sciences, Dharan. And today I am here to present a study which we conducted at BP KSS itself, titled Awareness of Cross-Infection and its Control Measures Among Patients Attending College of Dental Surgery, BP KSS, Dharan. So without any delay, let's start the presentation. The term cross-infection can be simply put as transmission of infectious agents between patients and staff in a clinical environment. A dental clinic invariably carries the risk of cross-infection due to the nature of its procedures, which involves frequent exposure to bodily fluids and handling of sharp instruments. Pathogenic microorganisms such as hepatitis B virus, hepatitis C virus, HIV, Mycobacterium tuberculosis have been associated with cross-infection in a dental setting. These microorganisms, they usually are transmitted by blood, saliva, or aerosol. And contaminated instruments play a major role in this transmission as well. Dental healthcare professionals frequently use gloves, masks, spectacles, and they routinely autoclave their used instruments in order to prevent cross-infection in their dental setup. It is equally important for the patients to understand what cross-infection is and why do dentists use these protective barriers. Because I want to share with you some data. Moving over to the next slide. A study by Umaga et al. Found over 600 dental clinics in Kathmandu, which were solely being run by dental hygienists. In Nepal, dental hygienists are not permitted to perform full-fledged dental treatment procedures on their own. And the same study also found that such clinics typically do not adhere to strict sterilization protocols. In another study by Pradhan, in Kathmandu itself, they found that only 34% of the dental clinics in Kathmandu were using autoclave to sterilize instruments, while majority of them were using boiling water. So from these facts, we can understand that the knowledge of cross-infection as well as infection control in patient is important. If they have that knowledge, they will stop visiting such dental clinics with low standard of infection control. Although misconceptions about cross-infection and its control measure have been revealed by several surveys carried out in other countries, similar information about the Nepalese population is not available. Hence, this study was designed with the main objective to assess the awareness of cross-infection and its control measures among patients attending College of Dental Surgery at BPKHS Dharan. This study was carried out for 3 months, and it's a cross-sectional descriptive study, and the sample size of 128 was calculated. Convenient sampling method was used for sampling, and a questionnaire was used to collect the data. A questionnaire used in previous study, which was originally in English, that was translated and validated in Nepali by forward-backward method, and the same questionnaire was used to collect patients' data. The questionnaire consisted of 14 questions. The 4 questions were designed to obtain the socio-demographic information, like age, gender, education level, and number of past dental visits. And the remaining 10 questions were close-ended, and they were aimed at assessing the awareness of cross-infection and its controls among the participants. The questionnaire was administered by one of the investigator himself, because not all the participants in the study were literate. Moving on further, talking about the results, out of 128 participants, 66 were males, 62 were females. The age of the participants ranged from 18 to 68 years. And talking about their education level, 48.5% of the participants had completed their education up to or lower than secondary level, that is class 10, and the remaining 51.5% had completed higher secondary education level or above degree. The main findings of the study, these are the questions. Okay. So the first number question, which inquired if there was any possibility for transmission to occur from a doctor to a patient. In that study, for that question, 82.1% of the participants agreed. Similarly, the other question, which inquired whether it was possible for an infection to be transmitted from a patient to a doctor, around 80% of the participants agreed. The third question, which inquired whether it was possible for an infection to be transmitted from one patient to another attending the same dental clinic, around 70% of the participants agreed, whereas the remaining 30% had no idea about this. From here, we can see the awareness about the transmission between doctors and patients that was adequate, whereas the knowledge of transmission between the patient themselves was inadequate. Similar findings have been reported by studies from other countries as well, like study from Sri Lanka by Ratnanaike et al. They reported similar findings, and another study from India, they reported similar findings. One thing which I would like to point out is that this study of ours was conducted at the start of the COVID-19 pandemic, and during that time, rigorous campaigns were being done by government, by the mass media and social media regarding the importance of face mask and cross-infection. And these awareness campaigns could have increased the participants aware. These awareness campaigns could have impact on their awareness as well. Regarding the importance of gloves and face mask, majority of the patient, you can see a 94.5 and uh, 85.9% participants respectively believe that a dentist must use a face mask and gloves to treat their face while treating a patient. The question number 6 and 8, which inquired if gloves and face mask protected only the dentist, or was it beneficial for both the dentist and the patient. There we can see that nearly 81% of the participants believe that it was important for both. And in question number 8, nearly 79% participants believe that face mask protects both the dentist and their patient. Here we can see that there are still a few misconceptions that has been revealed by some other studies as well. A study in Nigeria that they found out that patients generally endorse the use of gloves more than face mask. That was because the patient perceived that gloves was for their own benefit, whereas face masks were primarily for the benefit of the dentist themselves. And talking about question number 10, the overall knowledge of proper method of sterilization was found to be low in the study participants. As you can see, only 40.6% of the participants knew other ways, the better ways of sterilizing instrument other than boiling in water. Awareness of autoclave, that is the proper method of sterilization, has been reported to be low from many other countries also, such as in India, Sri Lanka, and Nigeria. But they have been reported to be high in countries such as England, the developed countries. And the awareness in England the higher awareness in England has been attributed to the various awareness campaigns conducted by the government on the mass media and the social media platforms. From these results, chi-square test was done to check the association of awareness with gender, education level, and number of past dental visits of the patient. Awareness was found to be higher among participants with higher education. Similar finding has been reported from other studies done in other countries as well. Finally, to conclude this presentation, I would like to say that there are still some misconceptions prevailing in the public regarding the transmission of infection between people attending the same dental clinic, as well as misconceptions about the proper sterilization method. We, as a healthcare worker, can have a key role in informing patient about the proper methods of sterilization or the proper knowledge of cross-infection. And the modern mass media and social media, they have been successfully used in other countries as well to help reach a larger section of population. They can be used in our countries as well to aware a larger number of population, a larger portion of the population. With this, I would like to conclude my presentation. Thank you.
Go ahead, Professor Prakash.
Thank you, Jivan sir. Thank you, Sushant, for your presentation. I now call upon Dr. Gunaraj Dungana on the topic therapeutic efficacy of bacteriophage therapy to treat carbapenem-resistant Klebsiella pneumoniae in mouse model. Dr. Dungana, over to you.
Namaste. My name is Gunaraj Dungana, PhD researcher from Central Department of Biotechnology, Tribhuvan University. Today I am going to present on therapeutic efficacy of bacteriophage therapy to treat carbapenem-resistant Klebsiella pneumoniae in mouse model. as we all know, global emergence of antibiotic resistance is a critical problem in modern medicine. Several million of people are dying in each year with antimicrobial resistant infections. It is estimated that 10 million people will die due to AMR in 2050. So the world is heading toward the post-antibiotic era, and WHO has also prioritized several microorganisms as a critical for the research and development of new antimicrobial agents. Among them, Klebsiella pneumoniae, especially carbapenem resistant, is prioritized as a critical group 1. So what are the possible solutions to mitigate this antibiotic resistant crisis? Among many options like probiotics, antimicrobial peptides, immune stimulation antibodies, phage therapy and phage-derived lysins are one of the promising agents. So what are bacteriophages? Bacteriophages are virus that naturally infect and replicate inside the bacteria. The bacteriophage was co-discovered by Frederick Todt and Felix Herrle independently. Bacteriophage has a special receptor binding protein in their tail, and they attach to the surface specific host and insert their genomic material inside the cell. The phage genomic material hijacked machinery of bacterial cell and synthesis of new phage particles, ultimately release the phage particle with the lysis of the cells in lytic life cycle. So in phage therapy, we use a lytic phase for the therapeutic purpose. And there are several examples are being used in Western countries in like America and Europe to treat antimicrobial resistant infections as a personalized therapy. So objective of this research project is to screen, characterize lytic bacteriophage physiochemically and molecularly from rivers of Kathmandu Valley, to explore lytic capabilities of isolated bacteriophage against multi-drug resistant bacteria and assess their potential use in phage therapy in mouse model. So essentially, we isolated phage against carbapenem resistant clinical isolates, Klebsiella pneumoniae known as KP56, which was characterized as carbapenem resistant molecularly. And we used that bacteria as a host, and we collected sewage sample to isolate bacteriophage. Here we can see here bacteriophage lies on the lawn of host bacteria in the form of plaque. Later on, we characterized morphologically using transmission electron microscopy. It was done in Jawaharlal Nehru University, India. And here we can see the phage particles having capsids and short tail belonging to caudoviral family. And we did experiment of the phage to tolerate its thermal stability and pH stability. The phage was found to be stable at 25 and 37 degrees Celsius without significant loss of its titer for up to 180 minutes. Similarly, pH stability also was good, and having optimum pH around 7 to 8. So after that, we did genomic characterization using whole genome sequencing. We used a MySeq platform. And after whole genome sequencing, we did several bioinformatic analysis, annotation of the predicted genes, and we found that phage was quite strictly lytic, and it did not contain any toxic or virulent genes inside its genome. Here we can see outside of this ring showing 45 open reading frames. Its size was found to be 41,000 kilobase pair. And these are predicted genes inside this genome. And this complete genome was submitted to the NCBI Gene Bank. This is the first report from Nepal to submitted to the NCBI Gene Bank. So after considering the phage is as a potential candidate for therapeutic purpose, we did animal model experiment. We did animal model experiment in Swiss albino female, Swiss albino mice. In Central Department of Biotechnology, we did experiment in two models. One is pharmacokinetics and pharmacodynamics model, and one is infection model. Groups of mice were injected with, in pharmacokinetics model, group of mice were injected with SM buffer as a vehicle control and phase only control. And after intervention, we killed the mice after 1 hour, 4 hour, 8 hour, 24 hour, 48 hours, and 72 hours to see the bioavailability of the phage inside the different organs of the mice. In infection model, we infected the mice with lethal dose of Klebsiella pneumoniae in one group, and similarly we treated with the SM buffer only. And another group of mice were treated with phage that we named as a KP Pocalde 002 through the intraperitoneal route, and another group with oral route. So minimum lethal dose was found to be 10 to the power 8 CFU per ml, which is considered as lethal dose, and we injected that dose to the mice. After intervention, we collected blood, kidney, spleen, liver, lungs tissue to estimate and determine the bacterial count and phage count. And from the blood sample, the pro-inflammatory cytokine markers, we did expression analysis by the real-time PCR, two of the inflammatory cytokines known as IL-6 and TNF-alpha. So this result shows the phage therapy 100% survive rate was found in the intraperitoneal treated through the intraperitoneal route, and 40% survivability of the mice was recorded through the oral route. And when mice infected with lethal dose of KP56 and treated with the SM buffer only, they died, 100% died within the 3 days of the intervention. So the pharmacokinetics also, parameters also was analyzed through the IP route. Their highest phase concentration was found after 4 hours of injection in the IP route, and similarly in the oral route, the phase distribution was found to be highest in the body organs after 8 hours of the injection. Similarly, in the presence of bacteria, the half-life of the phage inside the body was found to be quite longer as compared to in the absence of host bacteria inside the body. Here we can see in the figure A, the phage titer is high at 24 hours in IP route and oral route in the presence of host bacteria. We did histopathological examinations of lung, and we found that the infected and phage-treated mice lung tissue was found to be lesser extents of macrophage infiltration of interstitial fluid with macrophage and neutrophils, and repairing rupture of alveoli too. In this picture, we can see the pro-inflammatory cytokines level. The fold change in pro-inflammatory cytokine messenger RNA expression was found to be significantly lower in phase treated through the both IP and oral route as compared to the untreated group. So the bacterial quantification also was done. It was found that the bacterial load inside the body in different organs was found to be lower, significantly lower with the treatment with oral and IP route in both organs, in blood and lungs. So the conclusion, novel lytic phase was isolated against carbapenem-resistant Klebsiella pneumoniae from the river of Kathmandu. Whole genome analysis confirmed that the phase was strictly lytic and belonging to caudovirus family, and did not contain any virulent genes, and considered as excellent therapeutic candidate. The phage therapy using both intraperitoneal and oral routes sufficiently rescued the carbapenem-resistant pneumonia infection. As compared to oral route, IP route of the phage treatment showed 100% survivability. After treatment with the KP Pocalde 002, the bacterial count was significantly reduced as compared to untreated, and the expression level of pro-inflammatory cytokines TNF-alpha and IL-6 was found to be lower. Histopathological examination was also found lesser extents of lung infections, and can be considered as a best candidate for the phage therapy. I would like to acknowledge Central Department of Biotechnology, whole team, and National Cancer Institute Laboratory of Molecular Biology, NIH. Thank you.
Thank you, Dr. Dungana. I now pass upon to Professor Serchan for calling upon another candidate. Please.
Thank you, Dr. Dungana, for a very good presentation. Now I would like to request Kancha Srestha for his presentation on leprosy transmission. So, Dr. Kanta, please present your paper.
I'm Divya. I'm presenting on behalf of Kansa Sreshta, who is the first author of this presentation. Our presentation topic is leprosy transmission patterns of Nepalese family settings, a retrospective hospital-based study. In this study, we are trying to see how one member of a family will transmit disease to other member of the family. In Nepal, majority of Nepalese family are living in joint family settings, and the role of males and females are different. For example, males are more active in income generating activities, while females look over the household work of the family and rear the children. According to different epidemiological studies, it is very widely believed that household contacts of leprosy patients are more at risk compared to other people in the society. So if a person in a family is getting leprosy, there is more chance that he will transmit the disease to other family members in the same family. And it is also believed that leprosy is transmitted by aerosol and droplets. There are about 3,000 cases every year in Nepal. The objective of the study was, as we talked earlier, to see the dynamics of transmission of leprosy to better understand the risk factors of leprosy transmission within family households. The methodology of the family of this study was that it was a retrospective cohort study. We enrolled patients. We enrolled the patients when the family member of the same patient was diagnosed in our hospital earlier. For example, we divided patients as primary and secondary cases. Primary cases were those cases where the patient was diagnosed in our hospital. After a few days, months, or years, if a family member of the same family was diagnosed at our hospital, then we enrolled such peers in our study. We divided the age group into 0 to 5 years, 6 to 18 years, 19 to 60 years, and more than 60 years. This is because 0 to 5 years and 6 to 18 years give a specific activity. For example, until 5 years, we depend upon our parents. From 6 to 18 years, we are usually, or Nepalese people are usually involved in various school activities, and after school activities or other activities, and after 18 years, in general, we get married. Until 60 years, we are economically active, and after 60 years, we are retired. Other technical term used in this presentation is skin smear or bacterial index. This is the presence of bacteria in the smear of fluid taken from skin. For example, the ears. If there we can see bacteria in the smear, we call them skin smear positive. Otherwise, they are negative. Results. This is the breakdown of age of patients in the primary and secondary cases. In our cases, we can see the average age is similar in both primary and secondary cases, but there's a slight increase in standard deviation of the secondary cases. The range of age is also same. We found in our study that the number of males in the primary cases or the disease transmitters is higher compared to the secondary cases. When we compared the duration of disease before the diagnosis, we found that the primary cases were diagnosed late compared to the secondary cases. This may be because the primary cases were enrolled in 1960s or 70s where people were not aware of leprosy, so they took a lot of time before the leprosy was diagnosed. In this study, we found that parents were the biggest contributor of leprosy transmission in the family. This was followed by siblings, brothers and sisters, then offspring, then spouse, and then other relatives like uncles, grandfather, grandmother. When we looked at the contribution of parents to cause disease in females aged 6 to 18 and then 19 to 60, we found that the secondary female cases aged 6 to 18 were caused or were disease transmitted by their parents in higher proportion compared to the females of 19 to 60. This could be because after 18 years of age, the females get married and go to their husband's home, and before 18 years of age, they are still in their family, and parents are the more there is more chance that the parents will transmit the disease. This is not seen in the cases of secondary male because the male will remain in their family even after the marriage. We found that the skin smear positivity was higher in primary cases compared to the secondary cases, and this is also logical because the primary cases, if they are highly positive, they are more able to transmit the disease. Here we try to see if the male and female secondary cases, for male and secondary female cases, where the primary cases, males or females, while we find that for the females, the male to female ratio was higher, we could not find statistical difference between them. The conclusion of our study was that the first blood relationships like parents, siblings, and offspring contribute highest disease transmission. The transmission could be connected to male index rather than the other cases. Primary cases were more likely slitty skin smear positive. Female parents have parents as their primary cases when they were under 19 years of age. The average time to onset, duration of signs and symptoms before diagnosis was shorter in the secondary cases. We would like to acknowledge our friends and more the leprosy affected people whose data we used, and without which data we would not have been able to make this study. Thank you very much.
Thank you. Thank you, Kancha, for your nice presentation. I would now like to call upon Naveen Kumar Chaudhary to speak on prevalence of Helicobacter pylori infection among dyspeptic patients in Chitwan, Nepal. Dr. Chaudhary, please.
I'm Dr. Naveen Chaudhary from Department of Microbiology, Chitwan Medical College, presenting on the topic prevalence of Helicobacter pylori infection among dyspeptic in Nepal. Beginning with the background, Helicobacter pylori was discovered by Warren and Mercer in the year 1982 from gastric biopsy, stomach biopsy. Morphology of the bacteria is gram-negative, helical or spiral, motile with polar flagella. Habitat of bacteria is mucous lining of the stomach. This photograph a helical structure of Helicobacter pylori with the top of flagella at the mean, which resides in the stomach, and in some person it causes the gastric ulcer. This photograph is of the gram stent smear, which show the gram-negative, slightly curved bacilli. Dyspepsia is clinical syndrome, including manifestation related to the upper gastrointestinal tract, which may include acute, chronic, or recurrent pain or discomfort. More than half of the world population is infected with Helicobacter pylori. 80 to 90% of them are asymptomatic. However, about 15% of them get chronic gastritis, or ulcer, and in severe stage with an increased risk of developing gastric adenocarcinoma. The seroprevalence of Helicobacter pylori varies greatly among societies and geographical location. Understanding the prevalence and the factor associated with Helicobacter pylori sensitivity in dyspeptic persons can provide a guide for health policy. Moreover, it is still not clear which factors are associated with Helicobacter pylori infection among Nepalese citizens. We investigated the prevalence and factor associated with Helicobacter pylori infection among dyspeptic patients in Chitwan, Nepal. The objective of the study was to determine the prevalence of pylori infection in dyspeptic patients attending Chitwan Medical College Teaching Hospital. The specific objectives are to determine the prevalence of Helicobacter pylori infection in dyspeptic patients in relation to selected socio-demographic variables and to determine the association between prevalence of Helicobacter pylori infection and various lifestyle and symptoms presented by dyspeptic patients. Methodology. Study design was descriptive, cross-sectional. Study site was Department of Medicine, Gastroenterology Unit, and Department of Microbiology, Chitwan Medical College, Teaching Hospital, Bharatpur, Chitwan. Study population was symptomatic case of dyspepsia, visiting Department of Medicine, Gastroenterology Unit. Duration of the study was 6 months. Sampling techniques was non-probability consecutive sampling techniques. Sample size was 170. Inclusion criteria was patient of more than 10 years age, both gender and symptomatic case of dyspepsia. Exclusion criteria was the patient taking triple therapy for Helicobacter pylori eradication in past. Begins with the result. This pie chart showing the seroprevalence of Helicobacter pylori infection, which is 23.52% in the present study. Nearly similar, 22.1% was reported by Sam et al. This bar diagram showing the distribution of Helicobacter pylori based on gender. Among the positive cases, 67% was male and 32.5% was female, whereas in negative case, 56.2% was female, 43.8% was male. In our finding, the male 67.5 versus female 32.5. A similar finding, 56.3% among male versus 43.7% among female reported by Joshi et al. The reason may be the higher frequency of seroprevalence of Helicobacter pylori among male. The reason may be due to more exposure of male to alcohol, smoking, tobacco, and unhealthy and untimely diets. This table shows the distribution of Helicobacter pylori infection according to different age group. Age group are 11 to 20, 21 to 40, 41 to 60, and more than 60. So majority of cases was seen in the age group 41 to 60. A similar finding, 23.9% reported by Joshi et al., where the age group was 35 to 54. The reason might be the prevalence of Helicobacter pylori in middle age group patients. The reason could be possibly due to busy work schedule along with inappropriate and untimely food habits. This table shows the distribution of Helicobacter pylori infection based on number of family members. So family member up to 2, the positive 70 number, that is 18.48%, and negative 75, that is 81.52%. Whereas in a group of family member up to 10, the 23, that is 29.49%, and negative 55, that is 70.51%. So in this result, there is not much difference in the number of family members and occurrence of the prevalence of helicobacter pylori infection. But some of the research, like Ansari et al., reported that family with more members are prone to infection rather than family with less number of people. This table shows the distribution of Helicobacter pylori infection based on education. So it has been categorized up to education up to primary level, where 70% seroprevalence is seen, whereas in case of above primary level, 130% seroprevalence is seen. So our study shows that educated or literate people are less likely to be affected by infection when compared to uneducated people. A similar finding has been reported by Ansari et al. This may be due to the maintenance of hygiene, cleanliness, and awareness regarding the infection among educated people. This table shows the association between Helicobacter pylori status and various clinical symptoms presented by dyspeptic patients. The tables are nausea, vomiting, heartburn, sour eruption, bloating, bleaching, dysphagia, and weight loss. All the variables were statistically insignificant except sour eruption and dysphagia. A similar finding has been reported by Mabku et al., where the symptom heartburn, burping, bloating was seen in higher frequency. The presence of sour eruption in the Helicobacter pylori infection is possibly due to the increased acidic environment in the gastric. This table shows the association between Helicobacter pylori status and various lifestyle findings among the patients. Variables are smoking, alcohol, tobacco, diet, and socioeconomic status. Our study shows the people with habit of smoking, alcohol, and tobacco were more prone to the infection, as well as non-vegetarian had a higher frequency of infection as compared to vegetarian. Similar finding, higher frequency of infection among non-vegetarian been reported by Shrestha et al. But contrast to our finding, the habitual lifestyle such as smoking, alcohol, and tobacco were not directly related to the S. pylori infection reported by SMR. This may be due to the limited sample size, sampling area, and the area collected to different research. Instead,
Thank you, Mr. Chaudhary. You have crossed the timeline allocated for you. Moreover, your presentation is almost over. May I now ask Jivan sir to announce for another presentation. Jivan sir, please.
Thank you, Professor Prakash. Now I would like to ask to present Dr. Pramod Kumar Mehta regarding your presentation on transmission of lymphatic filariasis, transmission of lymphatic filariasis in the context of Nepal. Please, Dr. Pramod Kumar Mehta.
Okay. Namaste. सबैजनालाई. So my research title is Transmission Status of Lymphatic Filariasis in Human Population and Mosquito Vectors after 8 rounds of mass drug administration in rural area of Lalitpur. So this is my research title. So this is outline of presentations. So lymphatic filariasis is caused by the lymphatic group of nematode and most commonly Wucheria bankrupti. These parasites are transmitted by the different species of mosquito belonging to the genus Culex, Anopheles, Aedes and Mancomia. So more than 90% of Wucheria bankrupti which is transmitted by vector Culex cungifacitus, and globally 1.3 billion people are at risk of infection and about 120 million people are affected in more than 80 endemic countries in the world. So 25 million people are at risk of infection in 61 districts with LF in our country. So for this annual mass drug administration to eliminate lymphatic filariasis was launched in 2010 in my study area, and 8 rounds of MDO were completed in 2017. So antigen survey was carried out in 2017 as a part of transmission assessment survey to assess the impact of program. Result indicated that there was not recent transmission, but due to a cluster of antigen positive cases in some foci, there may risk of resurgence of infection. So this study was carried out to assess micropiria prevalence, antigen prevalence among children born after starting of MDA, infection and infectivity of vector mosquito, and chronic clinical manifestations such as hydrocele, elephantiasis, and in selected community. So this is my study area. This study was conducted in rural area of Lalitpur districts, Kathmandu Valley, and the district population was around 5 lakhs. Study area was purposefully selected for the study due to its story of high infection persistent of lymphatic filariasis. 8 rounds of annual mass drug were completed in between 2010 and 2017. So district has 6 municipalities, including 3 rural municipality and 1 metropolitan city. So Bugmati and Lalitpur metropolitan city and Dukuchaf of the Godavari municipality were the selected for a study. The present study was conducted in May 2020. So this is a reported treatment coverage in my study area during a MDA. And this is a sample size which I calculated and which I was collected. So in Lalitpur, Bugmati and Dukucha, for MF prevalence, I have calculated 385 samples. Out of this, 394 sample I have collected. And for antigen prevalence, 173 samples I have calculated. So for this 176 sample I had collected from my study area, and vector collection was done. So 1,275 vectors, mosquitoes were collected from my study. So these are the different materials which I was used in my study. So these are the different gravity trap, sucking a spectra, infrozen hair, and a stereoscope, test kit, and GPS. These are the different instruments which I was used my study. So method of data collections. So MF prevalence was carried out by night blood collection of finger prick method. Antigen prevalence in children which was born after MDA was carried out by immunochromatographic test, and vector infection and infectivity was carried out by collection of vector mosquitoes by gravity trap method, and collected mosquitoes was dissected. Drug uptake during MDA and chronic clinical manifestations such as hydrocele and elephantiasis data were collected by interview method during a study in community in 2020. Data analysis. So data were entered in Excel spreadsheets and subsequently analyzed with the Minitab 17 versions, and blood test result of circulating filarial antigen and MF, the presence of hydrocele or elephantiasis, demographic characteristics, and MDA complaints were compared by using a chi-square test, and p-value less than or equal to 0.05 were considered statistically significant. The lower and upper limit of the 95% confidence interval for the prevalence of microfilaria and antigen were calculated. So result, MF prevalence and disease burden, antigen prevalence and disease burden, MDA complaints concerning LF infection status, and entomological data of mosquito dissection analyzed for infection and infectivity with Wucheria bankrupti using microscope. MF prevalence and disease burden, so total 394 individuals above 10 years old, a range of 10 to 80 years old individuals were screened for microfilaria, and the overall male-female ratio was 0.8, and mean age of the participant was 39.77 years. So out of 394 individuals screened for LF infections, so 0.3% had microfilaria. So only one case was found microfilaria positive cases. So single cases was found that positive. Of the 52 individuals found with the chronic clinical manifestation of lymphatic filariasis, out of this 6.1% had hydrocele and 7.1% had a elephantiasis was found in my study. So no one individual with elephantiasis was found to have a microfilaria. So this table is showing the prevalence of MF and clinical manifestation of lymphatic filariasis infection by gender and age-wise in Lalitpur. So gender and age-wise, there is significantly more infection of elephantiasis in age group of more than 41 years individuals. So this table is showing that prevalence of MF and clinical manifestation of lymphatic filariasis infection by ethnicity-wise in Lalitpur. So in different ethnic group, ethnicity-wise, clinical manifestation of LF in Nepal ethnic group was significantly more infected in compared to other ethnic groups. Reported drug uptake in relation to their LF infection status. So in reported drug uptake in previous MDA and reported drug uptake in last MDA, that is 2017. So in comparative study, out of 394, 73.1% reported having a participated in at least one previous MDA round, while 74.9% participated in at last round of MDA. So individual who did not participate in any of the previous round of MDA were significantly more infected in compared with those with a recent history of participating in MDA. The percentage proportion of male with hydrocele was significantly higher in individuals who did not swallow drug in any MDA round, but not significant difference in elephantiasis. So table 6, prevalence of circulating filarial antigen and clinical manifestation of lymphatic filariasis infection by gender-wise in Lalitpur. So in gender-wise, total 176 individuals are screened for antigen and chronic clinical manifestations such as hydrocele and elephantiasis in age group of 6 to 10 years. So the overall male-female ratio was 1.1 and mean age of the participant was 9.1 years. Of 176 individuals screened for LF infection, 0.6. Only one individual found to be a positive for antigen, but that case was migrated from a different district, that is endemic district of Nepal. So there is no any local cases was found in that study area. So out of 176, 1.1% individual found with a chronic clinical manifestation of lymphatic filariasis with hydrocele, and no any one individual had elephantiasis was found in the age group of 6 to 10 years. So none of the individual with a hydrocele or elephantiasis were found to have a circulating filarial antigen. So prevalence of CFA and clinical manifestation in lymphatic filariasis infection by age and ethnicity wise. So never ethnic group of 8 to 9 years had hydrocele. None of individuals had a elephantiasis. So LF transmission indices, that is entomological data. Our total of 1,275 mosquitoes were collected using CDC gravity trap, of which 86.3% were collected Culex skinky facetus. So out of these, 13.7% were non-filarial other mosquitoes such as Culex vishnae, Culex pseudovishnae, and Anopheles mosquito was identified in my study. So filarial mosquito were dissected for parity and laboratory, and 979 Paros vectors were examined under microscope for infection with Wucheria bankrupti. None of the examined mosquitoes found to have infection with Wucheria bankrupti larva of any one stage. So there is no infection and infectivity was found in my study. Entomological data of mosquito sampling. So this is showing in the total collected mosquito, total dissection, and other mosquito was collected. So entomological data of mosquito dissection and analyzed for infection and infectivity with, there is no any infection or infectivity was found in my study. So summary of the infections, so total MF positive cases and only one, and total antigen positive case, only single one case was found, but that one case was from other district of Nepal.
Thank you, Dr. Mehta, for your nice presentation. Before I go on the comments and questions on the chat box, may I now come up onto my co-chair, Professor Serchan, to kindly provide your feedback, comments, and questions if there is any. Dr. Serchan, please.
Okay, thank you, Professor Prakash. I think there are a number of questions, but I think before that, I think we have to give the priority to our audience. If any questions from the audience, I think all of them are welcome for their queries and comments, and then I will provide some my comments and feedback also. So first, I think I would like to give the priority for the audience.
Thank you, Jeevan sir. Let me quickly summarize the questions which were asked in the question box. The first presenter, which is of quite interest to us and everybody at this pandemic stage, lots of questions on the box, including questions from Jeevan Sake, Dr. Basudev Pandey, Jeevan Sake, Madhav Chaulagai, and many others. The major question is, how do you claim with a limited number of samples the second wave in Nepal is due to Delta plus variant? This is one of the major questions. And with these 5 samples, the high variation in depth of sequencing, how do you respond to that? This is another question. And another question is from where the samples were taken, and these 5 samples were representative of the country. So this is a major question to the first presenter. There are questions to others in the chat box, which others will definitely respond. If Naveen would like to come back to quick response, please, Naveen.
Hello, good morning everyone. Thank you, chairs. First of all, I would like to start with the question from Dr. Vasudev Pandey regarding the severity of cases. And yes, we considered samples from cases with variable severity, which ranged from even asymptomatic cases to even the diseased cases. And to continue with another question regarding the variable sequencing depth. As I mentioned, there were variable severity and the samples had variable CT values as well. And this could be one of the reasons, but it requires more sequencing to confirm the same. And yes, the new variation is confirmed by whole genome sequencing only to address one of the questions. And I would like to particularly thank Mr. Kamal Ranawat for his interest and query in the section. And from our data, so regarding the main question here, that how do we claim it is Delta plus that could be involved in the second wave. So we are saying that the Delta variant is majorly responsible for the second wave, and which includes Delta plus variant as well. So from our data, out of 5, it is just only 5 samples which were Delta variant, but significantly 2 of 5, which accounts to 40%, includes the K417N mutation. So although sample size is low, I agree we need more sequencing to give a strong evidence, but it is well evident that K417N mutation is prevalent in the Delta variant in Nepal population. So to address the other questions from Mr. Madhav Chaulagai, the samples were from Dhulikhel Hospital and from the Kathmandu labs. The one of them to mention is Janamaitri Hospital, and the sample was facilitated by the NHRC team to our sequencing facility. And the origin of the sample is adequately acknowledged or mentioned in the GIS AID submission as well. The other questions regarding the travel history was during the peak of the second wave, the samples or the cases we collected did not have any travel history too far of our knowledge. And regarding the other questions on our effort to sequencing, so due to the limitations of the sequencing lab or other priorities which are set by WHO to sequence the sample, so we can do the sequencing in our facility also, but yes, the ministry had sent to the Indian, which is not the same samples. If I have not addressed some questions, I would be happy to check the Q&A sections.
Thank you.
Thank you, Chairs.
Thank you, Naveen, for your clarification. There might be several questions which you and we may not be able to answer everything at this moment of the time, but there are questions to other authors also. There are questions to Gunaraj, there are questions to Mehta, there are questions to others. Please kindly respond to the chat box on those specific questions which are very pertinent, but in the interest of time, may I now come back to Jivan sir for your remarks.
Thank you, Professor Prakash. I think all the 7 presenters, they have presented very nicely. I think most of them presented very innovative things also, and which are very useful for the new researchers as well. The first presenters, Naveen Adhikari, I think he highlighted mainly for this genomic analysis of SARS-CoV-2. I think that will initiation for the second wave of COVID-19 in Nepal. I think this is very, but I wonder how this Delta variant become more virulent is a very questionable question for Naveen Adhikari. And regarding the Rajesh Kumar Yadav, I think he highlighted on tuberculosis that he mentioned that there is a special emphasis need to educate the tuberculosis patient with the co-infection. So I think he need to elaborate which are the factors that is responsible for the co-infection of the tuberculosis. I think this is also need to be highlighted. And the next is Dr. Sushanta Pandey. I think he presented very nicely. And regarding his in conclusion, he has not elaborated that there is a lack of awareness of regarding transmission from one patient to another, and regarding proper method of sterilization, that has to be highlighted and need to be studied further. Regarding the Gunaraj Dhungana, I think presented very innovative work in animal experiment as well. But I little bit wonder how you will verify this phase therapy that provides that evidence of successful phase therapy against the carbapenem-resistant Klebsiella pneumoniae, which is experimentally infected in mouse model. I think this is very innovative, although there are a number of verifications as required. And Kancha Shrestha also highlighted a very nice presentation regarding, but I didn't wonder, this is the retrospective study, and the study was conducted only in a single center, hospital-based study, which initiated toward the interpretation was in the only single-based hospital. So the interpretation is little bit confusing. However, I mean, this will provide more evidence and more outcomes that will further help for the future study. And Naveen Kumar Chaudhary, I think he presented very nicely. And but this S. pylori is of course responsible for the gastric carcinoma, and of course you mentioned that there is a dyspepsia. But I have some number of questions that how these low-income people and low-educated people and their smoking habit and alcohol having will have a more evidence of the S. pylori infection. That has to be highlighted by sufficient evidence. And also there is a high degree of infection was found among the male population in Nepal compared to female. And I think he has to provide some more evidence why this male population gets the high infection of S. pylori compared to female. Maybe due to there are a number of factors. I think still there is a need for the study. So the last presenter, Dr. Pramod Kumar Mehta, also highlighted on lymphatic filariasis, the transmission of lymphatic filariasis. But there's little bit confusion and conclusion. I have read that the interpretation of results need careful understanding and correlation of familiar relationship dynamic in Nepal. What it means? Could you kindly elaborate the careful understanding means? Because you have you conducted number of studies, but you did your questions at the end of the conclusion. So that has to be highlighted very clearly whether what type of contribution your study has proved or contributed for the policy in terms of this lymphatic filariasis elimination program. So I think these are my conclusion and comments.
Thank you. Thank you, Professor Serchan, for your summarizing what has been presented by different participants and what were the questions and some of the queries which you have mentioned. In the interest of time and interest of session, my summarization is all good work, but there are some lacunae which we need to improve in the coming days. I'm sure with these comments in the comment box, which the presenter have received, if you are able to address those things, your publications would have very less comments. With this, I would like to thank all participants and my co-chair for taking your time to listen, present, and discuss. Thank you. Thanks a lot. And I now pass it on to the organizers to pass into others. Richa, over to you.
Thank you, Chairs, for your valuable remarks. We would like to congratulate and thanks all the presenters for bringing their valuable findings. Now, I would like to request Professor Dr. Gehenath Baral, Chairperson of NHRC, to present token of love to our distinguished chairs of the session. With this, I wrap up the session. Now I will hand over the session to Mrs. Alina Khatri. Thank you.
नेपालको स्वास्थ्य क्षेत्रमा उच्च स्तरीय वैज्ञानिक अध्ययन र गुणस्तरीय अनुसन्धान गर्न नेपाल स्वास्थ्य अनुसन्धान परिषदको स्थापना भएको हो। नेपालको स्वास्थ्य क्षेत्रको अध्ययन अनुसन्धान गर्न विक्रम सम्वत 2039 अर्थात् सन् 1982 मा तत्कालीन स्वास्थ्य मन्त्रालय अन्तर्गत नेपाल स्वास्थ्य अनुसन्धान समिति गठन भयो। वास्तवमा तत्कालीन स्वास्थ्य मन्त्रालयका सचिवको अध्यक्षतामा गठित नेपाल स्वास्थ्य अनुसन्धान समितिले नै नेपालमा स्वास्थ्य क्षेत्रको औपचारिक अध्ययन अनुसन्धान सुरु गरेको हो। विक्रम सम्वत 2047 मा नेपाल स्वास्थ्य अनुसन्धान परिषद ऐन नम्बर 29 जारी भएपछि 2047 चैत्र 29 गते अर्थात् 12 अप्रिल 1991 मा नेपाल स्वास्थ्य अनुसन्धान समितिलाई नै नेपाल स्वास्थ्य अनुसन्धान परिषदको रूपमा विकसित गरियो। 29 अप्रिल 1991 मा प्राध्यापक डाक्टर मृगेन्द्रराज पाण्डेलाई परिषदको अध्यक्षमा मनोनयन गरियो भने अन्य सदस्यहरूको पनि नियुक्ति गरियो। तत्कालीन स्वास्थ्य तथा श्रम मन्त्री माननीय श्री पद्मरत्न तुलाधरले 24 फेब्रुअरी 1995 मा नेपाल स्वास्थ्य अनुसन्धान परिषद भवनको समुद्घाटन गर्नुभयो।
हजुर के गर्ने भने उहाँ चाहिँ अनलाइन आउने पिडिएफ भएर छ उहाँको 2 घण्टामा हजुर त्यो त होइन Khatri, Research Officer at Nepal Health Research Council. I'll be hosting this session on nutrition. For this session, I'd like to invite Dr. Taranath Pokhrel and Ms. Pooja Pandey Rana to chair this session. Let's welcome our chair with big round of applause. We welcome you. Currently, Dr. Rana is a public health professional having 20 years of experience in nutrition program development in Nepal. Currently, she is serving as a chief of party in Suhara second project led by Helen Keller International, Nepal. She has published various research papers in different journals. Similarly, Ms. Rana had her expertise in program management, community-driven development models, health and nutrition, multi-sectoral programming, and evidence-based monitoring and evaluation. Let's welcome our respected chairs once again. Now, I'd like to welcome our presenters for this session. This is for your kind information that Q&A session will be at the end of this session. So I request participants to drop their queries at the Q&A box, which will be addressed accordingly. Now, I'd like to hand over the session to our respected chairs. Over to you, chairs.
Thank you, Elena ji. First of all, I want to introduce first presenter and call upon him for his presentation, Mr. Kedar Raj Parajuli. He is the first presenter of this session. Mr. Kedar Raj Parajuli is the Chief of Nutrition Section of Family Welfare Division, Ministry of Health and Population. Academically, he has done Masters in Public Health. Mr. Kedar has more than 30 years of experience on health sector in Nepal, from community level to ministry and managerial roles. He has published more than 8 peer-review articles related to nutrition in scientific journal. May I call upon Mr. Kedar Raj Parajuli for his presentation.
Good afternoon. This is Kedar Parajuli. Thank you, Mr. Chairman, respected chair and co-chair, intellectuals, senior and junior scientists, friends, observing this 7th National Health Scientist Summit, Nepal. I would like to thank you, NHRC Summit Management Committee, to provide me this opportunity as a presenter. With due respect, all of you, I will take a permission to present my paper titled Nutrition for We know very well nutrition is a critical part of health and development. Better nutrition is related to improve infant, child and maternal health, stronger immune system, safer pregnancy and childbirth, lower risk of non-communicable diseases such as diabetes and cardiovascular disease and longevity. Health is a lot better due to a cognitive development. To eliminate poverty and hunger everywhere in the country and planet, nutrition is the only path to move ahead. Nutrients are chemical compounds in food that are used by our body to function properly and maintain health. Balanced diet only provides such a nutrient in our body. Such a body will be strong, intelligent, with the ability to bond society, as WHO defined. Health is a state of physically, mentally, and social welfare. This is the content what I present today. We know that good nutrition is a basic need for everyone, an important factor influencing growth and immunity. And it is the foundation for healthy and productive lives and economic prosperity. Nutrition constitutes the foundation for human development by reducing susceptibility to infection, illness, and the disability and the mortality burden. So, investment in nutrition contributes for the health and economic prosperity of people and nations. This is the example. If we invest in our nutrition, we can get this type of benefits. So let's talk about nutrition for growth. It is a global effort to bring together country, government, donor and philanthropy, business, NGO and DO. It is a global pledging movement to drive greater action toward ending malnutrition and helping ensure everyone everywhere can reach their full potentials. The first Nutrition for Growth Summit was held in London in 2013. In 2017, stakeholders gathered in Milan, Italy for the Global Nutrition Summit. In 2019, Sun Global Gathering was held in Kathmandu, Nepal. And we are planning to hold the Nutrition for Growth Summit in Tokyo, Japan, especially focusing the continue to spearhead the effort to end the malnutrition in all its form. We have some key commitment of the Kathmandu Declaration too. In 2019, the big global gathering of Sun country was held in Kathmandu, and it has committed stepping up efforts to improve nutrition during the critical 1,000-day window from pregnancy to a child's second birth throughout the life cycle and targeting all forms of malnutrition, as well as transform global and local food system to deliver nutrition safe, affordable and sustainable diet within a planetary boundaries, and institutionalize a coordinated multi-sectorial, multi-stakeholder approach at all levels needed for a country lead, country drivers on movement as it's enter its third phase. Yeah, of course, government of Nepal also committed to the planning to practice delivering throughout the policy cycle, advocating, mobilizing for mass change, making a nutrition everyone's business, and strengthening capacity for impact at scale, multi-stakeholder action on universal challenge. And we are planning to conduct a summit in 2021, which brings together diverse actors to make progress towards ending malnutrition in all its forms by 2030. And it provides opportunity to transform the way the world tackle the global challenge of malnutrition and achieve the SDG target by uniting knowledge, resource, and commitments from countries, donors, NGO, business, and beyond. And it is ensured a good nutrition by adopting a stronger evidence-based nutrition policy at global, regional, and country levels, as well as pledging to increase financing for proven nutrition-specific and nutrition-sensitive intervention. Commitment to align and harmonize action across sectors and stakeholders. Making a commitment is an important feature for the Nutrition for Growth Summit in Japan, Tokyo. And the first Nutrition for Growth Summit was held in London in 2013, and it is committed more than $4 billion in a new nutrition specific commitments, as well as 19 billion committed in the nutrition sensitive area. Global Nutrition Summit, which was held in Milan, Italy in 2017, to track a pledge made in London and generated an additional $3.4 billion in nutrition pledges. At the Tokyo Nutrition for Growth Summit 2021 will be continue the Nutrition for Growth legacy and further accelerate the progress. And it is expected to get a new commitment to meet the 7 billion annual gap that remains to scale up the high impact nutrition intervention identified in the World Bank's investment framework for nutrition, which is the financing required to reach the World Health Assembly Global Nutrition Target by 2025. We have a key pledges of movement. In December 2020, there was a key event, Nutrition for Growth Year of Action launch event. The host was Government of Canada and Government of Bangladesh in a sponsor with Melinda Gates Foundation with the theme launching a year of action of nutrition to address effect of COVID-19, support greater gender equality and improve the health of women and children. Equally, we have planned to conduct a UN Food System Pre-Summit in 26 to 28 July 2021. UN and Government of Italy will be host, and its thematic area is generating momentum for the upcoming UN Food System Summit. Similarly, in September 2021, UN Food System Summit will be going to be held with the host of UN, and its main theme is strengthening food system to deliver safe, affordable nutrition for all. In December 6 to 7, 2021, the Tokyo Nutrition for Growth Summit event will be held, and Government of Japan will sponsor these events. Its focus on food, health, and prosperity for all and culminating a year of action on nutrition. We know that UN has declared the year of action from 2016 to 2025. It's a 10 years, which is called as a action of nutrition. And it's called as a decade of nutrition. I know we have some principle of engagement in nutrition for growth, like everybody should be, every country should be transparent about intention and impact, and be inclusive, and be right-based, and be willing to negotiate, and be predictable and mutually accountable, be cost-effective, be continuously communicative, act with integrity in an ethical manner, and be mutually respectful and do no harm. These are the 10 principles of engagement of nutrition for growth. Thematic area for commitment is identified, mainly the 3 areas. Number 1 is health.
Kedarji, I request to shortcut your presentation, please. We have a limited time. Yes. Just a minute left, please.
Health, making a nutrition integral to universal health coverage, because investing in nutrition services as a part of health system can lead to greater well-being and more equitable development. Food, building a food system that promotes healthy diet and nutrition ensure livelihood of a producer and are climate smart, because the way of the world produce and consume the food impacts people and planet. And resilience, effectively addressing malnutrition in a fragile and conflicted affected context, because people impacted by violence and instability are especially vulnerable to malnutrition, and young children in this setting need special attention. And these 2 cross-cutting areas like data as well as financing. And we have a 6 commitment type, like a political and the government's commitment, like commitment related to any intent and sustained action over the time by stakeholder group to advance food and nutrition on government agenda and attenuate the drivers and manifesto of the malnutrition. Policy commitment related to implementing any legal regulatory framework, policy, strategy and action plan relevant to improving nutrition, promoting healthy diets and attenuating the driver of the malnutrition. Financial commitment related to supporting increased financing for nutrition. Operational commitment related to supporting infrastructure and capacity building. Monitoring and reporting and the research. Commitment related to nutrition surveillance, data collection, analysis and reporting. Impacts, commitments in line with the World Health Assembly target and SDG and other relevant indicators such as food security and the diet plan. And we have some Nepal's action for nutrition for growth. Nepal is early riser of some countries since 2011 as an active member of global scaling of nutrition movement. National Multi-Sector Nutrition Plan is a national policy framework for nutrition, and the National Sun Movement of Nepal started implementation in 2013. Implementation of MSNP is strong means of achieve WHO target and the SDG target. Nepal organized Global Sun Conference in Kathmandu in November 2019, and Kathmandu Declaration was launched. This was the Kathmandu Declaration. Like scale of nutrition movement has been reached throughout the country, covering all. This is the Nepal's action for nutrition for growth. Scaling of nutrition movement has been reached throughout the country, covering all 753 local levels. After Kathmandu Declaration in 2019, during Sun Global Gathering, the nutrition sensitive and specific intervention has been ongoing nationwide. A task force has been formed by a lead of Chief of Nutrition of Ministry of Health. And yet with COVID-19 pandemic, most of the activities planned in MSNP second have been implemented. Together we are revealing what has been hidden to all. Our goal is better Nepal for especially our children. Improved nutrition, better lives. Thank you very much.
Thank you, Kedarji, for your excellent presentation and information on global initiative on growth, nutrition for growth movement. Thank you very much. and congratulations for presenting within limited time also. Now I request my co-chair Poojaji for introducing and calling upon next presenter.
Thank you, Dr. So our next presenter will be Mr. Anthony Girma, who's also a really dear colleague, and he'll be presenting on treatment of acute malnutrition in Nepal, which is a very relevant topic in context of COVID-19 pandemic. Anthony is a public health and nutrition expert who has more than 15 years of experience working in multiple African countries, and he currently works in Nepal as a nutrition lead in WFP, a Nepal office. Anthony has also worked in various INGOs globally, and he's an Ethiopian national with BSc and Masters in Public Health, including a PhD in Health Studies in Public Health Nutrition. So Anthony, the screen is yours. Antenna, are you going to share your screen? Zoom out. Anthony, could you share your screen again? It seems there's some technical difficulties. Sorry? Oh, you need to unmute. You're on mute, Anthony. We can't hear you. It seems there's some technical difficulties. Could someone look at it? We can share it now. Yeah.
Yes. So sorry.
We can see it now, Anthony. Go ahead.
Good. You can also hear me, right?
We can. So if you could press on slideshow. Yeah, it's clear
yes.
now. Yeah.
Sincere apologies. I encountered some technical difficulties. I would like to say thanks so much for Pojaji, Dr. Tara, for that nice introduction. Also the organizer for nice summit, also including nutrition as part of this important summit. Happy to virtually connect all colleagues, respected seniors, everybody on the call. Greetings. My presentation is very focused on wasting, management of child wasting, global challenge, opportunities, and practices, and sharing some lessons that can be applicable to Nepal context. Moving further with why child wasting, it's good to start to have that background information. First of all, as we all know, malnutrition is associated with more than half of child mortalities in developing countries like Nepal. Particularly wasting, when it is not treated, it increases risk of mortality of children significantly. We have enough evidence that severely malnourished children are up to 9, 10, 11 times at risk of death, while the same moderately malnourished children also at risk up to 3 times. The burden of wasting is also globally very high. In 2020, estimated 45 million children were found to be wasted, which is big number, much higher than the population of Nepal combined, of which 2/3 is estimated to live in Asia and the Pacific. Even though we have proven high impact interventions that can help us prevent and treat acute malnutrition, the attention, the coverage is low, uneven to some extent. And all this challenge has been further compounded by the current COVID pandemic, which is affecting various things starting across the food value chain, limiting access to food, particularly among the poor, also limiting access and utilization of essential health and nutrition services. So the already high rates of wasting in developing countries like Nepal is estimated to increase. There are modeled interventions that the COVID pandemic has already increased both cases of wasting as well as associated complications. Moving further, what data in Nepal is telling us about child wasting? So if we look into this data we have from DHS and Nepal Multi-Indicator Cluster Survey, the first thing we appreciate that we have the wasting rate has slightly decreased from 15% of 1996 to 10% in 2016 by as per the data of DHIS. However, the rate is so slow and is still very high, above the 10% global threshold of emergency level. Similarly, when we see data from MIX 2014-2019, the rate is still above high, even it is slightly increased from what it has been previously. Another thing, as you all know, in 2012, the World Health Assembly set some nutrition target, one of which is reducing child wasting to 5 and less than 5 by 2025. That target is further revised to reducing to 3 and below by 2030. If we see our data at national level, we are much behind those global targets. Moving further and looking at the data by province, both the DHIS and the MIX survey shows a huge variation of wasting across province, and the provinces such as Sudur Paschim, Karnali, Province 5, Province 2, and Province 1 are significantly contributing the higher cases of wasting in Nepal. Only Gandaki and the Bagmati are found to have less than 10% of wasting, and only Bagmati has less than 5, which is in line with that global target of reducing wasting to less than 5 by 2025. Given we are in 2021, only 4 years ahead, what will be this thing? So are we on track? So those are some of the questions we need to take into consideration in policy implementation and the research. Before that, recognizing this, I want to emphasize the commitment that has been put in place by national government as well as some development partners. As you all know, the CIMAM, Community Management of Acute Malnutrition, which is targeted to prevent as well as treat wasting, was initiated in Nepal a while ago, around 2007, within small districts, piloted and based on lessons. Some national level initiative was taken, including the development of IMAM guideline, Integrated Management of Acute Malnutrition guideline, which provides a continuum of care from prevention through community sensitization to outpatient treatment of wasting, both SAM and MAM, to inpatient treatment of child with wasting and medical complications. So that is, I think, huge move, commitment. Want to take the opportunity again to put in these kinds of things as part of national development things. Regardless of those comments, having guidelines in place and knowing what works well, if you look to the data, the most recent HMS data, I just borrowed this from one of the presentations recently made by Mr. Kedar Sanjay from UNICEF. Without going to the detail, in 2020, just last year of the Gregorian calendar, considering all factors, including the impact of COVID, there is about 1.1 million children estimated to have acute malnutrition, of which of which about 750,000 are estimated to be moderately wasted, while the remaining 250,000 are expected to be severely wasted. Looking into the treatment coverage from the health facility, we're able to treat only less than 1% of those children with acute malnutrition, of which 3% of some, 0% of moderate acute malnutrition. So this kinds of challenge is global, particularly in developing countries, and Nepal is not an exception. Taking this challenge into perspective, I would like to share some of the global initiatives that other countries, global development partners, including UN agencies, has taken into consideration to address this challenge of wasting. One of which is there are different initiatives, but I am focusing on these very three from the health system perspective. One of these global initiatives is the Global Plan of Action, which was initiated by 5 UN agencies, has 4 critical outcomes, including the early detection and the treatment of child with wasting. It is recently initiated, and there are some countries in the region, including Bangladesh, who has taken this thing seriously and have moved further. Another initiative is the universal health coverage, hugely advocated by World Health Organization, requesting member countries also to achieve this, which means everybody has a right to have access to all kinds of health services, from promotion to palliative care, regardless of their location, regardless of access to financial service. And for this to happen, access to quality nutrition is key and essential. So these are some of the good opportunities we would like to take. But the most important thing that I would like to emphasize related to the presentation is a simplified approach for treatment of child with wasting. This simplified approach, we're moving from evidence to practice, which is a very good thing. It is an adaptation, simplification taken by different countries to simplify the current global and national protocol for prevention and treatment of child wasting, with the intent of improving coverage as well as reducing the cost. There is no specific one approach, but there are different approaches which has been taken so far. And the most piloted, researched are some of these are the one you can see on the screen. In some you will see 6, in some there are 7. The first is family MOAC. This is a family-centered approach that enables as well as empower mothers, caretakers, to screen their children using mid-upper arm circumference and identify early and refer their child to health facilities. So that can also encourage early detection as well as treatment of acute malnutrition. But most important, using the opportunity to emphasize some of the impactful health and nutrition intervention and prevent malnutrition. Another approach, which is simplified, is treatment by community health worker, which is a task shift in terms of enabling capacitating community health workers, like the female community health volunteers in a Nepal context, so that they will be able to detect and treat children with uncomplicated child wasting in their locality, as well as able to identify those with risk of complication and refer to health facilities. Another simplification is frequency, reducing the frequency once a child is enrolled to treatment with the intent of enhancing adherence to treatment. Those colleagues who are familiar with CMAM, one of the challenges is defaulter. So this kinds of reducing frequency for follow-up is supposed to encourage adherence. Another simplification is modification of admission and discharge criteria from weight for height kinds of things, moving into simplification to using either MOAC with upper arm circumference and or edema only for admission, as well as referral that can make things very simple even for community health workers. Another is expanded admission criteria. It is the intent of screening and including more children at risk of child wasting into the prevention and treatment program, expanding from the current cutoff point to even a bit more. Another is 6/7 is the use of single product for treatment of both mom and the son. As we all know, previously there has been different products recommended for treatment of moderate acute malnutrition and severe acute malnutrition, but using one product for treatment of both is tested and found to be proven in different countries. Most commonly, they have been using RTF, ready-to-use therapeutic food. Another modification is, of course, reducing the dosage. So a combination of these things has been piloted, tested in different countries, and has shown some very significant impacts that can be considered in countries like Nepal to increase coverage as well as reduce cost, and so that we'll be able to reach more children with prevention and treatment interventions. As you see in the screen, it has been adopted by various countries, like the family MOAC is adopted by about 35 countries in Central and Western Asian countries, African countries, as well as in Asia. The modification, reducing the frequency of follow-up is adopted, piloted by 29 countries. It goes that way. So the adaptation, there is still ongoing discussion, adaptation, but country experience, particularly from Africa, Asia, shows that this adaptation is very impactful in terms of, as I said, increasing coverage and effectiveness of treatment. For example, in Kenya, they did a randomized controlled trials on integrating treatment of uncomplicated wasting into the ICCM, the Integrated Community Case Management of Childhood Illnesses. In ICCM, the community version of IMNCI, mainly child is screened for those diseases who are found to be contributing for high mortality, like fever, malaria, pneumonia, and diarrhea. So it is adding nutrition to that, nutrition screening treatment to that component by community health workers, and it is found to be effective. Moving further, my last slide is my key 3 take-home message for all of us on this call, and also colleagues who might be able to watch these things in the future. Is number 1 is considering wasting as a major public health problem in Nepal. When I arrived in 2019, I asked some colleagues, and what is the major nutrition problem in Nepal? And they told me stunting. It is true, stunting is high, but equally wasting is also very high. It is above the emergency threshold almost throughout the country, and this requires huge attention at all levels, at national, provincial, as well as among all of us experts in the field. And we have to consider, first of all, admit that it is a big problem. Second is giving attention to wasting. As I said, no effective intervention from prevention to treatment. Globally, adequate attention is not given, and we need to give more attention for wasting prevention and treatment, equally to other forms of malnutrition. In terms of attention, when I'm saying this is not only implementation, but also evidence generation. It is good to listen to senior researchers, young researchers since yesterday. Maybe next year and subsequent years, my request is also to have more evidence generated on wasting in Nepal context. Why wasting rate remains 10 and above in Nepal for the last 20 years. We need to research more and identify some of the driving factors and the related things. So evidence generation is one of the things. I think this forum can take it further. And the last point is, the key is prevention, as any public health program, is our top priority. The same applies for wasting, but treatment should be on the table whenever our prevention intervention fails and the child is wasted, either Sam or mom. Treatment should be there. So with that regard, taking the experience from some other countries, the simplified approach, either of the two or in combination, could be one of the options I think we can take as a country moving forward, and make sure children, whether they are moderately or severely wasted, are treated for the service they deserve in terms of saving their life, as well as in terms of promoting humanity, because health nutrition is a human right. Last point I'd like to say, as you see, it's already some action taken by the Ministry of Health with support of UNICEF and other partners as well, at least to start this simplified approach in Nepal context, considering the COVID and other things. These things need to be strengthened further, particularly in local, provincial, local levels. Finally, I would like to say thanks to all who contributed to this development globally, and these are some of the references. Anybody who is interested can refer and the things, and I will stop there, Toja. Thanks.
Great. Thanks so much, Antona, for a very insightful presentation. I think you rightly highlighted the need to do more for prevention and treatment of wasting in Nepal, especially in context of the pandemic, but also highlighting that we need more resources to generate evidence on implementation in order to improve the quality of services delivered by the IMAM program. So thank you very much, Antona. Dr. Fazli, next.
Thank you, Co-Chair Pujaji. Now this is a turn to present our nutrition roadmap to SDG. Before going to presentation, I want to introduce the presenter. About the brief presentation of the brief introduction of the presenter. Karen Courtney. Karen Courtney is a public health and nutrition expert with more than 15 years of experiences in Southern Africa, South and East Asia, including India, Bangladesh, Laos, PDR, and currently in Nepal in both developmental and humanitarian context. Currently, she is the Chief of Nutrition Section of UNICEF Nepal Country Office. Before joining UNICEF, she worked as a clinical dietitian and public health expert in Australia. She is an Australian national with master degree in nutrition and dietetics and master degree in public health. Now, may I call upon Karen Courtney for her presentation on nutrition roadmap to SDG. Now the floor is to you. Karen Courtney, please.
Thank you, Dr. Tara. Thank you, Co-Chair Pooja. Thank you for the honour of being on this panel, on this session on nutrition of the 7th National Summit of Health and Population Scientists in Nepal. My respects to the NHRC and again, my gratitude for being included in this session. My presentation today is going to be focusing on the Sustainable Development Goals and where we are with relation to the nutrition goals in particular. So let me begin just by reflecting a little bit on what the SDGs agenda is all about. So the 2030 Agenda for Sustainable Development is a blueprint of peace and prosperity for people and the planet, with a commitment that no one be left behind. So today I'll be speaking about how we're progressing towards that ambitious goal. Nepal has submitted both two review documents, voluntary national review updates so far by the National Planning Commission, which is a real testament to the commitment of the country to achieving the SDGs and also monitoring and reporting on them. So Nepal has been able to gear up a high growth rate, reduced poverty and macroeconomic stability since adopting and localising the SDGs. The periodic plans that have been fully aligned with the SDGs, and they provide a clear roadmap towards the prosperity over what is remaining 10 years. The graduation from least developed country status and achievements of the SDGs by 2030 are part of the important milestones of the long-term vision of Nepal, with national aspiration of a prosperous Nepal and a happy Nepali. So today I want to, as I said, focus a little bit on what the progress is towards particularly goal number 2. Only modest progress has been made or observed in the indicators related to hunger, nutrition and food security. This slide here, you can see that one of the first targets under goal number 2, target 2.1, there's at least some moderate progress being achieved, particularly with the prevalence of undernourishment of the entire population and per capita food production, and also some progress on the Global Food Security Index, but I think that may still be a little bit far off from being achieved. The challenge that Nepal faces of achieving the goals, the current rate, is the current rate that needs to be accelerated. The current rate of progress needs to be accelerated. And the main issue in achieving this goal of zero hunger, of food security and improving nutrition is that it's not just goal 1 that needs to be achieved. It's all of the goals are interlinked. And so goals such as 1 through to 6, 8, 9, 10, 12, and among others. So it's important that there's access to food, and improved nutrition is not only possible when people rise above poverty. There needs to be investment in education. There needs to be investment in social protection to universalise child grants. There needs to be investment in infrastructure to bring services to the community so the community can reach services such as essential health, education, food markets, etc. And there needs to be an increase in agriculture and food systems so that there's healthy, nutritious foods that are affordable and accessible for everyone all year round. Going back to the specific targets for nutrition, we can see from this slide that there's unfortunately a lot of red, a lot of targets that are off track. And we've just heard from the previous speaker about one particular indicator, which was the wasting. So we already know that the wasting prevalence in Nepal is higher than it needs to be, and it's certainly off track for achieving the SDG target. If we also then look at the other targets, particularly prevalence of anemia among women of reproductive age, we can see again that, and also the prevalence among children, is also very much off target for being achieved. So this slide speaks to the current rate of progress, particularly of one of the indicators, which is stunting. Sorry that it may be a little bit difficult to see the difference, but the existing average annual rate of reduction for stunting is 3.3%. Now, it's 3.3%, and this is not sufficient to achieve not only the WHA targets but also the SDG targets. We need to increase that rate of reduction up to at least 4.3%, if not more. And at the current rate, that's unlikely to be happening. And one of the things that's going to impact on whether or not we're able to increase this acceleration in progress is unfortunately the impact on nutrition of COVID-19 pandemic. We know from some modelling exercises done by globally and reported in the Lancet that there's potentially a 14% increase in the wasting prevalence in the country or in countries such as Nepal. What that means for Nepal is an additional 83,000 children who may be wasted as a result of mostly the secondary impacts of COVID-19 and not necessarily the direct impacts of infection. So this is really going to be the next challenge, is how do we stall or how do we reverse these negative impacts that the pandemic is having on the progress that Nepal has already made to date. Now, to do that, there are a number of publications, a number of documents, a number of policies. There's a number of strategies that have been put in place that are already in existence, that are in implementation. So the government is pursuing the efforts towards reaching goal number 2 through these various programs. And I'll just highlight a few, such as the Nepal Health Sector Strategy Action Plan, the Nepal Water Supply, Sanitation and Hygiene Sector Development Plan, the Food and Nutrition Security Plan of Action, and of course the Multi-Sector Nutrition Plan number 2, which is currently in implementation. But as I've said, we need to really be focusing in on leaving no one behind. And the interventions that are being put in place to address the malnutrition, particularly the malnutrition part of the SDGs, relate to what we call nutrition-specific interventions. And there's a plethora of guidelines, there's a plethora of strategies to support these programs and the program implementation. However, what's not fully achieved is full coverage of those programs. And until we see full coverage, we will not be able to achieve that goal of leaving no one behind. And as I've already mentioned, there's already been a need to shift in how some of these programs are being implemented because of COVID-19. And to that effect, the Family Welfare Division and the Ministry of Health have done enormous efforts to revise guidelines so they can take into account the context of COVID-19. And there's an example of those in the slide. So again, what's needed is national programs, but also programs that currently are not yet at scale. So we do already in Nepal have several programs that are nationwide and are contributing to the improved progress that we've seen in nutrition over the years. However, there are still programs that need to be scaled up, such as our previous speaker just mentioned, the program that treats children who are either moderately or severely malnourished. We also need to focus a little bit more in on maternal nutrition, what happens before women become pregnant, because we know that the pregnancy outcomes are greatly affected are in the age group of 0 to 6 months, meaning that the mother herself was not in a healthy position, and therefore the child has been born with either low birth weight or low gestational age, weight for age. As we heard from the previous speaker also, the government, particularly led by the Family Welfare Division and Mr. Kedar, has really stepped up in wanting to pilot and test some of these new initiatives that will take us towards improved progress towards achieving the SDGs. And they are both, as we've just heard, treating children who are moderately malnourished and also empowering women, empowering parents to be able to monitor their own children by measuring their nutritional status in the home, and therefore detecting children who need care and treatment early and referring them on. So in my concluding remarks, I'd just like to say that the commitment that leaves no one behind requires taking up both nutrition-specific and the sensitive interventions to scale. And UNICEF, WFP and all of the other development partners that are working with the Ministry of Health and working with the National Planning Commission to implement the multi-sector nutrition plan are fully committed to do that, and in the hope that soon we'll be able to show further progress and a reversal of the negative impacts of COVID-19. Thank you.
Thank you, Karen Courtney, for your excellent presentation on the nutrition roadmap to SDG, clearly explaining the SDG targets on the nutrition program and the special important intervention regarding it. Thank you very much for your excellent presentation.
Great. So our next presenter is Mr. Devendra Adhikari, who I also have the pleasure of working for more than 15 years. So Devendraji works as a senior nutrition specialist at USAID, and he also leads the nutrition portfolio for the USAID mission here in Nepal. He has specialization in nutrition, public health. He also has expertise in maternal and child health, neonatal health, and also monitoring and evaluation. Devendraji has more than 15 years of experience in program design and management, and he holds a master's degree in public health from Institute of Medicine and also Masters of Nutritional Science and Policy from Tufts University. So the screen is yours, Devendraji. And Devendraji will be presenting on factors of undernutrition in Nepal.
Thank you, Pooja ma'am, for the nice introductions. Just I want to share my slide first. Just a second. Can you see my slide?
No, not yet, Devendraji.
Okay. Can you see now?
Yes.
Okay. Thank you. Thank you. Good afternoon and namaste, distinguished participant, respected chair, co-chair, respected Kedar sir, and all presenters and all scientists. Today I am going to present about the drivers of undernutrition as maternal and child nutrition practices based on the review of the published and unpublished paper recently from Nepal. So thanks for the Nepal Health Research Councils and Ministry of Health and Population and Family Welfare Division for this opportunity. This is my presentation outline. Today I am going to focus primarily on the drivers of undernutrition situation in the country, as well as the maternal, infant, young child feeding practices and some disparities and some way forward. As you know that Nepal has made a remarkable progress in reducing stunting in the last 15 years period, or I can say 20 years period. But the prevalence of stunting, wasting, and maternal and child anemia, as well as adolescent anemia, remarkably high in the country. So we can say this is one of the major public health problems. However, we made a significant progress in the nutrition in last 20 years period. There are huge disparities in terms of certain indicators, in terms of provinces, geography, ecological zone, ethnicity, and wealth quintile. You can see here in the picture, the figure shows that some nutrition status indicator is actually increasing in some groups. For example, Dalit and Muslim ethnic groups, and province 6, 7, and 5, actually in all but the very hugely in province 6 and 5, the wasting indicator are alarmingly increased in last 5 years period. Over 50% of women and children are not receiving adequate diet as they required. High prevalence of anemia among women of reproductive age, adolescent, and children, and over 50% of women, households are food insecure, and there are other challenges, including the access to quality drinking water, as well as the sanitation facility, and the over 1/5 of the the girls are married before the age of 20, and another high prevalent of the early child bearing is one of the major the challenges in our country. So in terms of disparities, I would like to talk about some other indicator like anemia and low birth weight is equally. We can see we can see the inequitable distribution in different groups. If we see the data from 2011 and 16, you can mostly in the province 2, province 1, the anemia and is alarmingly high than the other areas. Similarly, the disparities seen in the as equally with the other indicators, stunting and wasting for the anemia, Dalit Janjatis are high prevalent of the anemia than the others, and also it is increasing in trend. The by wealth quintile, you can see relatively the poor are high prevalence of anemia, and also the children from the lowest wealth quintile or lower wealth quintile, they have the low birth weight. If we see the maternal nutrition status among the women of reproductive age, there are also we see the disparities in different groups by ethnicity, geography, as well as the wealth quintile, and there are actually, in fact, there is triple burden of malnutrition we can see particularly in the women of reproductive age. Mainly the remarkably increase in the overweight, obesity, not a significant reduction in the thinness, and even though there are slightly improvement in the maternal stature, and there are again the increasing trend of anemia and other micronutrient deficiency in the country. If we see the scenario in the nutrition practices, particularly in the child feeding practices, the similar in the women's, but I would like to give example about the child feeding practices. The child feeding practices is relatively low in the children who are from the Dalit or Muslim or other ethnic groups, and as well as the children from the province 1, province 2, and also province from children from province 5, 6, and 7, and also the children from the lower wealth quintiles. The similar scenario you can see here in the exclusive breastfeeding, except the wealth quintile. You can see in the wealth quintile the prevalence of the lower prevalence of exclusive breastfeeding in the richer or richest quintile. So here I would like to share about the determinants of malnutrition in Nepal. You know, we have done review over 300 papers globally and regionally and country. We reviewed over 100 papers that published recently, like this figure table that I show. Just you cannot see the figure, but I'll explain about it, the summary of this. Mostly about the different determinants of the malnutrition in Nepal. Here, based on the paper, the published paper, a paper published in the Journal of American Medical Association in 2020, it shows that the maternal nutrition is a major driving factor for the nutrition of the children, particularly the low maternal body mass index, short maternal stature are correlated with stunting, as well as the low BMI with this wasting and the infection prevention, unimproved nutrition facilities, maternal similarly, infection prevention, infectious disease, unimproved sanitation facility, and access to poor drinking water, and the maternal education is the major driving factor for
Devanuji, I think you're on mute. Sorry, Devanuji, I think you're on mute. If you could unmute your screen. Sorry, Devendraji. Excuse me, Devendraji. I don't think he can hear me.
He's on mute.
Devendraji.
Devanji, you are muted. Do you hear me? Oh, I think it doesn't. You are muted, Devanji.
You're on mute, Devendraji.
Please unmute.
Are you hearing, sir, now?
Yes, we can hear you now. Please go ahead.
Hello. Did you hear? Did you hear by this determinant? I don't know. I didn't did actually. Okay.
Yes, if you could start with slide number 6, Devendraji.
Is it determinant slide? This table?
Yes.
This slide?
No, the next one, please.
Okay, thank you. If you see the other determinants, the low birth weight had a significantly higher odds of being the wasted or severely wasted here in Nepal compared to the children who born with non-low birth weight. One of the key driving factors for the undernutrition is children who are not breastfed within the 1 hour of birth, or children who were not exclusively breastfed within first 6 months, and the children who received the prelactial feed is were more likely to be wasted. One of the interesting findings that we saw here in 2020-21, all these are based on the findings from Nepal studies, and animal source food, especially 2 or more animal source food consumption, was significantly correlated with the or 10% or 16% decline in stunting in Nepali children, respectively. Even we saw another study that we did in the mid-western Tarai of Nepal. It shows that even low level of serum aflatoxin level in the pregnant woman blood is significantly linked to the poor birth outcome, particularly in the small for gestation age. But there are also some extent in the growth, but that was not significant. Another area that maybe another area that we are not much focused, the poor head growth also represent another facet for the silent emergency of child nutrition and overall development. Then the next one is just I would like to talk about the drivers of the factor associated with the anemia or micronutrient deficiency. As for the Lancet series published in 2020, it shows that over 80% of women had at least 2 micronutrient deficiency, for example, iron deficiency, anemia, or vitamin B12 and others. The maternal anemia is also observed the very strongest and consistent predictor for the child anemia, and which is the children also were more likely to anemic those if they are also stunted. The better iron status, vitamin status, also that are very very associated with the less likely to anemic for all the groups, including the children for 6 to 59 months or adolescent and women of reproductive age. The recent fever or infection or glucose 6-phosphate dehydrogenase deficiency, genetic disorder, or acute inflammation and underweight were significantly associated with more anemia among the children of 6 to 59 months. So here, just those households who raising the animal source food better improvement in stunting and better minimum and also better minimum acceptable diet, and also consume more animal source food compared to those children receiving partial services. This is from the 2 studies, actually from the DHS further analysis as well as from the Nutrition Innovation Lab study conducted here in Nepal. The factor associated with the nutrition practices, if we see here in the more intermediate level result, in the Tarai, the children's over 3 times more likely to be receive the prelactial food than the mountain. There are the significant number of households have common diet lacks sufficient vitamin B12 and riboflavin and calcium in the mountain. If we see in the hill, it is the lacks in the vitamin B12, B6 and calcium and iron lack diet. Similarly, calcium, iron and vitamin lacks diet in the Tarai. So that also tell us how should our interventions should be tailored. And if we see another, for example, we have done a lot of work around the homestead production or home gardening. It shows the positive the association with the dietary diversity, also intake of nutrient-dense food for older, pre-school children. If we in terms of consumption of vitamin A or vitamin A is carotene food, that's both children and women nationally actually remains low. That's indicating supplementation is still needed. I wanted to highlight about
excuse me, sorry to interrupt. You have 2 minutes now.
Okay, so sorry. So I quickly go. This I can finish it. So if you see here in the framework, that's how we could our intervention or how our intervention can address the multiple form of malnutrition, particularly the leveraging the different type of intervention to address the drivers. For example, health systems interventions, food system intervention, social safety net intervention, as well as the food environment and then wash activities. Another I would like to highlight here about the concluding two slides. And under nutrition is remain a public health problems. It might be offset by the COVID-19 pandemics. Based on the evidence we have here, we have to intensify our effort to modify for addressing the modifiable factors such as breastfeeding, access to an equitable quality of health services, maternal nutrition, enhancement of nutrition knowledge, as well as improve the maternal and child nutrition. And then we have to continue our accelerated combination of strategies to reduce the micronutrient deficiencies. For example, breastfeeding, large-scale food fortification, supplementations, and infection control and dietary diversification that we need to continue what we are currently doing. But we need to have acceleration on this. We have to pay attention to women's nutrition through the life cycle. Also put care for the women nutrition at the center, not only for the health of mothers or nutrition, also for the children's health and nutrition and overall development. In the last slide, the policy intervention that is very crucial, to promote access and intake of safe, healthy, and nutritious food, including animal source food production, which are very critical based on the evidence. Continue refine health system programmings based on the especially quality, coverage, and equity aspect, and intensifying the food system and nutrition sensitive intervention based on the evidence and the context we have now here in the country. Last but not least, data-driven programming for the research to inform programmings and policy, and acceleration of high-level commitment, high-level political and donor commitment, and also promoting the leadership for the nutrition at all levels of the government and all the stakeholders, and also for sustainable improvement of nutrition as nutrition vision already highlighted by Kedar sir and Karen in the SDG goal. Thank you so much for your the listening. Please welcome for your questions and comments. Thank you so much.
Excellent. Thank you so much, Debendraji, for your really insightful and informative presentation, and also highlighting the key drivers of malnutrition in Nepal, and also the importance of equity if we want to really progress the nutrition agenda. So our next four presenters will be talking about food systems, mostly focusing on food environments in Nepal. They are mostly in urban setting. They are 10-minute recorded presentation. The first presentation is from Mr. Saurya Tungel, who will present on food environment in public facilities of Nepal from the perspective of policymakers.
Greetings to everyone who are being ears to this presentation. I am Saurya Tungel, Research Assistant of Department of Public Health and Community Programs, Kathmandu University. I'm here to present on my study titled Food Environment and Related Policies in Public Facilities of Nepal, Perspective from Policymakers and Nutrition Scientists. I'd like to give special mention to all my team members, Ms. Swarnim Bajracharya, Mr. Navin Adhikari, Mr. Mukesh Adhikari, Ms. Namuna Shrestha, Ms. Priza Pradhananga, Ms. Arati Dakal, Ms. Sangita Manandar, Ms. Nicole Eid, Dr. Gunanidhi Sharma, and PI of our project, Dr. Archana Shrestha. I'll basically be dealing with background, objectives, methodology, results, and conclusion of my study. Non-communicable diseases in total account for over 63% of global deaths. 40% of these NCD-related deaths are attributed to unhealthy diet. Unhealthy eating can be attributed to rise in NCDs such as type 2 diabetes mellitus, cardiovascular diseases, and cancers. The major dietary groups for non-communicable disease include sugar, saturated fats, trans fatty acids, and sodium. Healthy foods are regarded as diets that are rich in whole grains, fruits, and vegetables. Availability, accessibility, affordability, marketing strategy, and food trend extremely influence eating behavior of a person. The food environment across public setting has a crucial role in improving healthy food intake. Despite the cruciality of the previous statement being established, however, there is no specific policy in Nepal for food procurement. The development and adoption of healthy food procurement policy might be a promising strategy to tackle societal health issues associated with unhealthy food environment by increasing access to healthier foods in public settings. Public food procurement is a multidimensional initiative across agriculture, health, procurement, and marketing strategies. Therefore, we aim to assess the existing food environment by exploring existing policies, food security, nutrition standards on sales, intake, and availability of food in public settings of Nepal. The major objective of our study is to explore the perception of policymakers and nutrition scientists regarding existing food environment along with policies related to nutrition and food procurement in public settings of Nepal. Our specific objective is to assess the food procurement practice in public settings, to explore the policies related to nutrition and food procurement, to explore the necessity of having a specific food procurement policy for public settings. Study design was explorative qualitative study. Study participants included bureaucrats from health, education, national planning commission, agriculture, local body representatives, representatives from multilateral organizations, and nutrition scientists. We had purposive sampling of following theory of meaning saturation and took 50% non-response rate to finally reach a sample size of 20. We had open-ended, semi-structured in-depth interview of the key informants, which lasted from 45 to 60 minutes. Those interviews were recorded, transcribed, coded, and categorized to perform a thematic analysis in vivo. We established Cohen's-Kappa coefficient of 0.77 with 99% agreement between two coders to establish inter-rater reliability. Ethical clearance was received from NHRC, and we took verbal consent from each and every participant before the interview. Results of our study were as follows. Majority of our participants were bureaucrats from health, and 1/3 of them were nutrition scientists. In order to establish the gender sensitivity, we had female representation of 35%. Now talking about food procurement in public settings. Majority of the participants responded that food offered during seminars, meetings, and workshops were decentrally procured through the respective organization, through the respective department that was organizing the event. Mostly packaged foods such as samosa, momo, juice, apples, etc. were brought from canteens or nearby restaurants, mostly due to easy accessibility and distribution channel. Majority of the respondents said that food is provided from government to following public settings: primary school students, admitted patients in government hospitals, government-run elderly care centers, and juvenile correction facilities. Policies and guidelines that currently exist to guide towards healthy food procurement in Nepal. Respondents pointed out on different national food and nutrition-related policies such as Multi-Sectoral Nutrition Plan, Midday School Meal Plan, Food Act, Plant Production Act, Pesticide Act, and Regulation. Few participants even said that principal guiding document to assert food as a fundamental human right is the Constitution of the country. Most of the respondents were aware of the Public Procurement Act 2063 and Public Procurement Guideline 2064 as the basis for procuring food in larger quantities in public settings of Nepal. Now talking about the existing food procurement practice. Public facilities have to follow Public Procurement Act 2063 for procuring and tendering of food. Advertisement is given out in local newspaper with timeline of 30 to 35 days. And interested parties participate in the bidding process with the lowest bid who is going to win the tender. Now talking about the difficulties and feasibility in implementation of the current procurement policy, our respondents outlined that procurement policy for essential commodities such as food and medicine should not be as generic. They said that Public Procurement Act 2063 and Public Procurement Policy 2064 was very process oriented. Our respondents voiced that the current procurement policy focuses on quantity over quality as the lowest bid wins the tender. And there's always a problem of unrealistic pricing during bidding as the interested party cannot deliver the food in the same price in the future. And there's always a potential of bidders to cartel amongst each other, which eliminates the spirit of competitive bidding. However, there was some strengths as outlined by some of the respondents, as they felt that the procurement policy was uniform and it established transparency. The recommendation that our respondents gave for improving the food procurement practice that currently exists was basically to have a specific food procurement policy for public settings. They also said that provision of food from government institutions directly to public settings could eliminate the malpractices that currently exist in food procurement. They also voiced that strong monitoring mechanism to ensure the procurement policy is being followed in its right spirit should be there, and promotion of production and consumption of locally grown healthy foods by regulating the market price and having an enhanced supervision mechanism for ensuring food quality. They recommended following components to be incorporated if a specific public food procurement policy is to be drafted. They said price regulation, ban on advertisement of junk foods, promotion of local foods, focusing on food labeling, recommended nutrition requirement and healthy food availability, transparent yet flexible policy during public health emergencies should be brought in place. Majority of the participants strongly felt the need for public procurement policy as it promotes a healthy food environment which is integrally related to health. They suggested reviewing existing policies and having a series of consultations with different stakeholders to develop a specific food procurement policy for public settings. This is the implication and the way ahead from our study. A separate food procurement policy could be designed for which extensive literature review across national and international journals and food policies and food and nutrition guidelines need to be done. And formation of a task force with representation from different academia, ministries across health, agriculture, and consumers, media, health leaders, and chronic disease experts could sit in a task force which will work on drafting the food procurement policy. And the food procurement policy could be then presented to a larger audience to receive feedback. And finally, it could be implemented to measure its effectiveness. We'd like to thank Resolve to Save Lives Vital Strategies for funding this study. All the sources that helped us to map our potential respondents have been extremely helpful. We'd like to thank all the participants of the KAI without whom this study would not have been possible. Special thanks to NHRC 7th Summit Organizing Committee for giving us this platform. I would also like to thank NHRC Summit myself, as my journey started in NHRC Summit from being a volunteer and finally graduating to a oral presenter. This has been a very wonderful journey. Thank you so much. These were the references that we used.
Great. Thank you so much, Mr. Dungel, for your interesting presentation. I think building on this, this presentation is another study conducted in Nepal around perception on existing food environment in public facilities as well. The study, this qualitative study was conducted by Mr. Swarnim Bhattacharya. Could you please play the recorded presentation, please?
Hello everybody, I'm Swarnim Bhattacharya and representing my team for the presentation on perception on existing food environment in public facilities in Nepal, a qualitative study. These are our team members. Starting with the introduction, everyday food and beverages, including meals and snacks, are served and sold in public settings such as government offices, schools, childcare center, health center, community center, senior centers, military bases and prisons, as well as in shops or stores surrounding these settings. Unhealthy dietary practices prevail across different population groups and geographical regions. Unhealthy diets include excess salt and sugar and inadequate whole grains, fruits and vegetables. Unawareness of effects of these is prevalent in various settings. These remain a leading risk factor for death, disability and ill health globally. In Nepal, all forms of malnutrition are present, causing a significant public health problem. Problem of stunting, wasting, and underweight children contributes to 50% of child mortality. At the same time, rising cases of obesity and overweight are leading to an upward trend of chronic and non-communicable disease, also called lifestyle-related diseases like cancer, cardiovascular disease, and diabetes. Unhealthy food eating pattern, excessive intake of high amounts of fat, sugar, and salt, and a sedentary lifestyle are responsible for these health and nutrition problems. A health procurement, public food procurement and service policy establishes nutrition criteria to increase the availability of food that promises healthy diet and limit or prohibit the availability of food that contributes to unhealthy diet in public settings. The objective of our study is to assess the existing food environment by exploring policies, food security and nutrition standards in Nepal, and to be specific, We explored the existing food environment, policies guiding the food procurement, and feasibility of food procurement policy in public settings from public facilities representatives. And the methodology we included was we did a explorative qualitative study, and within it we did key informant interviews to public facility representatives. Ethical clearance was received from NSS and informed consent was received. And data analysis we interviewed and recorded, interview recorded and transcribed and coded and categorized for functionality analysis using NVivo software. Moving to the results now, we have we have maximum representatives from the schools. Then following it is care centers, then health facilities, and following it is last at other public facilities. And thematic analysis. First is food fashion in market. Majority of people buy their food from local market and very few do farming and kitchen gardening. Similarly, types of available in the market are ranges from processed food, simple food, day-to-day food, and organic food. It also includes fast food, adulterated food, profit-targeted food, and cultured food. And people prefer packaged and processed food, and very few people prefer simple homemade food. Food preferences, according to our representatives, were mostly people unhealthy foods such as packaged food, processed food, fast food, and consume those in such a quantity that is harmful for them, that is in an unhealthy proportion. Very few prefer healthy food and simple food in moderate proportion. And reasons behind these were were shared as taste, convenience, attractive advertisements. Very few prefer simple food due to health and economic problems. And regarding the healthy food situation in our country, our representatives share that healthy food is considered as organic food, home cooked food, nutrition and hygiene food. And very few people prefer it as tasteful and cultural food. And regarding the nutrition and nutritious food, nutrient and nutritious food in people, our representatives share that very few people, mostly people are unaware of healthy food and their availability and how to implement them in regular life. And those people who are aware, they don't know how to implement it in practice for their health. Regarding the fast food that is being how that they are being addressed are various awareness campaigns correlating it with chronic health conditions, and they also mentioned that there should be policies mentioning punishment for producing unhealthy food or that affects consumer health. And producing those food with healthy modification can help solve the fast food problem. Existing, we inquire about existing food guidelines and policies. We usually follow the General Public Procurement Act for procurement and tender of food. And within that, if the process of procurement is advertised in local newspaper with timeline for 30 to 35 days within the state government budget based on condition and mention. And they need to beat it, and we select the lowest bid and they will supply throughout the year. And supervision and monitoring is based on general procurement guidelines. And different institutions, because we interviewed a public facility representative, we inquired about the food procurement practice within the institution. They usually buy from the local food shop, tender food canteen, and for school and care centers, provision of particular budget for it from Nepal government, and some are grants from local organizations, like in child care centers, in old age home. And they have 6 menu and food items. And from canteen where one needs to purchase, they sell pay or some are free, and all kinds of items are available. And the food quality inspection practice within the institution is usually done by a supervisor on a daily basis or sometimes scheduled. And it needs separate team and training involving local government. There is presence of minimum service standard for health facilities, but it only mentions about space, furniture, and environment, not about quality of food. We inquire whether any particularly focusing food procurement policy is required or not, and they share that it is a need of the time and proper training is required for it, and it should be situation based on guidelines. If government implements it strictly, it is very practical, and it should be pre-informed and proper education and awareness about it should be done from time to time. And regarding the food procurement policy, we asked what type of policy it should be, and they shared that it should be target stated, like for schools, it should be different, hospitals and workplaces and so on. And the component that should be included within the policy were it should be practical, beneficial to farmers, should have standard norms and guidelines, and should have separate person responsible for its implementation. Primary should focus should have be on health education, awareness, and food quality control. Should overview situation in equity, and the policies should be transparent. And there should be appropriate budget set aside, aligning with the set norms. Consultation with the stakeholders need to consult with the stakeholders and consider the views and perspectives of local level to senior level. And monitoring should be done and supervision should be done time to time, and a control mechanism should also be established. And there should be guidelines explaining how we can use the fast food with healthy modification as well. And the barriers they shared for implementing these policies were presence of industries and manufacturers against the policy that develop the processed food, increasing trend of unhealthy or fast food, profit-seeking market, and hassling government work. And the ways they share that we could overcoming the barriers that are policies to the participatory approach involving all stakeholders, conduct monitoring from time to time, and involve expert in foundational implementation. Finally, moving to the conclusion, given the changing food trends and environment, having healthy guidelines for food and their targeted setting is important in order to curb the growing trends of packaged and unhealthy food consumption. Focusing on targeted setting and involving stakeholders and food quality inspections are enablers to achieving healthy food procurement in public settings. And these are our references and acknowledgements, and thank you.
Now we are nearly the end of the presentation. We have two more presenters left here. I request to present the recorded presentation by Mukesh Adhikari. That is on a systematic review on the healthy food procurement policies in public setting. Presentation, please.
So namaste. So let me introduce myself first. So I'm Mukesh Adhikari. I'm a senior public health officer. I'm working in DOSS Kathmandu, Nepal, and my title is a systematic review on healthy food procurement policy in public settings. So first of all, this is the list of research team members that are present in our project. So this project has been led by Dr. Archana Shrestha of Kathmandu University. So let me give the background of our systematic review. So according to Global Burden of Disease 2017, about 11 million deaths can be attributed to dietary risk factors. And one of the major contributing factors for this is a widespread availability of unhealthy foods that are high in sugar, salt, and saturated fat. So that's why the Food and Agriculture Organization and World Health Organization have recommended that there should be a food procurement policy to achieve two major purposes. One is to have greater access to diverse food, and then after all, to increase smallholder agriculture production. And then after all, the public food procurement policy have been practiced in a wide range in developed countries as well as in a few developing countries. However, a robust evidence on policy component and their nutrition and health outcome is limited. A review was conducted by Nebelski et al. In 2012 that covers a diverse settings such as schools, worksites, hospitals, and other institutions. And a few other reviews were conducted, but they were almost mostly confined in school settings. And the review done by Nebelski et al. In 2012, the rating of that review was very poor. According to AMSTAR tool, that is a tool that is used to measure the quality of systematic review, the score was very weak. The score was 2 out of 11. That's why a high quality systematic review on public food procurement policy based on PRISMA guideline has been lacking. Therefore, we conducted this systematic review to produce a high quality evidence on the component of food procurement policies and to update the existing evidence that was generated in 2012 by Nebelski et al. So the objective of our systematic review is to summarize the component of public food procurement policy and identify facilitators and barriers associated with those policies. And we are also thinking about the meta-analysis in this project. So the next step is that, but we are still doing and we are still in ongoing process. So let me go to the methodology section. We conducted a systematic review of literature using multiple online databases from Medline, Embase, Scopus, Web of Science, Global Health, SinaHealth, and Cochrane Library by using methods. For survey, we sort of use 4 categories, that is food, settings, outcome, and procurement. So, and then we all categories by using different words and through we provide our eligible studies. And almost all systematic review use like PICO approach. There is P means population, intervention, comparator, and then after outcomes. In our study, as a population, we use participant of any age groups, and intervention we use policies, strategies, standards, guidelines in public settings, especially schools, hospitals, worksite, and correctional facilities. As a comparator, we use similar kind of settings or population where food procurement policy are not implemented. And in terms of outcome, we use intake of salt, sugar, sodium, saturated fat, intake of fruits, vegetable, vitamins, minerals, and change in proportion of sales of foods. Going to the methodology section of inclusion and exclusion criteria, we include a wide range of study, starting from quantitative study and qualitative study as well. We also used observational study, randomized control trial, non-randomized control trial, control study as well. So our time frame is from January 1990 to June 2020, and the language is English only. And then after all, in excluding criteria, we excluded the paper of the conference paper, review paper, multi-component intervention, non-institutional settings, food industry level intervention like food fortification, change in infrastructure type of intervention, and then after all, studies that involved non-human participants. And it's interestingly, we use a robust kind of method. A highly trained public health librarian searched the literature, and then after all, which was further validated by another librarian researcher. And for that, we have got support from Yale School of Public Health. And then after all, in every step, we use at least two researchers that have independently reviewed the title and abstract, and then after all, full text. And if there was any conflict between two researchers and that was resolved by a third researcher, in some cases, we also discussed that kind of conflict in a research team. Let me move toward the results section. This is a Prisma flow diagram that is normally used in systematic review. We identified 40,436 studies, and then after all, we reviewed the title and abstract of 37,884 studies. And then after all, we screened the full text of 1,507 studies, and ultimately we included 145 studies in our systematic review. So let me share the major finding of our studies. So types of food procurement policy, there were 45 intervention studies, 40 policies, 18 standards, 17 guidelines, 12 programs, 7 acts and regulation, and 6 strategies. Most of the food procurement policies were implemented in schools, followed by childcare, hospitals, worksite, and multiple settings. Let me give some sort of like policy component, and we sort of categorize that into 3 major parts, that is school, hospitals, and worksite. In some schools, there was a provision of availability of healthy foods like whole grain, fruits, vegetables, low-fat foods. There was also some sort of, in some schools, they tried to use some sort of minimum standards in school lunch. In other schools, they have a provision of prohibition of unhealthy foods. Smart lunch program was implemented in some schools. There was elimination of sugar-sweetened beverages. Placement nudging was practiced. That means so healthy food are displayed in front of the counter kind of thing. And then after all, they also tried to reduce the price of low-calorie foods. In terms of work side, they tried to use minimal fruit program, fresh fruit program. They use diet group education, consultation through nutritionalists, and they also tried to use food color coding. That means the red food means unhealthy foods and the green food means healthy foods kind of thing. And then after all, they also tried to use food marketing approach by which they sort of reduce the price of the healthy food, and then after all, they also use promotional materials. And in some cases, they also use to train canteen staffs. In hospital, in some hospital, they use traffic light style color coding. That means the red, yellow, and green kind of color coding in hospital cafeteria. And in some hospital, they use the replacement of food items that are high in sugar, salt, and fat. And in other hospitals, they use increased taxation in unhealthy foods and subsidize healthy foods. We also reviewed the procurement mechanism. A majority of food policies has no specific food procurement processing or the mechanism. And after all, a few policies have promoted local food processing and concept of kitchen garden as well. Let me give some of the facilitator and barriers that are linked to food procurement policy. In terms of facilitator, we found that there was an increased attention toward healthy diets. There was a capacity of building of stakeholders, and we also found that after the implementation of this food procurement policy, there was increased collaboration between local farmers and public settings. In terms of barriers, we found that especially in schools, there was inadequate parental, student, and staff support, and especially the policies are like sound, but the implementation aspect was very challenging because of insufficient resources. And at the same time, in some cases, the healthy food options are unaffordable or inaccessible. And in some cases, the guidelines were unclear and hard to understand. So in conclusion, the systematic review signals that food procurement policies have a high potential or great potential to increase the consumption of healthy foods. Therefore, we recommend that there should be effective implementation of food procurement policy in public setting to enhance use of healthy foods so that the people can use healthy foods and there could be a reduction in non-communicable diseases. So these are our references. And then after all, thank you very much. If you have any question, I'm free to address your question. Namaste.
Thank you, Mukesh Adhikari, for your excellent, informative, and important presentation on systematic review on healthy food procurement policies and public setting. Now, at last but not the least, the next presenter is Srijana Dongol. And may I request Srijana Dongol to present her presentation on self-reported health conditions and nutritional status of elderly people living in old age homes of Lalitpur districts.
Namaste and a very warm welcome to all respected delegates and all presented here virtually in this summit. My name is Srijana Dongol. I would like to welcome you all in my presentation. The title of my presentation is Self-Reported Health Conditions and Nutritional Status of Elderly People Living in Old Age Homes of Lalitpur District. Here is the brief description about authors and affiliations. Now let me start with the background of the study. Elderly population is defined as the population of aged 60 and over. WHO explains that the world's population is rapidly aging. It estimates that people aged 60 and above will rise from 900 million to 2 billion between 2015 and 2050, constituting 2% to 22% of global population. The population of older adults 60 years and above in Nepal has increased from 1.5 million to 2.2 million in 2011. The 3.5% population growth rate of the older adults from 2001 to 2011 is higher than the population growth rate of the overall country. By 2019, 9.2% of total population were older population, which hints at a slowly shifting demographic structure in Nepal. Objectives of the study. The general objective is to assess health conditions and evaluate the nutritional status of elderly people living in old age homes of Lalitpur. Specific objectives are to assess the self-reported health problems and nutritional status of elderly people living in old age homes of Lalitpur. To identify the factors associated with nutritional status of elderly people and to identify the factors associated with self-reported health problems. Research methodology, cross-sectional study design was used. Elderly population of Lalitpur district were the participants. The study was conducted in old age homes of Lalitpur district and there were 20 old age homes in Lalitpur district. The study was conducted from September 1st, 2019 to February 28, 2020. Random sampling technique was used to select old age homes, whereas census method was applied to select the respondents of the study. Data collection tools and technique. The self-rating of health and screening tool, mini nutritional assessment (MNA), was used to gather information on health condition and nutritional status of study participants. The self-reported health was rated in Likert scale ranging from very good to very bad. Height and weight of the respondent were measured using digital weighing scale and portable standard stature scale, respectively, from which BMI was calculated. Data management and statistical analysis. The data were entered in APData and were then exported to SPSS version 11.5, and data analysis was carried out. The data were summarized in terms of frequency, percentage, mean, and standard deviation, and were presented in the form of tables and pie chart. Bivariate analysis was also performed using chi-square test and Kruskal-Wallis test to determine factors associated with self-reported health conditions and nutritional status of elderly people. Logistic regression analysis was also carried out to determine the independent association of factors with self-reported health condition and nutritional status. Validity and reliability. The screening tool MNA was a validated tool that had been used widely for elderly people with Cronbach alpha value of 0.83. Standard Nepali translated version of MNA was provided by the developer themselves for the study. Ethical consideration. Ethical clearance was obtained from Institutional Review Committee BPKIHS Dharan. Informed consent was also taken from the old age homes and participants. All the information about the respondents in this study were kept confidential. The participants were assured of the confidentiality and they had full authority to accept or to refuse to take part in the study. Now, the results. This is the demographic characteristics of elderly people, which shows that 38.1% of the respondents were aged 70 to 79. More than half of the respondents were female with 73.6%. 83.2% of the respondents were from advantaged Janjati, whereas 65.5% of the respondents belonged to Hindu religion. Similarly, 65.5% of the respondents were either widow or widower. 80.7% of the respondents were illiterate. This table here shows the self-reported health conditions of the elderly people living in old age homes, and it shows that 49.7% of the respondents self-rated their health as moderate or fair. The pie chart here shows the nutritional status of the respondent. It explains 58.40% were nourished, 37.60% were at risk of malnourishment, whereas 4.10% were malnourished. The Kruskal-Wallis test table here shows that number of meals a day is significantly associated with self-reported health condition of elderly people. Similarly, age was significantly associated with nutritional status of respondents according to Kruskal-Wallis test. This table here shows the chi-square test values, and it shows that marital status, smoking, and alcohol consumption were significantly associated with self-reported health condition of the respondent. This table here shows the chi-square test value of factors associated with nutritional status, and it explains that marital status, educational status, and chronic illness were significantly associated with nutritional status of the respondent. The table here is of logistic regression analysis, and it explains that with elderly people aged 60 to, with every increase in number of meals a day, elderly people were 18.385 times more likely to rate their health as good according to self-reported health condition. This is another logistic regression analysis table, which shows that elderly people aged 60 to 69 were 2.710 times more likely to be nourished than elderly people aged above, and which is significantly statistically significant as well. Similarly, ethnicity had significant association with nutritional status. Janajati were more likely to be nourished than other castes with odds ratio of 2.405. Also, respondents who were married were 1.879 times more likely to be nourished than those who were widow or widower with odds ratio of 1.879. For the chronic illness, respondents who do not have chronic illness were less likely to be malnourished than those with chronic illness with odds ratio of 0.436. Now the conclusion. It can be concluded from this study that elderly people were at risk of malnutrition. Majority of the respondents self-rated their health status as moderate or fair. Majority of them had hypertension and on medication for the comorbid condition. Variables like marital status, educational status, smoking, alcohol consumption, presence of chronic illness, and number of meals a day were associated with self-rating of health condition and nutritional status of elderly people in old age homes. These are some of the references. Thank you.
Thank you, Srijanaji, for your comprehensive and excellent presentation. Now we are going to the question and answer sessions. Before concluding the sessions, we are going to take some questions from the participants and request the presenter for their response.
So maybe I can list out, there's a couple of questions. The first one is directed to Mr. Devendra Adhikariji. And the question is around the key drivers of malnutrition. And it asks, do the country have regular monitoring mechanism on the key drivers of maternal and child nutrition to review progress made in addressing challenges around malnutrition?
Thank you. This is the, maybe can I answer it now?
Yes, please.
Thank you so much for the excellent questions. In terms of country, that means this analysis is based on the demographic health survey that we did we do every 5 years, and there is in between the demographic health survey there is a mixed survey, that's National Multi-Cluster Indicator Survey. Surveys these are the two surveys that we are using. We can say how frequent that's to collect, that is another question. This type of high level, always collecting this very high level of indicators. For example, maybe drivers, yes, we can collect those informations. But the question in there also itself. DHS is every 5 years. In between every 5 years, there is, as per the plan for the Ministry of Health and the partners, that's every 2.5 years there is survey. These big national surveys happening. That these are the how we are country doing this collecting those information. In addition to that, this information also annually there is Nutrition Lab is collected this information in annual household survey, but this is a project based, I can say, so that is not. So in the health management information system, currently government of Nepal is itself revising its indicators to include some of the intermediate level of indicator that's includes some behavior indicator that's collecting annually, but we need to improve the quality of those information. At the same time, there are the other ways we could make more effort to defining this collecting some indicator through the certain surveillance mechanisms, but selected indicators. There are the areas to improve, I can say, but we do now every 2 to 5 years, including DHS and mix. Thank you, and the SMS.
Great, thank you, Devendraji. There's another very relevant question to Mr. Soria Dungel. It's around the food systems. So the question is, people have no choice to buy unhealthy food. To to buy, I think he means healthy food, since our food system is failing to deliver healthy food in the marketplace. As a researcher, what is your recommendation to make transformative changes in environment to ensure healthy food is available everywhere so that people can procure healthy food of their choices? This question is directed to Mr. Soria Dungel.
Thank you for the question. Thank you for the question. I believe in order to ensure the healthy food availability in all parts, I believe food procurement policy specific to food, should be brought into place, which is one of the implications of my study. However, I'd like to further clarify that the implication is to draft a food procurement policy in public settings, basically due to adherence rather than for the whole public. I hope that answers the question.
Thank you, Mr. Dungel. Dr. Tara, if you have any questions.
Here are 5 more questions with me to the directed to 2 presenters. 2 questions to Devendra Adhikari ji. They are related to by anonymous participants. First question to Devendra ji is, do the country have a regular monitoring mechanism on the key drivers of the maternal and child nutrition to review progress made in addressing the challenges around malnutrition? Do the country laboratory capacity is sufficiently equipped in terms of the nutritional biochemistry lab and their relevant lab? What is the researcher's suggestion to establish a monitoring system on the changing landscape of the key drivers? This was a question related to monitoring. Next question is also to Devendra ji. Nepal has ample of opportunity to produce a milk and milk-based products and its marketing. This is the rich source of the protein and the calcium. There is a potential to fortify it with many micronutrients. Under this situation, it is interesting to know the researchers' view. How do they like to promote the milk and milk-based product in upcoming research and the program development? I heard that Nepal Dairy Association is interested to include the midday meal menu. Just wonder if the research is done to include in the midday meal menu. These 2 questions are to Devendra ji.
Yes, thank you, sir. I responded to earlier question related to monitoring. I'll respond to additional 2 questions. Thank you, sir. I think the first, the capacity in terms of nutrition biochemistry laboratory capacity in the country, certainly there are certain labs within the government and outside the government have the capacity to test some of those the biomarker related to nutrition because based on our experience. 6 to 8 we tested abroad, and now it's a gradually country has the capacity to test some of those, but there are a lot of areas to improve in this area. Actually, it's a very important area that I think we need to consider to regularly monitor, analyze those by the test. And strengthen to promote the laboratory capacity establishment within the health systems, academic systems, and outside maybe as the private sectors to do the sophisticated type of the molecular nutrition molecular analysis. That's required to develop the local capacity. That's one of the areas that we need to work in addition. But gradually it's increasing. I can say there are still there. In terms of the I think that's a very important question. Also, some of the findings related to my study findings. My comment is that it is not only about the fortification calcium. I think the consumptions, because for example, we can see the milk production here in the rural areas. I say that's as for my presentation, I see that's the calcium lacks in the which like by ecological zones in the rural areas. That means who consume the calcium-rich foods. Is mothers, children's, or mother children maybe received, and is mother adequately consume those calcium-rich food at the household level? That's behavior changing the social behavior change activities is the crucial. At the same time, increase the productions and promoting the the consumption of those calcium-rich food at the household levels or community level that we produce. That is one strategy. Another is certainly the food fortification is the another strategy. That's the very important strategies that cover the large geographies. Not only calcium, there are the key essential micronutrients that need to be fortified. For example, government of Nepal has a mandatory wheat flour fortification systems and policies and regulations. So that type of this area actually need to be, we need to work on that, considering the current context and then the vehicles that we have and food behaviors that we have, that we need to analyze and do the fortification in the large scale. That is the another strategy. That means what I am saying is the doing the food large scale food fortification is not the only the solution. There are the other solution I already included in my the conclusion. One is the promotion of essential nutrition actions, health system intervention, promotion of breastfeeding, the dietary diversifications that include the diversified productions and the consumption pattern, as well as the supplementation. For the supplementation, that means another area for required to targeted approach, and for the large scale food fortification to address the micronutrient deficiencies is certainly one of the areas that we need to work with critical analysis and the evidences. Thank you.
There are few questions and suggestions, rather suggestion also. See, two suggestions and question to Surya Dungelji, and two more queries to Srijana ji. So please, we are already far of the allocated time, so please see the chat box and respond from the chat box. Thank you very much for the participants. Now we are very near to the close end of this session. So before ending this session, I request the moderator for our.
Thank you to our respected chairs, Dr. Pokhrel and Ms. Rana, for your valuable remarks. We also express our sincere gratitude to all the presenters for bringing the remarkable findings and making this session informative, insightful, and lively. These scientific evidences will certainly be conducive in enhancing evidence-based decision-making in nutrition sector of Nepal. Finally, to wrap up this session, I would like to humbly request Dr. Gehenath Baral, chairperson of NHRC, to present the token of love to our distinguished chairs, Dr. Taranath Pokhrel and Ms. Pooja Pandey Rana. With this, I would like to request you all for the group photo before ending this session. Okay. Thank you all and have a nice time. With this, I will hand over the mic to Ms. Asta Acharya for next session. Thank you. Suru.
It's up to you today to start making healthy choices. It's up to you today to start making healthy choices. Not choices that are just healthy for your body, but healthy for your mind. With this beautiful quote on mental health, let's begin the next session on mental health and substance abuse. Namaste and a very good afternoon to everyone present here and to everyone who are watching us virtually through Facebook and Zoom. Distinguished delegates, ladies and gentlemen, hope you all are having a good time. It's my immense pleasure to welcome you all in this session. I am Astha Acharya, working at Nepal Health Research Council, and will be the host of this session today on mental health and substance abuse. For this session, we have two renowned personalities. I would like to humbly request Professor Dr. Saurabh Prasad Oza to connect with us virtually and Mr. Mahendra Prasad Shrestha sir on the stage to chair the session. Dr. Oza is a professor and head of department in Department of Psychiatry, Tribhuvan University Teaching Hospital since 2015. He is the president of Nepal Epilepsy Society and past president of Psychiatrists Association of Nepal. He has published more than 40 articles in peer-reviewed journal. Similarly, he is the principal investigator of National Mental Health Survey, and he has been co-authors in mental health system in Nepal. He has developed national training curriculum on OST approved by MOHP. He is acting as a commissioner for the Nepal NCDI Poverty Commission and also involved in international research collaboration. In addition, he is actively involved in teaching learning activities of undergraduate, postgraduate students for more than 20 years and capacity building training for medical doctors, lawyers, judges, and paramedics in Nepal. We are pleased to welcome you, sir. Moving on, we have Mr. Mahendra Prasad Shrestha sir. During the COVID crisis in Nepal, he has played a leading role in Ministry of Health, and currently he is working as a chief specialist in Ministry of Health and co-chair of Policy Coordination Committee. He was also the Director General of Department of Health Service from February 2020 to June 2020. Talking about his work experiences, it starts from grassroots level institution to the Ministry of Health and Population. He has worked in all the health institutions, that is health post, health center, district, zonal, and central hospital, likewise district manager, regional manager to central level. He has also participated in different national, international level conferences, workshops. His major roles and responsibilities includes management of district public health activities, mainly family planning, safe motherhood, immunization, nutrition, community-based management of childhood illness, tuberculosis control, leprosy control, malaria, and other communicable disease control. We are very pleased to welcome you, sir. Now, I'd like to hand over the session to our chairs. Over to you, sir.
Thank you, Astha. Namaskar and good afternoon. First of all, I would like to express my sincere welcome to all distinguished delegates attending here in this NHRC hall and attending by the virtually. And I welcome our young scientists for this very important session. Today we have five young scientists presenting on mental health and substance abuse. Two of them are young ladies and three are young boys. So welcoming them, I request to my chair friend Dr. Saurabh to proceed the session. Thank you.
Thank you, Mahendra sir. Thank you, Astaji. Respected to all the team from NHRC and our speakers and our participants. Thank you very much. I think you must be tired. You must be mentally exhausted. So probably if you are really tired, mentally tired, what I can suggest for you is there is one you can see and go and see in YouTube, deep breathing exercise. In the deep breathing exercise, if you inhale deeply by expand your abdomen, and probably for 4 seconds you take the deep inhale from nostril and hold it for 4 seconds and gradually exhale through the nose, through the mouth. And if you do it for 10 to 12 times, probably our mental health will be relaxed, because we are living in a challenging times, and you know, plenty of our energies, mental energies we are consuming. And during these times, according to WHO, fear, anxiety, worry, stresses are the normal response, not the abnormal response. So that is why we need to take care of mental health. So Let us start our sessions, mental health and substance abuse. As my colleague already mentions, 2 papers on substance abuse and 1 paper on geriatric older age people, 1 for the children, among the children, and 1 for the home isolated patients, COVID-19. So all are, anxiety, stress, depressions, anyway. So I request all the speakers, because you are given the allocated times 10 minutes. So maybe in 5 papers, so we'll be spending 50 minutes. And after that 50 minutes, we'll have a question and answer session, and finally we'll conclude. And once again, thank you very much. Welcome. And let us start the first session, first paper. The first paper is from the Puspa Basnet. She's going to present us factors affecting psychoactive substance use among bachelor level students of Nepalganj sub-metropolitan city. May I request Puspa Basnet for the presentations?
Namaste to everyone. I am Puspa Basnet. I have recently completed my Masters in Public Health from School of Public Health, Patan Academy of Health Science. Now moving towards the presentation. My research title is Factor Affecting Psychoactive Substance Use Among Bachelor's Level Student of Nepalganj Sub-Metropolitan City. This research is part of my master's thesis, and which is done under the close supervision of Associate Professor Sital Bhandari and Assistant Professor Resu Agrawal. This research is awarded by Postgraduate Health Research Grant by Nepal Health Research Council. Now moving towards the introduction. Adolescent has identified as the peak period in which substance use occurs the first. Similarly, gateway hypothesis suggested that adolescents' early experimentation with illicit substances worsening to more addictive illicit substances use later in adulthood. In the context of Nepal, tobacco and alcohol are the major drug which is used in Nepal. Moreover, cannabis, codeine containing cough syrup, nitrazepam tablet, and buprenorphine injection are other drugs which are commonly abused in Nepal. Problem of drug abuse are localized in urban, semi-urban areas and along with the border of Nepal and India. From the extensive literature review, gaps like lack of in-depth studies in psychoactive substances, and there is no use of theoretical approaches to identify the factor affecting psychoactive substances. Thus, this study aimed to explore the factor influencing psychoactive substances use among bachelor's level students in order to provide social counterforces and intervention strategies against psychoactive substances use among bachelor's level students. This is the theoretical framework on which study was based on. From the extensive literature review, the following framework was suited to fulfill the objective of the study. This framework also provides the themes for the analysis of the information to be gathered. The pre-identified themes were biological, intrapersonal, interpersonal, and socio-cultural. Now moving towards the research method. This study was a cross-sectional qualitative study conducted on Nepalganj sub-metropolitan city on the month of August to September with participant as an authentic source of information and researcher as a facilitator. 13 in-depth interviews were conducted with bachelor's level students using psychoactive substances who were selected through the snowball sampling, and 6 key informant interview with parents or guardian, and 6 key informant interview with teachers of those students who were selected through the purposive sampling. And interviews were conducted until the information saturation takes place. A bachelor's level student using psychoactive substances and are above 18 years old are only included in this study. Open-ended performance and interview guidelines were used for the data collection, and interview were collected through telephone, which were audio recorded. All the recorded interviews were transcribed into Nepali, and then some of the transcripts were written to the participants for the verification. And then all the transcribed interviews were translated into the English language. Deductive thematic analysis was done for the data analysis, where RQDS software is used for the data management, and analysis was done manually by the researcher. For maintaining the rigor, member checking, positive percent agreement, verification of code by international qualitative data expert, and process documentation were done. All the transcribed and translated transcript were stored into the passport protected computer. Audio files were destroyed after the verification, and codes were given to the participant. For the dissemination of finding, consolidated criteria for reporting qualitative research, 32 item checklist were used, and abstract presentation and research article. Ethical consideration was taken from the IRC, Institutional Review Committee of Partner Academy of Health Science. This is the detailed information of participant. In this table, we can see that the course were given to the participant, each of the participant that were later used to present their narratives. It also helps to maintain the anonymity of the participant. Now moving towards the result, here we can see that in biological domain, age and heredity were identified as the risk factor, and but sex and physiology were identified as the both risk and protective factor which affecting the use of psychoactive substances. In the below, there are verbatim which support the identified factors. In intrapersonal domain, curiosity, experimentation, habit or dependence to show off and use for fun were identified as the risk factor. Similarly, but employment, mentality or state of mind were identified as the protective factor, whereas awareness, economic status, education, ethnicity, familial responsibility, free time or leisure, individual perception, knowledge about substances, and low paid job and motivation were identified as the risks and both risks and protective factors affecting use of psychoactive substances. In interpersonal domain, peer pressure, peer influence, peer pressure, seeing or coping other use of psychoactive substances, and in family were identified as the risk factor, but care from family environment, friend circle, and guidance were identified as the both risk and protective factor affecting the use of psychoactive substances. In sociocultural domain, advertisement, availability of sacred place for use, festival, open border, social function, and social media were identified as the risk factor, but perception of society, rehabilitation, and reputation were identified as the protective factor, whereas availability, culture and tradition, residence, rules and regulation, social acceptance and social environment were identified as the both risks and protective factor affecting use of psychoactive substances. Now, strength of the study, different categories of participants were selected, which helps triangulation of information. Different measures such as member checking, positive percent agreement, and verification of code and process documentation were done to maintain the rigor of the study. Finding can be considered as a starting point to initiate other exploratory study for the generalization, and finding can help conduct other qualitative research in similar topic. Now, conclusion and recommendation of the study. From this study, awareness, development of positive attitude, formulation of strict rules, social discouragement, and social norms were identified as a protective factor, whereas local authority of Nepalganj sub-metropolitan city can coordinate with the college authorities to plan and implement different activities for prevention and minimization of the psychoactive substance use. Personal therapies like cognitive behavioral therapies and self-control therapies can be implemented for the prevention of use of psychoactive substances. Similarly, social learning from role model who do not use psychoactive substances can provide major assistance in preventing use of psychoactive substances. And formulation and implementation of strict laws also prevent the use of psychoactive substances. Now, I would like to acknowledge my guide and co-guide, faculties of the School of Public Health, Partner Academy of Health Science, Institutional Review Committee PAS, authority and participant of Nepalganj Sub-Metropolitan City and Bachelor's level colleges. Similarly, Nepal Health Research Council and my friends and family. This is my references. Thank you.
Protective factors, and we can see our health ministry policy makers are here, and probably your way forward concluding remarks will be, I think, considered by our expert also. Mahendra sir, can I go for next? Can I go next?
Yes, sure.
Yeah. So next presenter is Mitesh Karna, and Mitesh Karna is going to present us the prevalence of substance abuse and its associated factors among medical students across sectional study. The previous one was the bachelor student study, and this is the medical among the medical across medical students among the medical students. So let us hear from Mitesh Karna, the second presentations. And thank you, Puspa, for your timely presentations. On time, you have covered your presentation within the time frameworks. Mitesh Karna ji.
Hello everyone, welcome to the 7th Virtual National Summit of Health and Population Scientists in Nepal. I am Mitesh Karna, currently a 4th year medical student at Gandhiki Medical College Teaching Hospital, and I am going to present my original research entitled Prevalence of Substance Abuse and its Associated Factors among Medical Students, a cross-sectional study. So, substance abuse refers to the harmful or hazardous use of psychoactive substances, including alcohol and illicit drugs. According to the Global Burden of Disease Study 2017, 585,000 deaths and 42 million years of healthy lives were lost as a result of substance abuse. According to the United Nations World Drug Report 2019, 271 million people, or about 5.5% of global population aged 15 to 64 had used drugs in the previous year, while 35 million people are estimated to be suffering from drug use disorders. Substance abuse is one of the major problems globally. The history of substance abuse in medicine, however, is not new, and the pioneers of modern medicine, such as Osler and Halsted, were also addicted with the use of psychoactive substances. Substance abuse has serious consequences because it compromises the standard of delivered healthcare services. Evidence suggests that substance abuse among physicians starts early in their careers, and the problem of substance abuse in ongoing physicians may be because of the substance abuse in medical school. So we did a cross-sectional study to find out the prevalence of various substance abuse, to find out the factors associated with substance abuse and the consequences of substance abuse. For this, we did an online cross-sectional study at Gandhiki Medical College Teaching Hospital. We enrolled MBBS students and we used a whole sampling method. We used modified online version of the health professional questionnaire developed by Kenna and Wood, and data was analyzed in SPSS 25. So this table shows the baseline information. Our response rate was slightly over 52%, and 219 participants responded to our survey, of which 52% were males and about 48% were females. So the sex ratio was of almost 1. A quarter of the students were from preclinical years of study, while majority of students were from the clinical years, and most of them stayed in a rented house. We also asked the participants about the problems of alcohol and drug abuse in the family, to which about 17% responded that there was a problem of alcohol abuse in the family, and there was a problem of drug abuse in the family was acknowledged by about 4% of the study participants. Interestingly, about 70% of the study participants said that they were offered alcoholic beverage by their friends, and about 4% said so for drugs. About 14% of the study participants said that they worked with a colleague who was under the influence of substances. This figure shows the lifetime prevalence of various substance abuse in our study. Alcohol was the most commonly used substance, followed by cigarette and illegal drug use, and the prevalences were about 58, 22, and 14% respectively. When we analyzed the distribution of substance abuse with various variables, it was found that the use of substance was significantly higher in males if the offer of substances were made by friends and if the study participants shared workspace with an intoxicated colleague. The reasons for substance abuse, according to our study, most commonly was for pleasure, curiosity, or to go along with friends, followed by supervising on-self for medical condition and originally prescribed but now using on their own, and also peer pressure. We divided the consequences of substance abuse into major and minor dysfunction as shown. And when asking the study participant about the effects of alcohol and drug abuse, 33 study participants, or about 15% of them, said they had minor dysfunction due to alcohol abuse, and about 4% said they had major dysfunction due to alcohol abuse. Only 14 participants said they had minor dysfunction from drug abuse, and only one said they had major dysfunction from drug abuse. We also asked the study participants if they felt they used alcohol or drugs more than they would consider appropriate, and the study findings are summarized in this table. 84% said they did not feel so, 15% felt they did so for alcohol, and only one each study participant felt they used drug or both substances more than they would consider appropriate. The overall prevalence of substance abuse among medical students varies from 3 to 85, and this rate is higher in Europe and North America. In an extensive study in South Asian medical students, the smoking prevalence was about 32%, which was higher than our study findings. Another study in India showed the prevalence of various substance use was about 32%. The precise prevalence of substance abuse for both medical students and general population in Nepal is not available. Various studies show the prevalence between 28 to 64%. A study by Panthi et al., which was done across 3 Nepalese universities in healthcare students, showed the overall prevalence of about 43%, which was less than the our study findings. So why this topic is important is because medical students now are the future doctors of the nation. Substance abuse and its effects among medical students impairs their learning ability and clinical judgment as physicians, and this may affect patient outcomes. This tarnishes the image that physicians have held for a long time as healers, and people responsible for treating substance abuse are themselves indulged in it. This problem thus needs serious attention from stakeholders and policymakers for production of efficient and competent physicians, both globally and locally. Summarizing our study findings, the lifetime prevalence of substance abuse was 58% for alcohol, about 22% for cigarette smoking, and about 14% for illegal drug use, and alcohol was the most commonly abused substance. The most significant predictors were peer influence and sharing the workspace with an intoxicated colleague, the commonest reason being for pleasure, curiosity, or to go along with friends. Participants reported both major and minor dysfunction, and the dysfunction was higher among alcohol-using group. Concluding, the prevalence of substance abuse was high among medical students. Substance abuse of medical students may affect their professional career as physicians and affect patient outcomes. Peer support systems and reward punishment system may be effective interventions to curb this problem. These are the references. Please say no to substance abuse. Thank you.
Thank you. Thank you very much, Mitesh Karna. You were also presented on time, within given time, and you have presented the descriptive online questionnaire-based cross-sectional study, especially the prevalence of substance abuse among the medical students. As you have mentioned that the alcohol and cigarette smoking are the commonly used substances, and that is very interesting finding. And you have also mentioned about the reasons for the taking the substance where pleasure, for curiosity, or for peer pressures. So I think, thank you very much, and we will come to the question and answer session. Please be there. May I request another third presenter, and moving from the substance abuse to another presenter going to present us the geriatric populations, risks and protective factors for anxiety symptoms among older people in Nepal, implication for practice. And the presenter is Dipendra Kaji Thapa. May I request Dipendra Kaji Thapa for your presentations?
Hello everybody, namaste. My name is Dipendra Thapa. First of all, I would like to thank NHRC team for selecting this paper and providing me this opportunity for the presentation. The title of my paper is Risks and Protective Factors for Anxiety Symptoms Among Older People in Nepal, Implications for Practice. And my co-authors are Dennis, Rachel, and Michelle. They are my PhD supervisor, and this paper is a part of my PhD. This is my presentation outline. First of all, I would like to talk brief about population aging and mental health, which is a core construct of this paper. We all know that population aging, which is also called the phenomena of demographic transition, which means the increment in the proportion as well as number of older people across the world. Although the proportion of older people is higher in developed countries, it is estimated that the highest increment in coming years can be expected in developing countries. By the year 2050, almost 80% of the world's older people will be living in low and middle income countries. In case of Nepal, the proportion of people is 60 years and above account for almost 12% in the year 2019. Aging population is susceptible to many chronic diseases and consequent disability, which may contribute to adverse mental health. WHO estimates 15% of the older people are living with a mental disorder, and the disorders include depression, anxiety, dementia, post-traumatic stress, and so on. And there are a range of adverse consequences of mental health, including suicide, social deprivation, higher utilization of hospital and community services, leading to more economic burden to the society. There are few studies conducted in Nepal regarding mental health of older people, and the previous research in Nepal says that the proportion of mental disorder is higher in Nepal as compared to their younger counterparts. And there is little attention provided to anxiety disorders because there are very few anxiety disorders, and there are a handful of studies which attempted to study the correlations, which include risks and protective factors of anxiety disorder among older people in Nepal. So against this background, the objective of this study is to assess the prevalence of anxiety disorder among older people and to find out the factors associated with anxiety disorders and to identify protective social factors which may promote mental health among older people. The methodology is cross-sectional community-based survey. We employed multi-stage random sampling, and the study site included Arghakhachi and Rupandei district of Lumbini province. Study unit were older adults aged 60 years or above, having an adult children. We did a face-to-face interview using structured questionnaire, and the data was collected using RedCap, which is an online data collection platform in tablets. And the field work for this study was conducted in May-June 2019. This is sampling procedure. I have included different steps adopted for sampling. First, we selected 2 districts. Then after, from each of the 2 districts, we randomly selected 3 local units, either municipalities or rural municipalities. And from each of the selected rural municipalities, we further sampled 3 wards. So there were altogether 18 wards. And the sampling frame was developed from these selected rural municipalities, selected wards from the voter list of Electoral Commission of Nepal. A total of 794 samples were collected and analyzed. The exclusion criteria included older adults who are institutionalized. That means either they are staying in hospital or in old age care homes. Regarding the measure of concepts and variables, the main outcome variable was anxiety, which was measured by anxiety subscale of the 31-item version of depression, anxiety, and stress scale, which is also called DAS-21. And anxiety subscale has 7 items with the score ranging from 0 to 42. And this scale has been validated among Nepalese-speaking population in Hong Kong as well as in Nepal. I included a range of socio-demographic variables. both at household and individual level. You can see the list of variables which was measured in this study. Similarly, other independent variables included physical health, measured as perceived health status, and self-reported chronic conditions, functional ability, social support, participation in social activities, lifestyle habits, which included physical exercise, alcohol use and smoking habit, and adverse life events. Ethical approval was obtained from the Nepal Health Research Council as well as the University of Tasmania. And after the end of the interview, participants who showed symptoms of distress were referred to nearest local health facility. Data was analyzed using descriptive statistics, bivariate analysis, as well as multivariate analysis. For multivariate analysis, we use multi-level mixed effect logistic regression, estimating odds ratio. 3 levels hierarchical models were used as the samples were nested within municipalities and the municipalities were further nested within districts. And the final model were arrived using backward selection method, including only variables which are significant at p less than 0.05. Data was analyzed in Status version 16. Validity and reliability, we used random sampling at different stages, and the questionnaire was piloted prior to administration, and online data collection platform was used, which provided real-time monitoring and feedback provision. And regarding reliability, almost all of the tools were standard tools were used, and the reliability coefficient for anxiety subscale in this study was found to be 0.79, which is adequate. We have also conducted a study on psychometric properties of this DAS-21 scale in Nepal. Now I would like to go to results section. Here I have included socio-demographic characteristics. Slightly less than 50% were female. Mean age was 71.1 years. Similarly, you can see other socio-demographic characteristics. For example, around 90% of older adults were receiving pension, 58% were receiving allowance, and more than half have at least one children who are living outside the country at the time of survey. The mean score for anxiety symptoms was 3.6 with the range of 0 to 36. And as per the recommendations on the DAS-21 scale, I have categorized the score into normal, mild, moderate, severe, and extremely severe. And for this analysis, I considered this anxiety score into dichotomous binary variable, which means those who are showing any symptoms of anxiety were considered as having anxiety present, and the remaining were having no anxiety, that is anxiety absent. So that means around 82% has prevalence of anxiety symptoms, and remaining 18% they do not have. They have anxiety presence. So the prevalence of anxiety symptoms is 18.1% in this study. This figure shows the bivariate analysis on the difference in prevalence of anxiety symptoms. Here you can see female has higher prevalence. Those who have low level of education have higher prevalence. Similarly, those who are single, here the single means divorced, separated, or widowed, they have higher prevalence, 22.9%. And in this table, we can see those who watch television, those who read newspaper, they have lower prevalence. And those who have children migrated outside the country, they have higher prevalence. And further, there is a marked difference between older adults who are exposed to adverse life events. This is the results of multivariate analysis. You can see the adjusted odds ratio. There are a number of variables are found to be associated with anxiety symptoms. And I have summarized the key findings from the table in this slide. Basically, the prevalence was found to be 18%. That means compared to the previous studies in Nepal, it's a quite low prevalence, which could be because of the convenient sample and low sample size used in other studies, as well as because of the measurement instruments. And to our knowledge, this is DAS21 has been used for the first time among older adults in Nepal. And the risk factor identified were female gender, working in agriculture, perceived poor health, chronic conditions, migration of adult children, and exposed to adverse life events. Accordingly, the protective factors for mental health, especially the anxiety, is receiving an allowance, physical exercise, functional ability, and receiving social support. So in conclusion, given there is a lack of studies on older people's mental health in Nepal, this study aids our understanding on anxiety symptoms and provides a set of risk factors for anxiety symptoms, and the interventions for promoting mental health among older people should incorporate socially protective factors, which include promotion of physical activity, social support mechanism, optimizing functional ability, enabling community participation, providing public security such as old age allowance, and identifying and treating concomitant physical illnesses. The same thing I have depicted in this figure. So based on the findings, we can identify at-risk older people's populations for anxiety disorders. They are female gender, working in agriculture, who are exposed to adverse events, who have concomitant physical and chronic conditions, whose children are migrated outside the country and who have poor functional ability. So these specific groups can be further selectively screened for presence of clinically relevant anxiety disorders, and a set of health and social care interventions should be prioritized.
Okay, thank you, Dipendraji. Thank you very much. You have presented the anxiety symptoms among the older people of Nepal. Basically, you have discussed about risks and protective factors. Thank you very much. I think we will also come in the question and answer sessions. And moving to the another session, the fourth paper, depression, anxiety, and stress among home isolated patients of COVID-19 in Karnali province of Nepal. And presenter is Bikram Adhikari. May I request Bikram Adhikari for the presentations?
First of all, I would like to thank Nepal Health Research Council for providing me this golden opportunity for oral presentation in this 7th Virtual National Summit of Health and Population Scientists in Nepal. This is me, Bikram Adhikari, and today I am presenting on our research on depression, anxiety, and stress among home isolated COVID-19 patients in Karnali province of Nepal. This is the list of our team members along with their affiliations. COVID-19 has the potential to cause severe social, economic, and mental health crises with long-term consequences. Psychiatric disorders, including depression, anxiety, and stress, are substantially related to COVID-19 pandemic. The misinformation from the media, lack of knowledge on COVID-19, lack of effective treatment, and significant economic loss, they have resulted in higher level of depression throughout the world. In context of Nepal, COVID-19 infected people are forced to isolate themselves at their home, and there is COVID-19 related stigma in our society. These all are affecting the mental health of people and patients, resulting in depression, anxiety, and stress. There are limited studies conducted in context of Nepal addressing mental health issues of COVID-19 patients and COVID-19 patients under home isolation. Our study aimed to determine the prevalence of depression, anxiety, and stress among COVID-19 patients under home isolation in Karnali province of Nepal. And we also aimed to determine factors associated with depression, anxiety, and stress among them. We conducted cross-sectional study among home isolated COVID-19 patients in Karnali province. And the study duration was from January 2021 to May 2021. The recruitment process. First of all, our resource team received the list of COVID-19 patients under home isolation from Ministry of Social Development, Karnali Province. And our resource team actively called all those patients. And those who meet eligibility criteria, they were enrolled in our study. The inclusion criteria were COVID-19 patients under home isolation from Karnali Province and those with the age more than 18 years. The exclusion criteria were those who do not give consent and those with speaking and hearing disability. A total of 521 patients patient lists were obtained. And we called all those 521 patients, of which only 409 patients were available in telephone. And we access 409 patients, and of 409 patients, 402 participants were eligible for our study to enroll. We obtained ethical approval from Ethical Review Board of NSRC, and we obtained approval from Ministry of Social Development, Karnali Province. We provided detailed information about our research to participants and took verbal consent from the participants before enrolling them into our study. And we maintained confidentiality and anonymity throughout the study, and we assured that the participation was voluntary. In our study, the dependent variables were depression, anxiety, and stress, and they were measured using DASH21 scale. And independent variables were socio-demographic characteristics, including age, sex, poverty level, educational status, ethnicity, marital status, and type of family. Health condition and substance use include comorbidities, symptomatic status, home remedies, and alcohol and smoking. They were measured through questionnaire. The DASH21 scale, developed by Lovivond et al., it consists of 21 items, and the domain depression, anxiety, and stress were measured by 7 items. And depression, anxiety, and stress were categorized into normal, mild, moderate, severe, and extremely severe based on the cutoff value shown in the table here. The data collection was done in COVID Toolbox platform, and the data was directly exported to R for data analysis. Talking about statistical analysis, we presented normally distributed numerical variables as mean and standard deviation, non-normally distributed numerical variables as median and interquartile range, categorical variables as frequency and percentage. Klopper-Pearson method and Wilson method were used to find out the confidence interval around the proportion. Bivariate and multivariate logistic regression were used to find out the factors associated with depression, anxiety, and stress. And all tests were carried out at 95% confidence interval. Now let us talk about the findings of our study. Of total 402 participants, 67.4% were male. The mean age of the participants was 37 years. The majority of the participants were Brahmin and Kshetri. 74.8% were married, 83.3% were from nuclear family, and 18.4% were living below poverty line. Out of total participants, 10.4% have any one comorbid conditions. 41.5% have at least one COVID-19 symptoms. 76.9% did some home remedy for their condition. 91% were never smokers, and 99.3% did not use alcohol in past 7 days. Talking about the prevalence, depression, and anxiety. Talking about the prevalence of depression, anxiety, and stress, the prevalence of depression was 8%, anxiety was 11.2%, and stress was 4%. The prevalence of extremely severe depression was 0.7, extremely severe anxiety was 2.7, and extremely severe stress was 0.5%. The prevalence of moderate depression was 3, moderate anxiety was 2.5, and moderate stress was 1.7%. In our study, from multivariate logistic regression, we found that higher odds of stress was present in elder age group and those with COVID-19 related symptoms. The higher odds of anxiety was seen in the participants from joint family and those with the any comorbid condition and those with COVID-19 related symptoms. The odds of having depression among those with COVID-19 related symptoms was 2.81 times the odds of having depression among those who do not have any symptoms. Talking about the strengths and the limitations of the study. Strengths. Our study consists of relatively large sample size. We use pre-tested questionnaire, validated, reliable, Nepali translated standard -21 scale, and we cross-checked data, collected data for cleanliness either at the end of every week. The limitations of our study were the cross-sectional nature of our study prevents us to find out the directionality of the association. The symptomatic and comorbid status of the patients were self-reported, so they may not be accurately measured. And we could not control the confounding effect of childhood adversity and occupation-related factors like job insecurity, family or balance, etc. In conclusion, the prevalence of depression, anxiety, and stress were 8%, 11%, and 4% respectively among home-isolated COVID-19 patients in Karnal province. Depression was positively associated with symptomatic status. Anxiety was positively associated with being from joint family, comorbidity, and symptomatic status. And stress is positively associated with age and the symptomatic status. And thank you. At last, I would like to thank Bill Gates and Melinda Gates Foundation for financial support for this project, COVID-19 response in Nepal, through which we conducted this research. And we would like to acknowledge all those respondents of our study, and we'd like to acknowledge all those who directly and indirectly involved and support us in this project and research. Thank you.
Thank you very much, Vikram Adhikari, for your within time presentations. And you have brought the prevalence of depression, anxiety, and stress among the home isolation of COVID-19. We will be also discussing during discussion times. Thank you very much. And the final last presenter, this paper is going to present by Nishtha Shrestha, and she is going to present us 3 years later emotional impact of the 2015 earthquake on children in Nepal. So may I request Nishtha Shrestha for your presentations.
Namaste. Hello, everyone. I am Nishtha Shrestha, and I am a PhD student. Today, I will be presenting some of the findings of my PhD research. The title of this presentation is 3 years later, Emotional Impact of the 2015 Earthquake on Children in Nepal. The overview of the presentation, I'll be providing a background of my research, the methods that I followed, the results obtained, and the conclusion. Nepal is vulnerable to disasters. The recent incident of floods in Sindhupalchok is an example of how disasters tend to impact the citizens of Nepal. On April 25, 2015, 7.6 magnitude earthquake had struck Nepal. 8 million people were affected, out of which 3.2 million were children. According to Patel, research in child and adolescent mental health is very limited in low and middle income countries. Though trauma has various impacts such as depression, grief, shame, difficulties in interpersonal relationships, low self-esteem, PTSD has received the most attention from the researchers. Children below 14 years constitute 34.9% of the total population. And because of this particular reason, we need to look at what are the issues that this particular age group are facing. And this will allow us to provide the needed help to this particular age group. In Nepal, the mental health policies have been created, but they have not been implemented, due to which it becomes difficult to reach out to the people who need help. And according to Serjan, after the earthquake, there was a need for mental health service. But since the infrastructures were not in place, it was very difficult to meet this demand. There are some positive signs, such as the recent publication of the National Mental Health Survey. But overall, the mental health of Nepal needs a lot of improvements, and we still have a long way to go. The objective of this particular study is to identify the long-term emotional problems of the children affected by the earthquake in Nepal. This is the map that shows the different districts that were affected by the earthquake. And in this particular study, we focused on Kathmandu, which is one of the crisis-hit areas. In this particular study, children between the age group of 8 to 14 years who were studying in 4th and 5th standard were selected, and they were selected using the purposive sampling. The parents of the children completed the strengths and difficulties questionnaire, which is a 25-item scale that allows us to assess the emotional and behavioral problems of the children. And it has 5 subscales, which are the emotional problem subscale, the conduct problems, hyperactivity, inattention, peer problems, and pro-social scale. And children fill the level of exposure scale, which is a self-administered questionnaire that has 6 items, and these tend to measure the experiences of the earthquake. This particular figure shows how the sample in this particular study was chosen. As mentioned earlier, there were 14 affected districts, and Kathmandu district was chosen. Kathmandu district has 11 municipalities, out of which the Kathmandu metropolitan city was chosen. KMC further has 32 wards, and 4 schools in the wards with highest adult death rate were chosen. 616 children were identified, out of which parents of 526 children gave consent. And out of these 526 children, 72 children were identified to be ineligible based on the inclusion criteria. The inclusion criteria of this particular study was that the children need to be present in Kathmandu at the time of the earthquake. They should not have any prior illness, and they should not have undergone any form of counseling after the earthquake, and they should be studying in 1st and 2nd grade when they were in 2015. So based on these screening, the final sample was 454 children. The socio-demographic table shows that 220 children were from public schools, and 234 children were from private schools, and 208 were boys, and 246 were girls. Table 2 shows the distribution of the children into low, average, and high category of total difficulty score based on the different variables. And in this particular study, 149 children were in the higher category, 152 were in the average, and 153 were in the low category. The correlation between level of exposure and strengths and difficulty subscale shows that there is a positive correlation between total difficulty score and level of exposure, and also a positive correlation between level of exposure and peer problems. The study also explored the role of gender, socioeconomic status, type of family, and level of exposure on the emotional problems. And the bivariate analysis revealed that there were differences between boys and girls in terms of the total difficulties, conduct problems, hyperactivity, peer problems, and pro-social scale. And in terms of socioeconomic status, there were difference between the poverty and non-poverty group in terms of the emotional problem subscale. There were no differences in terms of type of family and level of exposure. The regression analysis revealed that there was a significant regression equation in terms of the conduct problems, and there was, and 4.3% of the variance was variance in conduct problems was explained by this particular model. And according to Ferguson, this is a recommended minimum effect size representing a practically significant effect for social science data. And in this particular model, gender and level of exposure were identified to be significant predictors in this particular model. In this particular study, the parents were also asked to identify the changes that they had observed in their children after the earthquake, and they reported behaviors such as restlessness, inability to perform tasks independently, refusal to attend school, poor memory, academic decline, etc. So all these observations of the parents also show that the children were impacted after the earthquake. The conclusion, emotional problems such as conduct problems, hyperactivity, inattention, peer problems exist even after 3 years of the earthquake. And this shows that we need to conduct monitoring even in the long term and not be limited to short-term measures. And another important point is that we need to conduct disaster skills training for these children. And these training need not only be limited to how to save themselves physically, but also teach them coping strategies. So that the advantage of teaching these skills is that they can use these skills to handle other stresses in their life as well. And based on the experience while conducting this research, parents and teachers also need to be involved when we are conducting research with children, because they provide information which are sometimes missed by the researcher. So this is something that the future researchers need to keep in mind. Gender differences to trauma exist because in this study it was found that boys had higher levels of conduct problems, hyperactivity, inattention, and peer problems. So these difference in the way how boys and girls respond to trauma needs to be kept in mind when we assess them. Exposure to trauma resulted in higher levels of emotional problems in children. So we need to prioritize these highly affected groups when we are designing and implementing interventions after a disaster. Lower socioeconomic status is a risk factor for emotional problems, and this could be because these people from the lower socioeconomic status had difficulties of fulfilling the basic needs. They had housing problems, lack of health care after the earthquake, and this could have impacted the children from this particular group. No difference in emotional problems based on type of family. In this particular study, we focused only on the type of family, but if future researchers could look into other aspects such as the parent-child relationship, type of parenting, parental psychopathology, then probably we could have more a better understanding of how family tends to impact the emotional problems in children. I believe that this particular study is relevant even in the current times because COVID-19 is a stressor for children, similar to the earthquake. And considering how the pandemic has disrupted the normal routines of children, exposed them to death, has made it difficult for them to regulate themselves. So these variables that have been identified in the study, such as gender, severity of exposure, lower socioeconomic status, all these variables have been identified as risk factors for children. So these variables need to be kept in mind when we assess children and we see how the pandemic has impacted the children. So I would like to conclude my presentation by stating that we cannot stop any disasters, and we also cannot protect the children from any form of trauma that they might face in their life. But what we as clinicians and researchers we can do is that we can conduct screenings, we can design interventions that are suitable for the Nepali population. And I believe that the school-based interventions are the best way to reach out to the children in Nepal because of the way that parents or the teachers listen or react to mental health issues. So if we are able to design school-based interventions that not only not only protect the children when they show the symptoms, but also prevent these symptoms from impacting the children, then if we're able to take these small basic steps, then I believe that we can protect the mental health of the children. These are my references, and thank you.
Thank you very much, Mr. Sestaji. Once again, congratulations all the 5 speakers. Your presentations was within the time. And Nistaji, you have presented the emotional problems of the Nepali children, especially even after 3 years of the great earthquake. And you have also described, you have also found the different types of emotional problems among girls and boys. And as you rightly mentioned, that school-based intervention is one of the key we can also initiate. Thank you, all the speakers. Now we will go for the question and answer sessions. Mahendra sir, would you like to?
Thank you, Dr. Saroj. I think according to our technical friends, all the queries arised by the participants are addressed by our presenter by chat.
Yeah.
And they have already responded.
Yes.
And I have just last one question. That is for Nista Shrestha. Comments from Ravindra Bhandari. Nistaji, were there any reasons behind the gender difference to trauma?
Among boys and girls.
and anyone's attendee to Nistaji, are the information given by those children when they were at class 1 or 2 after so many years reliable? Because the history effect that what are the bias you suspected and how do you overcome? Two questions to you.
First, thank you, sir, for reading out the question, and thank you for those questions. The first question was there any reasons behind any gender differences? So I suspected the reasons for how boys and girls react could be because in this particular study, the parents were the informants of the children's problems. So they were the ones who identified what were the problems that their child was facing. So and it's much more easier to see these external behaviors. So when children is moving around, it's much more easier to say that the child is not behaving normally than when we see children who are facing some sadness inside. So for parents, these external signs are much more easier to observe. So that could be one of the reasons why these children were identified. And also in Nepali society, it's okay for boys to be restless. It's okay for boys to be aggressive. But the girls are not trained in that way. We are taught, being a girl myself, like we are trained to be, we are trained to be docile. We are trained to be following the social norms. So I believe that this cultural factor could also be the reason behind the gender differences. And regarding the second question, I mentioned that the children were from class 1 and 2 in 2015. But when they were a part of this particular study, they were studying in class 4 and 5. And this was a major concern that people had suspected that whether children do remember these incidences. But when we talk about incidents such as experiencing death in the family or seeing some destruction or seeing death live, as some of the children in my particular study had reported seeing people being crushed by the buildings. So these kind of traumatic incidences tend to stay with children, though we tend to think that children don't remember such incidences. So I believe most of the time I encountered people in the study saying that children would have forgotten, they don't remember, so they're okay. So I believe this kind of myth also needs to be targeted, and I believe this study highlights that myth as well, because children remember. Just because we think that they are not showing any signs, we tend to ignore it, but it is our duty as adults to ask, and I believe if you ask them, they'll certainly tell what they are facing. I hope I answered the questions.
Yes, thank you very much. I think, no, I think all the queries were covered by our presenter in their respective chat box. First, thank you. First of all, I would like to thanks to National Health Research Council for giving this very important forum for our young scientists. And I think this is the 7th year continuously organizing this type of conference, and due to this COVID pandemic, and we are organizing differently, virtually. This is not the 7th virtual, this time is only the twice virtual, 2nd virtual and 7th National Summit. So that is very good, and thanks to all the team for organizing. And I'm much more happy with all the 5 presenters, because the topic covered, very important topics are now covered. Post-COVID, post-earthquake, and young children to adolescent, old age people, all the areas is captured in this 5 presentation. And most of them have managed their time. Only Dipendra ji, we gave him additional 2 minutes, and still not covered. So that was our limitation. And I must congratulate and thanks to all the 5 presenters. And I have very few suggestions to our our emerging scientists. Few papers were very vague. I think research should be concentrated on specific agendas. vague things, I think, makes very difficult. Whether this is research or survey or study is very difficult. So my humble request to be more specific, and that gives some guidelines for the further planning and action purposes as well. And having saying this, I think I have very experienced professor of mental health, and he will explain much more things. Having saying this, I again congratulate you all, and express my sincere best wishes for your coming endeavor. Thank you very much.
Finally, sir, thank you very much, Mainer sir. I must thank NHRC, Professor Gayanath Baral, and all the team from NHRC. And today's paper, especially the first two papers, Puspa Basnet and Mitesh Karna, substance use among the bachelor students, among the medical students. And this is not only bachelor medical students, this is very, very interesting things, especially alcohol and cigarette smoking is quite common. And these are the gateway substance. And from these illicit drugs to illicit drugs like cannabis, the opiates, and there are so many things. So, and these papers definitely give us some kind of the college-based interventions to primarily prevent the substance use problem in Nepal, I think. The third paper was from Dipendra Thapa, and especially he was talking about risks and protective factor for anxiety symptoms among the older people. Especially he was talking about, some kind of risk factors, female genders are the risk factor, chronic health conditions, especially in old age people, they are the risk factors. And interesting finding, he mentions like migration of the adult child. This is another risk factors. And in his findings, receiving allowances, social support, participation, physical exercise. So these are also the key things which I think we can also make some way forward to these geriatric people of our country. And the fourth paper by Vikram Adhikari, Depression, Anxiety, Stress among the home isolated COVID-19 patients. As I have already mentioned, we are living in that challenging times, and plenty of our mental energies we are consuming because of stress, because of anxiety, because of depressions. So always I like to say that these anxiety, stress, and depressive symptoms are the normal response during this pandemic, and we need to manage our mental health. And he has also mentioned about some factors associated with depression, anxiety, stress. That was interesting paper. And the final paper was even after 3 years, our children people, as Nistha mentions, 34% people of Nepalese population are under 14 years of age, and the impact of the earthquake, still the emotional problems like conduct problems, like attention problems or peer problems. So these are there, and we need to intervene these issues through the school base or some kind of general public awareness. And once again, thank you very much all the speakers and NHRC. With this, I would like to conclude this session's mental health and substance abuse problem. I would like to hand over the NHRC team. Maybe Astaji will take over. Once again, thank you very much and namaskar.
Thank you so much, Mr. Mahendra Prasad Shrestha sir and Professor Dr. Saroj Prasad Oja sir and all the presenters for making the session vibrant. Finally, to wrap up the session, I'd like to call upon Professor Dr. Gayanath Baral sir, Chairman of NHRC, and Professor Dr. Gaurav Raj Dhakal sir, Vice Chairman of NHRC, and Dr. Pradeep Gewali sir to hand over the token of love to our respected chair. Now I'd like to call upon Ms. Neelam Dhakal for next session. Thank you all.
Welcome back, distinguished delegates, ladies and gentlemen. A very good afternoon to you all. Namaste, I am Nilam Dhakal. I am working as a research officer at Nepal Health Research Council, and I'll be the host of this session today on environmental health, pharmaceuticals, and biomedical research. I feel privileged to welcome you all in this session. We are now at the very last session of this summit. I hope all the sessions have been informative to you all. To initiate the session, I would like to invite Professor Dr. Sarath Onta and Dr. Vishnu Babu Thapa as chairs. Dr. Sarath Onta will be joining us in a very short time. Till then, ladies and gentlemen, please welcome our respected chairs with huge round of applause. Introducing Professor Dr. Sarath Onta. I would like to introduce our chair, Dr. Vishnu Babu Thapa. Dr. Thapa has completed his MBBS from Manipal College of Medical Sciences, Pokhara. He has completed MS Ortho from National Academy of Medical Sciences, Kathmandu. He has done his fellowship in spine surgery from New Delhi, India. He was also a visiting scholar of spine surgery in China and Japan. He started his academic career as an assistant professor at National Academy of Medical Sciences. Currently, he is working as an associate professor at Nepal Army Institute of Health Sciences. He has published numerous papers in several journals and also presented papers at national and international platforms. We welcome you, sir. Similarly, I would like to introduce Professor Dr. Sarath Onta. For this session, there are two invited talks. Firstly, I would like to introduce our chair, Professor Dr. Sarath Onta, sir. Dr. Onta is a public health professional and academician. He has his degree on MBBS and MPS, and he has completed his PhD from Denmark. He is now a retired professor of community medicine and public health at Tribhuvan University. At present, he is president at Physicians for Social Responsibility Nepal. Likewise, he is also a country coordinator at People's Health Movement Nepal. Previously, he worked as an assistant dean at Institute of Medicine at Tribhuvan University. Similarly, he served as an executive vice chair of National HIV and STI Control Board under Ministry of Health and Population. He has also been a former member secretary of Nepal Health Research Council. Moreover, he has worked as a member of high-level policy advisory body at the Ministry of Health and Population. He has published several research articles in national and international journals, produced several research reports, and has contributed to chapters of several books. Welcome, Professor Dr. Onta.
Thank you. Thank you.
Once again, I would like to request all of you to welcome our respected chairs with huge round of applause. Now, for this session, there are two invited talks. I would like to welcome our invitees, Engineer Raja Rampote Shrestha and Mr. Binay Chalise, to this session. Further, we have 4 oral presentations in this session. I would like to invite all of the presenters to this session. At the end of this session, we'll have a question and answer discussion section of 20 minutes. Dear audience, if you have any queries regarding the presentations, kindly drop your comments on Q&A box, and it will be discussed at the end after all the presentations. All the presenters of this session are requested to be online throughout this session. Now with this, I would like to hand over the session to our respective chairs. Over to you, sir.
Thank you very much. Thank you. I think we don't have to remove the mask. And we shouldn't remove the mask. We'll stick with the mask. So good. So thank you very much. Now I think we should proceed with the. Yeah, thank you. Now we should proceed with the presentations because I think one of the positive points of this session is the diversity of the presentation, diversity of the themes that we are trying to cover. That the presentations will be covered in many ways. I mean the theme of the presentations are quite diverse, and the first presentation by Engineer Rajaram Shrestha. Engineer Shrestha is a National Professional Officer at World Health Organization, WHO, Country Office for Nepal. He has an academic degree on Master in Science in Civil Engineering, which completed the advanced course on Environment Management. He has also completed several training courses on environmental health related subjects at both national and international levels. And he has more than 2 decades of professional experiences with government, non-government, and international agencies. So please welcome Engineer Rajaram Shrestha. Now it's over to you, please. Presentation, please.
Yeah, thank you. Thank you very much, respected chairs, distinguished participants. First of all, I would like to thank NHRC for giving me this opportunity to highlight this very important public health topic, that is climate change. Yes, currently in Nepal, we are having problems of these landslides and floods in different parts of the country because of the extreme rain. And we all know that just yesterday, we heard about the deaths of around 230 people in Canada because of the extreme heat. So we know that at the global level, at the national level, and at a different level, the problem of the climate change is there, and our concern is that because it has the significant health impacts. I would not like to take much time under this global warming, because we all know that temperature is increasing at the global level and also at the national level. So when we talk about the global warming, we know that if you compare today's average temperature with pre-industrial era, it is already around plus 1.2%. And our worry is that it is continuing to increase. And also under this rainfall side or the precipitation side, the global trend is that it is going to decrease. That is the same true in the Nepalese context as well. That means that we are having the more drought in the near future. When you talk about the climate change scenario in Nepalese context, we have some good scenario analysis, because recently the Department of Health and Department of Hydrology and Meteorology published the reports, and it clearly shows that the average temperature, both in terms of the minimum temperature and also in the maximum temperature, they are increasing. The increase is almost most significant in the northern parts of the country, but there is also the increase in the Tarai as well. We know that the Paris Agreement has set a target to limit increase of temperature about 1.5 degrees centigrade. But when we see the recently published ICMOD report on the Hindukush Himalayan assessment, that shows that this 1.5 means to us, Nepal and the Hindukush region is around 2.2 degrees centigrade. So the global warming is very much significant to Nepal, and that's why the Nepal is one of the most vulnerable countries in the world. Although when we talk about our contribution to the global warming, it is only the 0.027, that is very negligible. But when we talk about the impacts of the climate change on all spheres of the life, it's very significant, and particularly on the health side. So we know that we have the increased temperature, we have the change in the rainfall pattern, extreme rain in some cases, and even in the monsoon, sometimes we don't have any rain at all. Uh, and there are some social and environmental determinants of the health. That is, we can call it is air pollution, changes in the bacterial ecology. There are some relation with water quality. All these determinants or the aspects have resulted in the public health issues. That means there are the number of the climate sensitive diseases like malaria, dengue, and it is not limited only to these vector-borne diseases. We also have some evidences, and in Nepalese context as well, there are some increased cases of the malnutrition like diarrheal diseases, also there's some health related heat-related issues, also the mental health impacts. So that's why the impacts of the health, impacts of the climate change, the health is very much significant and very much concern for all of us. WHO calculated that since 1970, only the climate change caused the deaths of the around 170,000. So the another estimates is that in between the 2030 and the 2050, there will be additional deaths up to 250,000 because of this climate change. There are the significant economic losses in the country, and the most important thing is that Nepal, like the developing countries with weak infrastructure, with health infrastructure facilities, have to suffer a lot, and that's why there is a time to address and time to build the climate resilience system. Not only in the Nepal, at the global level, in almost in all cases, there are the increase the cases of the vector-borne diseases, waterborne diseases. Recently, WHO published a report with analysis of the vulnerability and adaptation assessment of the 31 countries, and it shows that there are significant impacts of the climate change on the increase of the vector-borne and the climate-sensitive diseases at the globally, and that is also true in the Nepalese context as well. So the well-renowned Lancet document, even in the 2009, mentioned that the climate change is the biggest global health threat of the 21st century. That is still true. And recently, WHO Director General Dr. Tedros, when we discussed with the medical personnel in the Geneva during the March of the medical professionals, he clearly says that there is no vaccine for climate change, because at the time of this pandemic of the COVID, when we are talking about these vaccines to address the pandemic, but for the climate change, there is still no vaccine for the climate change, and we have to build and we have to strengthen of the health system, that is the climate resilient health system. Also, WHO CRO Regional Director Dr. Poonam Chatterpal Singh also mentioned about climate change as a major and one of the important risks to the public health while talking with the MEDA person, and when talking in the during the 17th session of the WHO season CRO Regional Conference in the Mali. When you talk about Nepal on the impacts of the climate change on the health, yes, in media, if you look into the media coverage, almost in every week there are many news on the impacts of the climate change, especially on the vector-borne diseases like Himal Chirachade Kalajar, Himama Lamkute, Himal Chetrama Olodo. Not only in the national media, even in the New York Times, this issue has been reflected, and it also shows that there is a concern from the media, concern from the general public, and not only from the government officials, also from all the people have felt the impacts of the climate change. So it is the right time to address this issue. We do have some evidences. I would like to cite a few of them. So there was a recent publication on the association of the vector-borne diseases with climate variables in Nepal in Science Direct, just recently in the May 2021. Dr. Dhimal is one of the authors, and this assessment and this study clearly shows that there is a close relation between the 6 climatic variables with several vector-borne diseases. Also, we know that the dengue first case was detected in 2004 in Chitwan in foreign. But when we see the reports from the EDCD in 2019, the case reached around 14,662. So it shows that there is a significant increase of the cases of the vector-borne diseases. One of the reasons is that is the climate change. The not serious issue for all the public health professionals. Also, with support from the WHO, NHRC carried out a study linking the diarrheal disease with the climate change, and the study also shows that if there is a 1 degree increase of the temperature, the 4.39% diarrheal cases will be increased. So it also shows that not only the vector-borne diseases, also the waterborne diseases has also close link with climate change. But we do have a few documents that is enough to build climate resilient system, health system in Nepal. One of them is operational framework that was published by the WHO headquarters in 2015. It's about the operational framework for building climate resilient health system. It also talks about the strengthening of the 6 building blocks from climate change perspective. For example, let us consider the health information system. That's one of the key building blocks of this health system. So till now, when we talk about the health information system, we talk about the generation of the data and the data management. But when we talk about in view of this climate change perspective, then we have to carry out the vulnerability and adaptation assessment on a regular basis using the health information system, based on the health information system. Similarly, we have to strengthen the early warning system. Also, we have to carry out the research focusing on this climatic impacts of the climate change impacts on the health system. So, but the good thing is that in Nepal, we have already carried out vulnerability and adaptation assessment of the health sector. That was carried out in 2015 with the support of the WHO. It covered the period from 2001 to 2010. Under the leadership of the Minister of Health and Population. And that report clearly shows that out of 10, 75 districts.
We have 2 more minutes, Engineer.
Okay, okay, thank you. Around the 42 districts were the higher and very significant in terms of this climate change impacts. So, based on that vulnerability assessment, Minister of Health and Population approved and now is being implemented this health adaptation plan with the 5 strategy objectives. Recently, Minister of the Forest and Environment is also working on the development of the National Adaptation Plan, with health is one of the key thematic areas, and it clearly identifies the district in terms of this health vulnerability. So, when we talk about the response, there are some good documents, and also there are some projects that has been supporting to build the climate resilient health system in Nepal. So we also have some achievements. For example, the issues have been well reflected in the policy documents. We already have the VN assessment and the SNAP. There are some research evidences even at the national level. Also, there are the training manuals on the climate change and health, training manuals on the climate change and BBD, and this training is being conducted at even at sub-national levels. And also the work on the strengthening of the climate sensitive disease surveillance system is ongoing. And also there are some resources that has been supported by the national government, provincial government, as well as there are some development partners which are willing to support to build a climate resilient health system. But again, still we have to do a lot of things on building the climate resilient health system, because there are several health program where this climate change issues have to be integrated. Also, another important thing is the strengthening of the technical capacity of the local governments, and also since the climate change is in the cross-cutting areas with the relation with the wars, with relation with this environmental determinants like the air quality, there must be the close collaboration and a multi-sector collaboration with different sectors. And also there is the commitment from the government that has been reflected in the climate change policy, recently submitted second national determined contribution, and also in the national adaptation process plan. Also, there is international commitments from the government side that has been reflected in the Paris Agreement, because Nepal is one of the parties of the Paris Agreement. Nepal has also signed this Mali Declaration
The
on
time
the
is
building
almost
climate
over,
resilience.
Mr. Srestha.
Yes, thank you.
Please.
That is over here. So we have some achievements, but many things have to done, and this is the right time, and we have to louder and we have to raise our voice to build a climate resilient health system. Thank you. That's over from my side.
Thank you very much. Thank you very much. I'm truly sorry to put you pressure on time, because this is the rule of this session. I know that the time will never be enough to discuss on such a very complex issue like climate change and also covering healthcare system. Please, now we have few minutes that will allow to the audiences for question and answering. Or sorry, last. Okay. So now I'm told that the questions, if there will be any, by any participants, please, you can put on the chat box, or you can also raise at the end of the session. Okay. Thank you once again. Thank you, Mr. Srestha. Now for the next session, I'll request to.
So our next presentation is forest cover and childhood infection, analysis of satellite data and health survey from Nepal by Binay Chalisi. Binay Chalisi is mixed scholar undertaking in his PhD at Hiroshima University. His research focuses on public health impact of development policy in low and middle income countries. Binay is also a recipient of Australian award from Australian government and undertook a Master of Public Health from the La Trobe University. His research engagement in Nepal involves contribution across evidence-based policy and health sector planning. So now over to you, Binay Chalisi.
Thank you so much. Good afternoon, all. And first of all, I'd like to thank NHRC for giving me this opportunity to speak in this session. So in this, in the today's session, I'm going to speak about forest cover and childhood infection based on the recent analysis that we carried out using the DHS data as well as the GIS data from satellite images. So infectious diseases are a major causes of burden of infectious disease causes major death and disabilities in many developing countries, and children are at the risk of those diseases. For example, like respiratory diseases and diarrheal diseases are the leading causes of infectious diseases, and children under 5 are the vulnerable groups. And out of those infectious diseases, they have an origin of environmental risk factor. For example, like most of the infectious diseases are associated with, in terms of environmental risk factor, most of the infectious diseases are associated with factors such as water or air. For example, 15% of death due to 15% of premature deaths in low-income countries due to water, and 8% of death due to 8% of premature death in low-income countries due to poor air. So in this sense, forest cover is an important determinant of health, and it provides a medium for us to become healthy in terms of environmental determinants. So there are several ways that forests affect our health. For example, from the ecological perspective, forests provide a medium for both agent and host that we can view from the epidemiological triad. Forest also provides a balance in ecosystem through biodiversity and maintenance of pathogenic activities through ecosystem balance. In terms of economic terms, forests provide us ecosystem services such as clean air and water, which has a positive externalities in creating a healthy atmosphere or health of the people. On the other hand, decreasing forest cover has a negative health consequences. For example, decreasing forest cover or decreasing forest area is associated with urbanization, migration, and it consequently causes overcrowding and air pollution. And studies also suggest decreasing forest cover associated with household air pollution in terms of use of low quality biomass fuel, which causes indoor air pollution and then respiratory infection. Here are some statistics about global forest cover and forest cover in Nepal. If you see the scenario in Nepal, then 33% of total land in Nepal is covered with forest, declining by 1% over the last 2 decades, and 12% of the decline is due to deforestation and commercial activities. And on the other hand, if you see the disease trend, respiratory infections and diarrhea diseases are also declining over the last 3 decades. So the declining forest cover on one hand and the declining burden of diseases due to diarrhea and respiratory infection in children on the other hand enthuse us to see if there is such association between forest cover and childhood infection in countries like Nepal. So here are some pre-existing evidence. So if you see the pre-existing evidence, there has been studies carried out in terms of forest association between forest cover and malarial diseases in several tropical countries, and the evidence are largely mixed because in some setting forest cover are associated with malaria incidence, whereas in some other setting forest area is not directly linked with malaria incidence or malaria prevalence. So for this study, in this context, the study applied a DSS dataset along with GIS tool to examine the forest cover how forest cover contributes to the infection symptoms, for example, diarrhea and respiratory infection among under 5 children in Nepal. The study objectives were to examine whether forest cover reduces infection symptoms among under 5 children in the year 2011 and 2016. And then to ascertain if the probability of infection symptoms reduced between these 2 years. So to achieve this objective, we use data from the demographic and health survey. We relied on the 2011 wave and 2016 wave of DHS dataset. 2011 there were 289 clusters, whereas in 2016 DHS there were 383 clusters. DHS also captured information on the symptom reporting by mother in terms of the common illness faced by the children in the past 2 weeks. We use that information to see if those symptoms were related with the forest cover. So for the forest cover data, we have to rely on the GIS dataset. So we use the GIS dataset based on the raster image available from the NASA dataset. So the raster image, basically, this is a image file that contains the geolocation of the forest at global level. We use the data from the NASA dataset and extracted data from Nepal. We also use GIS covariates that are captured by the DHS dataset and provided to the DHS member countries. This is the framework of how we utilize the GIS dataset and combine it with the DHS dataset. So here we in terms of analyzing the GIS dataset, we have a 2 approach here. We had to deal with the image file, which contains the forest cover data, and then we also have to deal with the DHS point, which is geocoded. So for identifying the DHS data, DHS GIS dataset in DHS data is like suffers from point displacement. So there are displacement in geolocation of the DHS cluster by 2 kilometers in urban areas and up to 20 kilometers in rural areas. So we have to adjust that displacement. So we carried out the buffer analysis, and then we extracted the forest cover data from the image data from the raster data that we get from the NASA satellite images. And then after we extracted the forest cover data, we assigned those forest cover percentage to each participants and then carried out the analysis, which I am going to describe in the subsequent slide. So here are our list of variables that we consider in our analysis. Our variable of interest is the symptom reportings by mother in terms of 3 symptoms. And our explanatory variables are the forest cover in terms of forest cover in GIS buffer, 22 kilometers for the rural areas, 2 kilometers for rural areas and 10 kilometers for urban areas. And then we also control for several other factors such as household characteristics, environmental characteristics, and maternal and child health characteristics. So we use PROVIT model to calculate the predicted probability to see what is the predicted probability of getting diarrhea symptoms for children living around the area where forest cover is more intense and where forest cover is more sparse. So we use the PROVIT model to calculate the probability model. This is our model specification, which I'm not going to go into detail here. So going to the major finding, we can see that the prevalence of diarrhea, respiratory infection, and fever symptom decreased in both urban and rural areas between 2011 and 2016. And we can see this declining trend in both urban and rural areas. So if you see the forest cover, the trend of forest cover between 2011 and 2016, we could also see the declining forest cover in these 2 years. So if you see the map on the downside of the screen, it shows the percentage change in forest cover by local government area. So the dark green area indicate some forest gain, whereas the brown color indicate the forest loss. So we can see more forest loss in the western as well as the central part of the country. This is the descriptive statistics of the covariates that we use in the analysis, which I'm not going to go into detail. Maybe we can have a look in your spare time. This is just a calculation of mean by DSS 2011, DSS 2016, and then in the pool sample of DSS 2016 and 2011. So based on our analysis of probit model, here is a major finding that we got from the probit analysis. So our major findings are in terms of like forest cover is associated with the likelihood of reused diarrhea symptoms. So if we have a more forest cover, if people are living near the forest area, then we can say like they have a tendency to report fewer cases, fewer symptoms of diarrheal diseases. And holding other variables at their mean, in addition to the forest cover, decreases diarrheal symptoms reporting by 3.9%. So the magnitude is like 3.9% less reporting of the diarrheal symptoms in areas where people are living, in areas where forests are more dense, or we have a dense forest. Forest cover is negatively associated with likelihood of fever and positively associated with the likelihood of respiratory infections, but these observations are not statistically significant, so we cannot conclude if they are true or if they are just by chance. And there is the probability of symptom reporting decreased between the 2 years, like 2011 and 2016, which we can also ascertain from the previous descriptive findings that I showed in the previous table. So here is a tabular representation of the similar finding that I showed in the previous slide. So if you can see here, we analyzed the impact by DSS year 2011 and DSS year 2016. So in 2016, you can see like the diarrhea symptom reporting decreased by 6.1%, whereas in 2016 diarrhea symptom reporting just decreased by 1%, very small effect after controlling for all those household and environmental characteristics. And we also carried out a pooled analysis here, and in the pooled analysis of 2011 and 2016, the symptom reporting decreased by 3.9%, and we could see some declining trend in the pool sample. We can see some declining trend for fever, but not statistically significant, and the same case for increasing trend for respiratory infection, but not statistically significant. So now I'd like to go to the conclusion of our analysis. So forest cover is associated with the likelihood of reduced diarrhea symptoms, but the probability is around just 3.4%. This is a small estimate, and we should also note that this is a naive. This is our analysis is a naive analysis. We didn't look at the causality, so we cannot say that the forest cover causes reduction in diarrhea symptoms. This is just an association study, and our reporting pattern is somehow different from the studies carried out in public health. We did not prefer to report on odds ratio, but rather than we reported on predicted probability to see the rate of change over the time. And there are several limitations with this study. So, for example, like infection symptoms are basically self-reported by the woman. So there are studies around the world, around the developing countries, where we can see some over-reporting of the symptoms in DHS studies. For example, studies conducted in Middle East countries shows that DHS report there has been a pattern of over-reporting of the symptoms in DHS dataset. For example, like diarrhea symptoms are more reported. Like mothers with higher education are more likely to report diarrhea symptoms than those in the lower socioeconomic group. So we can assume like similar pattern in Nepal. There might have been symptom over-reporting in the better socioeconomic class, whereas under-reporting in the low socioeconomic class. And there are certainly some issues with the DHS GIS dataset, with the DHS how DHS capture GIS dataset. So the DHS collect provide geolocation of each cluster, but they are displaced by 2 kilometer and 20 kilometer to 20 kilometer. So this has an impact on the exact positioning of the participants, as well as and in terms of assigning the forest cover to those participants. So they definitely have some impact. And there are studies that suggest rather than using the buffer analysis, using some other techniques to assign those GIS covariates with the participants. So we definitely need to consider those factors in the coming studies. For the way forward, maybe future research need to consider all those limitations, and then need to carry out. We need to try the similar analysis in data set that are rich in the forest cover. For example, Hans in 2013 has a rich data set in terms of global forest cover and for deforestation, including Nepal. So maybe the future research may utilize those data set and then extract those data set using GIS, and then calculate the morbidity using some other administrative data set by province and district and carry out panel regression. And in terms of policy, this study has several implications. So as we noted from the previous presentation, that Ministry of Environment and Forestry is also in the process of developing a national adaptation plan. So from the perspective of health, so this finding may provide some insight for those agencies to consider the health impact of environment and consider those issues while making non-health policies. So in other sense, this is including health in all policies. So this is the end of the presentation, and thank you so much for this opportunity. Here are some references that you might wish to follow, and I would love to hear some of your comments and feedback at the end of the session. Thank you very much for this opportunity.
Thank you for nice and a very innovative presentation. So if any query regarding this presentation, please drop your query in question and answer section. So Binay sir, please be connected till the end of this session.
Okay. Now we move to the next presentation. I think the next presentation is about knowledge of community pharmacists in the Kathmandu Valley, Nepal, about the risks associated with medication used during pregnancy. Of course, the rational use of medicine has always been a very, very pertinent issue in public health. And when you talk about the rational use of medicine, it starts from prescription to the dispatch and ultimately at the level of consumption of the medicine by users themselves. So now it's about the pharmacist. It means the use of rational way of medicine by the dispatchers, because the pharmacist we consider as a dispatcher of the medicines, and they also, of course, suggest the users to use the medicine. And I think this is a very important and very critical issue that we should look at. Now, we request to present the paper to Sajla Kafle, please.
The topic of my presentation is Knowledge of Community Pharmacists in the Kathmandu Valley, Nepal about the risk associated with the medication used during pregnancy. The authors are myself, Dr. Sajla Kafle, Dr. Nisha Jha, Ms. Yunima Sapkota, and Dr. Pathil Ravisankar. Prescribing in pregnancy, it requires the great caution. Some medicines like folic acid, these are beneficial in pregnancy, whereas other medicines like thalidomide, they have teratogenic effect in the developing fetus. In a developing country like Nepal, community pharmacists have a very important role in dispensing drugs to the general public, including the pregnant women. Hence, they should have adequate knowledge about the use of different types of drugs. Kathmandu is a capital of the country with a huge population. People from all over the country come to Kathmandu for employment and to support their family. Hence, the COURAGE study was undertaken to evaluate the knowledge of community pharmacists of Kathmandu Valley about the risk associated with the use of different types of drugs during pregnancy. The major objective of this study is to evaluate the knowledge of community pharmacists in the Kathmandu Valley, Nepal about the risk associated with the medication use during pregnancy. Materials and methods. Ethical approval was obtained from the IRC of KIST Medical College and Teaching Hospital. Community pharmacists registered in the DDA in the Kathmandu Valley were included in the study. A sample size of 344 were calculated. All the community pharmacists who gave consent for participation were included in the study. A cross-sectional study was conducted in the month of March from 1st March 2021 to 30th March 2021. Convenience sampling was performed and the data was collected using structured and validated questionnaire. About the results, demographic features of the respondents. Among the 344 community pharmacists who participated in the study, 76.7% of them were male and 23.3% of them were female. Almost 94.2% of the community pharmacists were between the age of 21 to 30 years. Almost 50.3% of the community pharmacists were located in the Kathmandu district of the Kathmandu Valley. 53.1% had work experience of less than 1 year. 57.6% had completed diploma in pharmacy. Almost 67% of the community pharmacists dispensed less than 100 number of drugs per day. The number of medicine dispensed to pregnant women daily was less than 10 in 61.6% of the community pharmacists. Only 28.8% of the community pharmacists always inquired about the pregnancy status while dispensing drugs to the women of reproductive age group. Regarding the median knowledge scores among subgroups of the respondents, the mean knowledge score among different age groups was 16 and the maximum possible score was 29. There was a significant difference in the knowledge score among respondents according to their work experience and the qualification of the respondents with a p-value of less than 0.001. In addition to this, a difference in knowledge score based on the average number of medicines dispensed to pregnant women with a p-value of less than 0.001 was also observed. The knowledge score was also different based on the status of inquiring about pregnancy to the women of the reproductive age group. Regarding the knowledge of the respondents about the US FDA medicine risk categories, 89.2% of the respondents had knowledge about category A, category B, and category C. The major concern expressed by the community pharmacist while dispensing drugs to the pregnant woman were unknown stage of pregnancy, which was mentioned by 64.2%, the risk-benefit ratio not clear, which was mentioned by 54.1%, only animal studies available, which may not be reliable, was mentioned by 34%, lack of clinical trials was mentioned by 21.2%, and most data obtained from observational study was mentioned by 12.5%. These are the different categories of medicines commonly dispensed by the community pharmacists to the pregnant women. The most commonly prescribed medicines was antiemetics, and it was followed by analgesics and vitamins. The most commonly used resources by the community pharmacists to obtain information about dispensing drugs to the pregnant woman was SIMS NDR. It was used by more than 60% of the pharmacists. Community pharmacists had very good knowledge on folic acid, oral iron, calcium, acetaminophen, oral contraceptive pills, cold remedies, alprazolam, amoxicillin. However, the knowledge of community pharmacists was inadequate on the following drugs. They were bismuth subsalicylate, guaifenesin, ibuprofen, pseudoephedrine, lamotrigine, and valproic acid. The major limitation of this study is that it was done only in the Kathmandu Valley and it may not represent the knowledge of community pharmacists of the whole population of the country. In addition to this, the study was conducted only in the day shift. Therefore, it might be possible that the knowledge of community pharmacists working in the night shift may be different than the day shift. Our study revealed that the community pharmacist had very good knowledge on the use of drugs like vitamin A, oral iron, folic acid, calcium, cold remedies, acetaminophen, oral contraceptive pills, alprazolam, and amoxicillin. However, the knowledge of community pharmacists was not good about the use of safety of different drugs like lamotrigine, valproic acid, bismuth subsalicylate, guaifenesin, ibuprofen, and pseudoephedrine. Our study shows that the knowledge score of the community pharmacist needs improvement. Various educational activities and the continuing educational programs may help the community pharmacists to improve the knowledge about prescribing different medicines during pregnancy. Thank you.
Writing time.
Thank you. Our next presentation is on design and development of simple and low-cost light source device for laparoscopic surgery by Diksha Chetri. Over to you, Diksha.
Namaste everyone. My name is Diksha Chetri and I am a biomedical engineering student. First, I'd like to thank the Nepal Health Research Council for selecting my paper to be presented in this national summit. I'm very excited to present our biomedical innovation, which is developed first of its kind in Nepal. Based on the news, in 2020, the medical equipment imported in Nepal in a month is worth rupees 350 million. So what if I told you that these numbers could be decreased if investment on local products and innovation are encouraged more, which will result in self-dependency on such equipments? And this device, which we've built, is an example to support this fact. In this context, let me explain a little about how we came up with this frugal innovation. During my college years, we came across an article titled Advances in Equine Laparoscopy, which grabbed our curiosity in the medical light source. Further study revealed the device's high cost in Nepal, leading us to question if we can reinvent a simple and low-cost light source device for laparoscopic surgery. And after detailed discussion with my supervisors, we began brainstorming for the prototype. In the context of developing countries like ours, it is necessary that the medical community can purchase the device without compromising on the quality. Which brings us to our topic, entitled Design and Development of Simple and Low-Cost Light Source Device for Laparoscopic Surgery. Medical light source helps in providing a virtual microsurgical view by illuminating the area that needs to be examined. Light from the light source is transmitted via fiber optic cable to a laparoscope that is inserted into a patient's abdomen during treatment, proving the importance of light source in laparoscopic surgery. The main objective of our project was to design and develop simple and low-cost light source device for laparoscopic surgery that passes all of the testing parameters such as lid's illumination, color, and heat. Going towards the methodology, the first task that we took is prototype designing. Before designing the actual device, we worked on the prototype by searching through different literatures. And then we came up with this prototype. The 3D model prototype design was done using SketchUp software. A SketchUp software is a 3D modeling computer program for a wide range of drawing applications such as in architectural, civil, and mechanical engineering. And after the completion of the prototype, we studied the market for the availability of the materials. Also, upon conducting further market study, we purchased the materials. And those materials that were not easily available in Nepal due to COVID crisis were ordered from India, which took a few weeks to be delivered. The second task we did was assembling. This picture gives us the overview of the materials that has been assembled. So the materials used to assemble the devices are a pulse width modulation motor speed controller, a potentiometer, a CVT90 LED, a 4 heat pipe CPU cooler heatsink with attached cooling fan, and also an extra cooling fan which works as a cooling system, a switch mode power supply, a condensing lens, a power circuit, a push button, and the coupler. This is the block diagram which gives us the overview of the light source. As you can see here, the switch mode power supply provides 3 to 4 volt to LED and 12 volt to rest of the system. The cooling system prevents the LED from overheating, and the light emitted by the CVT90 is passed to the condensing lens, which minimizes spherical aberration and focuses the previously collimated light at the fiber optic cable through the coupler. The intensity of the light is then displayed on the pulse width modulation motor speed controller, and its illumination can be controlled through potentiometer. And upon assembling everything, this was how our device looked like. The final task we did was testing. The heat and illumination testing was done through thermal gun and lux meter respectively. Here, in this picture, me and my teammate was doing the illumination testing, which was done through lux meter. Proceeding towards the result, finally, after the device is turned on, we can modify the intensity of the light by adjusting the potentiometer, as shown in the picture. This picture shows the intensity of the light at different levels, that is 10 and 100. Moreover, the heat testing of the device at 100 intensity concludes that the increment temperature of the device at 60 minutes is 1 to 2 degrees Celsius. In the bar graph, the vertical line shows the time at which the heat was noted by using the thermal gun, and the horizontal line shows the heat generated by the device at a particular time. The interval of the time at each data collection is 5 minutes. Additionally, the maximum illumination is 100,000 lux and the minimum illumination is 1019 lux, which was done through lux meter. Also, the color of the LED is cool white light having the color temperature of 6500 Kelvin and color rendering index of 70. So to conclude, the light source device for laparoscopic surgery has been successfully developed at a much cheaper level, that is Nepalese rupees 50,000, than in market price, that is approximately Nepalese rupees 150,000 or more, which fulfills the ultimate objective of building a cheaper yet efficient model. The device is also the first of its kind to be developed in Nepal. At the end, I'd like to express my gratitude towards our colleagues for giving us this opportunity, along with my supervisors for guiding us throughout the process, and finally my fellow group members for their input and hard work. Without them, this wouldn't have been easy. Thank you.
Thank you, Diksha. for this innovative and new. So now next, keep connected with us till the end of session. If query, we'll get connected with you.
Okay, now we move to the next presentation. One more time, we have a presentation about the pharmaceutical issues, which again has a very important public health relevance. So I invite to presenter Nisha Jha, who will be presenting her paper on assessment of the national pharmacovigilance system in Nepal using the indicator based pharmacovigilance assessment tool, IPAT. So I think it will cover the another dimension of the pharmaceutical issues in public health system of Nepal. Please, Nisha Jha.
Namaste, I am Dr. Nisha Jha. I am here to present our research and assessment of the national pharmacovigilance system in Nepal using the indicator-based pharmacovigilance assessment tool, IPAT. We are 5 in our research team. I from East Medical College, Dr. Subish Palayan from College of Pharmacy and Health Sciences, UAE, Dr. Patil Ravi Shankar from International Medical University, Kuala Lumpur, Mr. Santosh Kesi is from Department of Drug Administration, and Mr. Panbadu Chetri is from Ministry of Health and Population. Talking about the background of the research, pharmacovigilance started in the country in 2004, and Nepal became an associate member in the international program in 2006. The Nepalese pharmacovigilance system has 15 regional pharmacovigilance centers. These centers report adverse drug reactions to the National Pharmacovigilance Center located in the Department of Drug Administration. Reporting of ADRs is very low till the date. A systematic analysis of the national pharmacovigilance system has not been conducted so far and can provide useful insights for the improvements. The objective of the study was to assess the national pharmacovigilance system in terms of functionality, strengths, and limitations. Now, methodology starts with the ethical approval, which was obtained from the Nepal Health Research Council in October 2020. The design of the study was descriptive cross-sectional, and the duration was in January 2021. The study population included 14 respondents, 12 from the regional centers, and 1 each from the National Pharmacovigilance Center and the Ministry of Health and Population. The study tool used in this research was the indicator-based pharmacovigilance assessment tool, IPAT, with 43 indicators, 26 were core and 17 were supplementary indicators. This tool, IPAT, has been developed from the USAID. The inclusion criteria were all the regional pharmacovigilance centers and the National Pharmacovigilance Center, and the exclusion criteria were the hospitals other than the notified regional pharmacovigilance centers and public health programs like malaria, HIV/AIDS, Kala-Azar, and filaria. So the pharmaceutical industries and medicine importers were also excluded from the study. The data collection was done from contacting with the coordinators from regional pharmacovigilance centers individually through a phone call, and the data from the national center was collected by contacting the key informants managing these functions. Data from the Ministry of Health and Population was also collected by contacting the relevant personnel. Now the scoring of the data, all the responses with the numbers and percentage meeting the assessment criteria were coded as yes, and those which did not meet the specified criteria were coded as no. The score given for a yes response for a core indicator was given a value of 2, and for the supplementary indicator, the value was given as 1, and a no response was given a value of 0. Maximum score was 52 for the core indicators and 17 for the supplementary indicators. Data analysis was done by calculating the percentage scores, and the scores more than 60% was concluded that the component has met the specific needs, and similar kind of scoring was used for the presentation of the findings in other countries in the African subcontinent like Kenya, Rwanda, and Tanzania. So the results showed that 58.3% of the center coordinators were from the age group of 31 to 40 years with a dominance of male participants. 75% of respondents were having master's level of educational qualification. 58.3% of regional pharmacovigilance centers were established after 2016, and 10 regional centers were located in Kathmandu Valley, and only 4 centers are located outside the Kathmandu Valley. Maximum number of centers were attached to the hospitals with more than 500 beds, and half of the regional centers coordinators were having a work experience of 5 to 10 years. Now, this table is all about performance of National Pharmacovigilance Center. According to the iPad tool, there are 5 different components for assessing the pharmacovigilance. Number 1 was policy, law, and regulation. Number 2 is systems, structures, and stakeholder coordination. Signal generation and data management. Risk management, risk assessment and evaluation, and risk management and communication were the 5th component. So the overall all score were also calculated, and the scores did not meet the target outcomes as none of the scores were more than 60%. Now this table is all about policy, law, and regulation in the National Pharmacovigilance Center, which states different statements which has to be present in the National Center. For example, there has to be a policy document which contains essential statements on pharmacovigilance or medicine safety as a standalone or as a part of some other policy document. And this document is available in the National Center. So similarly, existence of specific legal provisions for pharmacovigilance in the national medicines legislation or similar legislation was absent. Legal provisions requiring that the marketing authorization holder mandatorily report all serious adverse drug reactions to the National Drug Regulatory Authority was also not available. And legal provisions requiring the marketing authorization holder to conduct the same or similar post-marketing surveillance activities for products as required by stringent regulatory authorities was also not available. Now, this table is all about performance of regional pharmacovigilance centers. And in this study, 12 regional centers had participated, and the scores ranged from 24 to 60%. So most of the regional centers, the target outcomes were not achieved. Now, the regional pharmacovigilance system program is functional but with limitations. The National Pharmacovigilance Center scored an overall score of 46.1%. And of the 12 regional centers studied, ADR reporting was actively carried out only in 5 centers, that is only in 41.6%. The regional centers scored for core indicators ranged from 26.3% to 52.6%. Supplementary indicator scores ranged from 16 to 66%. The scores were relatively better for 2 regional centers started in 2010 and 2018 respectively. And the values were less than 60% highlights the need of improvement in functioning. Now, this figure is all about the current situation of capacity building for pharmacovigilance system. So iPad tool has 5 different components for the structure, system, and rules, which talks about the existence of policy document and pharmacovigilance center unit, which further enables the use of staff and infrastructure for the pharmacovigilance communication, which further again enables the effective use of skills for conducting pharmacovigilance trainings, public education on pharmacovigilance programs, which further enables the effective use of tools like pharmacovigilance reporting form and pharmacovigilance database. Now, to conclude herewith, there are no policies and framework at the national level regarding pharmacovigilance, and the absence of guidelines and risk assessment, absence of signal generation, weak data management, and poor synchronization with national public health programs and weak communication systems impact pharmacovigilance at the national level. At the level of regional centers, physical infrastructure and qualified manpower do exist, but functioning has to be strengthened. And this research has also some recommendations. So pharmacovigilance should be mentioned in the medicine policy and regulatory frameworks in Nepal. The National Drug Regulatory Authority must mandate pharmaceutical companies to monitor and report any suspected adverse drug reactions occurring within the country. Pharmacovigilance is currently restricted only to ADR reporting, and there is a need to incorporate medication errors and drug therapy failure into the system. Regional centers should be encouraged to report more ADRs and publish drug bulletins and other information sources. Adverse drug reaction reporting in vertical programs like HIV/AIDS, malaria should be incorporated within the National Pharmacovigilance Program, and National Safety Advisory Committee with multi-sectoral stakeholders should be established for the smooth functioning of pharmacovigilance activities. Thank you very much for listening all this presentation, all the details about the research, and thank you Nepal Health Research Council for allowing us to present our work in this platform. Namaste. Thank you.
Thank you very much, Dr. Jha, for a very important and useful presentation. And please stay with us if there will be any question from the participants to you. Thank you very much.
Solid waste management is a problem of many cities nowadays. So our next presentation is on situation assessment of solid waste management at household level in Bharatpur Metropolitan City, Nepal by Simran Kafle. Over to you, Simran.
Namaste, I'm Simran, and I'm here to present our paper on solid waste management in Bharatpur Metropolitan City, Chitwan, Nepal. We are a team of 8 people, as mentioned in the slides, and I'm the corresponding author. So talking about the background, here we are going to present on solid waste management scenario in Chitwan. So if we talk about the global scenario, then the world produces 2 billion tons of municipal solid waste annually. And the World Bank estimates that this figure will increase by 70% in 2050. I tried to get the recent data, but it was of 2011, and it showed that municipal solid waste generation of 58 municipalities of Nepal was estimated at about 1,435 tons per day. And that means 5,24,000 tons per year. And recently, healthcare waste, electronic waste, industrial, construction and demolition waste are the emerging waste. Only 6 municipalities out of 77 have sanitary landfills. The rest of the municipalities dispose or dump the waste in the bank of river or in the middle of the jungle. Solid waste management is very important to maintain the health of population and its environment. We have assessed the amount, type, management, and implications of solid waste at the household level in Bharatpur Metropolitan City, Chitwan, Nepal. Talking about the methodology, we had conducted a cross-sectional study using a systematic random sampling of 402 households from November to April in 2021. The person who was mainly taking care of the waste was interviewed, and then household was also observed in terms of waste segregation, whether they do kitchen garden or not, whether they practice compost manure preparation or not. Similarly, the practice of rooftop farming, as these were the methods for solid waste management as household level. Similarly, the sampling frame was obtained from wards and the municipality's voter list. Moving on to the sample size, we used the formula for a non-population, and being specific, we selected 10 wards from Bharatpur Metropolitan City who were majorly located in urban areas. And the total number of households in those areas were 28,385. And P implies here 50% households with a practice of compost preparation from the household waste. That was our assumption. Similarly, Q implies the rest of the households without such practice. And assuming a non-response rate of 5%, the estimated sample size was 402. And the data was entered in SPSS. It was entered in CS-Pro, and we did analysis in SPSS 25 version. So moving into the results, we can see that the mean age of household, mean age of study participants was 42 years, and the majority of them were female, and half of them were living in nuclear family. Around 98% were able to read and write, and similarly, a majority of them were housewives, followed by business and agriculture. So talking about the volume of waste, the average waste generation was 133.9 gram per person per day in Bharatpur. And it means a household produces 753 gram of waste per day. And 5% of households reported suffering from illnesses that can be associated with poor waste management, and they were mostly dengue and diarrheal diseases in the past year. Talking about the composition of household waste, there was a silver lining, and we found that 68% of solid waste was organic waste, followed by plastic waste, paper, and metals. Similarly, others were also there. So here is an interesting fact that we found 83% of households practiced segregating the waste by degradable and non-degradable. But when we analyzed the management of degradable waste, then we found that 20% of those households were practicing composting, and 38% threw the waste in their farm without proper techniques of composting. And we can see that almost 1/5 of households practice throwing the household waste in the canal or river. Similarly, 1/4 of households send those degradable waste to the municipality waste vehicle, which are again dumped in the bank of Narayani River. And talking about the non-degradable waste, most of them are sent to municipality waste vehicle. Here is another table depicting the different types or techniques of solid waste management. However, we can see only 8% of households have biogas, 20% are practicing composting, 65% practice kitchen garden, and 10% practice rooftop farming. So the reasons behind not practicing kitchen garden was due to the unavailability of land. However, majority didn't have skills on rooftop farming and composting as well. So here is an association of the volume of waste by the household with their income level and number of family members. And statistically, we found a significant association between income level and the amount of waste. That means households with the income level above the median value, that means 3,36,000 per year, they were likely to produce double amount of waste than those households with the income level below the median value. Similarly, households with family members lesser than 5 were likely to produce half the amount of waste than those with more number of household members. So this figure shows the relationship between income and the members in comparison to the volume of waste. So to conclude, organic waste comprises of the highest proportion of household waste, but only 1/5 are preparing compost from waste. Therefore, promotion of composting, kitchen garden, and rooftop farming at the household level could be effective to manage solid waste. There is a need for mandatory waste segregation at the household level, followed by its separate collection and disposal in sanitary landfill. Here is a picture to depict how the waste laborers in the dumping site segregate the waste into degradable and non-degradable. Similarly, this is the scenario where even we can see the children working in the waste sector, working in the dumping site. And this is an island of waste in the bank of Narayani River. So thank you so much. Thank you, Bharatpur Metropolitan City Office and study participants for supporting this study.
Thank you, Simran. If there is any query, we'll get to you. Thank you. Very nice presentation. There is one question for Dr. Nisha Jha. The question is from Professor Dr. Dinesh Kumar Lamsal. And the question is, how did we minimize over-counter and polypharmacy using the drugs without prescription of doctor or health personnel? And how to make drug safety so that the poor situation of pharmacovigilance can improve in health system? Dr. Nisha Jha.
Dr. Jha, are you with us?
Yes, sir.
Yeah, please.
Yes, sir. Namaste.
Namaste.
Thank you, Professor Dr. Dinesh Hamza, for your excellent question. To minimize the over-the-counter and polypharmacy and also to promote drug safety, the Department of Drug Administration has to conduct its monitoring, and that monitoring has to be strengthened. And adequate training for the health professionals regarding drug safety-related resources and task-specific initiatives both at the health ministry level and the National Drug Regulatory Authority can be helpful for improving pharmacovigilance program, leading to better patient safety. Thank you, sir.
Thank you, Dr. Nisha.
So, I think we don't have more questions to the presenters. Yeah? Sure. Okay. So, that's all. Maybe you have few words to reflect. Okay, okay. So, we have one more, the last question to the last presenter, Simran Kaple. Interesting finding of 83% household segregating the waste. But the management seems poor by people. The question is whether there are separate vehicles for carrying segregated waste, otherwise segregation is worthless. I think this is the question to the last presenter, Ms. Simran Kaple. I think I'm not sure from whom the question comes from. Anyway, Ms. Kaple, you are with us. Please. Is the question clear?
Yeah, thank you. Thank you for the question. Yeah, you have noticed that 83% of households are segregating waste at the household level, but the municipal vehicle doesn't have the provision to have two separate vehicles for degradable and non-degradable. So despite of this good practice, they are all collected together and dumped in the bank of river. So this is a very common practice, not only in Bharat, but many other cities of Nepal, being based on the literatures.
Oh, yeah. Okay. So, thank you very much. Thank you very much.
Thank you.
Is there any? No, no more questions. So, since we do not have more questions, now we are in the process to conclude the session. Please. Maybe
so in this session, we had 6 all very nice presentation. So all the very interesting and suitable to the current scenario. The first presentation by Engineer Rajaram Shrestha, so climate change and health, and we are also not far from this problem because we are getting a lot of problem like flood and fire. So a very nice talk by Engineer Shrestha. And another topic is forest cover and childhood infection, also very interesting. And another next, design and development of simple and low-cost light source. This device is nowadays useful in many fields, like not only in general surgery, even in spine surgery, orthopedic surgery. So in coming days, we need more and more. So this low-cost light, this for minimal invasive and endoscopic surgery. So if we develop this device and can approved by the government of Nepal, then it will be very advantage for us and for Nepal also.
Okay. So I think as Dr. Thapa mentioned, that this is really very interesting session, especially because of the diversity of the themes that have been presented in the session. It's a environmental issue, including the issue of climate change, to the waste management at the household levels. It's a diversity of the environment, and also very important issue of pharmaceutical agenda which always has a very important place in public health. So I think I really congratulate all the presenters for the good presentations. I think there is not much to say about the presentation at the individual presentation level, but in general it was a very, very good and very useful session. I think even in this very hard time, I really appreciate Nepal Health Research Council to organize this important, very historical event, and also particularly organizing this session and offering me this beautiful opportunity to be here with you. So I thank you, Nepali Research Council, and again, I really appreciate the participation of all the participants in this session. And one more time, thanking very much to the presenters. I think we should close the session because the time is now over. So thank you very much. Thank you. Thank you.
Thank you, Professor Dr. Sarot Anta, Dr. Vishnu Babu Thapa, invitees, and all the presenters for making this session lively and informative. Finally, to wrap up this session, I would like to invite Vice Chairperson of Nepal Health Research Council, Professor Dr. Gaurav Raj Thakal, to hand over the token of love to our respected chairs. Again, I would like to thank Professor Dr. Sarot Anta and Dr. Vishnu Babu Thapa for your valuable time. Thank you, sir. We request for a group photo. With this, I would like to conclude the technical session of the summit. Next will be the closing session. Before that, we'll take a short break of 5 minutes. Please stay with us. Thank you all. Have a delightful evening. I would like to request Ms. Srijana Dangol to come on the stage to receive the token of love. For this, I would like to request Professor Dr. Sarod Anta, sir.
नेपालको स्वास्थ्य क्षेत्रमा उच्च स्तरीय वैज्ञानिक अध्ययन र गुणस्तरीय अनुसन्धान गर्न नेपाल स्वास्थ्य अनुसन्धान परिषदको स्थापना भएको हो। नेपालको स्वास्थ्य क्षेत्रको अध्ययन अनुसन्धान गर्न विक्रम सम्वत 2039 अर्थात् सन् 1982 मा तत्कालीन स्वास्थ्य मन्त्रालय अन्तर्गत नेपाल स्वास्थ्य अनुसन्धान समिति गठन भयो। वास्तवमा तत्कालीन स्वास्थ्य मन्त्रालयका सचिवको अध्यक्षतामा गठित नेपाल स्वास्थ्य अनुसन्धान समितिले नै नेपालमा स्वास्थ्य क्षेत्रको औपचारिक अध्ययन अनुसन्धान सुरु गरेको हो। विक्रम सम्वत 2047 मा नेपाल स्वास्थ्य अनुसन्धान परिषद ऐन नम्बर 29 जारी भएपछि 2047 चैत्र 29 गते अर्थात् 12 अप्रिल 1991मा नेपाल स्वास्थ्य अनुसन्धान समितिलाई नै नेपाल स्वास्थ्य अनुसन्धान परिषदको रूपमा विकसित गरियो। 29 अप्रिल 1991मा प्राध्यापक डाक्टर मृगेन्द्रराज पाण्डेलाई परिषदको अध्यक्षमा मनोनयन गरियो भने अन्य सदस्यहरूको पनि नियुक्ति गरियो। तत्कालीन स्वास्थ्य तथा श्रम मन्त्री माननीय श्री पद्मरत्न तुलाधरले 24 फेब्रुअरी 1995मा नेपाल स्वास्थ्य अनुसन्धान परिषद भवनको समुद्घाटन गर्नुभयो। तत्पश्चात विश्व स्वास्थ्य सङ्गठनको सहकार्यमा परिषदले स्वास्थ्य प्रणाली अनुसन्धान सम्वर्धन र विकास परियोजना कार्यान्वयन गर्न सुरु गर्यो। परियोजनाले युवा अनुसन्धानकर्ताहरूलाई तालिम दिनुका साथै स्वास्थ्य अनुसन्धानमा लाग्न अभिप्रेरित गर्यो।
नेपाल स्वास्थ्य अनुसन्धान परिषद यो नेपाल स्वास्थ्य अनुसन्धान परिषद ऐन 2047बाट नेपाल सरकारबाट स्वीकृत भएर आएको ऐनबाट चलेको संस्था हो। यसले नेपाल सरकारको स्वास्थ्य नीतिको अधीनमा रहेर स्वास्थ्यसँग सम्बन्धित विभिन्न विषयहरू राष्ट्रिय अन्तर्राष्ट्रिय लेभलका रिसर्चरहरू वैज्ञानिकहरू अथवा संस्थाहरूलाई रिसर्च गर्नलाई अभिप्रेरित गर्ने, त्यस्तै गरी त्यो रिसर्चको कल्चर विकास गर्न सहयोग गर्ने र त्यस्तै गरी रिसर्च चाहिँ को लागि स्वीकृति प्रदान गर्ने कामहरू गर्छ। यसले चाहिँ समग्रमा भन्नुपर्दा रिसर्च गर्ने र गराउने काम गर्छ। राष्ट्रिय अन्तर्राष्ट्रिय विषयमा चाहिँ यसले रिसर्च गर्छ आफैले होइन, हाम्रो ऐनीतिको चाहिँ अधिकार प्रयोग गरेर र अन्य रिसर्चरहरूलाई देश विदेशी रिसर्चर अथवा संस्थालाई रिसर्च गर्न प्रोत्साहित गर्छ, स्वीकृति प्रदान गर्छ, उनीहरूले गरेका रिसर्चको मोनिटरिङ गर्छ, इभ्यालुएसन गर्छ र आवश्यकता अनुसार चाहिँ उहाँहरूलाई सचेत गराउने, रोक लगाउने लगायतका सबै कुराहरू इथिकल नर्म्सहरू प्रयोग गर्छ होइन। एउटा स्ट्यान्डर्डमा हाम्रो यी सबै कामहरू गरेर हामीले दुईवटा अर्को महत्त्वपूर्ण काम गरिरहेका छौँ कि एउटा इथिकल रिभ्यू बोर्ड हाम्रो छ ERB सेन्ट्रल होइन, त्यो एक किसिमको साइन्टिफिक चाहिँ बडी हो। त्यसमा विभिन्न विषयका विज्ञहरू चाहिँ सम्मिलित भएको एउटा समिति हुन्छ परिषद अन्तर्गतको। त्यो समितिले जति प्रपोजल हामी कहाँ आउँछ इभन NHRC रिसर्च गर्दा पनि अथवा बाहिरका संस्था व्यक्तिले गर्दा त्यो रिसर्च प्रपोजलहरूलाई इथिकल हिसाबले साइन्टिफिक हिसाबले हेर्ने र प्रपोजल ठिक भइसकेपछि स्वीकृति प्रदान गर्नको लागि सिफारिस गर्ने काम गर्छ एउटा। र त्यो चाहिँ हाम्रो अन्तर्राष्ट्रिय हिसाबको फर्किया भन्ने संस्थाले प्रमुख इथिकल रिभ्यू कमिटी साउथ इस्ट पेसिफिक रिजनले स्वीकृत गरेको चाहिँ छ र त्यस अन्तर्गत गएर हामीले गाइडलाइन अनुसार काम गर्छौँ र यस अन्तर्गत विभिन्न मेडिकल कलेजहरू संस्थाहरूमा हाम्रो चाहिँ शाखाहरू छ, त्यसलाई हामीले IRC भन्छ, इन्स्टिट्युसन रिभ्यू कमिटी भन्छ, त्यसले काम गरिरहेको छ। र अर्को महत्त्वपूर्ण हाम्रो कामभित्रको जर्नल अफ नेपाल रिसर्च काउन्सिल यो JNHRC पब्लिकेसन गरिरहेको छौँ। त्यसमा चाहिँ उत्कृष्ट विधाका रिसर्चहरूलाई हामीले चाहिँ एउटा पब्लिकेसन चाहिँ ठाउँ दिएर चाहिँ गर्ने काम गर्छौँ रिसर्चहरूको चाहिँ अभिवृद्धि गर्नलाई होइन। र त्यो पनि अन्तर्राष्ट्रिय हिसाबको भइसकेका छ र हामीले चाहिँ यसले गरेका रिसर्चको मान्यता चाहिँ अन्तर्राष्ट्रियबाट दिने गरेका छ एउटा होइन हामीले गरेका। र अहिले चाहिँ समग्रमा आएर कुरा गर्दाखेरि कोभिडसँग सम्बन्धित विषय हामी धेरै कामहरू गरेका छौँ। अहिले कोभिड आइसकेपछि अहिलेसम्म हेर्दा 35वटा विभिन्न विधामा हामीले रिसर्च गरेका देखियो र NHRC आफैले र NHRC बाहिर गएर हेर्ने भने चाहिँ लगभग 500-600 रिसर्च चाहिँ कोभिडसँग सम्बन्ध मात्र गरेको।
नमस्कार सबैजनालाई। यस ऐतिहासिक शिखर सम्मेलनको दोस्रो तथा अन्तिम दिनमा हामी अब लगभग सम्मेलनको अन्त्यतिर छौँ। म कृष्ण अर्याल यहाँहरूलाई न्यानो अभिवादन गर्न चाहन्छु। नमस्ते पुनः। यस ऐतिहासिक शिखर सम्मेलन 7औं शिखर सम्मेलन स्वास्थ्य तथा जनसङ्ख्या वैज्ञानिकहरूको 7औं शिखर सम्मेलन हामीले यसलाई अन्त्य गर्नु अगाडि आजको एउटा इम्पोर्टेन्ट एकदमै महत्त्वपूर्ण सेसन हामीसँग छ जुनमा हामी मृगेन्द्र सम्झना मेडिकल ट्रस्ट ओरेसन जो चाहिँ प्रोफेसर Dr. Buddha Basnath, who has been a very eminent personality. We have had an opportunity to work with him for long. He used to be the vice chairperson of the Nepal Health Research Council and been associated with us for long. I'd like to request our current vice chair, Professor Dr. Gaurav Raj Dhakal, to introduce Professor Basnath for the oration, please.
Good evening, everyone. I am Dr. Gaurav Raj Dhakal, spine surgeon by profession, and it is an immense pleasure for me to introduce Professor Dr. Buddha Basnath, a graduate of St. Xavier's, Godavari. He is a medical doctor practicing medicine in Kathmandu, Nepal. His research interests are infectious diseases and high altitude medicine, both of which are in ample supply in Nepal. He has published widely in both these fields in prestigious medical journals and written chapters with co-authors in the latest standard medical textbooks. For example, Harrison's Textbook of Internal Medicine, Oxford Textbook of Medicine, and mentions tropical diseases. He has almost 300 publications in peer-reviewed medical journals, in all likelihood more than anyone else from Nepal. Indeed, that is a great achievement and a feat itself. He is the director of Oxford University Clinical Research Unit, Nepal, and is also the medical director for the Travel and Mountain Medicine Center, a travel medicine clinic, the Himalayan Rescue Association dealing with high altitude medical problems, and the Mountain Medicine Society of Nepal. In all these institutions, one of his primary interests is to encourage young people to do clinical research. He also works at Patton Hospital as a consultant in the Internal Medicine Department and is a professor of physiology at the Patton Academy of Health Sciences. Dr. Basnet is a fellow of the American College of Physicians and also a fellow of the Royal College of Physicians, Edinburgh. He is also the principal investigator at Nuffield Department of Medicine, University of Oxford, Oxford, United Kingdom. He is also the honorary consul for Canada in Nepal. May I now invite Professor Dr. Buddha Basnet to deliver his oration.
Thank you very much, Dr. Gaurav, and for giving me this honor. And I wish I could take my mask off and show that I'm actually speaking the truth, because you can then match my speech with my facial expressions, but I think that I'm a little old and I don't want to die of COVID-19. So it's very reassuring that everyone's wearing a mask. Some are double masked, even better. I wish I had. So anyway, it's how do I get this started? Let me, okay. You can just use the key, sir. Yeah, slideshow. Slideshow. Yeah, I saw it. Oh, okay. Back. Okay. So without further ado, as they say, this takes me back, bringing up Dr. Mirgendra Rajpande. My first research experience started with working with Dr. Mirgendra Rajpande. So I was just thinking how quickly time flies, and but I wanted to, so thank you very much again for this honor. Now, COVID-19 is an infectious disease, and what we've been doing for many years is work on typhoid fever. And I want to, bring these two together today. So, look, COVID-19 is a global problem, and typhoid is a local problem. So, but there are a lot of similarities. And the similarities come together in vaccines, diagnostics, and treatment. What I want you to understand, and you all probably know, but I just want to, emphasize that typhoid affects 500 per 100,000 population, not only in Nepal, but South Asia. So that's a lot. Look, anything over 100 per 100,000 in epidemiological or statistical terms is very, very significant. But look at this, it's 500 per 100,000. So, right now we have COVID-19, but that is causing a lot of problems. It's a pandemic. But, it's, what is important to understand is that there are other neglected illnesses that I hope that while we tackle COVID, it will put focus on these neglected tropical illnesses. So, if we if we look at vaccines, so like there is this typhoid conjugate vaccine that was studied here in Nepal, and the administration will hopefully start soon in our vaccine immunization schedule. So typhoid has been, as I've been saying, for like hundreds of years. But COVID-19, because it's a universal problem, and it's a new problem, but because it's universal, everyone got together and they made a vaccine within a year, and look how successful that vaccine is. But look for a disease like typhoid, or even take typhus or leptospirosis that plagues us, that gives us a lot of problems in poor countries like ours. There's just nothing happening. So, I hope that it gives us pause to think about this, that, when the world gets together, because this is a problem for everyone, it's a different story. And the same thing, I want to take this theme further about the rapid diagnostic tests. Now, every one of us has heard of the Vidal test. In fact, we've had the Vidal test, many of us. This is a test over 100 years old. It's a useless test. But, because this is impoverished countries' disease, no one does anything. Look how rapidly the antigen test has been invented for COVID-19. See, when the world's scientists come together, a lot of good things can be done. Look at these PCR labs that have sprung up, where places where there may be no blood cultures available. PCR labs have come up. But it's hardly any use for neglected tropical illness like typhoid. I want to emphasize that it's very, very important to tackle COVID-19. This is a global pandemic, and I don't want to take anything away from this. But at the same time, I think we have to realize that there are many diseases, and typhoid is a representation of those diseases, neglected illnesses that need to be tackled. And hopefully COVID-19 will focus attention. And what about therapeutics, treatment? Look, the Nepal Health Research Council is involved with this recovery trial. It's a treatment trial for a novel illness. What trials are we doing for typhoid or typhus or leptospirosis? Very few. And yet, I just told you that there's 500 per 100,000 being affected. So we should be running trials, just like we're doing for COVID-19, for these neglected illnesses. These randomized, we've now have seen the importance of these treatment trials, of these vaccine trials, of these diagnostic trials. So I think that with COVID-19 and infectious disease that affects the world, what affects us locally, we need to understand, because many others may not be, able to help us. And, obviously this also highlights the disparity between a local problem and a universal disease. So, this is just, so I just hope that even as we tackle, and this is my theme for this oration, even as we tackle COVID-19, I hope COVID-19 will help us focus on these age-old diseases in terms of vaccines, in terms of diagnostics, in terms of therapeutics, because they run parallel. And I hope that the world, not only us, will collaborate with us in trying to deal with this, just like we're doing with COVID-19. Okay, and in terms of vaccines, are we utilizing the vaccines that we have? So we now realize, I hope all of us, certainly everyone here in this room, realizes the importance of getting this vaccine against COVID-19. We realize this. And I hope that for other diseases too, like for meningitis, when I talk to students, medical students or medical doctors, interns, I say, have you taken the meningitis vaccine? no one's taken the meningitis vaccine, or very few. Have you taken the typhoid vaccine? Have you taken the Japanese encephalitis? All of these vaccines are very effective, but no one uses this. I think this COVID-19 tells us, emphasizes the point that we need to utilize the existing vaccines. Okay, because we just see right now, look at this, we're all masked up, and that is to prevent an illness that is preventable by a vaccine. So I really want to emphasize, we need to have proper utilization of rabies vaccine, meningococcal vaccine, pneumonia vaccine for people over 65, influenza vaccine, and COVID-19 reminds us of this. Okay. We have to, so like we do have a reliable rapid diagnostic test. We do not have a reliable rapid diagnostic test for typhoid, typhus, or leptospirosis. So we will need to solve our problems ourselves. Waiting for others to help us is probably not a good idea. As why? Because look what has been our condition waiting for the COVAX, to help us with the vaccine. For the COVAX group, as you know, they were supposed to help. They are still trying to help us receive the COVID-19 vaccine. But what is going on? So these charitable organizations want to help us, but there are other agendas also at play that prevent us, like, the countries like ours, from receiving these vaccines. And as a result of which, we will not be, we are all very anxious. So in terms of COVID-19 and typhoid, COVID-19, look, I hope that it brought about in this oration just the awareness of other infectious diseases, even as we deal with COVID-19. I hope that this helps us capacity build, in terms of research, in terms of other reasons, so that we are able to do these studies on our own, that we can collaborate. But just collaboration is not enough, because we also have to do things independently. So we learn from collaboration, but some of these things pertain to us, like typhoid. Why would America be worried about typhoid except for travelers? Why would Britain be worried? We are worried because I just told you there's 500 per 100,000. And the same thing with typhus, same thing with lepto, same thing with tuberculosis. So we have to collaborate, but at the same time, we have to be shrewd enough to realize that we have to do things on our own, learning from collaborative experiences. And I could not give you a better example than what has happened with this, with us not receiving any vaccines right now. We were all waiting, as I told you, for the COVAX to help us, but where's the vaccine? So it's important for us to, going forward, how do we collaborate, but how do we become independent too? How do we do a few things ourselves which are doable here? I'm not saying do great, like molecular biology reasons, but simple things need to be done. And for this reason, I want you to look at, this article that is out today, your Nepali Times ma Kul Chandra Gautam ji le lekhnu bhayeko. Please read this. Hope, hyperbole, and hypocrisy of COVAX. So first of all, you have to know what this COVAX is. Many of you know. I think they were, this is part of WHO, this is part of Gavi, this is part of where they are trying to help poor countries with vaccinations. But they had great ideas, great idealistic principles, but it hasn't translated to real life. I want, please take some time if you have some time. यो फ्रीमा पनि आउँछ, अनलाइन पनि छ, Nepali Times. यो कुलचन्द्र गौतम is very a big intellectual. UNICEF-मा काम गर्नुभयो पहिला. She's from the, so if you have time, please read this and you'll get a feel for why we need to be independent. We collaborate, but I just want to leave you with this thought that how do we going forward collaborate with others, but also start thinking about how do we do things perhaps down the line in an independent way. I think that's all I wanted to share with you. Thank you so much for listening so patiently. And I want to thank the organizers and also the Mirgendra oration, for giving me this honor with this oration. Us, thank you so much. Hey, Darsa.
Wonderful indeed to listen to you, sir. And it's our honor actually to have you over here to deliver this. At the same important moment and very precious moment over here, we have our Chairman Emeritus, Dr. Mrigandraj Pandey, over the virtual mode, who will be with us for a while. Can I please request the team here? And same time, we know Sir Buddha Sir doesn't have much time, but we are very thankful for you to be here, and we'll be delighted to honor you with award. And after Dr. Pandey delivers his very short remarks, he was supposed to be here. Let us see for a few seconds. Okay, it's okay. We will probably get back to him if he is connected. But for now, to honor you, sir, may I request our respected Chief Specialist of the Ministry of Health and Population, Mahendra Shrestha sir, and also our Chairman of the Research Council, Professor Dr. Gainath Baral, to jointly award this honor to Professor Buddha Basnath. Chairman. Thank you so much, Mahendra sir. Thank you so much, our Chairman, Dr. Baral. And thank you so much, sir. We are really honored to have you here, and we thank you from our inner core of the heart. Thank you, sir.
Thank you for this opportunity. I'm going to run away with
Sure, sir.
Thank you. Thank you, everyone.
All right, we continue with our closing session now, and we'll be moving ahead with the final session, the closing session of this year's summit. Very much historical, I would say, the 7th Virtual National Summit of Health and Population Scientists in Nepal. For the closing session, I'd like to request our chairman, the chairperson of the Nepal Health Research Council, Professor Dr. Gainath Baral, to chair as the chair of the session, please. Thank you.
I give permission to conduct this program. You can follow it.
Thank you, sir. So, and we are honored to have respected Chief Specialist of the Ministry of Health and Population as the chief guest of this closing session. Mahendra sir, would like to request for the chair. And sincerely, I'd like to request Vice Chair Professor Dr. Gaurav Dhakal to take his chair, please. And accordingly, our Executive Chief, Dr. Pradeep Khyawali, sir, please. And I'd like to request all of you to take seats wherever are available here, and thank all of the viewers from all of the country, maybe outside country as well, to be with us in this very important moment of the 7th National Summit. Moving ahead, without wasting much time, we'd like to look into the progress against the declaration of the 6th National Summit of Health and Population Scientists in Nepal, and what have we progressed on that? To put highlight on that, I'd like to request the Chief of the Research Section of Research Council, Dr. Meghna Dhimal. Dr. Dhimal, please. सर नमस्ते, हामीलाई सुन्नुहुन्छ?
हजुर सुन्छु।
Okay.
Sir,
thank you so much, sir. So we have finally been connected with Chairman Emeritus of the Nepal Health Research Council, Dr. Mrigendra Pandey. We'd love to hear from you, sir. We have actually just completed the oration delivery, and because of time constraint, Professor Buddha Basnet had just left after delivering his oration, the Mrigendra Samjana Medical Trust oration, and we'd like to hear a few words from you on that, sir.
अच्छा, बुद्ध जी को ओरेसन एकदम राम्रो लाग्यो मलाई, खुसी लाग्यो र राम्रो मान्छे छान्नु भएकोमा नेपाल हेल्थ रिसर्च काउन्सिललाई धन्यवाद दिन चाहन्छु, मनैदेखि धन्यवाद दिन चाहन्छु। त्यो मात्र हैन कि ओरेसन भन्दा पहिले पनि मैले दुई चारवटा प्रोग्रामहरु सुनेर बसेको थिएँ, त्यसले गर्दाखेरि रिसर्च काउन्सिलले यस्तो डिफिकल्ट टाइममा पनि कति राम्रो काम गरिराखेको रहेछ भनेर देख्दाखेरि मलाई ज्यादै नै सन्तोष आयो। यो काउन्सिल खोलेको ठीक रहेछ भनेर, यसले अझ दिन प्रतिदिन राम्रो हुँदै जान्छ भन्ने कुरामा मलाई पुरा विश्वास छ। हस् हजुर, धन्यवाद।
Thank you so much, sir. It's our honor to hear you on this special occasion. Thank you, sir.
Okay,
so we'd like to continue with the session proceeding now. Dr. Dhimal, please.
Thank you so much, Kisi sir. Respected chairs of the sessions, chief guests of the sessions, and all dignitaries in the desk. यो प्रत्येक वर्ष हामी यो समिट पछाडि घोषणापत्र जाहेर गर्छौं र गत हामीले 6 वटा समिट बनाइसकेपछि 6 वटा घोषणापत्र पनि भए र सधैँ एउटा आउने प्रश्न भनेको ती घोषणापत्रहरूको कार्यान्वयन पक्ष कस्तो रह्यो भन्ने हो र हामीलाई पत्रकार बन्धुहरूले पनि सोध्नुहुन्छ यो प्रश्न। त्यो भएर यस्ता हामीले के गरेको छौं भने गत वर्षका हाम्रा घोषणापत्र 7 बुँदे घोषणापत्र हामीले जाहेर गरेका थियौं र यो एक वर्षमा हामीले कति कार्यान्वयन गर्न सक्यौं, कति सकेनौं, त्यसलाई छोटो हामी समीक्षा योजना गर्ने हामी प्रयत्न गरेका छौं र मेरो आईटी टिमलाई चाहिँ हाम्रो आईटी टिमलाई म यो डिस्प्ले गर्न रिक्वेस्ट गर्छु गत वर्षको घोषणापत्र र हामी यो सालको घोषणापत्र सहित हामी अगाडि बढ्छौं। म यो सबै अगाडिको पढ्न चाहन्न, हाम्रो तल बुदागत रूपमा 1 नम्बरबाट तपाईहरुले देखाइदिनु भयो भने हामीले 1 नम्बरमा के भनेको थियौं भने वर्तमान देशको परिप्रेक्ष्यलाई मध्यनजर गर्दै अन्तर्विषय कार्यान्वयनात्मक अनुसन्धान गर्दै नीतिगत तहसम्म पुर्याउने भनेका थियौं र हामीले त्यतिखेर के भनेका थियौं भने नेपाल चाहिँ यो कन्ट्री लेड इम्प्लिमेन्टेसन रिसर्च अन युनिभर्सल हेल्थ कभरेजको लागि WHO ले सुरु गरेको थियो 2019 देखि र यस्ता प्रोजेक्ट हामी स्केल अप गर्दै जान्छौं भन्ने हिसाबले यो इम्बेडेड इम्प्लिमेन्टेसन रिसर्चलाई हामीले प्रायोरिटीमा राखेको थियौं र खुसीको कुरा के हो भने अहिले इथिकल एप्रुभलमा आएका धेरै जसो प्रपोजल स्पेशली एनजीओ को, आईएनजे को र हाम्रो नेपाल सरकारको पनि अहिले हामी इम्प्लिमेन्टेसन रिसर्चमै बढी चाहिँ प्रायोरिटी दिएर गरिरहेछौं र स्वयं स्वास्थ्य अनुसन्धान परिषदले पनि धेरैवटा रिसर्चहरू जस्तो इन्टिग्रेटेड डिजिज सर्भिलेन्समा, त्यस्तै गरी एयर पोल्युसनमा र हेल्थ इकोनोमिक्समा, त्यस्तै गरी हाम्रो यो एन्टी माइक्रोबियल रेसिस्टेन्समा, फार्माको भिजिलेन्समा चाहिँ अहिले हामीले इम्प्लिमेन्टेसन रिसर्च सुरु गरिसकेका छौं। त्यसले गर्दाखेरि जुन हामीले घोषणापत्रमा गत वर्ष लेखेका थियौं त्यसलाई कार्यान्वयनमा लानको लागि परिषद प्रतिबद्ध छ र ऐनले दिएको अधिकार अनुसार हामी गर्न र गराउन दुईटैमा यो इम्प्लिमेन्टेसन रिसर्चलाई चाहिँ प्रायोरिटी दिएको छौं, प्राथमिकता दिएका छौं भने मैले दोस्रो नम्बर बुदामा शैक्षिक संस्थाहरू, विद्वानहरू, अनुसन्धानकर्ताहरू र राष्ट्रिय तथा अन्तर्राष्ट्रिय सर्वकला निकायहरूसँगको सञ्जाललाई निरन्तरता दिँदै विस्तार गरिनेछ भनेका थियौं। यो लामो समयदेखि स्वास्थ्य अनुसन्धान परिषदले समन्वयमा काम गरिरहेछ, यसलाई थप गर्दै बेसिकली भन्नुपर्दा मैले डाक्टर प्रदीप गेवाली सरको लिडरशिपमा चाहिँ अहिले हामीले धेरै राष्ट्रिय र अन्तर्राष्ट्रिय समन्वयलाई बढाएको छौं र लगभग हामीले 10 वटा भन्दा बढी अहिले एमओयू साइन गरेका छौं यो वर्ष मात्रै। ती इन्टरनेशनल इन्स्टिट्युट आईबीआई इन्टरनेशनल भ्याक्सिन इन्स्टिट्युटदेखि लिएर फरेन युनिभर्सिटीहरूदेखि लिएर नेपालका जस्तै विश्वविद्यालयहरू, त्रिभुवन विश्वविद्यालय, काठमाडौँ विश्वविद्यालय, शहीद गङ्गालाल हृदय केन्द्र हैन, हाम्रो चाहिँ अब यो के भन्छ कान्ति बाल अस्पतालदेखि धेरैसँग अहिले हामीले चाहिँ MOU गरेर हाम्रो उद्देश्यले के रहेछ र नेपाल सरकारले पनि केमा बजेट विनियोजन गरेको छ भने अब सेन्टर फर एक्सलेन्समा हामी जानुपर्छ, अनुसन्धानका उत्कृष्ट केन्द्रहरू विकास गर्नुपर्छ भनेर हामी लागिसकेका छौँ, सुरु गरिसकेका छौँ। त्यो भएर यो घोषणापत्रलाई पनि हामी कार्यान्वयनमा गइरहेछौँ मैले भने। तेस्रो बुँदामा चाहिँ युवा अनुसन्धानकर्ता र वैज्ञानिकहरूको स्वास्थ्य अनुसन्धानमा ज्ञान र क्षमता अभिवृद्धि गर्दै आवश्यक तालिम र अनुदानको व्यवस्था प्रादेशिक तहसम्म पुर्याउने गरिनेछ भनेका थियौँ। र खुसीको कुरा अस्ति हाम्रो उद्घाटन समारोहमा पनि हाम्रो कार्यकारी प्रमुखले भन्नुभएको थियो, विगत 29 वर्षमा दिएको तालिमभन्दा हामीले यो वर्ष दिएको तालिम लगभग 2 वर्ष भनेपछि अहिले हामी लगभग 15,000 जतिलाई चाहिँ अहिले तालिम दिइसकेका छौँ। र एउटै तालिममा 500 जनासम्म राखेर जुन रिनोन साइन्टिस्टहरू हुनुहुन्छ नेपाली ओरिजिनको प्लस फरेन ओरिजिनको उहाँहरूलाई बोलाएर हामीले रिसर्चरको डिमान्ड अनुसार त्यसमा पनि उहाँहरूको आवश्यकतालाई सम्बोधन गर्ने गरेर एकदम बेसिक क्वालिटेटिभ रिसर्चदेखि लिएर प्रपोजल डेभलपमेन्टदेखि लिएर अहिले हामी सिस्टमेटिक रिभ्यू र मेटा एनालाइसिसमा गएर र खुसीको कुरा के हो भने यही समिटमा पनि 3-4वटा चाहिँ सिस्टमेटिक रिभ्यू र मेटा एनालाइसिसका पेपरहरू प्रस्तुति भएको छन्। यसरी चाहिँ हामी उच्च गुणस्तरको चाहिँ अध्ययन अनुसन्धानलाई प्रवर्धन गर्दै भोलिका हाम्रा क्लिनिकल गाइडलाइनहरू पनि इभिडेन्स बेस हुन् भन्नका लागि हामी दत्तचित्त छौँ र त्यसरी चाहिँ देशमा रिसर्च कल्चर विकास भइरहेको छ। र तालिमले मात्र हुँदैन, ती अनुसन्धानकर्ताहरूलाई कमसेकम सिड ग्रान्ट पनि दिनुपर्छ भनेर हामीले सुरुमा आन्तरिक बजेटबाट चाहिँ अन्डर ग्रेजुएटलाई, पोस्ट ग्रेजुएटलाई र प्रोभिन्सियल ग्रान्ट दिन्थ्यौँ भने अहिले नेपाल सरकारले कन्भिन्स भएर कोर फन्डबाटै रेगुलर बजेटबाटै यो बजेटहरू विनियोजन भएर हामीले 1 करोड लगभगको चाहिँ बजेटहरू प्रत्येक वर्ष अनुदानको रूपमा रिसर्च ग्रान्टको रूपमा हाम्रो अनुसन्धानकर्ताहरूलाई इभन प्रदेश लेभलमा गर्नलाई हामीले दिइरहेका छौँ। त्यसलाई पनि त्यो भएर हामीले निरन्तर दिएका छौँ। चौथो बुँदामा अनुसन्धान र यसको प्रसारका लागि डिजिटल टेक्नोलोजीको अधिकतम प्रयोग गर्ने संयन्त्रको सशक्तिकरण गरिनेछ भनेको थियौँ। यो मैले धेरै भन्नै पर्दैन, अहिले हामी आफै पनि यो डिजिटल टेक्नोलोजीले नै प्रयोग गरेर लगभग 1000 जना मान्छेलाई अहिले कनेक्ट गरेर र मान्छेको फुर्सदमा हेर्ने गरेर विभिन्न लाइभ प्रोग्राम हेर्दा हिजोको मैले बेलुका डाटाबेस हेरेको थिएँ 48,000 मान्छेले लाइभ हेर्नुभएको थियो भनेपछि यो चाहिँ अब जसले फुर्सद पाउनुहुन्छ त्यसपछि जहिले पनि हेर्न गर्न मिल्ने गरेर अहिले हामी स्वदेश विदेशका सम्पूर्ण वैज्ञानिकहरूलाई यो अनुसन्धानमा रुचि राख्ने व्यक्तिहरूलाई जोडेर अगाडि बढाएको छौँ। गत वर्षको 1 वर्ष भ्यू 1 लाख मान्छेले भ्यू गर्नुभएको थियो भने यसतारको हाम्रो लक्ष्य भनेको 5 लाख छ र मलाई लाग्छ 5 लाख नाग्छ। त्यसैले चाहिँ हामी यसलाई डिजिटल प्रविधिलाई पनि लाने गरेका छौँ। र अहिले हाम्रो रिभ्युअरहरूले सबै अनलाइनबाट हेर्नुहुन्छ, उहाँहरूको अनलाइन पेमेन्ट हुन्छ। त्यो भएर आर्थिक प्रशासनदेखि लिएर इथिक्सदेखि लिएर रिसर्च डिसेमिनेसन सबैलाई अहिले हामीले चाहिँ डिजिटाइजमा प्रविधिबाट गर अब हामी चाहिँ यो डेटाबेस पनि एउटा चाहिँ सेन्ट्रल सर्भर यहाँ राखेर गर्ने भनेर अगाडि बढाइरहेको स्थिति छ। 5औं नम्बरमा स्थानीय रूपमा प्राप्त तथ्यहरूलाई नीति र कार्यान्वयनमा ल्याउन नीति निर्माणकर्ताहरूसँग निकटतम सहकार्य गरिनेछ भनेको थियौँ। मैले हिजोको मेरो प्रस्तुतिमा पनि भनेको थिएँ, यो कोभिडको बेला हामीलाई जे सरकारले भन्नुभएको छ र त्यो हामीले देखेका छौँ, ती अध्ययन र अनुसन्धान गर्दाखेरि र यो टोलमा चाहिँ सहजीकरण सङ्घमा महेन्द्र सर हुनुहुन्छ, उहाँको अध्यक्षतामा म पनि त्यो सदस्य थिएँ। हामीले चाहिँ यो इभिडेन्स बेस चाहिँ जे गर्दा हुन्छ हामी लोकल इभिडेन्सलाई युज गरेर अहिले हाम्रा चाहिँ स्वास्थ्य मन्त्रालयका नीति निर्देशिकाहरू चाहिँ तय गरिरहेका छौँ। त्यसले गर्दाखेरि पनि यसले चाहिँ निरन्तरता पाएको छ। 6औं बुँदामा हामी शैक्षिक र गैर शैक्षिक अनुसन्धानमा स्वास्थ्य अनुसन्धानको जिम्मेवार आचरणको प्रवर्धन गर्ने भनेका थियौँ। अहिले नेपाल स्वास्थ्य अनुसन्धान परिषदको इथिकल रिभ्यू बोर्ड यहाँ भए तापनि हाम्रो अधिकारले हामीले 52वटा संस्थाहरूलाई इन्स्टिट्युसनल रिभ्यू कमिटी गठन गरेर दिइसकेका छौँ र अझै 20-25वटा चाहिँ अहिले विचाराधीन अवस्थामा छन्, एप्रुभल प्रोसेसमा छन्। यसरी चाहिँ हामी शैक्षिक संस्थाहरूमा त्यहाँबाट हुने फ्याकल्टीहरूको अनुसन्धान, विद्यार्थीहरूको अनुसन्धानलाई चाहिँ त्यही होस्, छिटो छरितो होस् भन्नलाई हामीले त्यसमा पनि हामीले चाहिँ सहयोग गरिरहेछौँ। त्यसरी चाहिँ एकाडेमिक पार्टनरसिपमा हामी काम गरिरहेछौँ र छिटै हाम्रो कार्यकारी समितिले पास गरिसकेको छ। अब हामी एकाडेमिक प्रोग्राम पनि चलाउँदैछौँ, फेलोसिपहरू चलाउँदैछौँ। त्यसपछि जोइन्ट पिएचडी प्रोग्रामको लागि पनि हामी अगाडि कुरा गरिरहेछौँ। त्यसरी चाहिँ हामी यसलाई निरन्तरता दिएका छौँ। र 7औं बुँदामा के थियो भने कोभिड-19 महामारीको तथ्य सङ्कलन सुदृढ गर्नका लागि राष्ट्रिय निर्देशिका अनुसार कोभिड-19 को सम्बन्धी स्वास्थ्य अनुसन्धान प्रवर्धन गरिनेछ भनेका थियौँ। हामीले यो कोभिड आउने बित्तिकै गत वर्षको जुनमा नेसनल गाइडलाइन डेभलप गर्यौँ इभिडेन्स जेनेरेसन कसरी गर्ने भनेर, र त्यो ग्लोबल प्रायोरिटीदेखि लिएर नेसनल प्रायोरिटी सबैलाई सम्बोधन गर्दै मैले हिजो पनि भनेको थिएँ हामीले गत वर्ष 2020मा 400वटा प्रस्तावहरू चाहिँ कोभिड सम्बन्धी स्वीकृत गरेका थियौँ। त्यसमा 35वटा हामी एनएचआरसीले आफै गरिरहेछौँ र यो साल पनि 81वटा प्रस्तावहरू स्वीकृत भएका छन्। यसरी चाहिँ कोभिड-19मा चाहिँ अहिले उच्च प्राथमिकताको साथ हामीले अरू नन कोभिड प्रोजेक्टलाई पनि निरन्तरता दिँदै कोभिडलाई चाहिँ उच्च प्राथमिकता राखेर काम गरेकोले गर्दा हाम्रा गत वर्षका जुन घोषणापत्रमा आएका मुद्दाहरू हामीले अक्षरशः लागू गर्न हाम्रो म्यानेजमेन्ट, कार्यकारी समिति, प्रतिबद्ध छ र उहाँले दिएको निर्देशन अनुसार हामी पनि गरिरहेछौँ भन्ने मैले जानकारी गराउँदै मेरो यो गत वर्षको घोषणापत्रको समीक्षा यहीँ अन्त गर्छु। धन्यवाद। र अब म चाहिँ हाम्रो कृष्ण सरलाई हेर्नु पर्छ।
Thank you so much, sir, for highlighting the progress against the declaration from the last summit, 6th National Summit of Health and Population Scientists in Nepal. It's always a pleasure to see the progress that we have made over the years, and glad to know that the progress has been made over this year has been also significant equally. अब हामी यो वर्षको समिटको डिक्लेरेसनको तर्फ लाग्दैछौँ, जहाँ हामीले 2 दिनको समिट पश्चात हामी सबै पार्टिसिपेन्ट्स, डेलिगेट्स लगायत सबैजनाले फिल गरेको कुराहरू यहाँ चाहिँ समीक्षा गरेर यसलाई समराइज गरेर हामी यो वर्षको डिक्लेरेसनलाई अगाडि प्रस्तुत गर्न जाँदैछौँ। र यसको लागि म रिक्वेस्ट गर्न चाहन्छु परिषदका कार्यकारी प्रमुख श्री डाक्टर प्रदीप ख्यावाली टु टेक दिस प्रोसेस अहेड अफ डिक्लेयरिङ द डिक्लेरेसन्स वी हैव मेड।
धन्यवाद कृष्ण अर्यालजी। आजको यस हाम्रो यो समापन समारोहमा अध्यक्षता गर्नुभएका नेपाल स्वास्थ्य अनुसन्धान परिषदका अध्यक्ष प्राध्यापक डाक्टर गेनाथ बरालजी, हाम्रो निमन्त्रणालाई स्वीकार गरेर स्वास्थ्य तथा जनशिक्षा मन्त्रालयबाट पाल्नुभएका प्रमुख विशेषज्ञ महेन्द्र प्रसाद श्रेष्ठज्यू, त्यस्तै गरी परिषदका भाइस चेयरम्यान प्रोफेसर डाक्टर गौरव ढकालज्यू लगायत अब हामीसँग यहाँ थुप्रै प्रोफेसरहरू सरहरू हुनुहुन्छ, हामीरा चेयर सरहरू पनि हुनुहुन्छ, प्रोफेसर सरराज अन्तज्यू, त्यस्तै गरी प्रोफेसर वासुदेव पाण्डे डाक्टर साहबज्यू, बुद्ध बस्नेत सर गइसक्नु भएको छ र मैले मृगेन्द्र राज पाण्डे सरलाई सम्झिनै पर्छ, उहाँलाई म नमन गर्छु। हाम्रो इमेरिटस अध्यक्षको हिसाबले उहाँहरूले हामीलाई जुन हौसला दिइरहनु भएको छ यो अत्यन्त हामीलाई इन्सपिरेसन छ। यहाँलाई पनि म स्वागत गर्न चाहन्छु। त्यस्तै गरी अब अन्य सम्पूर्ण पत्रकार साथीहरू, कर्मचारी साथीहरू, डिपार्टमेन्ट हेड लगायत सबै साथीहरू, त्यस्तै गरी हाम्रो आइटीका टिम लगायत सम्पूर्ण उपस्थितहरूलाई जुमबाट पाल्नुभएका सम्पूर्ण सर म्याडमहरूलाई आजको यस क्लोजिङको सन्ध्यामा मेरो व्यक्ति तथा नेपाल स्वास्थ्य अनुसन्धान परिषद तर्फबाट मैले यहाँहरूलाई स्वागत गर्न चाहन्छु। मलाई सुरुमा मलाई सबभन्दा खुसी केमा लागेको छ भने सुरु आइटीबाट काम गर्ने यो पेन्डेमिकको बेलामा गर्ने कि नगर्ने भन्दै हामीले 3 चोटि जति यो सारेको 10 देखि 12 अप्रिलदेखि अब गर्ने नगर्ने भन्दै 3 चोटि सार्यो। अनि होइन यो त चाहिँ किन भन्दा यो कल्चर यस्तो राम्रो कुरा, साइन्टिफिक कुरा जसरी पनि गर्नुपर्छ भनेर साथीहरू उत्साह दिनुभयो, अध्यक्ष लगायत बोर्ड सबैहरूले। र त्यसले गर्दा छोटो समयमा हामीले गऱ्यौँ होइन। र जे जस्तो भए तापनि म केमा खुसी छु भने अब यहाँहरूको सुझाव हामीले अत्यन्त स्वीकार गर्नेछौँ। कमजोरीहरू हामीले जुन कुरा सोचेका थियौँ सफल भएका छौँ, म यसरी भन्न चाहन्छु। त्यस कारणले गर्दा यसमा प्रत्यक्ष अप्रत्यक्ष हिसाबले चाहिँ हामीलाई सहयोग गर्नुहुने सम्पूर्णहरूलाई अफिसियल्स अथवा व्यक्तित्वहरू अथवा चाहिँ साइन्टिस्टहरूदेखि लिएर पत्रकार साथीहरू सबैलाई हामीले धन्यवाद दिनैपर्छ। हामी खुसी छौँ। र मैले यो धन्यवाद दिने क्रममा यहाँ हाम्रो हुन त अघिल्लोचोटि समापनमा के अरे उद्घाटनमा दिइसक्नु भएको छ, केही चाहिँ त्यतिखेर पनि छुटेका थिए हाम्रो तर्फबाट। र क्लोजिङसम्म आइपुग्दा पनि हाम्रो डिपार्टमेन्टबाट अहोरात्र खट्ने साथीहरूलाई मैले सम्झिनै पर्छ। डिपार्टमेन्टबाट सबैलाई अत्यन्त चाहिँ एमसी गर्ने चाहिँ भाइ बहिनीहरू पनि अत्यन्त राम्रोसँग गर्नुभयो, उहाँहरूको कला पनि देख्न पाइयो। हाम्रो रिसर्च डिपार्टमेन्टबाट मेघनाथले जसरी सुरुदेखि गर्नुभएको थियो विशेष धन्यवादको पात्र हुनुहुन्छ। त्यस्तै गरी चाहिँ एकाउन्टको चिफ सर अब हाम्रो शुभ सरले होइन हरेक कुरामा चाहिँ काम गरिरहनु भएको छ, लागिरहनु भएको छ, स्वागतदेखि लिएर एकाउन्टदेखि लिएर। त्यस्तै गरी विजयजीले ट्रेनिङको हिसाब मात्रै नै कि यहाँले पनि हरेक कुरामा सफल हुनुहुन्छ, उहाँले राम्रो काम गर्नुभएको छ। भूषणजीले आइटीमा पुरै सपोर्ट गरेर काम गर्नुभएको छ। नमिताजी घरमा बसेको भए पनि उहाँलाई ससुरा बुवाको शोक परेको छ, यहाँबाट हामीले चाहिँ शोक चाहिँ प्रकट गर्न चाहन्छौँ सबैको तर्फबाट। त्यस्तै गरी अब हाम्रो प्रशासन शाखाको हिसाबमा चाहिँ हरेक कुरामा युवराज सर धेरै सिनियर हुनुहुन्छ, सबभन्दा सिनियर उहाँ हुनुहुन्छ र धेरै कुराहरू चाहिँ सपोर्ट गरिरहनु भएको छ। हरेक कुरामा उहाँलाई बोल्न दियो, राम्रोसँग हँसाउनु पनि हुन्छ, गर्नुहुन्छ होइन, कहिलेकाहीँ रुवाउनु पनि सक्नुहुन्छ। आज बोल्न पाउनु भएको छैन, छोटो छ कि धेरै हिसाबले सबै अफिसरहरू, एकाउन्ट अफिसर्सहरू अथवा एडमिन अफिसर्सहरू, रिसर्च अफिसर्सहरू, एसिस्टेन्ट लगायतका हाम्रा सम्पूर्ण साथीहरूलाई म धन्यवाद दिन चाहन्छु, सम्पूर्ण चाहिँ बोर्डको तर्फबाट र व्यक्ति तर्फबाट। एउटा कुरा मैले के भन्ने मन लागेको छ भने यो काममा चाहिँ हामीले केही एडमिनिस्ट्रेटिभ चाहिँ कुराहरू चाहिँ हाम्रो जुन एवार्ड सिलेक्सनको कुराहरूमा हुन त पछि गणेश दङ्गाल सरले भन्नुहुन्छ एज एन एजुकेटिभ चिफ र यसको कन्फ्लिक्ट अफ इन्ट्रेस्टका कुराहरू पनि हुन सक्छन् कहिलेकाहीँ। म पूर्ण रूपमा के भन्न चाहन्छु भने जुन कमिटीहरू बने बोर्डबाट हामीले चाहिँ पछि सबै छलफल गरेका छौँ, सबै गरेका छौँ, गर्दाखेरि कुनै पनि हिसाबको एज एन एजुकेटिभको हिसाबले अथवा व्यक्तिगत हिसाबले मेरो केही पनि इन्फ्लुएन्स छैन, यो म डिक्लेयर गर्न चाहन्छु। र जो चाहिँ सरहरू म्याडमहरू सम्मान हुनुभएको छ म उहाँहरूलाई हृदयदेखि सम्मान गर्न चाहन्छु र उहाँहरू त्यसको डिजर्भिङ क्यान्डिडेट हुनुहुन्छ होइन। त्यो खालको हिसाबले गर्दा भर्खरै हामी केही समयपछि सुन्नु पनि सक्छौँ। र यसमा चाहिँ एउटा अघिल्लो वर्षदेखि मलाई के भन्न पनि मन लाग्यो भने मेरो आफ्नो आमाको नाममा पनि दुर्गादेवी गेवालीको हिसाबले हाम्रो जर्नलमा चाहिँ बेस्ट पर्फर्मेन्स अवार्डको हिसाब राखेका थियौँ। यो दोस्रो वर्ष पनि मैले कन्टिन्यू गरेको छु र त्यसको लाग्ने सम्पूर्ण खर्चहरू मैले चाहिँ मेरो आफ्नो हिसाबले खर्च गर्ने गरी चाहिँ प्लान गरिरहेको छु, त्यो अनुसार भएको छ। कार्यालय श्री बिरामीको नाममा चाहिँ मैले एउटा चाहिँ अवार्ड सम्मान राखेको र यसलाई म सधैँ कन्टिन्यू गर्न चाहन्छु। त्यस्तै गरी अब अर्को चाहिँ हामीले यहाँको स्टाफहरूको हिसाबले जसले चाहिँ अहोरात्र काम गर्नुभएको छ सबै यसका चाहिँ डिजर्भिङ क्यान्डिडेट हुनुहुन्छ, तर एकजना मात्रै सिलेक्सन गर्नुपर्ने अत्यन्त गाह्रो, पोहोर पनि मलाई गाह्रो भएको थियो। अनि त्यस पछाडि हामीले के गर्यौँ भन्दा होइन यो यसलाई अझै व्यवस्थित गर्नुपर्छ भन्ने हिसाबले प्रोफेसर डाक्टर गौरवराज ढकालजी उपाध्यक्षको संयोजकमा प्रोफेसर डाक्टर वन्दना खनाल र म सदस्य सचिव रहेर 3 सदस्य कमिटी हामीले गठन गऱ्यौँ र यसका सिरिज अफ 3टा मिटिङ बस्यौँ र केही क्राइटेरिया हामी बनाएको थियौँ। हुन त यसलाई अलिकति मैले अध्यक्षसँग सल्लाह गरेको छु, अर्को वर्षदेखि अलिकति मोडिफाई गर्नुपर्छ यसलाई, किन भन्दा एउटा मात्रै हुँदाखेरि कहिलेकाहीँ के छ भने हरेक थरीका साथीहरू हुनुहुन्छ यहाँ काम गर्ने, एउटा एडमिनिस्ट्रेटिभ हिसाबले काम गर्ने साथीहरू हुनुहुन्छ, एउटा रिसर्च हिसाबले काम गर्ने साथीहरू हुनुहुन्छ र कहिलेकाहीँ चाहिँ हामीले जुन क्राइटेरिया बनायौँ त्यो गर्दाखेरि एक लेभलको चाहिँ साथीहरू जहिले पनि रोकिने खालको पनि सम्भावना हुन्छ। त्यसले गर्दा अर्को वर्षदेखि म अध्यक्ष मार्फत यही नै के भन्न चाहन्छु भने हामीले 2 थरीका चाहिँ मेडलहरू राख्नेछौँ, एउटा एडमिनिस्ट्रेटिभ हिसाबले काम गर्ने बेस्ट पर्फर्मेन्सको हिसाबले र अर्को चाहिँ रिसर्चको हिसाबले काम गर्ने बेस्ट पर्फर्मेन्स हिसाबले हामी राख्ने गरी प्लान गर्नेछौँ अन बिहाफ अफ प्रेसिडेन्ट होइन बोर्ड होइन त्यो खालको छ। र अहिले हामीले क्राइटेरिया बनाएका थियौँ, सेल्फ इभ्यालुएसन हामीले गराउनु थियौँ, तपाईँले गरेका कामहरू आफै सेल्फ इभ्यालुएसन गर्नुहोस्, सर्टेन नम्बर राख्यौँ, टोटल 50 मार्क्स राखेको थियो र त्यस्तै गरी चाहिँ एजुकेटिभ चिफको पनि आफ्नै अब्जर्भेसन छ एउटा चाहिँ मार्क्स राख्यौँ। त्यस्तै गरी चाहिँ एटेन्डेन्सको हिसाबले उहाँहरूले वर्षभरिमा कति चाहिँ हाजिर गर्नुभयो, कसरी गर्नुभयो, यसका पङ्क्चुअलिटी कुराहरू हामी हेऱ्यौँ। त्यस्तै गरी उहाँहरूको सुपरभाइजरको हिसाबले आफ्नो मातहतका सिनियरहरूको सुपरभाइजरले चाहिँ कसरी चाहिँ हेरिनु भएको छ उहाँहरूलाई त्यो पनि कन्डिसन राख्यौँ र त्यस्तै गरी चाहिँ हामीले सिनियरिटीको हिसाबले पनि ध्यान दियौँ र यसरी चाहिँ हामीले 50 मार्क्सको हिसाबले चाहिँ राखेर त्यसको पनि एउटा चाहिँ सिलेक्सन गरेका छौँ। जो पर्नु भएको छ उहाँलाई धन्यवाद दिन चाहन्छौँ र अलिकति हामीले सल्लाह के पनि गऱ्यौँ भने अब काम गर्ने चाहिँ साथीहरूलाई अलिकति एउटा मेडलले त ठुलो सम्मानित गर्छ गर्नलाई र केही न केही अलिकति राशि पनि किन नराख्ने त भन्ने हिसाबमा हामीले केही राशिको पनि व्यवस्था गरेका छौँ र जो सम्मान हुन्छ उहाँहरूलाई हामीले त्यो राशिबाट पनि सम्मान गर्दछौँ। र अर्को चाहिँ अहिले योचोटि मैले अध्यक्षसँग कुराकानी गरेँ कि एउटा वर्षभरि चाहिँ बसेर एउटा कार्यालय प्रमुखको हिसाबले काम गर्दा उच्च मनोबलका साथ काम गर्नुपर्छ भन्ने हिसाबले हामीले डिपार्टमेन्ट वाइज कम्पिटिसन गराउने प्लान गरेका छौँ र यो वर्षदेखि हामी सुरु गर्दैछौँ कि अहिले चाहिँ हामीले कोभिडको लगाइसके पछाडि साथीहरू अहोरात्र खट्नु भएको छ, सबै डिपार्टमेन्ट चाहिँ यसका डिजर्भिङ क्यान्डिडेट हुनुहुन्छ होइन। विजयजीले बसेर चाहिँ रात दिन चाहिँ तपाईँको ट्रेनिङ गराइरहनु भएको छ, रातिमा पनि बसेर त्यसमा मेहनतले सहयोग गर्नुभएको छ। रिसर्च डिपार्टमेन्टले आफ्नै हिसाबले काम गरेको छ, एडमिनले आफ्नै काम गरिराखेको छ, नमिताजीले घरमा बसेर पनि राति प्रपोजल मलाई पठाइराख्नुहुन्छ। इथिकल हिसाबले हेर्दाखेरि पनि हामीले प्रपोजल चाहिँ पहिलाभन्दा बढी नै गरिरहेको छौँ, अघि साथीहरूले पनि बताइसक्नु भयो होइन। त्यस्तै गरी चाहिँ एकाउन्ट डिपार्टमेन्ट नयाँ डिजिटाइज सिस्टमबाट जाने गरी काम गर्नुभएको छ, सबै साथीहरू सबै डिपार्टमेन्ट जर्नलको हिसाबले पनि काम भएको छ भन्दाखेरि एउटा डिपार्टमेन्टलाई चाहिँ अलिकति किन भन्दा अलिकति कम्पिटिसनको भावना पनि गरौँ र डिपार्टमेन्टको चाहिँ बिचको आन्तरिक चाहिँ स्वच्छ प्रदर्शन गरेर अब काम चाहिँ अझै बढाउनुपर्छ भन्ने हिसाबले हामीले बेस्ट डिपार्टमेन्टको एवार्ड पनि सुरु गरेको छौँ। यसमा मेडल चाहिँ छैन, हामीले सम्मान पत्रको हिसाबले डिपार्टमेन्टलाई दिँदैछौँ र त्यसले गर्दा साथीहरू डिपार्टमेन्टमा बसेर आफूले हेरेर अब त्योभन्दा अझै कसरी राम्रो गर्ने अथवा त्यो डिपार्टमेन्टमा मैले कसरी राम्रो गर्ने भन्ने खालको हिसाबले यो पनि प्लान गरेका छौँ। यो पनि आज चाहिँ हामीले प्रस्तुत गर्नेछौँ र यति भन्दै मैले विशेष धन्यवाद चाहिँ दिनैपर्छ। अब सम्मान्य प्रधानमन्त्रीले अघिल्लो दिन चाहिँ हामीलाई हिजो शुभकामना दिनुभएको छ र हामीले चाहिँ एनएचआरसीले सोचे जस्तै गरी अब एनएचआरसी चाहिँ क्लिनिकल रिसर्चको बारेमा फड्को मार्नुपर्छ र अब अलिकति बढी इन्टरभेन्सन रिसर्च गर्नुपर्छ भन्ने हिसाबले भ्याक्सिन ड्रग ट्रायलका कुराहरू पनि उहाँहरूले हामीलाई शुभकामना मार्फत दिनुभएको छ र अब हामीले यसमा सोचिरहेका छौँ। हामीले अघि हिजो पनि भन्यौँ कि अब चाहिँ एनएचआरसीले एकाडेमिक हिसाबले फड्को मार्नेछ, फेलोसिपको हिसाबले 1 इयरको कोर्स पनि सुरु गर्ने जमर्कोमा छौँ। त्यस कारणले गर्दा यो नयाँ खालको प्रोग्राम हुनेछ र भर्खरै हामीले चाहिँ न्यामसँग पनि अगाडि बढ्न जाने गरी कुराहरू पनि बढिसकेका छ भन्दाखेरि अब यो फड्को चाहिँ एनएचआरसीले लिन्छ भन्ने हामीले विश्वास लिएका छौँ। यसको लागि सबैले चाहिँ साथ दिनुहुन्छ भन्ने विश्वास पनि छ र उद्घाटन सत्रमा हामीलाई सहयोग गर्नुहुने सोभिता गौतमजीले उद्घाटन चाहिँ मा सहयोग गर्नुभयो गरेर त्यसपछि गएर कृष्णजीले गरिरहनु भएको छ र सबै धन्यवादका पात्र हुनुहुन्छ। मैले जसलाई छुट्याएको भए तापनि मैले चाहिँ तपाईँको हिसाबले चाहिँ क्षमा याचना गर्न चाहन्छु। यति भन्दै अब मैले लामो समय नलिकन आज हामीले 2 दिनको चाहिँ पछाडि के डिक्लेरेसन गऱ्यौँ, अघि मीनाक्षीले भन्नुभयो हामीले 1 वर्ष अगाडि के काम गऱ्यौँ त्यसको चाहिँ काम गरेको कुराहरूलाई समीक्षा पनि हामी गऱ्यौँ। र फेरि म के भन्न चाहन्छु भने अर्को वर्ष यहाँहरूसँग आउँदा त फेरि पनि हामीले अहिलेसम्म समिटमा बसेर चाहिँ गरेका चाहिँ डिक्लेरेसनहरूलाई हामीले चाहिँ एनालाइटिकल हिसाबले हेरेर अनि यसको चाहिँ हामीले यहाँहरूको समक्ष पनि आउनेछौँ र यसमा नेपाल सरकारलाई सुझाव दिनुपर्ने कुराहरू भएका र छुटेका कुराहरू हामीले फेरि फलोअप गर्नेछौँ र अर्को वर्ष आउँदा हामी यो सहित आउनेछौँ भन्दै म डिक्लेरेसन पढेर सुनाउन चाहन्छु। Declaration of 7th National Summit of Health and Population Scientists in Nepal. The theme was Research in Public Health Emergencies, Evidence to Policy and Action, 1st and 2nd July 2021. Health research is the foundation of sustainable and evidence-based policy. The 7th National Summit of Health and Population Scientists addresses emerging need of appraisal and collation of evidence around the public health emergencies following the COVID-19 pandemic and calls for integrating all other disciplines of research to inform health policy and practices. The pandemic has widely affected every step of life. Scientific research to guide evidence-based policy and practice is the only way to overcome this pandemic. Advancing health research in Nepal's federal context requires greater coordination and cooperation across the 3 tiers of government and stakeholders that strengthens application of interdisciplinary and implementation research approaches. In this context, we all delegates collectively commit to the following declaration. We have 10 different declarations, so I want to read one by one. Number 1, increase investment in health research in the federal context to promote high quality scientific research in Nepal. Number 2, promote science diplomacy to facilitate evidence-based policy and practice across the government and stakeholders. Number 3, strengthen collaboration between researchers, policymakers, academia, scientists, civil society, and community to promote high-quality embedded implementation research for effective response to future pandemics. Number 4, promote human capital in health research by facilitating young researchers and scientists and enabling research culture. Number 5, strengthen organizational and individual capacity to conduct clinical trials for therapeutic purposes. Number 6, facilitate timely adoption and use of recent digital technologies towards strengthening the quality of research. Number 7, advocate for interdisciplinary research to understand multiple domains of health using One Health approach. Number 8, acknowledge potential shocks, stressors, and threats to human health and develop a responsive and resilient health system to tackle them effectively. Number 9, develop institutional capacity to ensure the vaccine and therapeutic development culture through the partnership with international vaccine and therapeutic agencies in various forms of trials. Number 10, reform the health research governance through a revision of institutional and legislative provisions in line with Nepal's federal system and best research governance practices. So, यति भन्दै सम्पूर्ण उपस्थित सभा अध्यक्ष लगायत प्रमुख अतिथि लगायत सबैमा विशेष धन्यवाद दिन चाहन्छु र यहाँहरूको सुख स्वास्थ्य को कामना गर्दै म बिदा हुन्छु। धन्यवाद।
Dhanyavad, sir. Thank you very much for first highlighting the different categories of awards that NHRC, through its National Summit of Health and Population Scientists in Nepal, been presenting to various its internal team as well as to scientists across the country. And finally, presenting the declaration of this year's summit, where we all commit and show solidarity towards implementation of those declarations that we have just seen over there. Now moving ahead, the most awaited moment of the closing session. It used to be very exciting when we used to have in-person attendance of participants, guests over here. I remember the cheers, I remember the moments that we all used to enjoy while presenting or distributing the awards, and obviously it had to be. Even though we now are virtually connected, we can cherish that and same time try to enjoy this moment as well of distributing various awards. Before going to the awards distribution, I would like to request the coordinator of awards selection committee, Professor Dr. Ganesh Dangal, who led the overall process of award selection, especially those from the invited applications, where there was a process set up by the coordinator, and we followed that procedure, the team followed that procedure, and we have selected the awardees. Professor Dangal, please. He is joining us virtually and should be here very soon.
Am I audible?
Yes, sir.
नमस्ते सबैलाई र धन्यवाद डाक्टर अर्याल। यस नेपाल स्वास्थ्य अनुसन्धान परिषदका अध्यक्षज्यू, कार्यकारी प्रमुखज्यू, उपाध्यक्षज्यू र यस समारोहमा अहिले उपस्थित हुनुभएका प्रमुख अतिथिज्यू लगायत एनएचआरसी परिवार र अहिले सभामा उपस्थित हुनुभएका सम्पूर्ण विज्ञज्यूहरू, वैज्ञानिकज्यूहरू र अवार्ड प्राप्त गर्नुभएका महानुभावहरू, सर्वप्रथम त एनएचआरसीले हामीलाई यो अवार्ड सेलेक्सन उपसमितिको रूपमा एउटा महत्त्वपूर्ण जिम्मेवारी प्रदान गरेकोमा त्यसको लागि हामी हृदयदेखि नै धन्यवाद दिन्छौँ। र यो टिममा चाहिँ प्राध्यापक जीवन बहादुर शेरचन, प्राध्यापक विष्णुबाबु थापा, प्राध्यापक सुबन बाबु मरठा, प्राध्यापक वन्दना खनाल, डाक्टर कृष्ण कुमार अर्याल, डाक्टर रोलिना धिताल, श्री विजय कुमार झा र श्री प्रदीप बेलबासे लगायत हामी बसेर यो चाहिँ उपसमितिले काम गरेको थियो। र यसमा विभिन्न अवार्डहरू यहाँहरूलाई जानकारीमै होला। हेल्थ रिसर्च अवार्ड एकजनालाई, मृगेन्द्र सम्झना मेडिकल ट्रस्ट यङ रिसर्चर अवार्ड मेडिकल डक्टर क्याटेगोरी एकजनालाई, मृगेन्द्र सम्झना मेडिकल ट्रस्ट यङ हेल्थ रिसर्च अवार्ड एनएचआरसी स्टाफ मध्येबाट एकजनालाई र हेल्थ रिसर्च लाइफ टाइम अचिभमेन्ट अवार्ड एकजनालाई र बेस्ट पेपर अवार्ड जर्नल अफ नेपाल हेल्थ रिसर्च काउन्सिलको लास्ट इयरको बाट एकजनालाई गरेर यी अवार्डहरूको लागि चाहिँ हामीले एउटा कार्यवाही नै बनाएर अघि हाम्रो कार्यकारी प्रमुखले पनि भनिसक्नुभयो, यसमा चाहिँ यो एनएचआरसीको परिषदको कुनै पनि प्रत्यक्ष भूमिका नरहिकन हामीले चाहिँ उपसमितिले एउटा गाइडलाइन बनाएर जुन चाहिँ डाइनामिक पनि छ, भोलिलाई पनि हामीले यो राखेका छौँ र त्यो गाइडलाइनको आधारमा हामीले चाहिँ योग्य व्यक्तित्वहरूबाट चाहिँ सम्मान प्राप्त गर्नको लागि चाहिँ सिफारिस गरेका थियौँ। र यसमा जेनरल क्राइटेरियाहरू सरसर्ती समयको पाबन्दी छ, म छोटोमा भन्छु। अवार्ड प्रदान गर्दा अवार्ड सेलेक्सन कमिटीका सदस्यहरूलाई समावेश गरिएको थिएन। अवार्ड प्रदान गर्दा अनुसन्धानकर्ता नेपाली नागरिक र नेपालमा अध्ययन अनुसन्धान भएको अनुसन्धानकर्तालाई मात्र समावेश गरिएको थियो। र हेल्थ रिसर्च अवार्ड प्रदान गर्दा नेपाल स्वास्थ्य अनुसन्धान परिषदसँग प्रत्यक्ष सम्बन्धितलाई समावेश गरिएको थिएन। प्रत्यक्ष भन्नाले परिषदका कर्मचारी, परिषदका कार्यकारी लाई हामीले लिएका थियौँ। त्यसै गरी मृगेन्द्र सम्झना मेडिकल ट्रस्ट यङ हेल्थ रिसर्चर अवार्ड मेडिकल डक्टर क्याटेगोरी प्रदान गर्दा पनि स्वास्थ्य अनुसन्धान परिषदसँग प्रत्यक्ष सम्बन्धितलाई समावेश गरिएको थिएन। त्यसै गरी मृगेन्द्र सम्झना मेडिकल ट्रस्ट यङ हेल्थ रिसर्चर अवार्ड चाहिँ जेएनएचआरसीको इम्प्लोइहरू मध्येबाट र कम्तीमा 3 महिनादेखि निरन्तर कार्यरत रहेको कर्मचारी मध्ये पबमेड इन्डेक्स जर्नलमा पब्लिस भएका विगत 5 वर्षमा पब्लिस भएका सबैभन्दा धेरै आर्टिकल भएको आधारमा हामीले छानेका थियौँ। त्यस्तै जेएनएचआरसीको बेस्ट पेपर अवार्डको लागि जेएनएचआरसीको सन् 2020 को जनवरीदेखि डिसेम्बरसम्म प्रकाशित ओरिजिनल आर्टिकलहरू मध्येबाट इभ्यालुएसन गरिएको थियो र ती नेपालमा अध्ययन भएका ओरिजिनल आर्टिकललाई समावेश गरिएको थियो। र एनी आर्टिकल द्याट इन्क्लुड एनी अफ द एडिटोरियल टिम मेम्बर्स JNHRC employee, NHRC executive as authors were excluded from the evaluation. त्यस्तै हेल्थ रिसर्च लाइफ टाइम अवार्ड्समा चाहिँ 60 वर्ष पार गरी स्वास्थ्य अनुसन्धानको क्षेत्रमा विशेष योगदान पुर्याएका आवेदकहरूमध्येबाट हामीले चाहिँ सेलेक्सन गरेको थियो। सबैभन्दा धेरै आर्टिकल, बुक या बुक च्याप्टर प्रकाशित गरेका अनुसन्धानकर्तालाई र बेसिकल्ली चाहिँ करेन्टली वर्किङ इन नेपाल र रिटायर भएको भए पनि दे आर वर्किङ इन नेपाल इन केस अफ एप्लिकेन्ट इज रिटायर्ड नाउ लाई कन्सिडर गरेको थियो। र एनी अफ द सिस्टमेटिक रिभ्यू र मेटा एनालाइसिसहरूमा चाहिँ वान अफ द साइट सुड बी नेपाल भनेर हामीले एउटा चाहिँ टुङ्गो गरेका थियौँ सिस्टमेटिक रिभ्यू र मेटा एनालाइसिसको हकमा। र एकपटकमा एउटा शीर्षकमा अवार्ड प्राप्त गरिसकेको व्यक्तिलाई फेरि त्यसको लागि छनौट चाहिँ नगर्ने आधारमा गरेको थियो। त्यसै गरी हामीले बेस्ट पेपर अवार्डको लागि हाम्रोसँग जम्मा 111वटा आर्टिकल थिए। त्यसमध्ये हामीले चाहिँ 86 लाई एलिजिबल मान्यौँ र 86 बाट विभिन्न आधारमा त्यसको टाइटल, ऱ्यासनल, अब्जेक्टिभ, स्टडी डिजाइन, स्ट्याटिस्टिक्सको युज, इम्प्लिकेसन अफ द स्टडी, इनोभेसन आदि गरेर हामीले चाहिँ 9वटा आर्टिकललाई सर्टलिस्टिङ गऱ्यौँ र त्यो 9वटा मध्येबाट चाहिँ बेस्ट पेपर भनेर हामीले चाहिँ सिफारिस गरेका थियौँ। त्यसै गरी त्यो आर्टिकलहरूको पनि विभिन्न टाइपको ओरिजिनल आर्टिकललाई फर्स्ट अथरलाई कति, को अथरलाई कति, रिभ्यू आर्टिकललाई कति, भ्यू पोइन्टहरूलाई कति, एडिटोरियललाई कति भनेर त्यो एक खालको चाहिँ हामीले अलिकति अब्जेक्टिभ बनाएको थियौँ। बुकलाई कति, बुक च्याप्टर लेखेको कति, एडिटर भएको कति भन्ने खालको चाहिँ आधारमा हामीले सिफारिस गरेका थियौँ। र अब यो अवार्डको पनि मैले नै नाम भन्ने हो कि कृष्ण सर?
पर्दैन डाक्टर साहब,
म छोटोमा मेरो यही नै हो। अब अन्तिममा हाम्रो टिमलाई पनि धन्यवाद, एनएचआरसी नेतृत्वलाई पनि धन्यवाद र सम्मान पाउनुहुने सबै बौद्धिक तथा अनुभवी व्यक्तित्वहरूलाई बधाई दिँदै यो मेरो छोटो चाहिँ मन्तव्य यही समाप्त गर्दछु। नमस्कार, जय एनएचआरसी। नमस्कार।
Thank you so much, Professor Dangal. It was I, being one of the members of the award selection committee, really enjoyed working in the team and during the award selection process. And I'm privileged to be here to be also declaring the awards in this closing session. So besides the categories Professor Dangal mentioned about the awards, there were two other categories. One is NHRC awards its employees since the very beginning of this national summit in 2015. We have been awarding the best employee of the year. So that is one category of the award, which will be continued this year as well. And the other award, as Dr. Pradeep Kyawali just explained, is about which we are initiating this year, is the Best Department Award over the year. So these are the two internal categories of awards, internal awards. And there are other two awards which are selected during the process of presentation during the National Summit. So the chairs where we have our very respected senior eminent personalities chairing different sessions of the summit selected a Best Paper Award in oral category, and then a Best Paper Award category in poster category was also selected by involvement of various scientific committee members. In selecting the Best Paper Award for oral category, we excluded all the members, all the presenters who were invited, or invited talks were excluded from the evaluation, and only those selected from the process of abstract submission and who were invited to present here were included in the evaluation. So in brief, this is what was different categories of awards. And now we will be proceeding towards distribution or the announcement of the awards. I take a pleasure to be presenting the awards over here. I'd like to start with the best papers presented during the summit. And the first category of award in the best paper poster category goes to Diksha Neupane, who is here virtually joining with us in the can we have Diksha on the screen, please? Hello, Diksha. It's great to have you here. We are sorry that you could not be here to receive the award, but your poster entitled Epidemiological and Clinical Characteristics of COVID-19 Cases and Their Contacts in Karnali Province of Nepal was selected the best poster in this year's National Summit. We heartily congratulate you for winning this award. Congratulations, Mr. Pradhan. To present this award to Diksha virtually though, I'd like to request Executive Chief of Nepal Health Research Council, Dr. Pradeep Ghiawali, to kindly present the award to Diksha, please. Okay, yeah, Diksha, you can feel the award from here from the distance. Your certificate and the medal is being presented here. You can collect at your comfort. And moving to the another category, the best paper award in oral presentation, as I explained earlier, goes to Nishant Katual. I think he is here with us. Nice to have you here. His presentation on evaluation of on-site training focused on molecular methods of COVID-19 testing in Karnali Province of Nepal has been selected as the best paper oral category. I'd like to request Dr. Pradeep Ghiawali again to present the award to Nishant, please. Thank you so much. Moving ahead, another category, which is the internal NHRC team member as well as department award. We have been, as I already said, this award for Best Employee of the Year is being awarded every year since 2015, and this year we have the name already here who is being awarded, and this is none other than our very favorite, ever smiling person in the council, who is very humble with us, and the name is Maheshwar Chaudhary. Chaudhary, he has been awarded as the Employee of the Year, who is popularly known as Chaudhary Ji and or Chaudhary Dai, and has not just been a person safeguarding the office, but a very valuable member in several office works, including assisting a number of teams in finance and administration, as well as the technical teams when and wherever needed. He is a very good human being in person, very humble and soft-spoken as we have known him over the years. It is a matter of pleasure seeing him being honored for this annual award. Chaudhary ji, हामी तपाईलाई यो अवार्ड प्रदान गर्दा एकदमै खुसी र गौरवान्वित महसुस गरेका छौं। तपाईको पर्सनालिटी, तपाईको यो परिषदको लागि गरेको लामो समयदेखिको अनवरत सेवा र तपाईले यो वर्षमा हासिल गर्नुभएको जुन उपलब्धि लगायत सबै कुराहरुको उपलब्धि सहित यस अवार्डबाट सम्मानित हुनुभएकोमा हामी एकदमै धेरै तपाईलाई चाहिँ कंग्रेचुलेसन्स साथ भन्न चाहन्छौं। हामी अगाडि छौं र यो अवार्ड प्रदान गर्नको लागि म महेन्द्र सरलाई रिक्वेस्ट गर्न चाहन्छु सर्टिफिकेट प्रदान गर्नको लागि। महेन्द्र सर, can you have the honor of having you presenting the award to Maheshwar Dai. And at the same time, I'd like to request Dr. Pradeep Ghiawali to honor him with the medal, please. And also, this award consists of a cash award, so may I request Dr. Pradeep to hand over the cash award also to him, please. This is of Nepali rupees 35,000. Being awarded as the cash award to him. Thank you, sir. Thank you, Dr. Pradeep. And the next one in the internal award category is the NHRC Best Department Award 2020. And as Dr. Pradeep mentioned earlier, this has been started from this year and will be continued in the coming years, where we'd like to see a healthy competition among the departments in performing well for the sake of council, for the benefit of the council, for the benefit of the health of the people of Nepal. This year, this award has been decided to be awarded to the Research Department of the Research Council. May I request Dr. Meghna Timal, Chief of the Research Section, who has been leading the research section for more than a decade now, to kindly receive the award on behalf of the Research Department of the Research Section. For this again, Mahendra सरलाई रिक्वेस्ट गर्न चाहन्छु यो अवार्ड प्रदान गरिदिनको लागि। Thank you so much, Mahendra sir. Congratulations, Research Department. Now we are moving to another category of award which Professor Ganesh Tangal just explained about. And to start with, we will be presenting the JNHRC Best Paper Award, Durga Devi Gyawale JNHRC Best Paper Award 2020, which Dr. Pradeep just mentioned about it, where he has established the award on in the name of his mother, Durga Devi Gyawale. She has been suffered with paralysis and has been incapacitated for now and could not be here. And on her behalf, this award will be presented by Dr. Pradeep Gyawale. And for this, the selection process was already explained. I don't want to go to that. But since last year this award has been awarded to the authors, the researchers who dedicate their time to love the national journal to get their work published. And NHRC would like to see more and more of high quality papers from such researchers submitting their work to the National Journal of Health Research, and encourages all health and population scientists to be a part of JNHRC family as much as they can. For this year's Best Paper Award, among the papers published in the Journal of Nepal Health Research Council throughout the year in 2020, and as already explained, some papers were excluded. We have a best paper selected out of those 86 papers from that year, and this year's Best Paper Award goes to author Narmada Depkota, who with her team Sisir Subba, Nandita Sharma, Janardhan Depkota studied diagnostic accuracy of a scale to diagnose an important mental disorder in children, attention deficit hyperactivity disorder. The paper is entitled Intake Assessment and Diagnostic Accuracy of Attention Deficit Hyperactivity Disorder, Diagnostic Scale being developed for children in Nepal, and was published in the Journal of Nepal Health Research Council issue April to June 2020. Narmada Depkota is here with us to receive the award. Madam, kindly come over the desk to receive the award, and I'd like to request Dr. Pradeep to hand over the award. Also the medal, please. The next two categories of awards. Can we have Chairman Emeritus Dr. Mrigandraj Pandey over the screen, please? Dr. Mrigendra Pandey in the screen, please, if he is available. Just in the screen. There are two award categories established under the name of Mrigendra Samjana Medical Trust. One of them is Young Health Research Award, which is especially dedicated for NHRC employees. That was as per the agreement with Mrigendra Samjana Medical Trust that NHRC has with the trust. Sir, we are distributing the awards that was established in agreement with Mrigendra Samjana Medical Trust. We are honored to have you here again, and we wanted to see you here while presenting the award, and we'd like to proceed with award distribution. And the first category, as I mentioned, that is the NHRC employee category, the Mrigendra Samjana Medical Trust Young Health Researcher Award, which in NHRC's agreement with the trust has been, we have been providing this category of research award especially dedicated to the young under 40 years, that is, researchers working at the Nepal Health Research Council, contributing to strengthening evidence based in health sector of Nepal. This year, this award goes to Dr. Vishnu Prasad Morasini, who is a senior research officer here at the Nepal Health Research Council and has been involved in drug discovery research and has established a bioassay lab in Nepal and is the recipient of the World Academy of Sciences Young Scientist Award. He is also the recipient of Vidya Bhushan Cup from the Right Honorable President of Nepal. He has published over 50 peer-reviewed articles and has a patent in his name. In the past, he had served as head of Department of Biotechnology, National College, and as editor-in-chief of International Journal of Medicine and Biomedical Science. Congratulations, Dr. Vishnu, and we wish you more in days to come and look forward to your contribution towards expanding the evidence base and supporting the national health system through the Research Council. I'd like to request our chief guest, Mahendra sir, as well as our vice chair to provide the another one. Thank you so much. We can continue to have Mrigendra sir over here in the screen. And also maybe I'd like to request the next category of award. As I announce the name, may I request the IT team to display the person who is virtually joining us, maybe after I declare the name. The next category is Mrigendra Samjana Medical Trust Young Health Researcher Award, which is again by agreement with the trust. It is for the medical doctor category. Medical doctor researcher are awarded with this category of research award, and with its agreement again NHRC with the trust has been providing this category of research award especially dedicated to the young medical doctors, that's again less than 40 years, contributing to strengthening evidence base in health sector in Nepal. Among the applications for this category of award, the committee has chosen Dr. Bipin Adhikari, who is virtually joining with us. Dr. Bipin Adhikari, can we have him on the screen, please? With the highest score in the process of evaluation to reward with the Health Research Award 2020, he has been awarded this research. He is a medical doctor turned public health researcher, currently a postdoctoral researcher at University of Oxford, based at Mahidol Oxford Tropical Medicine Research Unit, Bangkok, Thailand. He holds a Master of Clinical Tropical Medicine from Mahidol University, a Masters of Public Health from Chulalongkorn University, Doctor of Philosophy from University of Oxford, UK. Dr. Bipin is an active researcher in Nepal's health sector, especially in the field of health system, infectious and tropical diseases. Notably, Dr. Bipin has also contributions towards the National Malaria Control Program of Nepal through research and collaboration. He has ongoing research collaboration with the Central Department of Microbiology, Tribhuvan University, and various academic and healthcare institutions in Nepal. In addition, Dr. Bipin is expanding research around antimicrobial resistance in Nepal. He is an associate editor also in BMC Tropical Diseases, Travel Medicine and Vaccine, as well as BMC Public Health. Huge congratulations, Dr. Bipin. It's nice to have you here, though virtually. We congratulate you, and we look forward to seeing more of such wonderful work from you towards expanding the evidence base through generation of high quality evidence in Nepalese health sector. Huge congratulations. And to present this award virtually, I'd like to request our chief guest to present the certificate as well as the medal to Dr. Bipin, please. कति राम्रो सरको स्टुडेन्ट हो, झन् धेरै खुसी लाग्यो यो अवार्ड to receive on his behalf. प्रदीप बेलवासेज्यूलाई म रिक्वेस्ट गर्छु, जर्नल अवार्ड सेलेक्सन कमिटीको सेक्रेटरीको तर्फबाट प्रदीप बेलवासेले उहाँको नाममा रिसिभ गर्नुहुन्छ सर। म्याडम Thank you so much, sir. Thank you, Pradeep, for receiving the award. And can we unmute him, please? Dr. Bipin. Yeah, Dr. Bipin. Yes.
Can you hear me, sir?
Can we have very few words in brief from you, please?
Yes. सबभन्दा पहिला धेरै धेरै धन्यवाद. Thank you so much. I'm really honored to be selected for this Mrigendra Samjana Medical Trust Young Health Researcher Award. It is a great privilege to be associated with the legacy of Dr. Mrigendra Pandey, whose contributions in Nepal's research and public health are outstanding, and honestly, it inspires all public health practitioners, researchers, and clinicians in Nepal and globally too. And he's an exemplar for all of us who are doing research. But before I go on, Very much in line with the vision of Mirgendra Samjana Medical Trust, if I'm allowed, I would like to remember my Mama Maiju, Mr. Hira Regmi and Sapana Regmi, who I lost around just 2 months ago by the second wave of COVID-19. They always inspired me to serve Nepal's health sector through any means possible. They would have been very glad to see me today. May their soul rest in peace. With this award, I would also like to thank all of my collaborators who have always been helpful. And this award belongs to them as well, those collaborators, and all the young researchers and scientists who I represent. Thank you very much, NHRC. Thank you very much, Dr. Mirgendra Pandey. Thank you.
Thank you so much, Dr. Bipin. And once again, a huge congratulations to you.
Yes. Thanks and congratulations.
Thank you so much, sir.
Thanks and congratulations.
Thank you.
Thank you so much, sir. Moving ahead, the next category of award is Health Research Award 2020, which is an open category award that is for every Nepali citizens, open to every Nepali citizens who has high scientific contribution towards generation of evidence in the Nepalese context. And as detailed out earlier by Professor Ganesh Tangal, this also went through a rigorous process of evaluation. And among the applications for this category of award that was received within the provided time, the committee has chosen Mr. Uday Naran Yadav. Can we have him on the screen, please? With the highest score in the process of evaluation. I think he's with us virtually, yes, Udayji. With the highest score in the process of evaluation to reward with the Health Research Award 2020, Mr. Uday holds MPS from Manipal University, Karnataka, India, and is currently at the stage of almost acquiring his PhD from the University of New South Wales, Sydney, with the Centre for Primary Healthcare and Equity. His PhD research focused on studying co-designing an integrated model of care for developing comprehensive self-management intervention for multimorbid COPD in Nepal. He has won several grants, national and international, for conducting research, and most of his work are within the country itself. He has several publications focusing on health of Nepalese people in esteemed international journals. Majority of his publications are on non-communicable diseases, with a substantial number of papers in COPD in Nepal. He is a recipient of various prestigious scholarships, fellowships such as David Sackett Fellowship from the Nuffield Department of Primary Care, Health Sciences, University of Oxford. Uday also holds the position of Associate Editor at BMC Public Health for the Global Health section. To award him with this award, to present the award, I'd like to request our chief guest again to present him virtually, and then later on present that to the Secretariat, Pradeep Bilwase. Congratulations, Mr. Uday, and we look forward to seeing more of such wonderful work towards expanding the evidence base through generation of high-quality evidence in the Nepalese health sector, and also the medal, sir. Pradeep, can you please receive on behalf of Uday, please? Thank you so much, sir. Mr. Uday, can we have few words from you? Yeah. Can you hear us?
Thank you very much. So first of all, good evening, dignitaries. Good evening from Sydney. First of all, I would like to acknowledge all the known and the unknown martyrs of Nepal, and also would like to pay my respect to the peoples of Nepal from where I started the journey to conduct the research. And I'm very honored to be here today with you all, and thanks to the NHRC team for recognizing my contribution towards the research in Nepal. I'm very grateful to the amazing people of the Nepal who supported me since 2015 till now. And I have been representing Nepal in the different forums. And if you allow me, I would like to dedicate this award to my mom and to my PhD supervisor, Professor Mark Harris, who provided me the excellent wordcast environment at the University of Sydney to conduct the research focused in the Nepal. And in the future, I'm looking forward to collaborate with all the researchers in Nepal from the multidisciplinary field. As Dr. Ariel mentioned, my specialization lies with the chronic disease and the implementation science. I'm very much we can't address any problems with the single head. So we need to have we need to work together. So I'm looking forward to work with you all in this multimorbidity and management, and I'm currently developing the multimorbidity self-management plans for Nepal, and I will be sharing that with the NHRC and the other colleagues in the future. Thank you very much, and once again, namaste.
Thank you so much. Once again, huge congratulations for being awarded with this prestigious award of Health Research Award 2020. Now, coming towards the last but not the least, I would say actually the most important one, Health Research Lifetime Achievement Award 2020. This award, in honor of long contribution in advancing the research and evidence generation in the health sector, we have been awarding senior scientists of Nepal with the Health Research Lifetime Achievement Award. And amongst the several applications for this category of award, this year's award on this category goes to a very familiar name to all of us, Dr. Vasudev Pandey. Dr. Pandey has recently took his retirement from his service to the government of Nepal in several positions across various units of Ministry of Health and Population. Towards the end of his career, he served as the Director of Epidemiology and Disease Control Division, and it was in a hard time when we all were struggling with the global pandemic due to COVID-19. At present, he serves as the Director of the Everest International Clinic and Research Center, Kathmandu, Nepal. In the scientific fraternity, he is a well-known virologist. And his main area of interest is on arthropod-borne viral diseases that include dengue fever, Japanese encephalitis, chikungunya virus, Zika virus infection, and HIV/AIDS, as well as other several tropical diseases. His research areas range from clinical, epidemiological, and molecular studies to the operational studies with regards to disease control. He has more than 100 publications in all these areas, and we heartily would like to congratulate Dr. Pandey for achieving this. And for presenting the award, I'd like to request Chief Guest as well as the Chairman of Nepal Health Research Council, Professor Dr. Gainath Badal. Thank you so much, Mahendra sir. Thank you so much, Professor Badal. Sir, Doctor, please, 1 minute. So we'd like to congratulate Dr. Pandey once again for this, for the Lifetime Achievement Award. And we wish to see more from him, maybe even more, I would say, in the coming days in his post-retirement career of life in support of strengthening the evidence base of Nepalese health sector. We'd like to hear a few words from Dr. Pandey, please.
धन्यवाद। यस कार्यक्रमका अध्यक्षज्यू डाक्टर बराल, प्रोफेसर डाक्टर बराल र चिफ गेस्ट महेन्द्र सर, साथै ड्यासमा हाम्रा एनएचआरसीका एक्जिक्युटिभ चेयर र भाइस प्रेसिडेन्ट लगायत सम्पूर्ण महानुभावहरू, साथै एनएचआरसी फ्यामिली र यहाँ उपस्थित भएका महानुभावहरू, पत्रकारज्यूहरू लगायत सम्पूर्ण भर्चुअल्ली, नेसनल्ली, इन्टरनेसनल्ली हेरिराख्नुभएका सम्पूर्ण साइन्टिस्ट र अरू साथीहरू, आज म एकदमै खुसी छु। जब मैले पहिलो पेपर लेखेको थिएँ, म त्यति बेला चाहिँ मेरो प्रोफेसरले म जब पेपर लेखेर मैले उहाँलाई बुझाएँ, उहाँले चाहिँ त्यो पेपर च्यातेर त्यसपछि तपाईँले यस्तो पेपर लेख्ने भने यो गो ब्याक, म जहाँ गएको थिएँ, जुन युनिभर्सिटीमा पढेको थिएँ त्यो च्यातेर उहाँले फालिदिनु भयो। त्यहाँबाट सुरु गरेको पेपर लेख्नलाई अहिले आएर मैले यहाँ साथीहरूको नेसनल्ली मैले स्वास्थ्य मन्त्रालयमा सबभन्दा सुरु 2038 सालमा बागलुङको रेसा हेल्थ पोस्टबाट म काम सुरु गरिकन स्वास्थ्य मन्त्रालयका विभिन्न विभाग, महाशाखा, क्षेत्रीय निर्देशनालय विभिन्न ठाउँमा काम गरेर मलाई स्वास्थ्य तथा जनसङ्ख्या मन्त्रालयले हाम्रा साथीहरू यहाँ काम गर्ने सम्पूर्ण महानुभावहरूले उहाँले मलाई चिनाउनु भएको छ र यो काम गर्दा नेपालको म हिमालदेखि हामी अघिल्लो वर्ष हामी मुस्ताङमा गएर अल्टिट्युड र नन कम्युनिकेबल डिजिज हामीले हेऱ्यौँ। त्यस्तै अरू भागहरू, तराई, पहाड सबै क्षेत्रका हामीले रिसर्चहरू म र मेरो कोलाबोरेटर टिमहरूले गरिरहेको छ। यसमा इन्भल्भ हुने सम्पूर्ण महानुभावहरू, हस्पिटल लगायत सम्पूर्णलाई मैले धन्यवाद दिन चाहन्छु। र मैले अहिलेसम्म गरेको एचिभमेन्ट म पर्सनल व्यक्तिगत नभइकन सबैको यो साझा हो र उहाँहरूको सहयोगले म यहाँसम्म पुग्न सकेको छु। र भविष्यमा पनि म यो क्वालिटी रिसर्चको लागि, एभिडेन्स बेस्ड रिसर्चको लागि म आफूले जानेको कुरा अरूहरूलाई सेयर गर्ने र अरू अझ साइन्टिफिक कुराहरू गर्नलाई म म यो अवार्डले मलाई थप प्रेरणा दिएको छ र यति भन्दै यहाँहरू सबैलाई जो कमिटीमा हुनुहुन्छ र नेपाल हेल्थ रिसर्च काउन्सिल जहिले पनि पोजिटिभली हामीसँगै काम गरिरहेका छौँ र त्यसै अरू कसलाई मैले सम्झिनै पर्ने म जहाँ अध्ययन गरेको थिएँ टिचिङ हस्पिटल सहिकन नागासाकी युनिभर्सिटीको जो प्रोफेसर इगारासी हुनुहुन्छ उहाँ अहिले हुनुहुन्न र त्यस्तै म पोस्ट डक्टरल म थमस जेफरसन फिलाडेल्फियाबाट गरेको थिएँ उहाँहरू सबैलाई मलाई जुन सहयोग गर्नुभएको थियो यो बेलामा म सबैजनालाई म सम्झिन चाहन्छु साथै मेरो परिवार र सबैजनाले मलाई अहिलेसम्म यो रिसर्च गर्नलाई रात दिन खट्ने बेलामा जुन सहयोग गर्नुभयो सबैजनालाई म धन्यवाद दिँदै म एकदमै खुसी छु र यो कार्यक्रममा यसरी मलाई यो मौका प्रदान भएकोमा यहाँ सबैलाई फेरि धन्यवाद दिँदै मेरो भनाइ टु थ्याङ्क यू सो मच
Thank you so much, Dr. Pandey. It's really an honor to see you receiving this Lifetime Achievement Award. We feel very much privileged. Once again, huge congratulations to you. Moving ahead now, almost we are towards the end of the session as well as of the summit. We would like to hear from our chief guest with these few words, with directions for us to move ahead in the days to come. He has been always very much supportive to us, and it will be a privilege and honor to listen to him as well today. Mahendra sir, please.
धन्यवाद डाक्टर कृष्ण। आजको यो नेसनल समिट अफ हेल्थ एन्ड पपुलेसन साइन्टिस्ट इन नेपाल समापन समारोहका सभाध्यक्ष, एनएचआरसीका अध्यक्षज्यू, एनएचआरसीका उपाध्यक्ष लगायत सम्पूर्ण पदाधिकारीज्यूहरू, अब हाम्रो प्रोफेसर साइन्टिस्ट वासुदेव पाण्डे लगायत अरू प्रोफेसर साइन्टिस्टहरूले पनि देखिरहेको छु, पत्रकार मित्रहरू र एनएचआरसीका सहकर्मी साथीहरू। जिन्दगीमा एउटा नि रिसर्च नगरे मान्छेले यहाँ प्रमुख अतिथि भइयो है। मैले केही रिसर्च गरेको छैन, जागिर सबभन्दा लामो अहिले मन्त्रालयमा अब रिटायर हुँदैछु म चाहिँ नि सम्भवतः अब लामै वासुदेव डाक्टर साहब 38 रहेछ, म 37बाट सुरु गरेको छु। र अब मलाई आफूले गौरव के लाग्छ भने म नेपाल सरकारको सबै स्ट्रक्चरमा काम गरेको छु। हेल्थ पोस्ट, पिएचसी, डिस्ट्रिक्ट हस्पिटल, जोनल हस्पिटल, सेन्ट्रल हस्पिटल, डिस्ट्रिक्ट हेल्थ अफिस, ट्रेनिङ सेन्टर, रिजनल हेल्थ अफिस, विभाग, मन्त्रालय सबै ठाउँ। डब्लुएचओमा काम गरेँ यो टाइममा 1.5 वर्ष जति। तर मैले रिसर्च गरेको छैन। मैले एउटा रिसर्च गरेको छु, मलाई चाहिँ नि गाउँको रोटी खाने असाध्यै मनपर्ने, श्रीमतीले पकाएको कहिले डढ्या हुन्छ कहिले काँचो हुन्छ, हैरान भयो। अब यसमा रिसर्च गर्नु पऱ्यो भने रिसर्च गरेँ। अहिले मैले च्यालेन्ज के गर्छु भने गाउँको रोटी मैले सबभन्दा बेस्ट बनाउँछु है। त्यो कसरी बेस्ट हुन्छ तपाईँले त्यो रोटी खानुभएपछि थाहा पाउँछ। गाउँको रोटी कस्तो खानुपर्छ त्यो मलाई थाहा छ है। त्यो कसरी त्यो चाहिँ नि फक्क फुक्छ नि, फुकेर भित्र जुन तातो जान्छ त्यसले पाक्नुपर्छ, त्यो डढ्न पनि हुँदैन। र त्यो म च्यालेन्ज के गर्छु भने मैले 100वटा पकाएँ भने 100वटै भगुन्डो जस्तो बनाइन्छ है। त्यो मैले रिसर्च गरेँ। मैले के भन्न लाग्यो भने रिसर्च नगरिकन मान्छेहरू अगाडि बढ्यो भने त्यो लाइफमा कहिले पनि सफल हुँदैन। अस्ति हाम्रो डाक्टर वन्त जानुभयो, उहाँले राम्रो कुरा गर्नु, अनफिनिस एजेन्डा अफ माई लर्निङ भन्नुभएको छ कि कतिजनाले भाग लिनुभयो, असाध्यै राम्रो थियो त्यो। उहाँले के भन्नुभयो भने त्यो मैले पनि भन्ने गर्थेँ डिस्ट्रिक्ट हेल्थ सिस्टममा जाँदा, एउटा मान्छेले के भन्छ भने मैले 20 वर्षदेखि पढाइरहेको छु, 20 इयर्स एक्सपिरियन्स अफ टिचिङ भन्छ कि। अनि मैले महाराजगञ्ज पढाएको सबै टिचरले के भने 20 वर्ष अगाडिको त्यो स्लाइड ल्याउन देखाउँछ, उही हरेक वर्ष त्यो स्लाइड देखाइरहेको छ। अनि 20 इयर्स एक्सपिरियन्स भयो भएन, 20 इयर्स रिपिटेसन भयो कि। 1 इयर एक्सपिरियन्स, 19 इयर्स रिपिटेसन, डुइङ सेम थिङ विथ रिपिटेसन। मेरो बुवाले खेती गर्नुहुन्थ्यो होइन, मैले पनि खेती गर्छु, बुवाले जसरी खेती गर्छु त्यस्तै गरेर खेती गर्छु, त्यही नै तरिका गर्छु भने त मैले 20 वर्ष 30 वर्ष जति वर्ष खेती गरेँ पनि म 1 वर्ष सिकेँ, बुवासँग लर्निङ भयो, बाँकी मैले 29 इयर्स रिपिटेसन गरेँ। त्यसकारण थिङ्क डिफरेन्टली होइन, त्यो भनेकै रिसर्च हो होइन। रिसर्चले त्यसलाई चाहिँ नि सार्पेन गर्दै लग्छ।
मैले हिजो गरेको काम के थियो हैन। अब त्यसलाई अब अस्ति वन्तले राम्रो भन्नुभएको छ के, जस्तो आगोमा भाँडामा चामल राखेर आगो लगाएपछि भात पाक्छ, त्यो युजुअल प्रोसेस हो। आगै नलागिकन भात कसरी पाक्छ त्यो थिङ्क गर्नुभयो नि, देन आफ्टर रिसर्च कम्स हैन, नयाँ वेहरू आउँछ भन्ने कुरा उहाँले भन्नुभयो। अब मेरो त अवधि सिद्धियो, मैले त गर्नै पाइएन त्यो रिसर्च। अब मैले त्यो चाहिँ नि धेरै टाइम, तर एउटा दुईवटा पेपर भने मेरो निस्क्यो है। डाक्टर साहबले निकालिदिनुहोस् भने 2-3 ठाउँ उहाँले नाम राखिदिनु भयो। उहाँको रिसर्चमा मेरो नाम छ। त्यसपछि अरू थुप्रै साइन्टिस्टहरूले मेरो नाम राख्दैछ। ठुल्ठुलै जर्नलमा 2-4वटा 8-10वटा नाम निस्किएको छ, तर मेरो कन्ट्रिब्युसन होइन, नाम निस्किएको छ त्यसमा है। तर मैले रिसर्च गरेको छैन। रिसर्च बहुत मैले भनिहालेँ, तपाईँ चाहिँ नि जबसम्म रिसर्च गर्नुहुन्न तबसम्म त्यसको डेप्थमा चाहिँ नि जानुहुन्न। र यसमा हामी अलिक पछाडि थियौँ। मलाई लाग्छ यो केही वर्षदेखि एनएचआरसी अलिक भिजिबल भएको छ, तपाईँहरू राम्रो गर्नुभएको छ। र यो वास्तवमा 7th भर्चुअल लेख्नु भएको रहेछ, यो गलत भयो। 7th नेसनल समिट हो, 2nd भर्चुअल अनि 5 चाहिँ नि हुनुपर्ने, त्यो अलिकति सुरुमै त्यो अलिक गलत भएको छ होइन। 7th हो र यो चाहिँ नि अलिकति खारिँदै गएको छ, राम्रो हुँदै गएको छ। अब कस्तो छ भने हामी यही इन्भाइरोमेन्ट हो नि, हामी नेपालमा बस्ने, हामी यसरी पढ्ने, अनि अमेरिकाको रिसर्च जस्तो छ बेलायतको छ भनेर त भएन। हामी नेपालको रिसर्च गर्ने हो, हाम्रो इन्भाइरोमेन्टको कुरा, हाम्रो क्यापेसिटीको कुरालाई लग्दै लाने हो। यसमा राम्रो गर्नुभएको छ। अहिले टिम पनि राम्रो आएको छ, मलाई लाग्छ आगामी दिनमा राम्रो हुनेछ। र खास गरी मन्त्रालयको तर्फमा व्यक्तिगत तर्फबाट यो चाहिँ नि धेरै मेहनत गरेर गर्नुभएको छ। यसमा हामीले गफ गर्नलाई सहिलै छ, तर तपाईँहरू सबैको प्रयासले एकदम सफल भएको छ। म त्यसकारण एनएचआरसीको होल टिम, कार्यकारी कर्मचारी सबै साथीहरूलाई धेरै धेरै धन्यवाद आभार व्यक्त गर्न चाहन्छु। र सबै रिसर्चरहरू जो हुनुहुन्छ उहाँहरू वास्तवमा हाम्रो स्रोत केन्द्रहरू हो। हजुरहरूको चाहिँ नि अरू राम्रो रिसर्च हुँदै जाओस्, अरू विकास हुँदै जाओस्, यही शुभकामना दिन चाहन्छु। र सबै जुन पुरस्कृत हुनुभयो उहाँहरू सबैलाई बधाई दिन चाहन्छु। र हाम्रो अध्यक्ष कार्यकारीज्यूहरू सबै तपाईँहरूको सफलताको लागि पुनः बधाई दिन्छु। धन्यवाद, नमस्कार।
Thank you so much, Mahendra sir. It always feels very good to listen to you. हजुरको माया, हजुरको सद्भाव एकदमै प्यारो लाग्छ। हजुरले जुन हिसाबले गाइड गर्नुहुन्छ, जुन हिसाबले डिरेक्सन दिनुहुन्छ, हँसाइकन र जहिले पनि माया गरिकन हामीलाई गाइड गर्नुहुन्छ, र त्यो एकदमै हेल्पफुल हुन्छ, त्यो जहिले पनि प्रेरणादायी हुन्छ, र द्याट मोटिभेट्स द टिम टु मुभ अहेड पोजिटिभली अलवेज. We have come towards the end of the program and the summit as I have been talking. Now to thank all the people involved, all the resources involved, and all the efforts that has gone towards the successful completion of the summit, successful completion of the session. We would like to thank all, and to express the vote of thanks, may I request the Vice Chairperson of the Nepal Health Research Council, Professor Dr. Gaurav Raj Dhakal, to come over the dais and kindly present the vote of thanks to all those involved.
Thank you very much. It is never too late to conduct research. It is not a barrier. So with this, since we are approaching the fag end of this 2-day summit, I would like to thank everyone involved who have been able to make this summit a national success and internationally also. For once, let us appreciate the good work that we all have done, and let us give an applause to ourselves. I'd like to thank the Executive Committee members of Nepal Health Research Council. Everyone in the executive board and non-executive members have done a very appreciable job in the last few weeks. The Ministry of Health and Population, Department of Health Services, and all of its divisions need a well-deserved gratitude. The external development partners with which we work closely with NHRC and the Government of Nepal, the World Health Organization, UNICEF, World Food Programme, deserve a special thank you. And the Research Division, Ethics Division, Administrative Division, Accounts, Library sections, and all involved within NHRC deserve a round of applause. So the big guns in the steering committee who are serving as members, the scientific committee members, the organizing committee, the awards selection committee have done a tremendous amount of work and put in a lot of effort in bringing all these deliberations and presentations and selection of presentations and the awards selection. I think it's not a very easy job doing all these things. So all of you deserve a special vote of thanks. All the journalists present here who have been covering this event with much enthusiasm since the last 2 days also deserve a special thank you. The presenters who have presented the excellent work, and for me, on a personal level as a spine surgeon, and listening to all these 2 days of deliberation was an eye-opener for me, because it's a different profession to which I belong to. And it's given me a different paradigm to look into research and public health aspects of what's going on around this country. So it is also important that this event like this reaches out to all the members of other clinical societies in Nepal, so that other clinicians in Nepal are versed and come to know about what's happening in the field of research, public health, and clinical research around the whole country. And I would also like to thank Professor Mrigender for his excellent, time you have provided to us in coming online, and to the Mrigender Samjana Medical Trust for always providing your support and guidance. The IT team, the support staff, right from the lower level to the upper level of Nepal Health Research Council deserve a special thank you. And with this, I would like to conclude my vote of thanks. Thank you, everyone.
Thank you so much, sir. Thank you, Professor Dr. Gaurav Rasdakal, for honoring, actually acknowledging the support, effort of all those who are involved during this process and successful completion of the summit. Now it's time for me to say goodbye, and while saying so, would like to request the chair of the session, the chair of Nepal Health Research Council, Professor Dr. Gehanath Baral, to put his closing remarks, and with a message of to see you all in the next year's summit. I'd like to say goodbye and request Professor Baral to present closing remarks and conclude the session, conclude the summit. I, Krishna Aryal, take leave from here. Thank you.
Thank you very much. Respected delegates and guests, whoever is present and physically and linked with virtual means, within the institution, within the country and abroad. This summit would not have been success without your presence, your contribution, either physically or virtually. So we are very grateful to your presence and your contribution wherever you are, wherever you work. And all the teams within the institution, like IT, our media people, and our family are equally thankful for this contribution, and it will be continued for the days to come. And I think we'll be going forward with better efficiency than the before and than this time also. Now we have already come to a conclusion that this research will not be let. Age is a systematic fault for us. We can do research at any time. If you are active, we can do it. So that systematic fault should be breached by our research and work for the days to come, and that will lead to the prosperity of our health and research and our health of the people and the society. Previously, we were just working for the observations only. Now we are going upwards in upper range and in the quality research up to the systematic analysis and meta-analysis, systematic reviews. It means our quality of work, quality of research has been increasing from year and year. I think this time we are going to that level. Previously we were doing for the comparative study, now we are going for the clinical trial. That is necessary for us in our own way, in our own soil. So that will be appropriate and customizable to our people and to our society. That is the effort that is given, that is put by all of us, and that is very thankful, and that is good for us as well. And this is the time to generate evidences as evidence-based medicine, to practice and to intervene. And the evidence-based intervention, evidence-based medicine
is the one that is governing the whole world. Now it has gone up with the personalized medicine as well. For that, we have to go with a small cohort. That would be very, may not be cost efficient, but we have to go for that as well. That is very long way to go. Now we are just entered into the clinical trial only. Now I think we'll be going that way also. We are in the learning phase in the research. Still, we have we have earned many young and energetic researchers. We have already awarded some people as well. This award was also to encourage the people for research and to recognize them and to promote them as well. And this will be the example for the future researchers as well. Now, we had already declared some declaration from this year's summit, and we had compared the previous declaration as well. I think this declaration will be in effect for the whole year, and will be coming with a further other advanced declaration next year, so that our research will be at par with the global scenario and we will be visible all over. That is the good thing, and I congratulate you all. And at the conclusion, I respect your presence, your sincerity, and your viable and energetic work day and night to make this summit successful. Thank you very much. I conclude this session from today. Thank you very much.
यो हटाऊ दुईटा हटाऊ